A very good morning to all the faculties, delegates, and the members of the pharma company who are attending Gofcon for the second day of the event. I'm your moderator for the session. My name is Dr. Akshat. I'd like to call the chairpersons and panelists on the stage, Dr. C.S. Yadav, sir, Dr. S.P. Gupta, sir, Dr. Kumar Jitendra, sir, and Dr. Jibendu Chaudhary, sir. May I request Dr. Ravi Kumar, sir, for his demonstration of the video on osteo.
Good morning. My talk is about real life of the high tibial osteotomy. These osteotomies around knees are game changers for joint preservation. Primarily indicated for young individuals between 45 to 60 who have a single compartment osteoarthritis, middle compartment osteoarthritis. The purpose is just to delay the need of knee replacement by slowing or stopping the destruction of the middle joint compartment. If you look at the literature, the results are excellent. The return to sports and work after osteo is close to 90% with an average follow-up for around 65 months. So we had this patient, young 55 years old male patient with a knee pain of over 2 years. Foremost, we need to get an alignment X-ray. It's a proper alignment X-ray done. We need to calculate the MPTA and LDFA. The MPTA was less. Then we went, since the patient was having severe pain, we got the MRI done. The MRI was having severe osteoarthritis, tricompartmental osteoarthritis, along with the degenerative tear of the middle meniscus root. So the plan was high tibial osteotomy with root repair. If you look at the literature, the results, it's ambiguous actually. The results after single high tibial osteotomy versus high tibial osteotomy with root repair, it's almost similar results. So that's how the compartment looked like after diagnostic arthroscopy. There were full thickness tear of the full thickness cartilage defect over the middle femoral condyle and the middle tibial plateau. Just go slowly. Yes, you can appreciate the full thickness cartilage defect over the middle femoral condyle. There was a degenerative tear of the posterior horn of the middle meniscus. There's complete root tear, degenerative root tear. So we did just a little bit of debridement, a little bit of microfracture. I didn't go for the root repair. So prior to doing high tibial osteotomy, it's important to do the step of diagnostic arthroscopy. The important landmark before high tibial osteotomy is to identify the middle joint line. Okay. The medial joint line, then you have to mark the patella tendon. Two important structures we have to appreciate is that deep MCL, it's around 1 centimeter distal to the middle joint line. Deep MCL, and the next is the distal attachment of the superficial MCL, which is almost 6 centimeter distal to the joint line. Incision, it's always a incision around 1.5 inch medial to the tibial tuberosity, around 6 centimeter in length, starts almost 1 centimeter distal to the joint line. After the skin, we have to take a full thickness, we have to remove the pes in full thickness. It's an inverted L-shaped incision. Just remove. That's how we do. We just remove the full thickness of the pes ancillaris. After removing the pes comes the distal attachment of the superficial MCL. Once we are done removing the pes, we use a curved osteotome or a curved osteotome to remove the distal attachment of the superficial MCL. Next step is to remove the muscles on the posterior surface of the proximal tibia. Once you remove the muscles, it's important to ensure that you just put your index finger and palpate for the head of the fibula. If you can appreciate the head of the fibula, you are ensured that you have removed all the attachment over the posterior surface of the proximal tibia. I can appreciate the fibular head. This is to ensure that we have removed adequately. Next is to plan the osteotomy level. Ideally, it should be at the level of tibial tuberosity or just proximal to that. My plan was to do a biplanar osteotomy. Biplanar osteotomies have a large surface area. They have good healing. Side effect is that biplanar osteotomies, they will increase the posterior tibial slope, and there is a risk of injury to the hinge in biplanar osteotomy as compared to the uniplanar osteotomy. Normally, we start at the level of tibial tuberosity. This 2 mm guide wires, they are put at the level of tibial tuberosity. Next step is to put a hinge protection K-wire. Again, a 2 mm K-wire is used to protect the hinge. Ideally, when we pass the hinge protection K-wire, it's passed through, we ensure that we take a proper lateral view of the knee joint, and the K-wire should be inserted between the Guddy's tubercle and the fibular head. If you go by the literature, there are people who use multiple K-wires, 2 K-wires to protect the hinge. Next, after putting the K-wire, okay, so this K-wire should be directed towards the head of the fibula, and it should be at least 2 cm distal to the joint line and 2 cm medial to the fibular head. We start osteotomy, and that's how it looks like. Once you are done with the osteotomy, we just confirm the alignment. It should be at the level, it should be at 50% of the joint line. Again, how much correction is required, it depends upon how much is the severity of the knee joint osteoarthritis. There is some Fujisawa's point, which is at 62.5% from the middle surface of the tibia. But there are reports which talk about just using the 50% as a landmark. Again, it depends upon how much is the joint destruction. If it's severe osteoarthritis, you can go up to the Fujisawa's point. Again, if you can appreciate, once we are done with the osteotomy, we use a high tibial osteotomy plate. Just to ensure that the posterior tibial slope does not increase, there is something called differential distraction. By differential distraction, we mean that anteriorly, the gap should be less as compared to the posteriorly. So if the gap is around 6 mm anteriorly, it should be around 10 or 12 mm, depending upon how much alignment correction is required. So differential distraction ensures that you do not increase the posterior tibial slope, or you can reverse the posterior tibial slope depending upon whether the patient is having ligament deficiency or not. Another thing is that, another trick is that if you put the hinge over the anterolateral cortex, just anterolateral cortex, that again ensures that you can reverse the posterior tibial slope. However, if the hinge is on the posterolateral cortex, you will end up increasing the posterior tibial slope. So 2 different techniques to ensure that the posterior tibial slope does not increase. First one is the differential distraction, and second one is the hinge placement. So that's how it looks like. Post-operatively, we ensure that the patient is having partial weight bearing from day 1 up to 6 weeks. From 6 weeks, patient move on to full weight bearing walking. Thank you.
Thank you, Dr. Ravi, sir. Thank you, Dr. Ravi, sir. I'd like to call the next speaker, Dr. Vivekanand, for his talk on from OT to running tracks.
Good morning. First of all, I'm extremely thankful to the organizers, especially Maurya sir, to have given me this opportunity. I am Colonel Vivekanand Upadhyay, and I'm a sports physician. My job, my contacts take me to many sportsmen across India, and I have been lucky to have worked with all levels of athletes, right from the baseline to the top performing athletes. For every athlete, the basic dream is getting to the Olympics. This picture, which I put right on the first slide, is from the Olympics, which represents a dream shattered. A South Sudanese Olympian during the 100-meter heats fell down on the track. She had to be carried out on stretcher. Incidentally, this also gave rise to some of the most beautiful moments that one can see in Olympic sports. That is something which embodies the Olympic spirit. But the talk is not about the Olympic spirit. The talk is about what happens once you fail and once you have to get back to the track. I remember a case, I think it was the year 2011, when a young girl came to me. And that was when I faced the dilemma about what is to be done. The CDC guidelines have been rather explicit, and they mention that you have to start coming back slowly to the regular activities, then you progress on to the light and to the moderate, thereafter to the heavy activities, and then you go on to the practice and non-contact sports, and then to the competition. But what it leaves unanswered, the question that it leaves unanswered is, what is the criteria from progression from one stage to the other? This is where I found that I need a slightly different parameter. This girl who had come to me, a young 14-year-old girl, she was the captain of her school basketball team and had very high ambitions. She wanted possibly to represent India. She could have, had it not been for the injury. That is what she told me. When she came to me, she had an MRI with her saying that there is an ACL rupture. My examination showed that she had a grade 2 ACL laxity, and we decided first to try the conservative approach. We went on for going for the basics, muscle balance, increasing the range of motion, pain control while avoiding as much as possible NSAIDs. There was a very good recovery. She recovered, went on to get normal activities of daily living, became very happy, went on to play a match, ruptured it completely. The second time when she came to me, she already had completed her arthroscopic ACL repair. And she came to me literally in crutches. The range of motion was to around 45 or 50 degrees, as if I am able to recall correctly. And that is when I was faced with the problem about how to get this young lady back to the playing field. There is a criteria which has been described recently, which basically breaks it up into 3 different and distinct stages. The first stage, of course, is the stage where most of us try to focus. That is the clinical stage. That is the time when we try to take a decision about whether surgery is to be done or not. But that is not the end of it. The next stage goes when you try to prepare the patient and turn the patient into an athlete. This is the phase where, under supervision, under a proper team approach, this is where the coach, the parents, the society, and everybody comes in. However, the patient is not to go back to the track at this phase. The third phase is when actually the patient goes out and, well, smells the grass. This is where you actually get the feel of the game and you decide whether you are fit enough to come back to the play or not. Let me talk about these phases in a slightly greater detail. The phase 1 begins with an accurate and early diagnosis. This is the most important beginning point. Without an accurate diagnosis and without an early diagnosis, you have lost the athlete. You might not lose the patient, but the athlete and the patient will be dead forever. Once you reach the diagnosis, you have to make a plan and, most importantly, communicate the plan. The plan has to be communicated not just to the patient but to all the stakeholders. The parents who keep saying, "Bete padhai kar lo, kya kar rahi ho?" The teachers, the coach, "Bete jaldi se aa jao, bas ek match hai, school ki baat hai." The principal, "Yaar, school tumhare upar depend kar raha hai. You are the captain, how can you not play?" Everybody has to be in line. And the team approach is the most important one. Then you have to go for the acute management. A very important decision is whether a surgery is to be done or not. There are lots of criteria, but I'll not be talking about those criteria. And at this stage, you have to assess the contralateral limb and you have to assess the complete kinetic chain. Very frequently, I have seen a patient coming with a shoulder injury and progresses on to a contralateral knee injury because the load shifts, the biomechanics shifts, the weight pattern shifts. Thereafter comes the gym phase, which can be the gym stage, which can be divided into 4 distinct phases. Initially, after the surgery or without the surgery, you have to start loading the contralateral limb. This is to ensure that the other limb does not become functionless, and the most important thing involved here is ensuring that the muscle balance is maintained. So for instance, the quadriceps and hamstring balance, it has to be maintained at the adequate ratio. In most cases it is 60 to 40, but it's going to vary. Thereafter, you have to come for the early loading and a normal movement. The next stage is going to be a rehab progression pathways. This is where you come to build up the capacity. You go on to different stages, which ensures that you are able to reach almost normal movement and you are ready for a movement outside. Then you take a lot of tests and you decide about what is to be done in the next stage. The next stage is going to be on the track or on the field. This is where you move out of the clinic, out of the rehab gymnasium, and go back to the field. A controlled rehabilitation where you introduce different aspects of the sports in a controlled manner, and slowly you get back to the basic level where you can start playing initially friendly games, thereafter competitive sports, and then going for the final competition. To summarize it, it's going to be, the first stage is going to be about decision regarding surgery and acute management. Then you go for contralateral loading, where you basically have to focus on maximizing the ROM, the range of motion, while ensuring that the contralateral limb is perfectly available. The muscle balance is more important than the muscle strength at this stage, both for the ipsilateral and the contralateral limb. Then you go for the early weight bearing till you go for the complete range of motion and the normal movements. Then comes the stage of strength and introduction of the plyometrics and the jump and the counter jump, initially with both legs and then after the one leg. Thereafter comes the stage for the functional integrity and the anatomical integrity, and this is where you actually go for a complete readiness profiling, including psychological tests as well. Once you're back to the grass, the initial stage is going to be a higher intensity, lower volume. Intensity means how fast you can go, volume means how many repetitions you are doing. Initially, we can go up to 65% of the intensity and 1/3 of the maximum volume allowed, which increases up to around 80-85% of intensity and 60% of the volume, then almost match play. This is where you can actually, at this stage, you can come to the level of friendly matches, and thereafter you realign with the coaching team and get back the person back to the normal periodization cycle. Important aspect before you return to the sports is the biopsychosocial model of the return to play, where the injury characteristics, the psychological factors, the physical factors, and the social factors, each is going to be, has to be taken into account. The results can be really great. This was the great Djokovic. This was Kane Williamson. Majority of these players will get back to sports in a due time. My player, well, in a matter of around 1 year, she went on to play basketball for her school, and thereafter she went on to represent her university. Today, she is a sports physiologist. These are the slides that I want to boast about. These are the people that I've worked with. These are the people that I pride in. Thank you, sir.
Thank you, Dr. Vivekanand, sir. For the next talk, I'd like to call Dr. Piyush Mishra, sir, for his talk on management of comminuted fracture of lower end of radius.
Good morning, everyone. Thank you, organizing team, for giving the opportunity. After such an illustrative talk, now I'm a little bit boring talk. The management of comminuted fracture distal radius. The theme of the this conference and lesson, learn from mistake. So what I have learned from this mistake, I'm just sharing with you. A 40-year-old a car mechanic with the history of fall of 2 days before came to me with pain, swelling wrist, no numbness, tingling, no compartment syndrome. And he brought this X-ray. Now, I want to ask you how to proceed further. The patient is with this fracture. Dr. Yadav, sir?
I want to operate, I will refer to my colleague.
Oh, this is the problem with joint surgeons. Dr. Kapoor, sir, the patient has come with this X-ray. How to proceed? Further investigation or direct intervention. Okay. Okay. Okay.
So this fraction, whenever you put on the traction table
Okay.
and anesthesia, and you could put a traction, the whole morphology changes.
Yeah,
Then
definitely,
you are
sir.
able to find out where you have to focus on that.
Okay. This is the CT and different view of CT scan. You can see the grossly comminuted fracture of the radius with fracture of the ulnar styloid tube. And this is the 3D reconstruction. One more, what are the indications for CT in comminuted fracture? Is every comminuted fracture requires CT scan? Dr. John?
Talking about distal radius?
Yeah, comminuted fracture.
Any intra-articular fracture, I would get a CT scan.
Okay. That's one indication. And another indication, sometimes the patient doesn't want surgery. This will help. The 3D reconstruction will help you for convincing the patient that you require surgery because so many disturbances are there in the 3D reconstruction. Okay, sir. Now, how to proceed? What should be the planning in this patient? Volar approach or dorsal approach? Dr. Amul, sir? Yes, sir. Should we go for volar or dorsal approach? How we plan? Fixator?
Can you go back?
Yeah.
So when you go through this, first approach from my side will be always a volar approach.
Yeah, definitely.
Try to reduce it, whatever fragment we can reduce it, go on rotating the C-arm, see for it, and maybe another time I will have to think for the lateral fixation of the styloid also. Buttress, something from the buttress.
Yeah, that's good, sir. And what about bone grafting, sir?
Here I will not go for. If I have reconstructed it well, I will not go for the bone graft.
Since metaphyseal combination is there, Dr. Yadav कह देंगे sir कि मैं तो very very for the patient. Dr. Amit, आगे Dr. Amit आगे. हाँ, how plan? This is the 3D reconstruction. Plain exam showing you plain X-ray. Bone grafting is required or not? Metaphyseal combination is there when you elevate the. And age is 40 years.
No, I will not do bone grafting.
Okay. So, any other option apart from the volar plate, fixator or bridge plating?
Show me the axial cut at the wrist. Axial cut. You have the 2D. Okay. Volar plating though is a must, but then dorsally also that capsular component is
there.
Yeah, you have to take a capsular stitch there.
Okay.
Yeah. It will do well. You have any traction views?
Pardon, sir? Yeah. Yeah, definitely, sir.
Even after that, if you have problem, you can have for 3 to 4 weeks X fix. You can put
X fix is an option.
there is even another option of putting it that for 3 to 4 weeks if needed. Otherwise, I think it can be fixed through the volar approach.
I have done this. Any comment on this thing? Dr. Amit Rastogi, sir? Dr. Amit, sir?
I think it's a fair job. Nicely done. You got good articular reduction. The only thing is that you've got a overhang of the dorsal cortex.
Yeah.
And the articular surface has not been lifted up dorsally as much as I would have liked it to have.
Yeah, yeah, that's the one mistake I have done.
Yeah.
And another is this. Yeah, sir.
Yeah.
During, after surgery on the table examination, it appears stable. So I skipped fixing this ulnar styloid. This was the movement after 15 days. Restricted. It may be due to this is after 15 days.
15 days. It will improve
Yeah.
definitely.
And after 2 months, this was the X-ray. And I removed wire on 7th March, and then after 7th March, this was the movement. There was restriction. This is a prominent of this ulnar styloid. And patient has difficulty in pronation supination. So what I learned from my mistake is always fix ulnar styloid, even if you find that it is comfortably stable on the table. That's all.
But it was not reduced, na? That ulnar styloid जरा एक बार देखा ना last X-ray.
Actually, during surgery, it was appears to be stable, but after 2 months, it's displaced. You know, ulnar styloid is displaced.
In this type of case where the ulnar styloid is very small, what should be the ideal mode of fixation? Simple K-wire or just some suture? K-wire.
But do you think it is because of the ulnar styloid that that deformity is there? I don't think so. Look at your lateral X-ray in this.
Yeah, lateral is subluxated. It's posteriorly.
It is subluxated. So that is the reason. Ulnar styloid will not give such a big deformity.
For few weeks, you can put no.
The distal, sir, distal radial ulnar joint is in place. That is not the cause of deformity.
But it has moved.
There is some subluxation there in the wrist.
Yeah.
Initially, during surgery, the patient wrist was stable. So I skipped fixing the ulnar or something like this. I think what is maybe the reason of this subluxation, Dr. Amit?
The lateral cortex, if you see, it's widened in the lateral view. The cortex, the distal end of the radius is widened.
Okay.
So there is a lot of gap in the fracture site, and I'm not happy with the dorsal fixation.
Sir, have you done the piano test after fixation?
Yeah, I have done.
Was it okay or not?
It was okay.
It was okay
during surgery.
Okay.
That's why I skipped this ulnar styloid fixation.
Okay.
John sir, initially it was okay. Later on, there is a problem then.
Yeah, so this is if you look at this lateral, the radioulnar joint is subluxated in this view itself. So either the piano sign was not adequately
it may be
assessed,
possibility.
because it won't dislocate after that if the piano sign is negative. Very unlikely. If there is, then in this case, I would fix the ulnar styloid, but I would also maybe fix the distal radioulnar joint temporarily with a wire.
Now, what can be done?
Now it depends on his problem. If he doesn't have a problem, I would leave it alone. If he has a problem,
Pronation, supination is a little bit restricted.
Then something like a suave kapanji would be the answer.
It is only 3 months old, sir.
Doesn't matter. I mean, if it is not, so physio exercises, and then, because if you just fix the ulnar styloid now, it's not going to get rid of the pronation supination problem.
Thank you.
Any more questions to the three speakers?
Yeah, any questions from the floor for HTO? Dr. Ravi, do you do uni as well? No? Just HTO? So when you would do uni, prefer uni over the STO, indications are almost same. Mike?
Biplanar osteotomy is, as compared to uniplanar, has a better biology, better healing because of the large surface area. Even though there is always a risk of reversing the, increasing the posterior tibial
Posterior slope, yeah.
But
yeah.
by differential distraction, you can ensure that it doesn't happen.
But healing take place in any osteotomy.
Yes.
So is it not safe to do conventional osteotomy, open ways?
So I have no experience of uniplanar.
Yeah. Okay, Ravi.
So
Thank
just
you.
one question. Do you routinely do an arthroscopy? Because that's what you suggested.
I do that.
Okay, so we tend to rely on the MRI. So the ones where we think needs an arthroscopy or might need an arthroscopy, we'll do an MRI and decide on that whether we need to do the arthroscopy or not. Because there's some evidence to show that if you do an arthroscopy, you're actually increasing the risk of infection. Okay, so that's, I mean, it's very minimal, but yes, there is. So even if you look at the Lobenhofer group and etc., they don't routinely do an arthroscopy unless it's indicated.
So, usually what happens is that if the patient is having middle compartment osteoarthritis.
I think your mic is not working.
Sir,
Yeah.
usually what happens if patient is having middle compartment osteoarthritis, they will have a degenerative tear of the root. Or
But you're not doing anything for that anyway.
No.
So there's no evidence to. So yes, so you get an MRI.
Yes.
And if you think it needs an arthroscopy, you do it. Okay. But you don't have to do it in every case that you're doing an osteotomy.
Thank you, Dr. Piyush.
That's the way we
very
look at it.
very lesson making and thought provoking case. I don't do, but I learned a lot, honestly speaking. Yeah. Thank you. Yeah, we close the session. Thank you. Thank you.
Can I have all the speakers for a group photograph? So we conclude the fifth session. I'll like Dr. Anshu Anand on the stage. Dr. Anshu.
Dr. Anshu Anand is a very famous orthopedic surgeon here, doing lots of arthroplasty work and very popular in Patna, not only Patna, in the neighboring districts also. Over to Dr. Anshu Anand.
Good morning, respected seniors, colleagues. Thank you, Amulya sir, for kind words. I would like to begin the session 6 with a variety of talks from eminent speakers. I would like to invite the chairpersons for the session, Dr. D.P. Bhushan, Dr. Amit Ajgaonkar, Dr. K.K. Mukhopadhyay, and Dr. Mithilesh Kumar on stage, and Dr. Dinesh Kumar sir. Thank you, chairpersons. We will have the discussion at the end of the session. And now I will like to call upon Dr. Aarti Devan, ma'am, for her talk.
Good morning, everyone, and thank you, organizing committee, Dr. Maurya, for inviting me. Today I'm going to talk about dismantling the hidden curriculum and the stereotypes. Of course, talented individuals, they always thrive for building an inclusive and equitable culture. That is what is required. But education shaped not only by the training and by the talent. So there are unspoken lessons, assumptions, and images that surround it. Increasing focus, we always focus on diversity, equity, and inclusion. Do we have it? So there are hidden barriers still persist despite the formal progress. So this is beyond the topics. We just only talk about formal curriculum, the informal curriculum. They only taught us about the surgical skills, written textbooks, scheduled lectures, and the clinical protocol. What to do is the formal, but hidden is how to belong it. It is beneath the official surface, quieting the teaching lessons about who is expected to lead and which traits they are to evaluate. So socialization through customs, rituals, and taken for granted behaviors, this comes in the hidden curriculum, transmission of implicit values, and this is learned via role models, jokes, and even the silence. Only this depicts the behavior quietly but powerfully, often without being questioned. How it operates and what are the invisible architecture that is involved in hidden curriculum, the cultural values, the circular choices, the institutional roles, and the everyday language that depicts the casual phrases that reinforce the gender and the social stereotypes. What is the language of exclusion? Everyday language, the cultural values, and the invisible architecture of the department. Is our language inclusive, or we are just using the casual stereotypes that reward conformity over the individuality? These small and daily choices, they determine the clinical atmosphere. A pervasive influence is always there in stereotype. So the hidden curriculum, it reinforces patriarchal systems. There is hyper athlete male surgeon, we use the word, there's perception, bone focused technicians, but we are all familiar with these terms. But what is important is that students and patients perceive us. So these are the stereotypes. So they discourage the talented, diverse people from applying before they give us a chance. Whose future is being built? A contrast matters. When the students repeatedly see certain identities like leadership, expertise, or success, they begin to internalize these patterns. But representation is not always the decoration. It's a signal about the possibility. When a classroom image repeats the same story, the hidden curriculum writes the rendering before the student begins. Beyond gender, other hidden biases are socioeconomic status, the cultural capital, and the physical environment. What is the data? So data shows there is a leaky pipeline that women, they should or should not. This gap is inevitable. It reflects behavior, barriers that begin early and build up over the time. Another myth is the physicality, the muscularity, the endurance culture. Hidden curriculum reinforces the idea that need brute strength to be orthopod. This assumption suggests that women's or other kind, they are less suited for the culture regardless of their actual surgical incompetence. So what is the invisible bias, the unconscious preferences, or the selection bias? So all these are blind spots. Implicit bias isn't always loud. It shows up in who we choose to mentor and who we overlook for the opportunities, creating a barrier that is often invisible to those who are in majority. The cost of being othered, the microaggressions that we see, the lowered expectations we see, and the cost of these stereotypes is real. It leads to diversity deficit where qualified peoples self-select out because the culture feels closed or hostile. What is the impact? That is very important on the patient. The less diverse teams are there, that reduce our innovations, cultural gaps in patient care. So bias can affect the decision making, the communication, and the outcomes. So to redefine the culture, what we do from fit to belonging, in our old mindset, does the person fit into our existing social and cultural norms? So now the new mindset. So we have to make a people to belong and thrive it. We need to move away from hiring from the cultural fit, which often just means people like us. True belonging means we change the environment to support the different styles and the backgrounds, not the other way around. Redefining a good surgeon, a technical excellence, precision, and a teamwork always is required to emphasize only on the skills. Communication, that is very important, that values the clinical judgment and the patient outcomes. So let's redefine what a good surgeon is. So it's only the precision, the skill work is required, or excellence comes in many forms. When we value precision and communication, we value endurance, and the doors are open for a wide range of talent. So mentorship, that is very required, and sponsorship. Mentorship is just providing a guidance, but sponsorship is that it changes the career, because it opens the doors and challenge all the people to make a room for others. So how to reinforce and how to reevaluate? Objective criteria should be there, standardization should be there. It should not be a gut feeling, bias feeling should not be there that it's a personality fit or not. What are the strategies, other strategies for equitable learning? The conscious language, the inclusive resources. Equity becomes real through our daily course, whether it is an example we choose in lecture or we distribute cases in operating room. We must be intentional about including everyone. What is the path forward we take? Making invisible visible, awareness among the communication, the open dialogue, that is very important. We can no longer treat the hidden curriculum as a neutral. In a school, if we see a ringing a bell, all the children, they raise their hands. So it is a hidden curriculum. It's not a formal thing. So it is through our bias. Then what is the leadership? Accountability. Leaders must model inclusive behavior and tie diversity to the institutional goals. So safe reporting should be done, and cultural change stops at the top. When leadership makes inclusive a priority and tracks data on recruitment and retention, it signals that department is serious about the progress. Early exposure and outreach should be done. Debunking myths should be avoided, and broadening of the pipeline. What is the future? Innovation is always there so that it improves the patient outcome, the patient care is improved, diverse teams improve communication and clinical outcomes. This isn't just about the fairness, it's being about a good doctor or a better doctor, and a representative specialty is more accurate and technical, excellent specialty. Be the change, commitment, small actions, and the cultural change. Future directions are policy changes are required, continuous feedback system, and global push for the inclusive surgery. So takeaway messages that it shapes the career silently, stereotypes limit the talent and equity, and change requires awareness, action, and accountability. Thank you so much.
Thank you, ma'am. And now I would like to call upon Dr. Arun Kapoor, sir, for his talk on tibia condyle fractures.
A very good morning for the early risers. Well, over the last many years, what we have noticed is that the tibia condyles are breaking in their own different fashions. Like the ankle, you have so many different systems that the different fragments that they're coming off. Similarly, it has been seen in the tibia. Or maybe it is just a fact that the mind sees only what the eye see, only what the mind knows. So maybe we are getting a little more knowledgeable and seeing too many condyles in the medial and the posterior medial, the lateral, the posterior lateral. There have been different classifications from the proximal tibia. The Schatzker and AO and OTA classifications have been on the X-ray radiological features that we have seen on the plain images. And now, recently, Feng Lu has come along with a 3-column fixation for a complex. A 3-column fixation is more based on a 3D CT image, like what you have on the posterior column also. So what is important now is a medial, a lateral, and a posterior column in itself, which again is divided into posterior medial, posterior lateral. And this in itself happens to be a lot more helpful for the approach you take, for the condyles you see, for the style of fixation that you move into your surgery. A case, this was 2017, maybe the good old times, as I said, when we see two condyles and we go in with a lateral plate, and that is how it was. And 4 months down the line, see nice little curves coming in. Generally, orthopedic surgeons do like curves, but not when it is going into a varus. So after 4 months, I slipped in a plate on the medial side. Maybe it had not been taught that the medial condyle was in the varus common is going to be too bad at that time, and we were not like कि घबरा गए वायरस देख करके. आजकल के you see varus in the orthopedics, दिमाग पूरे खुल जाते हैं और बत्ती खुल जाती है, लाल बत्ती जल जाती है, and the ears go up. So took care of the varus part, put in a medial plate, and well, that was later, 4 years down the line. And even on the other side, I think Dr. CS will say कि दूसरी side का तो पहले कर दो, इस वाले को करने की ज़रूरत नहीं है. He was looking a little more varus on the other side. This is looking a lot better. He lived happily ever after. Then there was this one, a very standard medial and lateral condyle. Again, now of course we start looking at the medial condyle first. Fixed in the medial condyle, went into the lateral condyle. What I meant to emphasize was again another case, a standard medial and lateral condyle, a little longer. Fix the medial condyle, fix the lateral condyle. The earlier the approach had been fix your posterior medial condyle to the medial condyle, get the medial complex okay, and then get the lateral condyle back into place in that place. What the myth, in fact it is not a myth, the understanding that we had earlier, but now what we want to see is the different fracture and the geometry of the condyles now should dictate what you approach first and what you fix first. It has to be very open. It's an open job now. So this was a different guy, totally shattered. There was a lateral condyle that was depressed. It was separated to an anterior lateral and the posterior lateral fragment, and the medial condyle was tilted posterior. This is the one job over here, and this was the other one. The medial condyle tilted, depressed, anterior and posterior. The medial condyle tilted back. So now what do you do? What do you do first? Go into the lateral side first, elevate, expose, fix it temporary, come back to the medial side. Now there was a last posterior lateral fragment, if you had noticed. It was a pretty large one, as I said. And I had gone from the medial side, opened it nicely and placed two plates over there. One I slid in, this was the one, and this has been placed over the posterior lateral condyle, an overbent plate. Biomechanically I did that overbent plate, fixed it over here, no screws here, obviously you can't put in screws over there on the medial aspect, and then fix the medial. And this is that the plate that I was referring to. It is nicely buttressing that posterior condyle up, and this is the posterior medial condyle that has been fixed. The clinical picture, there is enough space over here. If you do go in over here, there is enough space for two plates that have generally been, if you are able to dissect out pretty well. Now this was it, came back onto the lateral side and then fit a lateral raft plate. Another guy, not looking too bad, but there was a depressed lateral condyle with a split, and there was a large posterior fragment. Again you see a posterior fragment over here, which you just can't bypass. There is a depression here. There is a big nice depression over here. Elevated on the lateral aspect first. Put in two anterior posterior screws, one at the apex and one a little up over here so that doesn't rotate. I didn't go to the posterior side, let me tell you, and I put in a raft plate on the lateral. The medial plate, the medial condyle was also fractured, so just to be on the safe side, I put in a percutaneous screw over here. Now it looks a little pretty apparent. I am not very happy approaching the Frosch and the lateral epicondyle flip approach on the lateral aspect. I found it a little too morbid. So I have been going in from the medial side, approaching the lateral condyle, coming in from the anterior to the posterior, and finding it not too bad. Of course, it is a controversial statement. People do want to go in for the lateral, posterior lateral, but generally I have been able to do this on this one. So this speaks for the posterior lateral aspect. Now there was a big push from the lateral femoral condyle, which threw the medial condyle off. The lateral condyle is depressed, and the anterior combination, if you see, is pretty apparent. You have the depressed lateral and the anterior combination, which you need to look up at, and there is a widely separated spiral fracture over here. When on the lateral side first, the anterior lateral aspect, you need to push up your lateral support, put in a little bit of bone graft, then come back to the medial side, get your reduction right, put in a long plate because it was pretty well separated, put in that long T plate over there, and then get back to the anterior lateral aspect and put that small plate over there for that anterior combination. So sets in for the pretty good reduction and fixation. Reverse condyle slopes over here. Medial condyle is tilted back and shifted back. The tibial tuberosity is attached with the lateral condyle. Generally these are a little troublesome because the tibial tuberosity is pulled up. This is how it is. The tibial tuberosity attached with the lateral condyle. The whole thing shift. This is the lateral one. The medial shift, as you see, you have a posterior medial beak. You need to understand the beak and then fix it. So now what do you do over here? Not too comminuted on the top. There is no depression. It's just a matter of separate like two states. So it is a matter of two condyles. They are moving in two different directions, and you need to approach and fix in that particular fashion, like, see, no depressions there. What I would have wanted was get, of course, the medial condyle doesn't need much talk about it. You just need to get it back. But the lateral condyle, that has been pushed up. I want something over here which catches here, pushes it down. An anterior posterior screw, of course, does a good job, but then that needs to be reinforced another plate. It was nicely compacted over here, so that getting that lateral condyle back into place with two K wires over here and jostled down was a little job. After the medial plate head was put bang posterior, I got things back into place, fixed it temporary. Well, the medial condyle was exposed first, reduced, the lateral exposure reduced the lateral condyle, the medial condyle fixed first, AP screws in the lateral condyle, AP to backwards, and then the lateral condyle fixed with a distal tibial anterior lateral plate. Now, does that trouble you? This plate over here is a hockey type of plate. All the screws are going in different directions. You have the top screws going backwards, like I put in that diagram, in the early diagram. All the screws are going backwards into the posterior aspect, and these screws are anchoring in a different tangential manner. So there is no way that that can come off. That makes about a very stable fixation. So that is how it was. Again, another essentially a metaphyseal with articular extension. There's a large posterior medial and a medial combination, as I will, and the lateral condyle is attached with the tibial tuberosity, needs to be pressed down, as I said again. Just another example of the same type of plate I had done. There was a fibular tib avulsion. This I wanted you to appreciate is the amount of the large posterior fragment that you need to look up at, and the medial combination is something that you cannot forego. You also do need to look at that. So now how do you approach?
Can you quicken up, please? Time is over.
Okay. This is how it was done. The posterior medial plate and the medial plate obviously they look after, and the long posterior medial plate, because that requires, that is the compressive side. You need to push it back, push it up. And the lateral condyle fixed with the distal tibial, anterior lateral plate again in two different directions. Well, this guy combinated, I can go ahead on that. Depress different planes, anterior combination, just another routine work. Different planes, time is up. And the posterior medial and the medial plate and the lateral plate put in over there. Done up pretty well. Now this was another one, just want to focus on this. Now there's nothing to do on the lateral condyle, but the medial condyle is fractured into two, the posterior medial and a large medial fragment. Now what do you fix first? You can't put in the posterior medial fragment back first, because there is nothing over there. First
nice
you fix the medial condyle.
Yes.
Okay. First you fix the medial condyle, you get your posterior medial condyle back onto it, and there's a large plate over there. I don't want to show the video, I think it will take time. A periarticular, single plate, double plate, and thank you. That's what you want to show. Different approaches, different condyles, different geometry, and different fixations. Thank you.
Thank you, sir. Would like to call upon our next speaker, Dr. John Mukhopadhyay, sir, for the management of Pipkin type fractures.
So I'll call them femoral head fractures. Okay, so we're going to talk about femoral head fractures, and these are uncommon injuries, usually involve significant trauma and associated with hip dislocations, and they can be difficult to treat. Okay, and we all are aware that the medial circumflex femoral artery supplies the major part of the head. There's some supply from the central artery in the ligamentous teres. Now, the classification by Pipkins was way back in, I think, 1957. He divided it into 4 parts. The one, type 1 was inferior to the fovea, type 2 was superior to the fovea, 3 had an associated femoral neck fracture, and 4 had an associated acetabular fracture. Now, the associated acetabular wall fractures is not uncommon. If you look at them really closely, there's often labral injuries, but sometimes you can get a fairly clear acetabular posterior wall fracture. And most of these dislocations are posterior, although some of them can be central or anterior. So your decisions that you have to make are whether you're going to treat this conservatively or surgically, whether you're going to fix them or excise the fragment, what approach are you going to use, and the methods of fixation. So here's a young patient with a dislocation. So what we do is do a closed reduction and then assess. And you can see that this is an infrafoveal fracture right at the bottom, and it's not causing any problem. So we actually treated this conservatively, and this went on to heal well with no problems at all. So the early management is a gentle closed reduction. Okay, so be careful that you don't use force for your reduction. Okay, if you have any difficulty in the reduction, don't hesitate to go on to an open reduction. And obviously Pipkin 3s, you don't try a closed reduction at all. So this is a patient who was treated elsewhere. This was a young patient, and I think he was 27. This was the original X-ray, and they tried a closed reduction, and that's what they ended up with. So they converted a Pipkin 2 to a Pipkin 3, and this was the disaster. If that was not bad enough, they decided to do a hemiarthroplasty in a 27-year-old. And if that was not bad enough, it went on to get infected before he came to us. So this was a disaster, starting from the initial management to what happened later. And so when problems happen, they don't seem to happen once or twice, they seem to happen in a number of situations. So I think your indications for surgical management would depend on the type and size of the fragment, the displacement and how you reduce it. They can be irreducible dislocations, so don't try to use force. If you get a non-concentric reduction, you need to operate. And if you have an unstable reduction, you need to operate. And the approaches that we have, if you look back in the literature, initially it was the posterior, then it came to the anterior, and now you have the trochanteric flip, which is the Gans approach. So 70s, it was the posterior approach. You come to the 90s, you had the anterior approach, and now the Gans approach has become increasingly popular, especially if there's an associated acetabular fracture. So you go to the back, then you do an osteotomy and go to the front. So interestingly, so when we go back, we did the posterior approach for some of our cases. But the problem is that you often have to dislocate the hip to be able to visualize the fracture properly, because the fracture is usually anterior. Okay, so this particular patient did well. This is him 5 months post-op, and this is him 30 months post-op. He went on to do well, but this is not uniform, and you can risk AVN if you dislocate the head again. And the other reason is that this fracture is usually anterior. So if you do a CT scan, you'll find that the fracture is more on the anterior part, and trying to fix this posteriorly without dislocating the head becomes very difficult. So here's the anterior approach. This is courtesy Karl Stoffel. This is, you do the vertical limb of the anterior approach, what's known as the Hutter approach. That's how you go between the tensor fascia lata and the sartorius. You get down to the capsule, and then you do a T-shaped capsulotomy. That will give you access to the fracture, which you can then fix with screws. We tend to use locking head screws, 3.5, but you can use headless screws or whatever you like. That's your choice. But you need to countersink the screws so that you don't have anything sticking out. So this is an elderly lady, in her 50s, who came to us. Shouldn't call her elderly at this stage, but that was the fracture in the femoral head. That was, again, you see, it's more anterior than posterior. So a closed reduction was successful. We went in, and then we went anterior. You can see how we've done the anterior approach. Gone on to put screws after you reduce the fragment, get back a good reduction, and then you put in screws from front to back, countersink the screws, and they go on to heal well. The Gans approach is something which involves sort of safe surgical dislocation of the hip, and this has been described, where you actually divide the capsule, dislocate the hip, and then do your fracture. So if you have a type 4 fracture like this, this is an interesting case because it actually had the head fragment lying outside the joint, which is unusual, part of the head fragment lying outside the joint. The head had come back and then actually gone on to the anterior side. So that was the CT scans. You can see the acetabular fracture there. The posterior wall is gone, but you can see that there's a fragment lying outside the joint. Okay, so these are the 3D CT scans. So here what we did was we went posteriorly, we sort of fixed the acetabulum. Then we did a safe surgical dislocation. This is the trochanteric flip osteotomy. We got this head out from the posterior side, and then we had to put it back onto the anterior part after the dislocation of the hip. And this, we put these screws in, and this was the post-op image and post-op X-ray. As you can see that. Went on to do well. This is him at about 6 months post-op. This is him at 2 years post-op. And the most recent follow-up, we have 7 years follow-up. He's still maintaining his hip, although he's got some early osteoarthritic changes. But if it lasts him another 5 years or 6 years, then we can safely do a total hip at that stage. So your treatment basically depends on, would be either fragment excision, if it is a small infrafoveal fracture. Most of them would need open reduction and internal fixation. And arthroplasty is in the elderly, comminuted, and associated neck fracture. Occasionally you get surprises. This patient came to us 3 days after the injury, with 4 days after his injury, with his limb stuck like that. And this was a patient we decided to take into the OT without bothering with a CT scan. We went the posterior approach because of a posterior dislocation and an acetabular fracture. And we actually fixed the fragment from the back and then went on to deal with him, and he did well. So your complications could include heterotopic ossification, AVN, or degenerative arthritis. So in the take home would be that these are challenging injuries. Look for associated injuries. You need to reduce them early so that you don't get AVN. The small peripheral acetabular fractures are very common. An anterior or Gantz approach is today preferred. If you get it relocated, go for the anterior approach. If it's still dislocated, go for the Gantz approach. Thank you very much for your patient hearing.
Thank you, sir, for your descriptive talk. I'd like to call Dr. Shekhar Srivastav for his talk on joint preservation surgeries in knee arthritis.
Good morning, everyone. And first of all, I thank the organizers of Gofcon, Dr. Amulya Mishra, the Bihar Orthopaedic Association, for inviting me to this very efficiently and very meticulously arranged meeting. So the topic given to me is the non-arthroplasty option for osteoarthritis knee, and especially in young patients. So now, as we see, 60s are the new 50 and 80s are the new 60, because overall the activity level of the general population is improving. People are getting more and more active, and now we see even younger patients with arthritis coming to us for management. Now in a patient of say around 75-80 with this kind of problem, there is no doubt that a treatment like this will give good result. But what about these patients who are say around 40s, in 50s, and coming with this problem? And all of us see this kind of problem very commonly. So what are the various options available to us? Treatment of arthritis in young individual is always a dilemma, because they are more demanding, they want more activity from their joints, then the treatment has to last long, and you also have to consider that they will be needing a revision, so you have to plan accordingly. Now the various causes of early arthritis can be traumatic, or it can be generalized also, metabolic also, but mostly it is because of trivial trauma, which if it not addressed properly leads to early arthritis. So intra-articular fractures, ligament injuries, meniscal injuries, these leads to subtle instability in the joint, and the joint usually doesn't tolerate instability very well, and then it gradually progresses to osteoarthritis. Similarly, in athletes where there is excessive demand on the knee, which exceeds the capacity of the knee to repair itself, that also leads to OA changes. Now, we all know the objective of the management: to relieve the pain, to allow the patient to do their functional activity normally, and to prevent the deformity. Now, if the conservative management has failed, then in that case one has to consider the surgical options. And in these patients, if we consider the non-arthroplasty options, then I would think of these few options: the arthroscopic procedures and osteotomy. Of course, partial knee replacement and total knee replacement are the arthroplasty solution in advanced arthritis. Now, arthroscopic procedure are totally out if there is any malalignment. If there is any mechanical malalignment, then the arthroscopic procedure should not be done. It doesn't work. It can be done in conjunction with osteotomy, but standalone arthroscopy doesn't work. So arthroscopy for osteoarthritis knee came in a big way in 70s and 80s, and where the arthroscopic lavage with debridement was very common. But then this study came from New England Journal, which basically suggested that the results are similar whether you do arthroscopy or not. So that put a question mark over the role of arthroscopy in osteoarthritis. But is it such? Is it that the arthroscopy doesn't have any role? No, it's not like that. If in early osteoarthritis, if the mechanical alignment is okay, and the patient is having mechanical symptoms in terms of locking, which can be either because of loose condyle fragment or because of any meniscal flap. So those are the few subset of patients where perhaps arthroscopy has got a role. So arthroscopic strategy in osteoarthritis knee will be arthroscopic debridement, which will include meniscus removal, loose body removal, and especially nowadays we see lot of patients with medial compartment OA with root tear of the medial meniscus. So in these cases, if the root repair is done arthroscopically along with osteotomy, then the patient gets good relief, and the life of that knee can also be extended by few years. So these are the few extended indication of arthroscopy in osteoarthritis. Microfracture is basically for focal defect. Similarly, similar is the role of osteochondral autograft and autologous chondrocyte. So in meniscus tear, degenerative meniscus tear, the results of repair are not very good. So basically, if the patient is having mechanical symptoms because of loose meniscal flap, it has to be excised. If there is a root tear, then it can be repaired back along with the osteotomy if there is mechanical malalignment. So this is a patient. You can see that the patient has started developing condyle changes with meniscal tear, degenerative meniscal tear, and these tears you cannot basically repair them, and even if you repair them, they are not going to heal. So these cases have to be excised. So you don't want anything loose inside the joint. That is not good for the joint. So similarly for loose body, only if it is causing, if it's a sometimes you can see that there is a loose body, but it's actually not loose. Sometimes they are so big that they don't come into the joint, so you don't need to address them. But if it is coming into the joint and causing mechanical symptoms, then it has to be removed. Now during this procedure, during meniscus procedure or root repair, if you see that there is condyle damage, say around 2 square centimeter, in those cases one can also do microfracture or subcondylar drilling. It can lead to generation of fibrocartilage, and this cartilage is not as good as the hyaline cartilage, but still it gives some relief for for at least 2 to 3 years, and then slowly the result starts deteriorating. So these are the few situations where you can go for microfracture. Osteochondral Oates procedure is basically for focal defect. So if there is a full thickness defect, in those cases one can take the osteochondral cylinder from the non-weight bearing part and can put it to the weight bearing part. But this is in very early stages and basically for focal cartilage defect and not for generalized osteoarthritis. Similarly, autologous chondrocyte implantation is also for focal defect, and it doesn't really work in osteoarthritic patients, because you see what happens in these patients, it's not just the cartilage which is gone, it is the base, the subchondral bone, which has also become sclerotic, and so over that, even if you put a cartilage, it usually doesn't work very well. Then the other option in early arthritic knee is osteotomy. Osteotomy is a wonderful procedure, especially in patients who have got metaphyseal varus. So if the varus is not in the joint but is in the bone, in the metaphysis, in those cases osteotomy works well, and we all know, all of us do our osteotomy, and we know that it gives benefit because of both biological as well as mechanical thing. So basically it is done in patients who are less than 60 years of age with a BMI less than 30. Active patients, the knee should be stable with good range of motion. And nowadays most of the time osteotomy is also combined with arthroscopy, where you do where you remove the loose
we had discussion on
condyle
that previously, and your time is up also, sir.
Okay. So so these are the various options which are available in young arthritic patients, where one can try to manage without arthroplasty. Thank you.
Thank you, sir. And now I would like to call Dr. Abhijit Vahegaonkar for his talk on fragment-specific fixation.
Good morning, everyone, and respected chairperson, sirs, dear teachers, seniors, friends, and colleagues. My charge is to talk about a topic that's very close to my heart, and that's distal radius fractures, and I have no conflict of interest. We will try and understand this concept of fragment-specific fixation based on these outlines which are presented on this slide. I'm sure that a lot of us have grown up with this aphorism by Abraham Colles, who said that distal radius fractures, even if they malunite, will seldom cause much of a functional disability. But the question that we really need to ask, is it really valid today when we have so much of high velocity accidents and people who are involved in sports and recreational activities? And there are several treatment options that we all employ, right from casts to pins and plasters, fixators, volar locking plates, fragment-specific fixation, and even intramedullary nails. Whatever the treatment that we employ, the modality of treatment that we employ, I think the goals of treatment remain the same, which are to restore the anatomical relationships when and if possible, to maintain that reduction until such time that the fracture unites, and of course to optimize the outcomes while we minimize the complications. However, is there a guideline that helps us to determine which are those fractures which will require fixation? And yes, surely enough, we have the AAOS guideline, the white paper, but way before that, LaFontaine had published these criteria in 1989, which kind of form a really good fallback system to determine and to identify the unstable fractures that will require fixation. So with that behind us, let us now try and understand the classification systems, and there are several of them, right from eponymous classifications to the AO classification, but most of these, at least to me, are quite confounding, and we all know there's a huge amount of inter as well as intra-observer variability in these classification systems. So do we have a classification system that helps us consistently correlate the fragments and different views on the X-rays every time we look back at the X-rays, and also when we look at the CT scans? And surely enough, I think this is where the column concept comes into picture, which was described by Rickley and Regazzoni. Very simplistically, there is a radial, an intermediate, and an ulnar column which rest upon a pedestal. It is only the intermediate column that has a little bit of nuance to it, in the sense that it has a dorsal wall, a volar rim fragment, a dorsal and a volar ulnar corner fragment, and free intra-articular and metaphyseal defects. And we also need to recognize a new concept that was introduced by Greg Bain in identifying the very distal fractures as osteoligamentous injuries rather than just fracture fragments. And there are definite fault lines that are present between the ligamentous attachments of the radiocarpal ligaments, which give consistent fracture patterns. So coming back to this X-ray again, if we use the column concept, we are very, we find it very easy to correlate those fragments both on X-rays and CT scans quite consistently. So the concept is very simple. It is like building blocks. We try and achieve a stable fixation of all the columns and components thereof, starting with the simplest techniques and then advancing the techniques. So case in point here, this schematic diagram shows a volar ulnar fragment, which is also called as a tetrahedron fragment, which can be very well stabilized with a very simple fragment specific fixation limited to the volar ulnar corner. Whereas if there is a dorsal fragment, you can buttress it, and a radial component also could be stabilized. Case in point here, the PA view looks quite innocuous until we look at the lateral view, wherein there is a lot of combination on the dorsal side. CT scan shows there is an incarcerated intra-articular fragment. So we kind of disimpact that fragment, we fix the intermediate column, but this very clearly shows that this plate is inadequate to address the radial column component, and therefore we come in on the dorsal, on the radial side, put in a plate on that side, and buttress the dorsal ulnar corner fragment to achieve and restore the anatomy. Here is another case. Again, the X-rays look quite innocuous until you pay attention to that corner. And what you see here is a very small dorsal ulnar corner fragment. Now, the problem with fixing this fragment on the volar side is that you're risking your screw being intra-articular either in the radiocarpal joint or the radio-ulnar joint. Not only that, there'll be very inadequate purchase of that particular fragment. And therefore, we come in from the volar side, we fix the intermediate column and also the radial column, and then the dorsal approach is used to buttress that corner. Now look at this case. So what happens with that fragment is illustrated in this particular case. Some surgeon decided to treat this, very well done, I believe, but this patient came with severe ulnar-sided pain, and this is what he presented with. You can, I think, appreciate the significant DRUJ instability that is present, and all that he had was this malunited dorsal ulnar corner fragment, which was completely unaddressed. And this is the cat. He had no problem with his wrist movements, but his ulnar-sided wrist pain was quite debilitating. And therefore, to achieve good fixation, we have certain approaches. This is not alien to any one of you, I'm sure. The only nuance is that little dart that we use. This is the Orbe modification of the Henry technique. We go through the FCR subsheath, and you get a very nice exposure. I won't belabor too much on this, but a new approach that perhaps would interest you is also the volar ulnar approach. This is for that volar ulnar corner fragment, which is also called the tetrahedron fragment, and you can use this approach between the ulnar neurovascular bundle and the flexor tendons to get in your your tine plate to reconstruct the teardrop, just like so. And of course the dorsal approach, which for some reason a lot of orthopedic surgeons shy away from, but is a beautiful technique in our armamentarium. We raise full thickness flaps on either side of the incision, and then you use the extensor pollicis longus as your lighthouse. You approach the fragments subperiosteally, elevating the second and the fourth extensor compartments of the distal radius. You use the combination as a trapdoor, through which you can disimpact the incarcerated fragments, bring in some bone grafts, put in the bone grafts, and then you buttress that fragment with these pre-contoured plates that are available. What's very important is the closure, and the closure can be achieved consistently quite well if your soft tissue dissection has been well. You can even use braided non-absorbable sutures for these osteoligamentous fragments to anchor them to the plate, and then when you close the compartments over the plates, you will very, very seldom have to even remove them at a later date. There are certain tips and tricks that I would like to share with you. Here you can see that there is a flap that's marked distally. This is called as a transient fibrous zone. Why is this important is because when you look at these two different plates, it is very important to raise that flap, which gives you a little bit more access to the distal end of the radius, because this plate is inadequate to address that fragment. And when you raise that flap, you can get your plate all the way to hug the volar rim of the radius. Very quick word about the ulnar styloid process. Not all of them need to be fixed, but every now and then you will encounter a case wherein the styloid is really very bad, the DRUG is unstable. The basic tenet is that you have restored the distal radial anatomy in terms of length, height, and inclination, and that is when you can fix it with whatever method you fancy. Certain caveats: these fractures are not devoid of their complications. You need to be very aware of them and avoid these complications in your practice. So in summary, I think we should recognize that distal radius fractures will continue to challenge us. We need to understand our failures before we can understand our methods of fixation and success. So with that, I thank you for your kind attention. Thank you so much.
It's open for discussion. Mic is there. Please, all the speakers, please be there.
Yeah, Dr. Arun Kapoor, you just reminded me. The distal anterolateral plate you have been using for the proximal tibia a lot of times. Yeah. So, and I think most of the times you are successful in that. So you
most of
put
the
those.
Generally, I have always been successful on that.
Then you have to publish it. But then the thing is that this plate you are putting it more on the anteromedial, anterolateral side. And then the other way around, so the tibial tuberosity and the above portion.
Yeah, above that. There's a bald area over there.
Yeah. But is it really anatomically? No. No. It's not an anatomical
style
plate.
of the plate, like says, you send the screws in different directions. You want to compress it down. You want to buttress it.
Yeah.
You get a buttressing effect. You fix it. When you fix it, you have to actually bend it and get it contoured with the anterior surface behind the tibial ligament. The tibial ligament, behind that, it should not be irritating that ligament. That you have to be very sure. There's a bald area over there. I think all joint surgeons have seen that. And you can fix in a plate over there. There's enough space on that.
Generally, what people do is put a small recon plate.
A recon plate. Yeah.
Oh, the circumferentially.
Yeah, but then if you realize on this, you have screws going in different directions. And when you fix it, you fix it with a leg up, like it comes to the anterior border of the tibia. And when you press that down to hold it over there, it is really compressing it down now. When you fix your lower leg onto the tibial shaft, now you are actually compressing the whole thing down. You won't let it won't let it come up. And those screws on the tibial shaft, even if there are two screws over there, they don't come off.
Okay. Yeah. And even if your apex is on the posterolateral side, you said that you go by the Lobenov-Horst approach, and from the medial side you go to on the lateral side. You're not very fond of the Frosch approach, huh?
Agreed.
Why?
I'm not good
is
enough.
A much better approach, no?
It may be
for
a better
the
approach,
posterolateral.
I'm not comfortable on that. I'm not comfortable on that.
John, your opinion? Huh?
So I think it depends. If the posterolateral fragment needs something from the back, then you have to go to the back. Whether you use a lateral posterolateral approach or a Frosch approach, where you can go anteriorly as well and put a long plate, or you use a fibula osteotomy. So you have different choices. And I think each surgeon has his own way of doing these things. So I don't think any particular way is better than the other.
Dr. John, posterolaterally a long plate. Is it very easy to do?
No, posterolateral you can't put a long plate.
Can't-
That's why you
can't
put
do,
a
yes.
small plate posteriorly and an anterolateral long.
Yes, yes,
So that's
yes.
what Frosch allows you to do, is to go anteriorly as well.
Yes.
So the Frosch approach
Windows,
is not
yes,
a Frosch approach is not a posterior approach only. It's a posterior and anterolateral approach.
understand.
So the posterior approach only is described by the Chinese guys. I can't remember his name. But yeah.
Vaigaonkar, a common question I was discussing here. We are very fond of showing the X-rays and then the plates. We show CT scans pre-op. Why we all are shying away from putting a post-op CT scan?
So a lot of times we don't get post-op CT scans, sir. I think the function speaks for itself, and it's only the rare case wherein if you have an intra-articular hardware or if there is a collapse, late collapse that happens inadvertently, and that's when perhaps a CT scan would be kind of very meaningful. But I do have a series of malunions that have presented to us wherein we have got CT scans done, but that's segregated to the malunion kind of talks, not here.
Dr. John.
I think it's like if you went 10 years ago, you didn't do CT scans for everything. 15 years ago, you didn't do, or 10 years ago, you didn't do MRIs. 15 years ago, you didn't do CT scans. Today, there are people who are doing CT scans for their post-operative reduction checking as well. So you can argue about whether it's necessary or not, but it's a matter of time where people will start doing it as a routine, okay? Because you can't assess the fracture without a CT pre-op, so how do you assess it post-op without a CT, except just looking at function?
And in this really bad intraarticular fractures, we use arthroscopy assisted reductions, which is much, much more accurate real time. We are also able to assess condyle damages as well as ligament injuries. So that helps intraoperatively.
So it depends on which fracture you're dealing with. So distal femur, you can usually look at it into the fracture. Proximal tibia, very often you can't see exactly what you're doing. Acetabular fractures, sometimes you can't see exactly. So some people would get CT scans as a confirmation of their reduction and checking that no screws are intra-articular, etc. So, I mean, it's a matter of time where it will become gradually a more often practiced this thing. But at the moment, we are not doing it routinely, but there are people who are doing it routinely.
So we all have seen clinically that traction of the lower end radius does quite a good job even before surgery. How frequently we apply external fixator before fixing the lower end radius?
So truth be told, so we do take traction views. External fixators are not redundant, absolutely not. However, we tend to use the internal external fixator more often for very comminuted distal radius osteoligamentous fractures than external fixators. External fixators can sometimes be used as an intra-operative adjunct to, giving you, maintaining the length while you're fixing the distal radius fractures, corrective osteotomies, and sometimes if the soft tissue is bad and you want to come back later on for fixation or compound injuries. But bar these, few situations, I don't remember the last time I used a fixator for a distal radius fracture.
I think what has been found is that when you use external fixators for a long time, they almost always lead to stiffness. Okay, so you use it temporarily and then you've got better ways of doing internal fixation today, so people are resorting to internal fixation. But I mean, there are people who are doing external fixators. There are people who are doing these Jess or Miros or things like that and claim just as good results. So, I mean, I think you have to decide for yourself what works for you.
Another input with the CTs, a lot of CTs requiring for the articular fractures. Like you said, all articular fractures I go in for a CT. There's this little deformity at times, which is a die punch deformity at the center of the radius. Innocuous, very innocuous looking X-ray, nothing much to look back. Even on the knee, on the lateral condyle, when the femur hits down on the central part of the lateral condyle, and you'd see it depressing down and coming up. So on a first look, there is nothing much, neither in the radius or neither in the tibia. But you need to be very wary of it. If there's a fleck on the lateral aspect, or on the medial aspect, or not, you need to see below the joint line. If there is another joint line, another opacity over there, but you need very good X-rays for that. So in that case, that is the reason why you need to go in for CTs more often than not. in these articular
Yes,
injuries.
that's
Thank
right.
you, sir. Thank you for the
So
insight.
we are very thankful. And पीयूष साहब का पूछना है अरे और वैसे मैडम आरती दीवान जो बोली हैं वो नहीं करेंगे तो हम लोग कुछ नहीं करेंगे.
Definitely, sir. Dr. Abhijit, one thing, how often you repair TFCC?
Not very often. So what we do is after we have fixed the distal radius fracture, we ensure that the parameters like I talked about, the length, inclination and tilt have been restored. We examine the DRUJ for stability in 3 rotations: pronation, supination and mid-neutral position. If the DRUJ is unstable in pronation and stable in supination, we just immobilize in an above elbow slab or a cast for 6 weeks, no less. If it is unstable even in supination, which is the position of maximum stability, that is when you need to, that's telling you that the TFCC is not okay. If there is a large ulnar styloid fragment, you fix it, whatever, tension band wiring, K-wires, screws, hook plates. However, if the fragment is small, then there are 2 reasons why you may have instability. One is the dorsal and volar radioulnar ligament injury and the TFCC proper, in which you can either repair it with a suture anchor, open or arthroscopic, depends upon your logistics and your training. So these are the few situations wherein you do have to address the TFCC.
Regularly you
We can have the further discussion downstairs, please.
One last question.
One question, sir, from Dr. John Padre regarding pipkin.
आ जाइए सर, हम लोग नीचे डिस्कस कर
Bilophobia.
लेते हैं. चलिए, जॉन साहब बैठेंगे अभी चेयर पर.
Thank you, sir. Thank you, chairpersons and
Let us have a
speakers,
photograph, please.
for a great session. Like to call our next moderator, Dr. Taral Nagda, for the next session. Thank you.
Can I have the slides? So like this song in Naseeb which says John, Jani and
Number
Janardhan.
92, Dr. R.K. Singh. Registration number 92, Dr. R.K. Singh. Yeah, please come forward.
Amulya, should we start? Yes, sir. Okay, so you remember this Naseeb song which says John, Jani, Janardhan? But we have John, Jaswinder and Ritesh for this show. So I would like to invite Jaswinder and Ritesh to join John for this pediatric trauma session. Can we have the slides? So good morning to everybody. This is Rising Sun from Ganga Ghat at Patna. And this whole session of 1 hour is going to be about pediatric elbow cases. So John told me let's take an audience poll and ask what audience wants. How many of you want to know about supracondylar fracture? Just raise your hand. Yeah. How many of you want to know about lateral condyle fractures? Raise your hands. So we are going to disappoint you completely because we are not going to include supracondylar or lateral condyle fractures. And this session is about something which is different. Amulya told me that, serve something fresh in the morning. And these are absolutely fresh cases which have come from all of us. And for some local flavors to start with, for Saturday morning breakfast, I want to invite Ritesh. Ritesh, you can come here and tell us few cases of elbow trauma which you have seen here, and then we'll have audience discussion, faculty participation, and conclude. Ritesh, over to you.
So thank you very much, sir. So I will be starting with this case. So we can see this was a 7-year-old child, and injury just 3 hours back. And there is no confusion in this. We can see it's a combination of proximal ulna fracture with dislocation of the radial
So we don't
head.
want to hide diagnosis. This is Monteggia fracture dislocation. Absolutely fresh, just 3 hours old. And we want to know from audience, how many of you feel that this can be treated by close reduction and plaster? Just raise your hands. Okay, how many of you would feel that some sort of surgery is required for this? Yeah, so John, what is your take on this? Close reduction or plaster? And then Jaswinder.
So for me, this would be an open reduction. Fix the ulna, get the length back, and that should take care of the radius dislocation.
And how will you fix that?
Something like this, I would use a plate.
Plate. Jaswinder? You follow your boss?
Same, sir, and probably the radial head would not need anything else. If it's
Anybody would put a K-wire or a nail, intramedullary nail for this? Yeah. Okay. Yeah. Ritesh, show us what.
Length unstable, so that's
This is length unstable. It's an oblique fracture, so let Ritesh go through some recommendations and tell us why a plate would be necessary.
So before that, how many of you will opt for a closed reduction in ER just to reduce the dislocation? Or should we directly take him in the OT and do all the reductions and fixations?
Yeah, one time. Yeah, one time.
So this child the fracture was reduced by closed manipulation in the operation theater only, and above elbow splint was applied. And these are the images after reduction. So is anyone now, like we discussed, the plan was open reduction and plate fixation. So does that treatment plan changes now, or we continue with that only?
So, just for the audience, if I were to see, even if you are closely treating Monteggia, what is required in Monteggia, which is anteriorly dislocated radial head, is to give a slab in 70 to 80 degree flexion. And why it is required is that will negate the biceps force, which is going to yank out the radial head. Like supracondylar, we generally give slab not in too much flexion, because there is swelling, but in Monteggia always give slab in flexion, whether you are treating ulna by a close reduction or plating, because radial head needs to stay back.
So Taral,
yeah,
just to be clear, what do you mean by 70 degrees flexion?
70 degree flexion in slab, so not 90. So this is almost
more than 90
more
degrees.
hyperflexion.
So that's not
hyperflexion.
70.
Go for a open reduction and internal fixation with a plate. But before that,
go ahead. We have a lot of cases.
So before that, we went through some literature, and this was a publication from Journal of Pediatric Orthopaedic Society of North America, and like they have done a systematic review comparing the conservative versus surgical treatment for Monteggia fractures, and it was a review of 13 studies. And as we can see, they mentioned good outcomes with both the treatment approaches. However, they emphasize that early diagnosis and speedy treatment is essential for good outcome, and there is a role of conservative treatment in some cases, like stable fracture patterns, the green stick fractures, incomplete green stick fractures. They can be managed effectively in a cast. And they also mentioned that there are more complications with surgical management of these injuries. So indications for surgical interventions where the failure of conservative treatment, where you still have an unstable reduction of the radial head, or the reduction is not maintained, and the unstable fracture patterns like transverse fractures, long oblique fractures, and comminuted fractures, they are the absolute indications for surgical intervention. And when we are opting for surgical intervention, the type of fixation also varies. So for length stable fractures, that is the transverse fractures and short oblique fractures, you can opt for intramedullary tensional or intramedullary K wires. Whereas if you have length unstable fractures like severe comminution or long oblique fractures, that needs fixation with a plate which restores the length.
So Ritesh, it's very simple. Incomplete fractures, either plastic deformation where bone is bent but not broken, or if it's a green stick fracture where one cortex is intact, close reduction and cast is sufficient. But if you have a complete fracture, if it's a transfer fracture, put a nail. If it's a spiral or comminuted fracture, put a plate. Right. Go ahead.
So this is what was done. We went for open reduction and fixation with a plate, and a lag screw was used to achieve compression at the fracture site. And these are the successive images showing good healing, restoration of length, and a stable elbow. And these are the clinical pictures showing restoration of all the movements and restoration of length, and overall a good outcome. So the learning points from this case are early diagnosis and speedy treatment is absolutely essential, and surgical intervention for unstable fracture patterns, and plate is chosen for length unstable fractures as discussed just now. Now this was another case, a 4-year-old girl. She had injury around her right elbow 30 months back, and in this clinical picture we can see there is a slight protuberance over the anterior aspect of her right elbow. And these are the radiographs. So on the left side we can see this, it was at the time of presentation. We can just figure out some plastic deformation in the ulna. Other things are pretty well looking, but when she presented to us after few months, the anterior dislocation of the radial head can be very well demarcated.
So this is very common when ulna is not fractured, no John? Radial head is not paid attention to. So mistake at injury is not to take a lateral view of the elbow with forearm. So that's why radial head dislocation has been missed. And what you see at presentation, what you have drawn as a red line, this is known as Mubarak's line. Yeah. And this Mubarak's line, ulna should be touching. But if ulna forms an arch over the Mubarak's line, it means that the ulna is deformed in hyperextension, and that is what has caused the radial head to dislocate anteriorly.
To remain dislocated as well.
Yeah.
So regarding this case, these questions arises like what to do for this child and how to achieve it. So
should we ask the audience the first question? Can it be left untreated? No. What will happen? John, what will happen if you, for 30 months she's been untreated, and you must have seen cases where for a very long time the patients have been left. What happens to these children?
Yeah, so they are very often asymptomatic at that stage, but over time they can develop various problems, including tardy ulnar nerve palsy, PIN palsy. They can have valgus deformity of the elbow, pain in the elbow, etc. So I think what they found is in the long-term studies that they tend to develop problems even if they don't have it early.
So most of them become painful, and the reason of pain are three. One is either nerve related pain, which John has discussed about. Secondly is lateral laxity. So medial collateral ligament gets overstretched and you get pain over the medial side. And third cause of pain is anterior pain, and this pain occurs because the radial head keeps hitting over the lower end of humerus. And in many cases, Jaswinder, we have seen the lower end of humerus actually develops a dent because of constant pressure, because of the radial head pushing it all the time. So if they don't become painful now, in future she is going to become painful. Rather than waiting for the pain to appear and treating, it's much easier to treat at this stage. So that's why all of us would treat. Then what is second question?
How much delay is safe to intervene? Like, is it unlimited time period or there is a limit to the?
So how many of you have treated Monteggia fracture dislocation in a child which has come after 1 year? Just raise your hand. 1 year, after 1 year? Many, many, many. After 2 years? After 3 years? After 5 years? So who has treated the Monteggia fracture dislocation after the longest duration? I think it must be
after
John.
6 years.
मैं हूँ John, yeah.
6 years.
Six
and
years.
then 4. That is the two which I've done.
I
which
treated
is-
one girl at 18 years age, and the parents came because she was getting married, and she had injury at 6 years. And by that time, the radial head was deformed completely, but we chose to still reconstruct because she was getting a lot of pain. And the key in those cases, I feel, is to over distract the ulna so that you actually create a gap between the capitulum and radial head. And then the shape of the radial head does not matter in those cases.
So those are the ones which I would do a gradual distraction.
Gradual distraction.
So
and not treat acutely.
Yeah.
Absolutely. Right.
But at the age of 18 years with
if you
no
do
remodeling potential
Yeah,
and a
no
deformed
remodel.
head, won't
Yeah.
there is fear of
There was
inducing
too much
arthritis?
pain, so we had choice between
Excision and this
excision and reconstruction, and we chose reconstruction. And we've done few cases, and it's worked. And I'm
Yeah.
telling you that the tip is to over distract ulna, and that can be done only by gradual distraction.
Yeah.
I have to get you that long-term follow-up. And patient-reported outcome measure, I think we need to add that in pediatric patient. Did the patient get married or have a stable girlfriend? So stability of fixation is important, and stability of marriage also is equally important. All right. Yeah.
So the next question was, should we go for acute or gradual reduction of
Jaswinder,
radial
in this
head?
case,
That is
acute,
open or closed?
Acute ulnar lengthening or correction or gradual?
This is a fresh case, right?
30-month-old. 30 महीने हो गए.
Again, I think acute would be done
Acute.
with.
All right. Next.
And do you need to reconstruct the annular ligament?
So open versus closed reduction. Radial head, will it require open reduction, or can you manage still close?
So again,
with an ulnar osteotomy.
In acute cases, most of the time I'll get it without opening it.
This case.
In close, in delayed cases or revision surgeries, most probably we have to open it. Annular
John, what is your
ligament reconstruction probably will not be needed.
So if you had asked me this question 15 years ago, I would say yes. If you ask me this question today, I'll say no.
So
I would check it. If I had doubts about the stability, then I would reconstruct.
So
the
we go with a la carte approach. You
That radiocapitellar joint. So this is what was done we went for open reduction of the radial head and a distraction angulation osteotomy of ulna. And as discussed by Taral sir, we can see intraoperative, this is how we check for the stability, and we can see the radial head is stable in all range of movements. So this is just a brief of how to do it. So do the ulnar osteotomy first, and then I prefer a lateral cocker approach to open the radiocapitellar joint. And since the osteotomy is already done, the reduction is very much easier, and you can temporarily fix it by a radiocapitellar wire, and that will angulate your ulna in the desired position.
So that's only on the operation table, and then you remove it on the operation table.
Yes.
You don't keep the wire.
We don't keep it. Yeah. And then you come back to your osteotomy site, mold your plate and fix it. And the angulation, the direction of angulation is opposite to the direction of dislocation of the radial head.
So two important things I want to add to what Ritesh has said. First question is, people ask where you do the osteotomy. So it may not be at the original fracture or original angulation. It is done at the third hole, which your DCP or LCP will take. So it is more proximal you do, the less is the translation required. More distal you do the osteotomy, you know, the ulna translates a lot and it's very difficult to fix. Okay, that's the first principle. And secondly, how much to angulate? Swadanusar, you know, so that is what people would say in the recipe, Swadanusar namak. So as much as required to keep the radial head stable. So Ritesh has very elegantly shown you put the radial head back and see how much angulation is required in ulna to keep the radial head stable. And then you fix in that position. Yeah.
So also the proximal osteotomy site gives you a good control to reduce the radial head.
Better lever arm. Yeah.
Yeah. And this was about closed versus open reduction. So we can see this review, it clearly mentions that closed reduction usually is not successful in long standing cases, and open reduction is normally, it is required many times. And use of transcapitellar wire, actually we don't prefer to use transcapitellar wire for a longer time. If you have done a good osteotomy, then it is usually not required. And similarly, the reconstruction of annular ligament is also, it varies from case to case. So this was the result. After 6 months, we can see the radiograph. There is a stable capitellar joint. The osteotomy has healed well, and patient has a normal range of movements.
Great, yeah.
So these are the learning points. Prevention is better than cure. Don't wait for a neglected injury to present to you. As discussed in the previous case, manage it at the earliest. And open reduction of radial head is needed in most of the cases. Ulnar distraction angulation osteotomy, if done in a nice way, then transcapitellar wire and annular ligament reconstruction are usually not needed.
Yeah. So thanks Ritesh for those two cases. One where you did ulnar plating in an acute setting, and then how you treated a child who presented 30-month-old. Yeah, so with this I want to invite Jaswinder for still more difficult cases.
So
where
the couple of things just
John,
so the
anything you want to add?
The one we did after 6 years, initially the radial head was really deformed. Okay, and it's interesting that if you followed him up over time, it had remodeled.
Yeah.
Okay, so it was looking a lot better at the end of 2 or 3 years than it was looking at the time of surgery.
So this again tells us that what's written in literature is not always the truth. You know, what is John's experience would show, you know, would work better. So two things both of us agree to is that though the literature says after 36 months you should not operate, we do operate and they do well. And secondly, what the literature says that open reduction of radial head is needed often, really not, because there are papers on both sides. And you know, one should do a la carte approach. First do ulnar osteotomy and see if the radial head reduction comes, and if it comes and if it's stable, you don't proceed further. If it doesn't come, then you open the radial head. After opening, if it becomes stable, then don't do annular ligament reconstruction. But if it's not stable, you do a reconstruction. And if it's unstable, even after that, then you can use a transcapital wire.
So what we found in this thing is up to 6 to 9 months, closed reduction tends to work.
Perfect.
After that, it's very rarely that it works.
Right. So less than 1 year and close reduction would come. After 1 year, it may not come. Yeah.
Yeah, I had discussed this case with you once,
Yes.
The patient had come to me at the age of 7 with this.
Yes.
Montegia. I had plated it.
Right.
He came at the age of 5 years later.
Huh.
With a dislocated radial head.
Right.
Then someone in the village, he went to his village, someone did a radial head osteotomy.
Yeah.
Excision.
Yes.
And then it regrew. He came to me again when he became around 17,
Regrew
18.
in dislocated position.
No, it was excised.
Excised, and it came back.
It came back.
Right.
And he came back at the age of around 17, 18.
Right.
And what we did was, I had CT scans, I sent him to Mangal.
Right.
CT scans were done, and then 3D models were prepared.
Right.
So in the 3D model, what I found was this flexion osteotomy was not helping.
Right.
So what I did was an extension osteotomy.
Right.
So in the extension osteotomy, the head came back in its place. That regrown, it was not the original radial head.
Right.
So I've got the whole.
So was the head posterior?
It was not in its normal. I don't remember now. But
Yeah,
it
because
was
if
not
it's
in its
posterior, you have to do an extension.
I remember it was posterolateral.
So then you have to do an extension osteotomy.
So let's go back to Jaswinder. He has a similar case to discuss and see if we can get any answers from that.
So good morning, thank you everyone. Continuing with the Montegia lesions only. So this is a 8-year-old male patient, and he had been operated 4 months ago for the Montegia, and these are the X-rays. His complaints were there was pain around the elbow, which is after 4 months of the first surgery, and there is a terminal restriction of flexion.
So John, what's gone wrong? We see that ulna has been plated, but radial head is still dislocated. So what is the problem here? What
So
could have
obviously the angulation has not been done.
Right.
The osteotomy is very distal rather than more proximal.
Right. It's a fracture fixation.
No. No, this was.
So
this,
I'll show you.
This was not the primary fracture. This was.
This is the X-ray which was before the first surgery.
This was
and
done
after
for a late Montegia elsewhere. Yeah.
So this will also happen when the plate is lateral, either medial, ulnar side or radial side. You cannot give adequate flexion when the plate is on that surface. So many times you don't want a subcutaneous plate, you don't want plate to be felt, and people would not put a plate on the posterior border. But it is essential to do that, because otherwise you cannot give that angulation.
And it's probably not united because of the distraction.
So what should we do now? Ritesh, so already operated, plated.
4
So
months.
it needs a revision, like adding proper angulation and probably a bone graft at the osteotomy site, because it didn't unite here.
Yeah. Let's Jaswinder, what was done?
So we had similar plans. So the radial head is dislocated. So those are the lines before. This is before the first surgery. We have already talked about Mubarak line. So we expose with the same old incision. We removed the plate. There was a non-union there. There was a fracture gap. There was an attempt to union. And then after kind of manipulating it, the radial head was not budging back. So we had to take out the fibrous tissue around the radial head. And then.
And where is that ligament? Have you taken from? Where is it?
No, that is not the ligament. That is the fibrous tissue around the radial head. Actually, we are just excising it. So in this case, we thought of doing a step cut osteotomy. So something like this. And this was the diagrammatic representation, and that is what we did. So if we can make out, there is a line there for the step osteotomy, a vertical line and then a horizontal going there. And once we did that, we distracted it. We corrected the angulation with the posterior apex. And then we held it provisionally with a clamp. And then the radial head, we checked intraop, the radial head was sitting in its position, moving well. We checked the flexion extension, everything looked good. And finally, we fixed it with a plate, with a longish plate, because the old fracture was distal to our step osteotomy. And because of the step osteotomy, we got a good surface area in contact after the fixation, so there was no need of graft also. So those were the post-op X-rays. That was a kind of a lag screw with the fixation of the step osteotomy, posterior angulation, and the radial head in position.
So what happens to these patients? They will be unhappy because of one reason, which is the prominence of the ulna. And what you need to do is, when you do the plate removal, you will have to shave off that bump on the ulna with a saw, so that it becomes flat and does not become prominent, because it is painful sometimes. Yeah, let's go ahead.
Yeah, so these are the immediate post-op X-rays. This is at 1 month post-op, union in progress, 2 months post-op, radial head in position, and that is the 1 year follow-up of the same patient. Patient doing well, regained complete movements, no complaints as such.
So one benefit of doing this osteotomy is there is no chance of non-union. Basically, if you do a transverse
because of the larger surface area and good contact.
And we can distract also, correct the angulation, the same setting.
Yeah, only thing you require a very good small saw if you have to do a step cut osteotomy in a pediatric ulna, which is already very small. So the way to do it is, you will make multiple holes with a K-wire and then join with a saw to do it. You can, make drill holes and then join with a saw. Yeah, go ahead please, Jaswin. I don't do it, sir. But
No,
if you have to lengthen, not necessary. So this patient, you have to lengthen the ulna. So either you have to put a graft, and if you don't want to put a graft, a step cut osteotomy alleviates need for a graft, because it is self-stabilizing. It works very well. This was described by Ganga people.
Yeah, so
and
I
all of us
got
follow
it from Ganga, but they should just put a screw and not a plate.
Yeah,
initially.
we put a plate.
So after we started putting plates, they've also now started putting plates.
So we don't do it for children who come within 1 year. I think simple flexion
Simple
osteotomy
angulation
will do. These are for difficult cases where you really need to elongate a lot.
So very old cases, etc.
Yeah.
So there were a lot of learnings from this case. So
Some
we have to get the angulation correct. We have to get the radial head reduced, either with if it comes close or open. Step cut osteotomy works well without a graft also, and the level of the osteotomy was distal in the first case. We made it a proximal. Coming to the second case.
Jaswinder, just one question, like many people have recommended using fixators also in such cases to avoid the chances of non-union. So to lengthen the ulna and gradually.
You can use it, but it's a mess. Ulna fixators for lengthening or this purpose are not very easy to use. So unless pressed for, you will not use it. But even if you're using fixator, after finishing the distraction, you will put a plate and graft. You're not going to depend on the fixator.
Coming to the second case, so this is my case. This is a 10-year-old female. She had a supracondylar fracture some 10 years back and now presented with a cubitus varus, and range of movements were quite good. That was a cosmetic deformity. No other complaints as such, no pain. So as most of us will go ahead with a corrective osteotomy, a French osteotomy. The valgus on the left side, the normal side was 15-degree carrying angle, and on the right side there was a varus of 20 degrees, sorry. And so this is what we did. We did a modified French osteotomy. I translated the distal fragment a little more medial just to avoid the bump, but the plate was a bit prominent, and that was the intraop correction I got. I did a correction of near about 10 degree, and I was quite happy. I didn't measure intraop, but I was quite happy with it. And any comments still here?
So it is rectus, and in a girl you would rather give a valgus to match the other side. That's the only comment.
Right.
But she's skeletally mature now.
She was 10 that time. Now, yeah.
So the interesting thing is, people don't complain about a little bit of valgus,
Right.
but even a little bit of varus, they are sometimes very unhappy with.
So valgus, they don't complain. Is that what? Yeah, right. Yeah, let's see the outcome of it. Right.
Sir, I would say I was quite happy with the fixation. It's quite stable as such. If she would have been some 6-7 years, I would have just put TBW and 2 screws. But as you said, like I mean, it was quite stable.
Adolescent, this would work. So most of us.
10-year-old, this will work fine, sir.
Yes, yeah.
This was
10-year-old, this will work fine. She's 10.
She's 10 years. 10 years.
All the epiphyses they have fused already here. So how can she be 10?
Pardon, sir?
All the epiphyses have fused here, so how can she be 10 only?
Maybe premature, but in adolescent, up to 16, a 4-hole plate will be fine. If you put a longer plate, again the problem of radial nerve and those will come. But far away. Anyways, yeah.
So going ahead, this was at 1 month post-op. Things looked good, but there is not enough valgus. That is what I would comment. And then at 6 month post-op, the valgus actually seemed like further reducing, going to a bit of varus. And at 1 year, there was a varus of around 5 degrees. And these are the, clinical pictures. So on the right side, there is a bump on the lateral side. Probably that is because of the plate, and it is not adequate valgus. Range of movement.
Why do you think the valgus has reduced over time?
So I'm not very sure. Probably I didn't do enough correction. That is
no,
one
but then
thing.
it should have been right in the beginning. No?
Yeah,
It cannot reduce.
So
if you had not done enough correction, it would have held up in that position.
that is my concern, sir. That is the
So
point.
do you have a trochlear growth arrest or something like that?
No, but it
doesn't look like it.
She's skeletally mature.
Already mature now at this exercise.
It may be a different view, just a different radiological view. It cannot change because of growth. But you know, the message is that you have to give almost 15-degree valgus, which is the valgus angle. You just can't correct the deformity. You need to overcorrect in case.
So would adding a splint for
No.
initial
No,
2-3 weeks at least? So
Splint will not.
We did give a slab initially, but yeah, we had given that.
After doing a plate, I don't think that will prevent this.
So I asked her
Can you compensate comparatively fixation which is not good enough with the plaster slab or a sling or anything? I don't think you can really compensate with that.
You can't.
Unless you give a full plaster.
No, that was not for the
One of the options in these cases is to use an external fixator for cubitus varus osteotomy fixation. So if you feel that post-surgery, if your correction has been inadequate,
you can
then
adjust
it can readjust. Yeah, but
the fact that the deformity recurred, there was some mobility at the fixation.
Yeah.
So why was that mobility?
Yeah, you want to answer that? Yeah. So so the whole idea would be a better fixation and overcorrection.
All again comes down to 2 screws above, which is probably not good enough.
We have a lot of cases to cover.
I'll finish it. So I asked her to get reoperated for a corrective osteotomy. She denied. She just wants an implant removal. Yesterday we did implant removal. So the learning is for me is there should have been more valgus correction initially. That's it.
Thanks, Jaswinder. So we have a lot of cases to cover, and I'm going to go very, very quickly. Amulya, is that okay? You know, Patna Express, so that we can cover most of that to go on. So we'll first go to some unusual injuries, which are proximal forearm injuries. So this girl, 8-year-old, came with an elbow injury and a lot of swelling. And whenever there is a lot of swelling with an elbow injury, it points that, you know, there is something else. She was referred as a radial neck fracture. And, you know, my resident said the plan is to do close reduction. John, very quickly, is there any additional injury?
Yeah, I'm not liking the look of the olecranon there.
Right.
Yeah.
Yeah. So probably there is also an upper ulna injury. So this is not plain and simple radial neck fracture. This fracture is known as Hume's fracture, where there is a ulna fracture and radial neck fracture. Jaswinder, how will you treat this? Radial neck, how will you treat? And proximal ulna, how will you treat?
So
this is the CT scan. Yeah.
Metazio technique for the radial head.
Okay.
And
so Metazio meaning you will put a intramedullary wire and correct it.
Yes.
Okay.
And probably I'll check again intraop C-arm images for the olecranon if it looks.
Yeah. So Jaswinder is saying that you reduce the radial head first and then check what happens to ulna and then decide what to do for ulna depending on what is status of the ulna. Exactly. So this is what we did. We have these options. We now do close reduction of radial head neck rather than doing an open surgery. Most of the time you will be able to get a close reduction. There are various methods of doing it. There are methods in flexion, there are methods in extension. But I think I really like this method which has been described by our own Indian pediatric orthopedic surgeon, Maulin Shah, where he has described 3 stages of getting a radial head, a radial neck reduced. And even with very severe injuries also, his method has worked. So there are 3 steps. One is giving varus stress so that you open up the lateral side. The second step is to pronate the forearm. And third step is in hyperpronation, you flex. Okay, I'm going to show videos of that in one of the patients. But what you do is you first give varus stress, okay, and then try to reduce it. Now in this case, we were not able to, get the reduction, even with Maulin Shah's method. So what we did is we put a K wire between the radial head and the shaft, okay? You put and this has to be put in no bend zone. What I mean by no bend zone is you want to avoid the posterior interosseous nerve. So you go from behind, between radial neck and the ulna. You go in that zone because radial posterior interosseous nerve does not come anywhere in that zone. The second important point is the position of the forearm. You should not have forearm in supination. But you rotate the forearm so that you can see radial neck in maximum profile. So probably you will have to keep it in mid-prone or little more pronation position. And in that position, using a lever, using this K-wire as a lever, you will be able to reduce the radial head. So we reduced the radial head, and as Jaswinder said, at end of that, we looked at the ulna. So ulna, Jaswinder looks quite all right. But we wanted to confirm this is an intra-articular fracture, and we wanted to confirm the intra-articular reduction is all right. Not just the bony piece of ulna olecranon is fine, but the joint looks okay. And this is a technique of doing arthrogram for the same. So a lot of time we do arthrogram for elbow over the radial neck. There is another technique for doing arthrogram which is done on top of the olecranon. This is easier because you can do it in a lateral position of the elbow. So this is how we do it. We put a 16 number hypodermic needle, and then this is the first needle is put to know the position of the K-wire. So I don't now directly drill the K-wire. I will put a needle, take a C-arm shoot, and then using that as a reference, we put a K-wire to fix. And once that has been fixed, I take the same needle again, put it more proximally into the joint. So you can see this is second needle into this joint. And then we inject dye around 2 to 4 ml of dye. Now in that day, we did not have a dye available in that hospital. It was taking time to bring it from the radiology department. So we injected air. So the situations where you don't have a dye available in an orthopedic setup, then it is okay to use just around 2 to 3 ml of air ammonia. It is free of charge. And air in the OT is sterile. So there should not be any problem. So we did air arthrogram, and then we passed these 2 wires, kept them outside because this is a metaphyseal fracture. It's going to heal very fast. Give a slab in pronation here, and then we removed the wires once the fracture was healed and started mobilization. This is another 11-year-old child, and he came with a fracture, again, injury to the forearm, John. So this is just an isolated metaphyseal olecranon fracture in a child. Now, how will you treat? I want to ask audience, how would you treat this? How many of you would just put K-wires and fix this after open reduction?
How old is this child?
11-year-old.
Okay. So for 11-year-old is almost like an adult for me, but you have the option of biodegradable pins and vicryl
In Bombay,
sutures.
we don't get. In Patna, yeah.
We get them in Patna, unfortunately.
Right. Yeah. So pin fixation. But what about compression? This is a avulsion fracture.
So I would use a.
It is not going to.
No,
it does not hold. You're
so
right.
you need the tension band type of a fixation
you
here,
can-
like an adult olecranon.
Sorry, I said use vicryl as your wiring technique.
Olecranon apophysis is open. So if you use a tension band steel, it will restrict the growth of the olecranon. So what do you do, John? Yeah, you use vicryl stitch. Okay. So this is what we did. We opened it, open reduced it because it was an intra-articular fracture. Not possible to reduce this close. Put 2 wires and then a vicryl stitch to hold it in this manner. You can also use some of the other forms of degradable fixations in this case. This is 2 months, and then we said we will do the implant removal. This was scheduled on 26 January for an implant removal because patient had holiday and family thought that I should not take holiday on 26 Jan. So they asked me to operate on that day, but he presented 2 weeks earlier with injury to the opposite side. And he had exactly same fracture on the opposite side. And we treated it exactly in the same manner. Now, was this a coincidence? Ritesh, was this a coincidence? Patient, how many of you have having same fracture, either upper tibia injury or, olecranon fracture in a child or an adult, exactly same fracture on the other side? Anybody? So what was happening, Ritesh? I'm asking. Yeah, absolutely.
So,
Who picked up that? Ajit, absolutely right. That's hallmark of a good teacher. Look into patient's eyes, okay? And when you look into the patient eyes, many times we are told, look into patient's eye and talk. So the patient had blue sclera, which means this was a case of osteogenesis imperfecta. Ritesh, you want to say something?
So always, if you are getting identical injuries, you should suspect for something else rather than just assuming it as a coincidence.
So he had no other
fractures. Osteogenesis imperfecta
yes, sir,
doesn't necessarily give you an identical fracture on the opposite side.
Yeah, but
it can give you fracture anywhere. That's a different thing.
Absolutely. So this was type 1 osteogenesis imperfecta, and these patients are known to get olecranon fractures, and many of them will have repeat olecranon fractures and fracture nowhere else, because hyperflexion injuries, they will get that. And we investigated him, so then we started him on bisphosphonate injections, and finally after almost a year we did implant removal. But many times in OI children with olecranon fracture, it is advised that don't remove the implants because they will have a refracture. But in this patient, the implant was hurting, and we had already improved his bone density through medical treatment.
So if you keep the implant, it will not affect the epiphysis there?
So because there is no tension band. So any implant which is going perpendicular to the physis and it's a smooth implant will not affect. So in OI, we pass transepiphyseal the nails, interlocking nails. So and that does not affect the growth. So there are telescoping nails which are used as a treatment for deformities in children, and that does not affect the growth. So any implant which is put perpendicular to the physis and it's not holding across, then that will not affect the growth. Anyway, let's come back to some more uncommon injuries. So these are all real life patients, and though these are uncommon injuries, we are seeing it very commonly now. Amit, what fracture is this? Amit Asgaonkar. This is a 7-year-old child, and it came to your hospital with this fracture. I'm sure that you're going to send me a WhatsApp at 11 p.m. and ask me thoroughly, kya lagta hai? Anybody? Medial epicondyle fracture, right?
At this age, do they have a medial epicondyle?
7-year-old child. Absolutely. So the medial epicondyle ossifies by 8 years in a female child. If 7-year-old child has an epicondyle fracture, actually it is a medial condyle fracture. And how do we confirm that? First is, of course, clinical evaluation. And this patient came with a CT scan, which shows that there was a very big fragment. Also came with an MRI, because the doctor did not understand. It's fine. He did the investigations, and when he found that this is something which is not my cup of tea, he referred to us. So medial epicondyle fracture. Ulnar nerve is most common.
Sandeep Patwadan has a case where child presented with a medial condyle fracture, and the surgeon put an incision on the lateral side, thinking that this was a lateral condyle fracture, because we commonly deal with lateral condyle fracture, and actually fixed that, and he's shown that cases in one of the iFix meetings. But here we picked up, and just for again documentary evidence, we did an arthrogram. So this is another way of doing arthrogram, going above the radial head. You can also do an elbow arthrogram, very simple technique, and that delineated the fracture, and we can see this is the medial condyle fracture. It needs an open reduction through anteromedial approach. We fixed it with K wires, converted one of the wires into a screw, because this is a shear fracture, requires compression fixation.
You didn't use air this time.
Pardon?
You didn't use air this time.
No, we opened it, no?
But no, you did an arthrogram.
We had. So that hospital, we had a dye available. I wanted to show that one should not stop. There are always jugaads possible in life, and you can always, change things. So this wire we remove first. The screw is removed after 6 months, and this patient did well. This is another 8-year-old child with an elbow injury. And these are the patients we now regularly get: gymnastic injuries, cycle injuries, skating injuries. And this patient also has, John, a medial condyle fracture. But if you see a lateral view, this is a lateral view. What is happening, John, here? This is AP, and this is lateral.
So this is where a CT would be very helpful, because the anterior part is also separate, yeah?
Yeah. So we did a CT scan. Pardon? Also injury on the lateral side. So we have not seen, sir, these injuries for so many years. I have not seen. Last 5 years, there is an epidemic of these kind of injuries. So you see a medial condyle fracture with a vertical lateral condyle fracture.
So they are more like adult fractures taking place in children.
They have, completely new fracture patterns, and all of us should be aware of that, because if it's happening in Bombay, Amulya, soon it will come to Patna, and it will soon come to Pagwada, Dr. So everyone should be aware of these injuries. We investigated it, did a CT, and we were able to print just a bone model for academic reason, which showed that this was a problem. And now the job was very simple. We did a medial approach, open reduction of the medial condyle, fix it with wires, and we fixed the capitulum fracture with a Hubbard kind of screw. And this patient did well, had ulnar nerve injury, but that recovered over a period of time, and we removed the K wires, but we kept the capitular screw in place. So these are again some unusual injuries. Elbow dislocations again are being very common in children now. And whenever we have elbow dislocation, there is always something plus. So they come with some fracture in addition. So this is elbow dislocation with a radial neck fracture. And here the plan is to reduce the elbow dislocation first, and then you can also close reduce the radial neck. And these are different methods, but this is Moulin Shah's method, and I'm going to illustrate you actually in a video how that method is done. So this is how exactly it is done. You give a varus stress first, and after giving a varus stress, you pronate the forearm, okay, in extension. You look at the radial neck and then push with your thumb to try and get it into the best position possible. And as you hyperpronate, actually you are reducing the shaft over the radial neck. You're not reducing radial neck over the shaft. You're reducing the shaft over the radial neck, and then you hyperflex. And as you hyperflex the radial neck, most of the time, it will sit back into its position, and then you take AP and lateral X-ray, and to everyone's surprise, everyone in the OT suddenly feels relieved that doctor has got a close reduction, but this works well. The only issue here was after reduction you check for stability, and you check for stability here in varus and valgus. So reduction was stable in varus, but in valgus it was displacing. So just putting a plaster is not going to be helpful in this patient. We have to fix this. And how do you fix? Not with K wire, but with intramedullary wire which goes through the radius. So this is the Metesio technique Jaswinder was talking about. I don't use 10 nails. Don't use 10 nails. Don't use Talwalkar nails. Don't use rush nails. Use simple K wires. And when you use K-wires, don't cut the tip. The problem with elastic nail is that it has a bent tip and it cannot fix very well with ease the radial neck. This is what I feel. So I just use a K-wire. You bend the tip of the K-wire but keep it inside. And after 2 to 3 months, then we remove these K-wires and this patient would do well. One more elbow dislocation. This patient had distal radial fracture, elbow dislocation. Anything else happening here? Amulya?
That's the, sorry.
Yeah, Amulya. You're not Amulya. Yeah. For your Amulya's valuable opinion. So Amulya is valuable. So your Amulya opinion. Yeah.
There is a clear-cut case of elbow dislocation with the bony chip inside.
वो कहाँ से आया? Chip कहाँ से?
Looks like a medial epicondyle.
Yeah.
Looks
So
like,
how are you sure this is medial epicondyle?
We'll have to go for this traction view and maybe a valgus and valgus strain. That
10-year-old child, so you should see a medial epicondyle. If medial epicondyle is absent, where is it? That
in
is
the joint.
It is joint.
Absolutely. Right. So this patient was initially treated with just a closed reduction. The doctor did not realize that there was also medial epicondyle which was incarcerated. And that patient had severe restriction of movements, also had myositis, and somebody thought myositis should be excised. And when patient came to us, we realized there was an incarcerated fragment. And the surgery here was to remove that incarcerated fragment, fix it back into its original position, and also do an ulnar neurolysis at that time, or at least free the ulnar nerve, because that is also involved. It was in the elbow joint, the ulnar nerve, and was getting irritated. So this is how it was fixed. Don't fix this with K-wires, fix it with screws, and that should do well. So with this, I think to end this session, we have 2 legendary cases from John, and when you have something from John, it has to be something special. I was talking to Dr. Tanna in the plane, and I asked him, name 3 speakers you enjoy listening to. In Gofcon, name 3. It's not that others don't speak well, but he took, Dr. Tanna took John's name, and no, this is so that you speak well. You have no choice now.
Yeah, so this is a 4-year-old child who fell and injured her right elbow, and these were the original x-rays. Anyone wants to comment on that? So thoroughly you know the case, so I think Jaswinder, you know the case, so Ritesh is left.
So all of you are disqualified.
Ritesh is not.
So it looks like a radial neck fracture with fracture olecranon and some subluxation at the elbow.
Okay, so this was treated with closed reduction, and she came to us on the 5th day with these x-rays with a slab on.
So I would do further imaging in this patient. Yeah.
So what imaging?
Here CT.
Okay.
CT will be done.
So there's I'll just show you the 3Ds because the 2Ds are a bit difficult. Okay, so that's the 3D picture.
Right. Yeah. So I think Ritesh was right. It is a olecranon fracture, possibly a radial neck fracture, and there is dislocation.
So anything else? You can't tell on the CTs.
So is there a proximal ulna, like a coronoid fracture?
Exactly.
There's something on the second image on the right side, the middle image. I see a piece which.
Yeah, so this is the thing, that because it's mostly cartilaginous at this age, you will not see a coronoid fracture, and this is the reason why if you look at the past, a lot of these have been handled badly. So you have to have a very high index of suspicion. If you get a subluxation in this or a dislocation, always think of coronoid fracture. The problem with MRI in these little kids is that usually you need a GA or something like that. So we don't do it routinely, but you really need an MRI to be able to diagnose a cartilaginous injury as opposed to a pure bony injury.
So in a CT, you don't need anything like that.
No.
CT and MRI both.
But CT will not tell you a cartilaginous here.
So CT doesn't
pure
need
cartilaginous
GA.
injury.
CT doesn't need GA.
No, sir.
In a child.
No.
It is very quick sequence. In around 5 minutes, they'll be able to do elbow. So
okay, so So this is what we did. We looked at it, and I suspected that there was something more to it. So we did a posterior approach. You can see the olecranon fracture there. So you can see how the fragments are much larger than they looked on the X-ray and the CT, because again, this is mostly cartilaginous. So that was the ulnar nerve peeping out, and we had to actually free out the ulnar nerve. Okay, and then if you look carefully, you can see there's a fracture in the coronoid here. Okay, so that's the coronoid, and here there's a fracture. That's the piece of the coronoid there.
Yeah, it's all cartilaginous.
It's all cartilaginous.
It's much
okay?
larger than what you see on CT or X-rays.
So how do you fix this? Yeah, so what we did, so we used a suture anchor. So if you, we'll show this X-ray, this picture when it comes on, because you can see clearly the place where the fracture is. Okay, so you can see the area of the fracture there. Okay, that area of the bone. Okay, so what we did was we got that piece back there, and then we used a suture anchor. So this is the drill for the suture anchor. Okay, that's the drill for the suture anchor, and then you put a suture anchor inside, and those sutures you tie the coronoid. So you can see now the coronoid is nicely reduced there. You tie that on, and then you go on to the olecranon. So again, because it's a 4-year-old child and we had biodegradable pins available, we use these biodegradable pins. You can see that there. Okay, and this is the drill hole to kind of, you do that and then measure the thing, and you can put in the biodegradable pin. Okay, so that's the biodegradable pin going on, and we use this Weichel suture around it. Okay, so that gets resorbed. That's her at the end of surgery. Those are the C-arm pictures. That's the post-op X-ray. This is at 4 months down the line. You can see now how the fracture is going on to heal. This is her 9 months post-op. She's got a good range of motion. And we got further follow-ups at 18 months, 3 years post-op, again with almost a full range of motion with that. So I think these are the newer injuries. We've got some literature. So if you look at the literature on terrible triad in children, it's all from the 2020s onwards. Okay, so there's some papers. This is a lesion where they talked about the olecranon fracture being one of the parts of a terrible triad in children, as opposed to adults, where you don't see that. This is an elbow dislocation accompanied by ulnar coronoid fracture and radial head fracture. So there's a report on a terrible triad injury in child. This is again in 2025. And so we go on to the next case. This is a 15-year-old child, and this is the initial X-rays. Okay, so this is again a lateral epicondyle.
Yeah. So it's a fracture dislocation. Dislocation of elbow with lateral condyle fracture, which has gone higher up.
Okay, so this was treated with closed reduction elsewhere, and if that was not enough, it was serially X-rayed over time. Okay, so you can see how it's again getting dislocated. This is at about 6 months, and it was 7 months before she came to us, and that's the situation now.
Whole forearm here has gone with the lateral condyle, and the rest of the humerus has been anterior.
So what do you do here, Ritesh?
At 7 months, we can still think of doing the, recreating the fracture, doing intra-articular osteotomy, some reduction osteotomy to reduce the size, put the things back in place. And
so how do you, what approach?
Posterior approach.
Okay. Jaswinder? I think you know the case, but still. No, this was before your time.
Do we have CT scan? Do we have a CT, sir?
Yeah, we'll show you all that. So That's,
Even
that's,
if,
a, that's a
if
clinical
I
picture.
am treating this acutely, day 1, still I will go down from a posterior approach to reduce and fix. Lateral condyle, normally people say you should go from lateral approach to preserve the vascularity, but this is one of the cases where you can take a posterior approach and
But why you
fix
want
this.
to take a posterior and not lateral?
For this fracture, it become very easy. So it is described by Neil Kamal Mohan, one of our people. But in unstable elbow with lateral condyle, it become very easy to go from behind because you see the fracture site immediately, sir.
Yeah, but I think that's a matter of choice as to what approach you
Because
use.
from the lateral also you'll be able to do the same job.
So it's difficult. You have to retract a lot because in unstable situation, the fracture line has gone way medial into the trochlea.
But because this piece is separate, it's actually just as easy whichever approach you use.
Okay.
And getting it reduced, and you need to reduce the elbow and the fragment. Okay, so it comes back into place once you've reduced the elbow usually. It gets very close. So this is the clinical picture. So she's got some range of motion at this stage. You can see the varus deformity, and the CTs are there. Okay, so what does the CT tell you?
I think it confirms the diagnosis that there is a lateral condyle vertical. It's going almost vertically up.
But it's going into the trochlea.
Into the trochlea.
And it is now united to the shaft of the humerus.
Right.
Okay, so this makes it a little more difficult. So what approach would you use? Now, Ritesh.
Now we have to go anterior actually. So
Anterior.
anterolateral, basically the Cocker's, lateral Cocker's approach.
Yeah, so we used a combination of the lateral and medial. Okay, so so in something like this, you always want to release the ulnar nerve because almost inevitably they'll end up with problems with the ulnar nerve if you haven't released the ulnar nerve. Second thing, I'll tell you why we did it, which you'll see around in the operative pictures. Okay, but always, almost always in these late cases, we would first get to the ulnar nerve and release the ulnar nerve.
But it is only for the ulnar nerve, or it's also for the release, because
In
the
this
whole
case,
thing is
it was also
dislocated.
it was also for reduction, but
Yeah,
for an
because you will not be able to reduce unless and until you do the whole excision
approach,
there.
yeah. So that's a different reason in this case, but even if it's a stiff elbow for an arthrolysis, we always start with the ulnar nerve to make sure that, because we've had a couple of patients where we didn't do that and we had ulnar nerve problems later. So as a rule, we do the ulnar nerve
John,
first.
this becomes similar to the elbow arthrolysis approach.
Absolutely.
Because you have to release all around and bear the distal humerus.
Totally, yeah.
Apart from the ulnar nerve, John, you will not be able to reduce it back there. You will not be able to reduce at all unless you go all round.
Yeah, absolutely. So that's, I mean, that's why I went medial. You asked me that, so I'm giving you the answer for that.
I'm answering you.
Yeah. So there, so we first got the ulnar nerve, then we went laterally. Again, we've released everything. You can see laterally, and you can see the fragment which is united there. So we have to osteotomize that fragment. You can see the osteotome there, going at exactly where the fracture line was. And then what we did was, we released it all the way, went back to the medial side. So you can see the ulnar nerve out of the way, released the joint completely. We actually dislocated the joint medially to make sure that we've got it reduced. We fixed the lateral condyle fragment along with the joint so that we had a good intra-articular reduction, and then checked the movement. We went, put it through the full range of motion.
So you fixed it under vision.
Absolutely.
And how was the blood supply to that lateral fragment? Was that some?
So you still attached to the whatever it was attached to earlier.
Some muscle,
So we did not. So that's what I'm saying. We reduced the elbow, and then the place thing came more or less in place. So those are the three screws.
After fixing the elbow, it was stable.
Absolutely.
You could see it in extension. It was stable.
But
Because generally, if you have to do so much of the soft tissue release, it's not stable all the time.
Yeah, but we'll still, in something like this, I would still use a cast for 3 weeks. Okay, so that was her in the cast. That was removed at 1 month. She came back at 1 month, so that was her after that has been removed. This is her at 3 months, quite stiff at this stage, but the joint is looking a lot better. And this is the last follow-up we have at 18 months. Again, a reasonable range, not a full range of motion, but a functional range of motion. She can get it to her mouth, and she's got a good and the joint is looking a lot better than it was earlier. So I think these late presentations are still worth doing. If you look at the literature, there's very little in it, and Taral is going to tell you about that.
Literature. We just come to the last slide, Amulya, and going to end. The first take-home message is children do not read pediatric trauma books. I know orthopedic surgeons don't read, but kids also don't read, and they come with newer fractures now.
Taral, just one thing to Dr. Mukhopadhyay.
Yeah.
Can you put these people in cast in extension? Because I'm sure that if you remove it after 3 weeks, you will get much better flexion. Or does it make any difference?
Try to fully extend the elbow, it's likely to be more unstable. So for a lot of the arthrolysis we do, where we put them in extension and then open out the front and then start mobilizing them. Very much like Bhattacharya did originally.
So maybe not a full extension, maybe 5-10.
Yeah, so here we would flex it a bit to make sure it's stable, and then take out the cast at 3 weeks and then start mobilizing.
Flexion is more important.
Easier to get a flexion than the extension. Last few degrees of extension almost is always lost in these situations.
So that's what, when we do the arthrolysis, we actually cast them in extension and or a slab in extension and take out the front and start mobilizing them straight away.
So thanks Amulya for allowing this session, for John, Jaswinder and Ritesh for being excellent faculty, and the audience. You know, a big round of applause to the audience for being such an interactive audience. Thank you everybody.
May I request Dr. Anand, the next moderator, please. Dr. Anand Bhushan, are you here? I will request the chairperson for the next session, session 8, Dr. Kiran Acharya, Dr. Shekhar Srivastav, Dr. Praveen Kumar Saho, Dr. Kaushlendra Kumar, and Dr. Mohammad Farman Ali. All respected chairpersons, please come to the dais. At present, we are running about 20 minutes late. Over to the chairperson, sir. Dr. Kaushlendra and Dr. Mohammad Farman Ali. Right, over to your chairperson, sir. The first speaker, Dr. Vijay Goni, is not here, so may I request Dr. M. Ajit Kumar.
Yeah. इनका presentation
A very good morning. Thanks to Dr. Amulya and his team for this opportunity to be back in Patna for yet another Gofcon. My brief is to talk on displaced fracture neck femur in the younger individuals. Yeah. So nothing to declare. All of us know that this is an unsolved fracture, and particularly the younger people, the more problems that we face and dilemmas in management also. We all know that there is a high rate of failure, both biomechanically as well as biologically. So various ways to fix it, right? But the failure rates are quite high, and there's a lot of literature from time immemorial saying all these problems are there. So I'll just rush through because of the paucity of time. So various methods of fixation have been tried, and compression screws, Powell screws, valgus osteotomy, particularly in the elderly. I think Dr. Maghu's publication in the over 60s osteoporotic, primary valgus osteotomy in neck femurs. The BDSF technique, FNS, all these techniques are there. And of course the biological ones, whether it is muscle pedicle or a vascularized fibula, all these techniques are there. And then comes open reduction, particularly popularized in the American continent. Okay, so this is one that has been described. So there is the risk of AVN, whatever we do, and there is also the failure rates are quite high in this problem. So lot of publication about FNS, but many of us are not too happy with this also. We can discuss that later. So whatever be the modality of fixation, there are problems with that. Professor Kulkarni has this concept of making a like a rigid fixation. You should not have a compressive fixation to avoid the controlled sliding. So he's devised this sort of a fixation method, so which prevents the varus collapse of the implant. So basically looking to see if there is any other way that we can address this problem, particularly in the younger individuals, because these people with a higher velocity injuries, they tend to have a more complex type of fracture, that is a more vertical type of fracture. So you have these type of fracture configurations, the Powell's classification that we all are aware of, and various ways to fix it. Ideally, the fixation device should be at about 90 degrees to the fracture line, and we need to look at the CT in this particular technique that we talk about. So in Powell's type 1, the DHS gives you a perpendicular sort of fixation, so the lag effect is there, but as the incidence of the angulation increases, you don't get a perpendicular sort of a screw fixation here, and that's where the Powell screw comes in. It goes perpendicular to the fracture in the type 3 type of fracture. Okay, so in the pre-op planning, you need to look at the CT scan. You need to have a CT scan and then plan accordingly and then go ahead. Okay, and you also need to look at the comminution, whether there is anterior comminution, whether there is posterior comminution, or in some instances in very high velocity injuries, you can have both a complex type of comminution there. Okay, so wherever there is comminution, we sort of put a position type of screw. The compression screw comes at the far end. The compression screw comes here, and at the comminution site it is the So if bilateral or anterior and posterior, if there is comminution, both are put in a position screw type of mode. We don't try to achieve compression because that will shorten the neck, right? So this is just to show that the CT, there is anterior comminution, as you can see here, there is anterior comminution. So once you achieve the reduction, slightly valgus reduction there, that's the trajectory of the Powell screw. That's initially put there, and then another one in that direction. In the AP view, it looks like that's overlapping, but in the lateral there is adequate space there, and then that's the trajectory for the DHS that goes in. Right. So once you get the compression with the Powell screws, you can put in the DHS to get your added stability. Right. So that's one. So this is the post-op protocol that we tend to follow, and I'll just run through a few cases for want of time. So here's another one, very acutely angulated there, as you can see in the CT. That's the thing. A similar type of fixation, right? So if there is comminution, then you do not compress that, you just put it like a position screw there. Sometimes you can combine it with a lag screw as well. The whole idea is to prevent post-op collapse. The same principle as what Dr. Kulkarni is talking about. You get your, here there is comminution both anteriorly and posteriorly, as you can see in that particular picture. So 2 position screws and 1 compression screw. Though the fixation holds until union most of the time, right? So this has been our experience. So this is one particular case with neck with shaft. Okay. So this particular patient, you see the vertical fracture in the neck with a shaft fracture. So this went on to fail with a single implant. Professor Tanna will say you should never have done that in the first place. So, yeah. So this is a shaft with neck, another example. So this has held on, right? Okay, so this is another one. Both left and right hips are involved. One side acetabular fracture, the other side this sort of fixation. I mean, he came with an open fracture. This was just pre-COVID sort of time. You see the comminution there in the neck fracture. Of course, the acetabular fracture is there. So this is what was done for the compound fracture. An orthofix was put in, and then the Powell type of screw fixation with DHS there. Right? Okay, and the acetabular side fixed on the other side. And the orthofix, unfortunately, disappeared during COVID time, and then he came back with that well united post-COVID. So I think, so that's the total number of cases that we had. So the advantage is the neck length is maintained and very minimal sort of post-operative collapse happens with this type of configuration that we have. So thank you very much for your attention.
Thank you, sir, for your excellent presentation.
Thank you.
Now, I call upon Dr. Rohan Singh Parhar for his presentation on challenging and revision scenario in a 12-year-old infected failed TKR with distal tibia fracture, salvage or amputation.
Good morning, everybody. Thank you, Dr. Amulya, sir, for the opportunity. So I'm just going to quickly present a couple of cases of an experience of infection plus salvage. So this is a 64-year-old lady, multiply operated 8 times, 12 years since index surgery. Wife of a pulmonologist, wife of a doctor from my own city, working with me. Infected TKR, revised and debrided 8 times. Bedridden since 12 years, presented to me with a fall in 2021. So this is the X-ray. As we can see, it's an infected TKR with a distal tibia fracture. So these kind of cases, the problem is the patient is not walking, and you have such a 12-year-old infected knee. The patient has gone to multiple medical colleges and taken an opinion for an amputation also. So 12-year-old infected knee, to tackle or to send it to your best friend. I think this is a case, if you take it up, then you have to have a lot of situations, a lot of problems, and you have to persevere with the patient. It's a challenging situation. How to manage the daily dressings along with the fracture management and the infected joint, different opinions and different thought processes. What came to my mind and what was more logical, I did that in my own hands, and I tried to salvage this situation. Because it was a chronically infected joint with a fracture and a long battle of 12 years have gone by, so we decided about the prognosis is going to take at least 2 years for this patient to be better, and a plan for a salvage trial with a trauma reconstruction. And this is the intra-flowing pus from the sinuses. So this is what is going on for last 12 years. So you can see multiple sinuses, the pus is coming out, and when I ask my assistant to really press on the thigh, it starts flowing. It's on the table. You can just see it is all flowing out. So this is what the patient is suffering. She's from Jhansi and she's a doctor's wife. And this is what happening. So intraop, once we've taken up the case, we open it up. This is a complete gutter of ball of pus inside the joint. You have to massively take out everything and debride very radically. And this is the intraop picture of the infected limb and the implants. As you can see, a massive loss of the segment of the distal femur and the proximal tibia with a lot of infection. Thorough cleaning was done. This is the post-first look, the post-first debrima. And we change up all the paint and the drapes and everything. And we do a second look debridement on table with this kind of a case. Get it cleaned up nicely, the whole segment. And what I did was spacer blocks, 3 spacer blocks for the massive defect in the distal femur and the knee, and coupled it up with a antibiotic rod for the distal tibia fracture, and coupled it up with an external fixator kind of a setup for the rotational stability of the fracture. So taking care of debridement, removal of the infected implants, and the space in the massive defect has been taken care with the massive blocks which have been put in the distal femur and the knee compartment. And for the fracture stabilization distal tibia down below, we have put an antibiotic rod and a fixator to get this stability. So this is the 3rd, 4th post-op dressing. The skin is chronically infected. You can see how black it is because of 12 years of all this problem. In 3 to 4 weeks, the skin had healed up well. There's obviously a lot of shortening, and there was completely no more sinuses. The scars were healed up. No draining sinuses were there anymore. It took about 6 to 8 weeks for all this healing. And this is the X-rays, as you can see, a little overexposed. This is a better one. 3 months post-op. with the block system and everything, with the fixator and the antibiotic rod. And this is a 6-month follow-up of the same patient with no more infection after the explantation. And the fixator was removed at about 5.5 to 6 months. I removed the fixator, put her on a caliper, and she was started mobilizing for the first time with a walker. And the fracture is completely healed. You can see in the distal tibia, and this is an antibiotic-coated nail. So I had it with this. It was a long journey for 6 months because obviously it was a doctor's wife. So the whole block system was nicely fixated. It was maintaining its stability, as you can see in the massive defect. So the challenge was not what to do further. The agony of 12 years had gone by. I had left her alone in a walking caliper. That was gold standard for me at that time. But the husband and daughter didn't want anything else. They wanted to wait. The lady came back after 4 months asking to offer something else, as she knew that the infection was over and we had really taken care of her in this last 6 months. So in the second stage, reluctantly, but yes, with a lot of conviction, I went in to do a distal femur mega prosthesis for her for the massive defect. And we put a lot of antibiotic loaded stimulant for the antibiotic prophylaxis, and these are the lateral long leg films of the prosthesis. So this is the Adler Restore mega prosthesis, and the 12 years, this is a good flexion of the patient. As you can see, it has gone by, the agony is completely done, the infection has gone by, and we have also reconstructed the massive defect. This is the 1 year follow-up of the distal femur mega prosthesis of the same lady. This is a 3 year follow-up, and it's a healed distal tibia fracture, as you can see down below. And it's a 5 year follow-up of the same lady. So these kind of fractures or these kind of situations which come out of the ordinary require a lot of trauma reconstruction, plus later on a lot of planning and salvaging, and which will go on for so many years, and you have to be with the patient. And I think the take-home message for such kind of cases, revision surgeries are a major threat. You need careful planning, and you have to keep on accepting your problems and your failures. So I have about a couple of minutes. I'll just quickly run through. It was 75-year-old lady with a 9-year-old infected TCAR, 7 surgeries, multiple debridements, shown me once in 8 years. Now the point was whether to go for a 1-stage or 2-stage. This is the original X-ray of the TCAR. She's infected. I did this 2-stage revision after the stage 1 X-rays. So I put this antibiotic spacer and everything after the culture sensitivity and the HPE. But the post-op 2 months period, the ESR was still in hundreds. Even after the radical debridement and antibiotic spacer, the pain was less, but she was not comfortable. The wound was not soaking anymore, but she was still uncomfortable. So if the ESR and CRP are convincingly high and the patient is in discomfort and pain, it means it's still infected in a joint. So being about 77-year-old lady, clinical pictures intraop, distal femur bone loss, you can see with the necrotic cystic infected segment in the 2nd stage with pus ooze from distal canal pus and a foul ooze. So this kind of cases, once you've isolated the organism, there are 2 or 3 strategies now. Either it is a 1-stage revision or it's a 1.5 or a 2-stage. We've already done the 2-stage method, and this time with a chronically infected joint and isolation of the superbug that we had done it for this case. What we did was a radical resection of the whole necrotic segment right up from the distal femur till the proximal tibia, as you can see. And it's a double radical, like a tumor surgeon, though I'm not a tumor surgeon, but we are radically excising all the infected segment in such a case. And we again used a distal femur mega prosthesis at about 77 years of her age, so that around 80-year-old octogenarian can mobilize from day 1. This is the post-op X-ray of the same patient. This is a 1-stage revision we do for octogenarians and septuagenarians now. And this is a follow-up X-ray of the patient. These are the intraop clinical pictures, just 30 seconds. So this is an intraop video. So you can't tap it like a normal TCAR. You have to be very careful. There are special instruments, and very gently you have to put your, the tibia and everything. I'll just move on quickly. And even in the femur, you have to be very gentle once you're putting your implant in, and you have to take the help of the linea aspera and just, take the normal rotation of the femur where it is falling. And after that is the time when you do the connection of the femur to the tibia. It has to be gentle. Everything has to be done very carefully because it's a hinge knee kind of a prosthesis. Even the hinge gives away, it's a problem. So the story doesn't end here. At 3 months, she had a wound gape. So it was not chronically infected now, but it had a wound gape because it had a dead space. So what we did was we put her on a vacuum assisted closure, 2 dressings inside the hospital. And we did her later, we closed the gape primarily by advancing the skin from the medial side after the closure of the dead space with 2 vacuum assisted closure dressings, as I said. And we were able to close the wound at 3 months. Just finishing up, 3 years follow-up. And it's a 4th year running for her. And she's walking now. I've done the other side TCAR also. So the take-home message is multiply operated recalcitrant.
The speakers speak to us about periprosthetic knee fracture. He is not here. We are now proceeding to Sudeep Kumar, intraoperative complications during total knee arthroplasty.
Thank you so much. This is not, I'm not going to talk about anything very fancy here. I'm going to talk about something which easily happens during a severe varus knee or sometimes a valgus knee, is that MCL gives away. Okay. So you know that we do release the deep part of the MCL to get exposure to the joint, but the superficial part is the one that is very important for us, and we don't touch it. We can do some pie crusting some of the times, but many of us have done away from the pie crusting as well. But then the MCL, if it gives away, it's a big disaster because you're not prepared to manage it. In the OT, you don't have the constrained implants probably in most of the scenarios, but so you have to be very, very careful. Okay. It's a rare but a serious complication, leads to instability and poor outcome. Okay. You can't sit on it and you think that, okay, it's going to give up. So incidence wise, I checked the literature, it's 1 to 8%. More common in valgus knee, but then it is also common in a severe varus knees as well. This is what literature says, but I disagree. It is very common in the varus and the common knees that we all do. Okay, and of course, it's not only that these morbidly obese patients, this is just from the literature. In my little experience, I've seen mostly in the varus knee and with the thin patients as well. So it happens because of overzealous medial release. You're not able to balance the flexion and extension gap to push the poly, and when you're extending, this is the time when the MCL gives up, either it avulses or it cracks open. Okay, it can happen with sharp dissection, it can happen with saw blade injury if you are not very careful, but then most of us are mostly careful. It can happen with excessive retraction. That is one thing that you have to be very careful. So stepwise, you have to understand how this happens, how to handle it. Okay. Most important is that mostly unrecognized and denied. Okay. The surgeon will deny, the assistant will say ready to finish it off, but then it is always there. If you want to recognize it, it is there right in front of you. Okay. Suddenly you have tried it with 8 mm poly or whatever, 8, 9, and suddenly now even the 8 is loose and you are able to give 10 or 12, then it's the time that you know that something is wrong and it's mostly the MCL. Okay. So the first is that you expose the tibia nicely. You keep the Homan retractors on the side to prevent the saw blade getting skiving off of the dense hard bone and cutting your MCL. Second is that you remove all the osteophytes. Okay. Release posterior-medially, not dead medially, but posterior-medially, and then you come medially. Do a good reduction osteotomy. That is where you can actually save a lot of MCLs getting damaged and your balance getting good. You may use the pie crust if it is not coming, and you may elevate the superficial MCL, but be very, very careful. Okay. Sometimes you get this much of osteophyte removing. This is not only from tibia. Okay. It's not from tibia, from femur and all. You can get this much of the extra bone. And when you are releasing, you will find that there is a lot of bone lying dead posterior. Okay, I'm just trying to go fast. And these are the times that you don't release anything. You take out these bones which are lying stuck. These are broken osteophytes or the medial part of the bone, and you take it out and then suddenly find that your release has happened. Okay, you don't want to touch the soft tissue. Remember, all these things you have to plan well in advance. And if you want to release, you have to go dead posterior. You go dead posterior. This is where you start posterior. This is where your capsule is struck, and this is where the easy part is there. Okay, you can see that I am subluxating, trying to release posterior rather than dead medial. I am trying to salvage, keep my superficial MCL intact, because this is what is going to save me in longer run. Okay, and of course, if you are not going in the first go, you just release it, shape the tibia, cut it, and then of course you will be able to go in the next go. But then these are all sequential. Everything, steps have to be kept in mind, that how to go sequential. So coming back to the MCL injury, it could be partial or complete, iatrogenic or traumatic. It could just be a bony avulsion, okay, or a mid-substance tear. If you can identify the mid-substance tear, you can repair it directly. Feel it, intraoperative valgus instability, post-op giving away, okay, flexion gap becomes used as I just mentioned. So you have to see what you can do. Now coming back to what you can do. So mid-substance tear you can release, you can repair actually. If it's a high demand patient, then you can take a graft and repair it then and there, like an MCL repair reconstruction that we do, or repair that we do in scopy patients. Okay, you can, if it's a bony avulsion, easy part, you can put some screws, suture ankles and staple. Okay, you can augment with graft as well. These are some of the descriptive picture. You can just augment, repair. You have allograft, which we don't get. You can harvest the semi-T, which is right there, and you can repair it with bio screws. But then remember, all these things are not present in most of these OTs. When you're doing a joint, probably you will not be having a bio screw or some suture ankle. If you are, that's good, but keep that in mind, how you will manage, okay, because this can easily happen. These are some pictures from literature, not my pictures. So I'll just skip with the want of time. Screws, what we normally do, these are some of my cases. We have done screws, the big bony avulsion, and these bony avulsions do very well actually. You brace them for 4 weeks, maybe 6 weeks, depending upon patient, then give them range, the range comes back. And of course you can change the implant. You can go to some constrained implants, but remember, you might not be having it in your OT. If you have it, it's better to change if you're not committed yet. You just probably have to take a deeper notch cut and change it along with repair or reconstruction of your MCL. Post-op, I've said. So this was one Korean study in 2009. They said that 15 patients, they recognize it post-op, and they just brace them for 2 weeks. I don't brace them for 2 weeks, I brace them for at least 4 weeks. I'm a little bit more conservative, 4 to 6 weeks. Don't give them flexion. Start flexion after 2 to 3 weeks, and I go very gentle. So rare but critical complication, early recognition and management is very, very essential. So I think I'll stop on MCL only because that's the one complication. Thank you so much. Thank you.
Thank you, Sudeep. We'll take the questions at the end of the session. Now I invite Dr. Nishikant Kumar. Disastroplasty, impossibly difficult joint replacement.
From the outset, I would like to thank Amulya sir for giving me the opportunity. So, I shall be talking about disastroplasty. I don't know whether this noun or adjective has ever surfaced or not. So, don't get confused with traumaplasty. Traumaplasty is basically for arthroplasty in traumatic conditions. Disastroplasty is somewhere in between, mostly for arthroplasty for cases that are disastrous, mostly complex primaries and revisions. So, I know everyone is aware of this Harry Potter. For those who don't, so this is a fictional novel by J.K. Rowling. So this story of a young chap who is an orphan, who lives with a very mean uncle and aunt and a very obnoxious cousin. Very lately, by the age of 11, he realized that he's a wizard. And to enhance his wizard skills, he has to visit a school, that's Hogwarts. And for these, he needs some stuff. From where he will get this all stuff? And that's Diagon Alley. So where's Diagon Alley? Diagon Alley is a place in the heart of the London, which is behind a bar. There's a brick wall, and you tap these 3 bricks, and this brick wall opens. And that's Diagon Alley. So disastroplasty is actually a Diagon Alley for arthroplasty surgeons, where only wizards can visit. So what I have done, I have compiled few of the cases which are really disastrous and how I have dealt with them. So this is a case of bony ankylosis, did the tibial tuberculostomy and came to plasty with size 8 poly. And this is the range of motion on day 1. These are follow-ups. Now she got convinced and agreed for the next knee as well. And this is the 4-year follow-up. And you can see the range of motion. There's no extension lag, and came out on the both sides with a simple primary knee arthroplasty. Another case of a very popular politician's wife of Bihar developed this acetabular fracture, fixed in Patna with this kind of construct, failed, went to, which is very common in Biharis, they always prefer going to Delhi. Someone did this dual mobility hip arthroplasty, got infected, revised there, wound department was done. Now came with this kind of septic loosening. So decided to do it in 2 stages. Stage 1, removed all the implants. So the acetabulum was totally flat. So decided to do the customized implantation in this. So this was the acetabular. So I decided to use the integrating case in this, which is made by the Judgel. So this was the customized implant where you can direct your screws according to your wish. So this was the intra picture. Use this cage, implanted a cemented dual mobility cup inside, and this is the follow-up. You can see this pubic rami screws, which will give the extra stability, and this is the 2-year follow-up. Another case done at Hyderabad, 7 years post-op. The exotic implants was used, which I think they. So if 7 years with this kind of loosening, bone loss, this is the lateral views. So this was the intra knee, no constraints, size 10 poly for the both side. And this is the 1-year follow-up I have. Another case, simple primary distal femur fractures, fixed at some center by this, destined to fail. These are the follow-ups. Went to Chandigarh. Someone did this, the Badwas, very great surgeon. So patient did very well for 10 years. At 10-year follow-up, presented with this. So decided to revise it. There's a huge metallosis inside. So there was a metal on metal wear. The poly got worn out, and this whole metallic component was rubbing over the femoral component. Whole metallic component was rubbing over the femoral component. So this was this implant. So this was the part which worn out. So revised it. So mega prosthesis was revised with this. Another case, 70 years, neck femur fracture. Someone did this bipolar arthroplasty, developed this periprosthetic fracture. Someone did this fixation. Subsequent follow-ups, this failed. Came to me, subsequent follow-ups, this failed. Came to me, used this hip arthroplasty with tapered fluted vaginal stem, size 14, 2 to 5. Size 14 don't have 265, that was my fault. Augmented with a plate, again, kept on the follow-up, fault. Augmented with a plate, again, kept on the follow-up. Now, this is a 1-year follow-up, and the patient is doing good. Another case, robotic. This is the new term everybody is obsessed with, and I am getting a complication of robotic, I think, every week. And I am revising robotics every week. So this is a case by Meko, intraop periprosthetic fracture. Surgeon put a plate over it. Follow-up, 2 months, 8 months, the plate broke. So CR knee, robotics, failed. Presented with this. So this is a CR knee. So I had to use a different kind of nail into it. We call it 10-degree Herzog's bend RFNA. So put this new synthesis RFNA with 10-degree Herzog's bend, and we augmented with a plate as well. This is the construct. The 3-month follow-up. This is a 2-year follow-up. Now the fracture is united. Another case, patient from Nepal with this kind of open injuries, with this kind of construct over the knee, the patella was fractured, the fracture the subtrochanteric region as well. So someone did this X-fix with managing the soft tissues. The patella was fractured, was managed with K-wires. Nailing was done in the subtrochanteric region, taken out, got infected. So someone did this at CMC Vellore, this wound embedment and putting the cement spacers. Came to me for range of motions and painlessness. Use this Indo model hinge. And this is the patient. I have 4 years follow-up this patient, and this patient is doing good as well. So thanks a lot for your patient hearing.
Thank you, Dr. Nishikant. And now may I invite Dr. Ranjit Kumar Singh, who will be speaking on management of neglected dislocation after THR.
Thank you, Chairman, and thank you, Amulya, for giving me this opportunity. Nishikant saw a lot of cases. I have just one. So, this is a clinical presentation. 65-year-old female, inability to ambulate for 8 months, severe right hip pain with deformity, marked functional disability. This was the X-ray she presented with. Looks like anterior dislocation and highly anteverted cemented cup. CT was also with the patient. Acetabular cup was found to be excessively anteverted. Clinical course, October 2023, sustained right fracture neck of femur, underwent cemented THR. Day 3, developed painful deformity with inability to mobilize, underwent close reduction under GA. Persistent recurrent dislocation noted in follow-up, managed with repeat reduction and hip spica. Persistent pain and inability to ambulate after spica removal, referred to higher center. And then patient came to me with this X-ray. This was a case of anterior dislocation of the right prosthetic hip, excessive anteversion of the acetabular cup. On CT, though it's not very important, it was 40 degree, radiographic about 28 degree. There are different ways of measuring anteversion in AP view, I prefer Leo or Levenick, inverse sin into D1 by D2 sort of. Suboptimal femoral stem cementation is also there. Then why this operative and what you call radiographic anteversion? There is a difference. One, for so many people who are not aware, what you do at or observe at the time of operation and what do you find out in the radiograph, there is a difference, and that is quite logical. There is a difference. Suppose, and so many people have come up with this, so many formulas, but generally 8 to 10 degree, what you get provide at the time of operation as anteversion, if you look at the X-ray, it is less by 8 to 10 degree, while the inclination increases by about 2 to 5 degree. So you have to keep in mind, because you have to target your cup position according to Levenick safe zone, but same should not be done at the time of operation. So this is why does it happen. So this picture, because we look at the orthogonal to the, handle of the introducer, while the X-ray looks perpendicular to the body. That's why the difference. So surgical management, revision surgery performed via posterior approach. Original was also posterior. Acetabular component removed. Cemented dual mobility. DM cup implanted. Target radiograph, we have planned for 15 degree of radiographic or less than 15 degree of radiographic anteversion. So operative target for operative anteversion was something around 20 and 21 around, or 22, something around 20. So get a radiographic anteversion of less than 15 degree. Femoral stem evaluated intraoperatively, stem found to be stable, and patient was not behaving well on the table. Anesthetist was giving you warning, so stem was retained in view of patient's deteriorating intraoperative condition. This is the postoperative picture. We measured the combined version also. It found to be very stable. This is the post-operative X-ray. A stable reduction achieved. DM cup in satisfactory position. Femoral stem retained. And this is 6 weeks follow-up from her home. She is from Sitamarhi. She cannot get X-ray also because her village is any center where she can get an X-ray is 25 kilometers from her village at the Nepal-India border. And now after 1 year, 9 months, she has sent me this video recently but couldn't send me the X-ray because she lives with her daughter-in-law and grandson, and her son lives in Bhopal. So I am unable to provide the X-rays, but she is doing fine. So key challenges in management: chronic neglected dislocation, unusual anterior instability following THR, soft tissue contracture, malposition components, particularly acetabular version. The surgeon was doing it from posteriorly and just being apprehensive that it doesn't dislocate, he anteverted the cuff excessively. Malposition components, particularly anteversion, difficulty restoring hip biomechanics and soft tissue tension, revision in a functionally and medically compromised patient. Neglected anterior dislocation after cemented THR is uncommon and technically demanding careful preoperative planning, correction of acetabular malposition, a use of a cemented dual cup mobility construct can provide acetable reduction and satisfactory functional outcome. Thank you.
Thank you, sir. Now may I invite Tanna sir for his talk on tension band wiring.
Powell in 1935 demonstrated an application of engineering principles of tension band. Uninterrupted I-beam connects. When you put a pressure on one side, it compresses here and it distracts on the opposite side. Spring in the same side compresses and spring on the opposite side distracts. If the tension band is applied on the opposite side, this is the way which we do the operation. Tension is resisted and uniform compression occurs on both sides. This is the basic principle of tension band. Now, how do you make a wire? This is the way first you have to make a wire for a tension band. Put it onto the gun, power gun, hold it on the opposite side. And then just it will become a good and straight one, so there will be no loops in the wire. And now the wire has been ready for the tension band. The tension band which is being done normally in a patella fracture is you put a K wires, and majority of the people do the tension wire around the K. This is a Indian copy of an imported instrument which is available in Indian things. So I do not like to tighten with the pliers, so it is use a single loop With the pliers, many people use it because if you don't have the higher Harris wire tightener, you do it with the plier and it doesn't work all the time efficiently. And in the olecranon, how do you put the wire? Make a small cuts in the triceps, put the wires back right inside into the bone through those triceps muscle cuts, and put in the tension band not on the wire but around underneath the triceps. This is the one which is described. But still 95% of the people do the tension band around the wire. That works at times, it doesn't work at times. If the wire becomes loose, it will not work. So oblique fracture, you can do a leg and then can do a tension band. And this is the patella. Surgeon did it around the wire, he did the tension band. Once the wire becomes loose, the tension is gone. That's the reason the wire has to be behind the triceps and not around the wire. Then even if the wire becomes loose, the compression will not go. Now here the patella wire which is there, which is non-union, which you're doing it, cerclage wire and the tension band, and you are really trying to neutralize it because it is a non-union. You are trying to utilize with putting another wire in the tibial tuberosity. And this is the one which will give you a good time. These are another uses of a tension band which you can do it very well into the GT fractures in the trochanter and the GT fracture in the humerus. The medial malleolus, I feel if there is a medial malleolus which is there, first wire should go vertical to the medial malleolus. In a distal transverse fracture I am talking about, and do the tension band. Otherwise the medial malleolus, which is a lower down fracture, it will not be able to get the compression which you desire. These are the ones which are typical tension band wire which you see. It has to go around the deltoid, around the supraspinatus. If it goes around the wire, again it doesn't work effectively. All these are the ones which has been seen what is exactly the tension band principle works. Now these are the beautifully one done when there is a lower down fracture. This is not a tension band principle. This is only immobilization. Two wires and the wire here baiting, doesn't work on the tension band principle. When you flex it, it has nothing to do with it. So this is also the use of we talk it as a tension band wire, but this is not a tension band wire. This is actually the immobilization. So double tension, this is the one which works very well into the lower end of the femur. Now, majority of the people when they do the GT wiring, it goes around the soft tissues. If you go from posterior to anterior, you have to go through the anterior to the posterior. This is again, it is in the soft tissues. Basically, you have to go to the anterior to the posterior, and then only you will be around the bone, and that is the only tension band which works. Don't go from posterior to anterior, you will be muscles. So in conclusion, most fascinating engineering principle adopted in the orthopedics, and this is the one which if you've done it properly, I think it gives you a marvelous results. Thank you very much.
Thank you very much. Sir, please stay back on the stage. I invite all the speakers to come on stage for an interaction with the audience. Ajit, you can bring the plate along. Mics for the speakers. Any questions from the audience? I have one question for Ajit. Have you considered, there's a mic here. Have you considered publishing your work?
It's been
in the pipeline.
Yeah, follow-ups are the problem. We have a huge series. The follow-ups are a problem. So I think there are about almost 30% who are not come back. So we're just working on that.
Okay.
But the principle has been published in the Injury in 2019 as technical.
So, Dr. Ajit,
Yes,
you do a lot of arthroplasty also. So, what will be your indication for arthroplasty in a young fracture neck of femur?
I think almost always no, sir. I can't remember. I mean, if it is associated neck with Pipkin, that's a different issue. There are 2 instances where I've done a total hip in this neck with Pipkin, 2 cases. In under 30, I have done a total hip. But otherwise, almost always it is fixation. Yes, there have been failures. And just now Dr. Rastogi was showing one case where he had done an open reduction very elegantly and put a plate there. We had done 3 cases, 2 of them failed in young people. So those I had to convert. But primarily only 2 patients, one was actually distributing his wedding card when he met with an accident. So we had to do his total hip in a primary situation.
Above 60, 65, 70. Still you will try to fix it up?
No, sir. No, sir.
Sir, what difficulty, Ajit sir, you find in doing arthroplasty when it fails DHS with a lot of screws? What difficulty you find during revision, during doing arthroplasty?
Yeah, I mean, really not much of a difficulty because it's like doing a difficult primary. The problem is getting the gadgetry out and then having appropriate implants, the long stem if you need to, that sort of thing.
It's not difficult for Ajit sir now, it is all difficult for us.
It's a difficult primary, it is difficult. It is difficult, but now No, I was asked to talk on a difficult primary hip. I told him that all my primaries are difficult, you know.
So it is for you or for everybody is difficult? You think?
I don't know. I mean, they are master surgeons.
This is for Dr. Ajit again. I saw a number of your cases, like your quest for going in for an absolute fixation. You have taken a good compression and an absolute fixation. You have gone up to the tune of putting in 3 6.5 mm screws along with the DHS. So that is a 19.5 and an 8.5. Works out to be maybe a 28 millimeter inside. Does it ever bother you, like how much of bone are you leaving over there? Does it make a difference, or just the absolute fixation that you are aiming for that neck fracture?
Yeah,
is
so
good enough.
the main problem with fracture necks in all the fixation devices that we have is the so-called control collapse or whatever. That shortens the neck even if it unites, and they do have a lurch, and we are talking about young individuals here. So in the long run, the failures or the collapse will lead to long-term problems. So the thing is, people have moved away from the concept of controlled collapse or whatever. I mean, it's the sort of similar. If you are using a DHS, it's the same for an IT fracture that you're talking about. So now people have come with what you call angle stable fixation concept. So this is one modification of the same thing.
Yes.
The only issue is in adult males we can get that many screws, but in young ladies it's a little difficult.
Yeah, like that angle stable fixation concept, like it is total absolute fixation because you're getting from 2 sides. And how do you compare it with BDSF? Have you gone through BDSF?
Yes, we have done. I found it a bit of a struggle, and because the literature, there were case reports of subtrochanteric fractures or iatrogenic fractures with this technique, because nowadays the youngsters push me out of the theater and they do the things. So I said, if I have a subtroch fracture, I can explain to the individuals that I did it and it happened. But if I say you did it and it happened, then it's very difficult for me to explain to the relatives. So in my unit, we don't do BDSF now.
Okay, because in my input I have done a lot of BDSF.
Yes,
I have found it very successful. But इसके माँ बाप नहीं है इसको promote करने के लिए कि कोई बड़ा company वाला है कुछ करने के लिए. तो it's a very simple and a very forgiving technique, and I have not found many cases that have actually failed. Sir, तो खैर master बताइए. Sir, आपका comment.
Basically, the concept today is to avoid a collapse.
Total collapse.
Because if you has a collapses, there will be a lurch and they will not be able to walk for a long time, as you know it very well. Yes. So any fixation, like BDSF, which is non-parallel fixation, that screw which you put in, it will not allow you the collapse after compressing it initially, or you change it with the fully threaded screws. So that a rigid fixation has now become
the goal after initial compression, you do not allow further compression. So your BDSF works exactly in the same way, changing the screws and all the newer implants which have come or putting in the plate, all of them, they work on the same principle. Whether it works or no, still it has not been established. Okay. So it is still at the moment hypothetical that this will be able to work. It is still being considered.
Thank
and
you,
the
sir.
issue is now they talk about it in 60s or a late 50s. If you get a collapse, you will have a lurch and all. So with the good results of THR, you go ahead and do a THR, 30 years of results are very good in a person who is going to be a table and chair life. Probably in the village still it is not valid.
Thank you, sir. Yeah, please. Dr. Amulya, can you come on the stage for the group photograph? Until then, we can have one more question. Yeah.
Ajit, you are using a dynamic implant.
Yes, sir.
And you are propagating that it is a stable fixation, like a rigid fixation where you don't want collapse.
Yes.
But if you go retrospectively in all your x-rays, there is a collapse.
There will be a little bit, yes.
Yes. So you are propagating it, there will be no collapse. So in a dynamic situation, the collapse is evident. And therefore there is a Tanasar has said that the concept of rigid compression and then no further collapse. This is the recent trend. But your method of doing this dynamic principle and a single screw of a Powell's with again a dynamic implant, I don't think it will work, because in a long term probably you will have a non-union or...
No, sir. 80 odd cases. We have more than 80 odd cases with this technique. And I think there are just 2 failures or 3 failures. That's it. I can show you the entire series on my phone.
No, I don't...
The only problem is whether there is a little more collapse than what we started off with. Yes, that is there.
I think neck femur being an intra-articular fracture, we need absolute stability for direct healing. The 2-3 screws that we are additionally adding is going to avoid the excessive collapse which the dynamic screw will cause. So it will collapse a little bit, but it will unite.
I think, Doctor, this discussion can go on throughout the day. So I think we have to move on. Yeah, please.
I have a question. What was
They must be want that CT angio vascular thing. Everything has to be done. Work up. You will see this result.
For the next moderator, Dr. Srijan. Yeah, please. Dr. Srijan, the young budding orthopedic surgeon, is here.
Good morning, everyone. I am Dr. Srijan Prasad, a second-year PG resident from Saharsa. Thanks a ton Gofcon and Dr. Amulya sir for having me as a moderator today. I would like to call upon our esteemed chairpersons, Dr. Bharat Singh sir, Dr. Kanhaiya Singh sir, Dr. Amit Rastogi sir, Dr. Bhuvan Singh sir, and Dr. Samarth Mittal sir. Thank you so much. Thank you. Thank you. I would like to call upon the first speaker, Dr. Bharat Raju sir, for management of coronoid fractures.
Good morning, everyone. At the outset, I would like to thank Amulya Bhai, the GOF team, the Global Orthopaedic Forum team, and the BR Orthopaedic Association for inviting me again and giving me an opportunity to be a part of this tremendous Gofcon 2026. I'll be speaking about coronoid fractures management. So anatomy, as you all know, it provides around 50% of the constraint for the anterior elbow translation. It also acts as an anterior buttress. It provides attachment to major stabilizers of the elbow. The coronoid tip is less significant for stability as it's a small fragment. But whereas the coronoid base is very important for ligamentous attachment and also for load bearing, the medial facet of the coronoid is important for varus stability. Ligamentous anatomy, the medial collateral ligament complex, of which the anterior band plays a crucial role. In the lateral collateral ligament complex, the lateral ulnar collateral ligament is a primary stabilizer. The articular orientation, the distal humerus is angled approximately 30 degrees anteriorly, whereas the semilunar fossa faces backwards. So this complementary alignment helps the coronoid to resist backward dislocation and also contributes for joint stability. Most of the time it's a traumatic shear injury. Isolated fractures are less common. Most of the times it is associated with other injuries. It is never an avulsion injury, as nothing inserts to the tip of the coronoid. The commonest associated injuries are the posteromedial rotatory instability, the posterolateral rotatory instability, olecranon fracture dislocation, the terrible triad of the elbow. Clinically, it presents with pain and swelling, restricted range of movements, ecchymosis, varus instability or posterolateral instability. There might be associated neurovascular compromise and other associated injuries. Classically, the radiographs anterior-posterior, sometimes it might not be sufficient. You can also get a radial head capitellar view. The limitations are small fragments can be missed. There are overlapping structures. The fracture pattern is not well defined. So CT is the gold standard to plan your management, and it's essential to rule out the other injuries around the elbow. Classifications, earlier classified by Regan-Murray, 3 types, less than 25, based on the coronoid height, from 25 to 50 and more than 50. The old Driscoll classification, which takes into account the tip fracture, the anteromedial fracture and the basal fracture, and further subclassified. Coming to the management, primary goal is to restore and maintain the elbow stability. Non-operative indications are, if the fragment is less than 25%, you immobilize, followed by early range of motion exercises. Indications for operative management: a displaced fragment which is more than 25%, elbow instability, or a failed conservative management. Various approaches: the Cocker's medial approach or the anterior approach. These approaches should address the associated injuries. Anterior approach, it provides direct access to the coronoid fractures, especially in case of isolated or anteromedial type of fractures. It offers an excellent exposure when compared to other approaches. Indications are large anteromedial fragment or a basal fracture which requires a direct anterior-posterior screw fixation or a buttress plating. When the optimal visualization of the coronoid base is necessary, it provides more than 2 centimeters square of surface area exposure compared to other approaches. Various fixation methods: if it's a small fragment, you can go in for a suture lasso technique. Medium fragments, screws or headless screws. Large comminuted fragments, always better to have a buttress plate fixation. So always flex the elbow to relax the brachialis and reduce the coronoid. Under direct vision, you can provisionally fix it with K-wires, and a lag screw can be applied, and a low profile buttress plate to counter the forces. So you apply the buttress plate. First you put the proximal screw, don't tighten it, rotate the plate, Then fix it with the second screw, tighten the first screw after achieving compression, and then fix the distal screw. Advantages of the anterior, as I already told, it gives a wide and clear operative field. More than twice the coronoid surface area is visualized compared to other approaches. And it is ideal for complex fractures, and it also supports early post-op post-fixation mobilization. Disadvantages, it's more technically demanding. There is a risk of iatrogenic injury to the neurovascular structures, potential for flexion contracture if not mobilized early. The suture lasso technique, it's better biomechanical fixation than the traditional open reduction and internal fixation, less chances of implant failure. The technique, you use a flexible suture fixation which allows dynamic stabilization. It is preferred in terrible triad injuries. Outcomes are excellent range of movement and the Mayo elbow scores. So it is ideal for small type 1 and type 2 fractures. So you drill a hole from the dorsal aspect to the coronoid base. The hole should be as far apart as possible within the fracture bed. Then you reduce it again by flexing the elbow and passing the suture around the capsule if possible. Avoid passing it through the brachialis as it might cause displacement. Coming to terrible triad, I think this has already been discussed yesterday. The treatment hierarchy, you always treat the radial head first, then the lateral collateral ligament complex, then the coronoid. The various options for radial head are open reduction, internal fixation or arthroplasty. Coronoid suture lasso is the preferred technique. So this is an example of a terrible triad managed with suture lasso technique and plate fixation for the radius. Post-operative care is very important. You start immediately, you immobilize, and early range of movement should be started within a week. Active assisted range of motion within 1 to 6 weeks, progressing to strength training based on radiological healing after 6 weeks. Outcomes, a favorable Mayo elbow performance score of 80 is assumed to be good outcome. Potential complications are implant failure, heterotropic ossification, which is very common, stiffness, neurovascular injury, and infection. So, a study by Hub D. Clark et al. Has shown that coronoid fractures in traumatic elbow instability, the coronoid process is key to the concentric elbow alignment. Malalignment can contribute to post-traumatic osteoarthritis. So recommendations are for small isolated fractures, conservative treatment with early range of motion, displaced or unstable fragment, open reduction or suture lasso. Terrible triad, always treat the head first, then suture lasso for coronoid. CT is mandatory. Functional outcome depends on the associated injuries along with the coronal plate. Thank you. With this, I seek your blessings and support to be your voice at IOA as Secretary General. Thank you.
Thank you, Dr. Bharat. And with that, we have Dr. Naveen Thakkar speaking on distal ADS fractures, a cost-effective, minimally invasive fixation alternative.
Good morning to everybody. We are thankful to Dr. Amulya Kumar and team and the Gofcon for allowing us to share, contribute and learn together. Chalu hai? So we are going to have a possibility, one of the possibility of stable fixation, cost-effective rational fixation. I request you all for registration for IOCON 2026. This is your conference. This is for this subset of the patient where these patients are economically compromised patients. Why we are thinking so for the distal radius? What are the problems? What are the pitfalls? And how we can plan to avoid these pitfalls and how we can solve this problem. If you see the literature, these are the problems, controversies. When to what? Anatomical reconstruction, acceptable limit, function, extra fixation, internal fixation, implant,
what to do, all these problems. And there is a spectrum of the treatment, non-operative to arthroscopic assisted reduction and fixation, with increasing complexity and the cost both. This is the question. Everyone wants this goal. Is the anatomical reduction is must? Let us explore this. This is the patient, woman at time of surgery, age 74 years, displaced in the cast. What next? Dr. Piyush, can you say what will you do? Surgeon has done the cast but it is displaced. Now what will you do? Sir को mic देंगे कोई? It is not acceptable. Okay, what will you do? Pleating?
Definitely, sir.
Time is less, that's why I am just leading you. So exactly what you said, the surgeon has done the pleating and he has checked arthroscopically also. Anatomical reduction. Is it okay? What do you think?
I think, I don't think it is okay, sir.
What is the problem? It is not okay. That means some problem. What is the problem?
Radial height and ulnar stellar avulsion TFCC.
What will happen?
Stiffness.
Stiffness. Okay, let us see what happens. After this 9 years, this is the X-ray. But the function is good. X-ray is bad, but the function is good. You can see the clinical function and the X-ray. Patient is happy. Now, let us continue with Piyush Bhai only. Again a patient, conservative cast treatment, reduction is done by the surgeon like this. Will you accept this?
Radiologically and theoretically not acceptable.
Not acceptable, right. You are right. But again after 10 years, X-ray is bad, but the function is good. So the next question comes to our mind that this author, Jupiter and all, they said in the benchmark paper in 1986, anatomy is must, right?
Yeah.
Now the same group has said, same authors, anatomy is not must. So we are changing. He said one conspicuous question has become evident: to what extent are these conclusions clinically relevant? After long-term outcome studies have demonstrated that the intra-articular malalignment does not necessarily correlate with the loss of clinical function and the patient satisfaction. So even among the highly active elderly, this is the paper. Another paper, anatomy is not must. Another paper, RCT in the Journal of Hand and Surgery, functional outcome is same. Multiple RCTs are compared, functional outcome measured for each modality, and for the plate 22 to 27% complication rate. It is reported in the literature. Again a paper, fracture of the risk factors for complication after low volar pleating, and you can see these are the number of patients in this study, early and late complications. So we are getting newer and newer designs for every fragment, every type. Even if you see in the market, every new plates are coming. Again a study, no radiological correlation with the function, increased cost, increased complication. These are the various literatures. Is there a possibility of low cost fixation alternative with the stability? We know the radial column, we know the intermediate column, we know the ulnar column. We know these are the low transmission pattern, just like a proximal femur trabecular pattern. It is very strong here, it is weak here. We know this. So this is one of the alternative possibility. This is not the only method. What I am presenting is alternative method possibility for a certain subset of patient where you can do a wrist block, hematoma block, gyroadrenaline in this part, and once you do, you check it, manipulate, it is painless. Once it is done, you reduce under C-arm like this. Once it is reduced, a stab incision here, and the first wire from volar to dorsal and from radial side to ulnar side to fix this radial column, and the next wire from dorsal to volar, ulnar entry, and in this trajectory for this fragment intermediary. and then bending of the wire like this. Once you bend the wire, you join this. Linking is very important. Linking of the wires with the link joints and two rods to get the stability on table itself, and you can check the stability on table. This is the final fixation and the padding and the dressing. And you can check on the C-arm the stability. You can check every movement on table itself because of the only a wrist block. And patient walks as a daycare from the OT itself. Another, all three column fixation, this is a possibility. Wrist block, again this column, and the ulnar column also fixed, and all together made one implant joined with the link joints. And once it is linked with all this, then it gives the stability. Another possibility, volar part. Usually we do the volar plating for this, but for a cost effectiveness, you can put a incision, reach to the bone, and then you can put a volar to dorsal wire, and you can fix also. This is also a possibility. Again, another patient where you choose the same series of the block and everything. Each fracture requires a different plane of the stability, and you get the flexibility where to put the wire. You may have to change the position of the wire in each case. You can put the 4 wires, 2 here, 2 here, to get the stability. If you feel that ulnar column is required, then you can add the 1 wire more. This is the alternate method. Again, the question was punch. Yes, punch also can also be treated with this. You can raise that and you can fix it. Rim fracture, nothing is possible with the plate. Then you can have a distraction plate. Here is the one case where you can see that distraction place and the teardrop is fixed. There is a proximal fracture and the distal fracture, where you put this distraction plate that gives rise to your complete stability, but still the teardrop is remaining. You have to take care of the teardrop. So teardrop is again here put with the minimally invasive one screw here from ear tip to here. In the lateral view you can see here, screw has been made here. So these are the possibilities in the distal radius. So learning point is radiological outcome in elderly does not match with the functional outcome. Identify distal fracture where it requires according to column fixation. Whatever the method you choose, either you plate or anything, but the column has to be taken care of, irrespective of the implants. Thank you very much. Thanks, sir. The team IOCON is working very hard, and the work is going on a daily basis. These are the 3D images of planning has been going on there. So we all invite you at the IOCON 2026 Ahmedabad Mahatma Mandir from 1st to 6th December. Thank you.
Yeah. Right, Amit. Dr. Amit Ajgankar for Masonov fracture.
So, what is a Maisonneuve fracture? Prasham Shah sir? No, don't remember. Acha, theek hai. Ranjit sir? Maisonneuve fracture. नहीं, just ऐसे इतना simple topic है sir. क्या उसमें Maisonneuve fracture? Chalo, look. Whenever a patient comes to you with a swelling at the ankle, and the patient is pointing out that there is a pain somewhere there, up, just below the knee joint on the lateral side, then you have to always suspect something. That index of suspicion always has to be there. Ankle x-rays were taken first because there was swelling over there. Many times what we do is we take x-rays of the knee joint and chalo plaster kar dalte hain. What is the science behind this? Most of us know. You all seniors, trauma surgeons must be knowing, but then I'm talking for the others. Look, this was what had happened down there at the ankle. And up there, there is a fracture. It's an oblique or a spiral fracture of the upper end of the fibula. How does this happen? There is an interosseous membrane between the tibia and the fibula. What happens is external rotation of the talus goes externally rotated, and then it pulls on the medial complex, that's a deltoid, which gets ruptured. Then the anterior tibiofibular joint ligament gets ruptured, that's one of the syndesmotic ligaments. Then slowly the interosseous also starts rupturing, and it ruptures right till the up there until it forms a fracture over there. All the forces come out from this fracture. So this is a mesonev injury and not a fracture. It should be called as a mesonev injury, and you have to always, this is a very, very grievous injury in orthopedics. This is a syndesmotic injury. Mesonev fractures involving the fracture of the proximal fibula associated with an occult fracture injury at the ankle. Always suspect something at the ankle. There is a ruptured interosseous, syndesmotic rupture, and a deltoid ligament also which can be torn. So, proximal fibular fracture alone can give rise to ankle injury and it can be missed. Sprain of the ankle, you have to take x-rays of the proximal side also. So, in Hall, I now remember what and I really appreciate, he has taught me so many things. When we used to present cases as students, he used to tell us one joint above, one joint below, the whole leg, tibia fibula, you have to take x-rays. This is the teaching, you know. And now, after so many years, I am talking about it. No. No, sir. Thanks a lot that you have taught us so much. Long leg films that include the ankle is mandatory in all these cases. Patient with a proximal fibula fracture, you have to exclude the presence of an ankle injury. Always, I'll show you some case examples. Unexplained increase in the medial clear space without a fracture. In the ankle, there might be no fracture. You have to get a proper mortised view. And unexplained increase in the medial space, this space, the tibiofibular overlap. Tibiofibular open space is there. So there you have to go down. Medial clear space you have to see, and the tibiofibular clear space should be less than 5 mm always. You have to treat it. You have to treat it even if there is no bony injury. Pass 2 screws, pass 3 screws or a plate, whatever you want, at least fix your syndesmosis. And even after that fixation, by the external rotation test, your medial clear space is opening, then what are you going to do? To suture your deltoid ligament. So this is a grievous injury. You don't consider mesonev fracture, you might not do anything for that, the upper end of the fibula. You have to fix your ankle, which is very, very important. Look at this. So common is it is to miss. And here, down there, you can also have a shaft fracture. High fibula fracture. Many a times what happens is that high fibula fracture and you just have a posterior malleolus. Posterior malleolus fracture on the AP view or on the lateral. Sometimes, many times it can be missed if you don't have any malleolar injuries. That's the posterior, that's the third malleolus. It is because the posterior tibiofibular ligament is ruptured. So you have to note that. All these are avulsion fractures, if at all, or ligament injuries. It's a fracture dislocation resulting from external rotation forces at the ankle through the interosseous ligament to the fibula. Proximal fibula fracture from external rotation forces to, it causes a spiral and oblique. Now, a mesonev fracture always is a spiral and oblique fracture. Whenever you have a proximal fibula fracture, which is a transverse fracture or a comminuted fracture, just last 2 days back, I had a patient, I had a relative of mine, a road traffic accident, and she had a proximal this fibula fracture. But it was comminuted, it was transverse fracture, but yet we got an ankle x-ray done. Ankle was absolutely normal and no pain, nothing. The squeeze test, you have to do a squeeze test at the ankle joint, so just to note the injury at the syndesmotic level. Ankle components could be medial malleolus avulsion or deltoid ligament rupture, simple. An anterior talofibular ligament rupture or an interosseous ligament rupture or a posterior malleolus. So everything, you can have anything down there. You have to have an index of suspicion and get proper x-rays, if not get CT scans or any further scans. So mesonev injury is a syndesmotic injury always, and a syndesmotic injury requires a reduction and fixation. So in all, a mesonev fracture will require a reduction and fixation of the ankle. and not of that fracture. So that is the significance. You have to reduce and fix your ankle and get your syndesmotic fibula back into your incisura and fix it with screws. Look this way. High index of suspicion is necessary to diagnose and treat this injury. Again, look, this is a mesoneum fracture and this ruptured intraosseous syndesmotic rupture, torn deltoid, and it can cause posterior or deltoid ligament ruptures also. Look at this here again. Down there we did this and we had this fracture. Another mesoneum type of upper fibula fracture, a spiral one, and we had to fix this down there. Now this is another fracture of a medial as well as a posterior malleolus. We went up and there was a mesoneum fracture. So always suspect this. The intraosseous ligament is gone. This is a 48-year-old male, road traffic accident. No bony injuries. But there is a fibula fracture up there, mesoneum fracture. This is the mesoneum fracture. But look at this. There is a medial clear space which is opening. There is a tibiofibular overlap which is not there. So we went down and we had to fix this with a tight rope and a screw. This is a 38-year-old female, pain in the ankle, medial clear space open. There is a mesoneum fracture up. Went down and put the screw with a tight rope fixation. This is another case, a mesoneum fracture. And look, it can have a shaft femur fracture, shaft tibia fracture also. But what we missed was this. This lady had come from UK. She's a UK citizen and had operated it on an emergency basis. On table, I was not, this was around 12-15 years back. So posterior malleus concept I did not have. And mesoneum also concept I did not have. I came to know that this is this way. So on table, I realized that there was a posterior malleus fracture. I put one screw and that did well. She went back and she sent me these x-rays and it had all united later. Concluding, upper end fibula fractures should lead all of us to take x-rays of the ankle and the shaft. Any ankle syndesmotic injury, an x-ray of the proximal fibula is a must. If one has a combination of upper fibula and shaft tibia fractures, always look out for a posterior malleolus fracture. So in all, once you have diagnosed, you have all your treatment options open. But diagnose it well and treat it well. Your syndesmosis is very, very important for future function. Thank you so much.
Thank you, Amit. Dr. D.P. Bhushan, sir, with Hoffer.
जी सर मेरे को आता नहीं सर पंगा वही है Hoffer's fracture you can suspect here Albert Hoffer, more known for hip dislocations, Hoffer's pad system and Hoffer's massage system. Now for the fracture. Definition, mechanism, radiology management and Bagaria's classification. It's a coronal fracture initially due to flexed injury on a bike accident with the axial load. Presents in 38% of the cases, 4 times more common in compound. Lateral is 4 times more common, 4:4. Always ask for CT. If fusion is usually in type 2, varus vulgus test is clinically mildly positive, and in radiology, there is a problem because AP overlap might make you miss it, especially the lateral, you suspect it, oblique, you see it. So always say that, well, there is not a good X-ray, get me oblique view. CT scan confirms it, and the coronal CT. Lateral classification came 1978. It became very popular, type 1 and 3, divided into 3 parts, 1/3, 1/3, 1/3. But the middle 1/3 was divided into A, B, C, and middle 1/3, if it is a fracture, probably you don't have the capsule attached to it. A cadaveric study confirmed it, that the capsule is not attached in the lateral type 2. A traumatic approach to the fracture, anatomic reduction, rigid fixation, early mobilization and physiotherapy is the treatment. Plan is just like any fracture.
The only one thing you should know extra is the swashbuckler approach. You should go behind the vastus lateralis, or the Gerdy's tubercle avulsion approach for the medial Hoffer. You should go through the medial approach. For posterolateral Henderson approach, or the posterior approach if it is the posterior fragment. Swashbuckler, cut the skin like this, deep tissue like that. You see the structures, you fix it with the K wires. Finally with the screw, medial approach. As you can see, vastus medialis up, pes and serenus down with the vessels, and Gerdy's tubercle, TTO. So these all the approaches are important, and the posteromedial Henderson is also important. There you take care of all the three components of insidinus behind and vastus medialis above. Posterior approach, we all know one has to be careful about the vessels and vessels only. If you remove the vessels, you remove the nerves also. See the medial gastrocnemius, see the capsule, cut it and fix it. Lateral condyle, 10-degree angulation, medial condyle, 25-degree angulation in the anteroposterior plane. Two wires are necessary to make it a strong fixation. Generally, this is the principle from anteroposterior. Try to put screws inside the bone. And selection of a screw, you can either have a simple screw or a Henderson screw. If it is a simple screw, cut the cartilage, make it go down, and do a counter sink, then cover it. Many a times there is tendency of upward displacement of this posterior fragment. Apply an anti-glide plate with the standard principle that the nearest hole to the fracture should be fixed first, followed by all the lateral screws. Complications are known, and we are wary of complication more because it's malunion, neurovascular damage, redisplacement, avian for type 2 Lateral, early arthritis, subsequent redisplacements later on, malunion. Silver lining of the future, biodegradable implants, arthroscopic repair for the Lateral type 3 or the Bulgaria type 4C. So pearls, important thing about Hoffer to learn, to remember and go back with these facts. High index of suspicion, always CT scan. Surgical approach, before you decide to operate upon Hoffer, please think about the surgical approach, plan it well. Reduction and fixation, go posterior to anterior, it is biomechanically more sound. Counter sink is the key, as you can see with the red line, cheese grater. If counter sinking is not well, you will have a cheese grater. जब पैर चलाएगा कुर करेगा. And for screws numbers, 2 is 1 and 1 is none. If you have applied 2 screws, your fixation is solid. Start passive range of movement within 48 hours, because remember the line, a stiff knee after a Hoffer fracture is much harder to fix than the fracture itself. I'll repeat it again. A stiff knee after a Hoffer fracture is much harder to fix than Hoffer itself. So take home message, high index of suspicion, always operative, full range of motion to be confirmed and stable under image intensifier, always appropriate, accurate approach, high tech, low skill. High tech, low skill fracture. Bulgaria classification is there. As we know, after CT, all the classifications have changed. It is changed to this extent that AP, lateral, and the CT views are important to decide. Bulgaria has made it very beautifully, the decisive approaches, and they are like this. Silver line magnesium screws, biodegradable. It is used mainly in 2 fractures, hallux valgus and Hoffers. The initial problem of magnesium screw was hydrogen bubbles. Later on, with the development, these hydrogen bubbles have been taken care of, and even these hydrogen bubbles are absorbed by the bone. And last but not the least, sir, we are doing our Gofcon on 31st October and 1st November at Dhanbad. As you can see to come to see the earth emitting spewing venom fire. धरती से निकलती हुई आग देखिए, सुरंगों में जाकर कोयले की काट देखिए. धन्यवाद.
Thank you, sir. Dr. Brigadier Chetan Sood.
Good afternoon, everybody. Firstly, I'd like to thank the organizers, Dr. Maurya, and me and Dr. Maurya go a long way. We are from the same college, the Armed Forces Medical College. I was in the military for about 30 years. I recently left, and I had the Merrill Academy. I work with Merrill Life Sciences, which is an orthopedic manufacturing company, and also the Director of Joint Replacement in Yashoda. I'm talking about the direct anterior approach. So before I start my talk, if I can take a poll, anybody, what approach people use here? Anybody using posterior approach for the hip joint? All those who use hip, please raise your hands who are using a posterior approach. Anybody who's used the lateral or the anterolateral approach? Sir? Lots of people, almost equal. But anybody using the direct anterior approach? Okay, so if I don't have much support, so I'll argue so I did my training in the US for the direct anterior approach about before COVID, but then practice didn't get the opportunity because of COVID. But after COVID, the surge of replacements especially in the young actually made a lot of sense in my doing this. So I usually do this approach only in the young people now, that is less than 50 years of age. These are my credentials. So everybody is aware of patient, it's not the surgery, it's the experience of the surgery. What he wants is less patient, it's not the surgery, it's the experience of the surgery. What he wants is less pain, leg length issues are sorted out, faster recovery. So I think DA approaches give both the aspects, from the surgeon aspects and patient aspects. There are few advantages that I'm talking about the conventional table, where I can easily put the patient. This is how I can use a conventional table, and it's easy to assess the leg length at the end. As you can see, I can assess the leg length. Oh, sorry. So I can assess the leg length very easily because the patient is supine. And some of the disadvantage, you need a second assistant. Learning curve, about 50 cases the learning curve in my opinion. So I'll start the video demo. This is actually a video demo, it's about 5 minutes. The direct anterior approach, it's a so-called minimalism, but the incision sign is not important. It's a lateral. The incision is conventional lateral. It's about 2 centimeter below the ASIS and about 2 centimeter anterior to it. So we'll develop the incision, and this is important to catch the fibers, and you see this really bluish, whitish TFL fascia, and that's the most important aspect of it. What differentiates it from the Smith-Peterson approach. We split the fascia, and as you can see, I split the fascia and use the back of my BP handle to, back of my, the fingers to develop this. So we have to go below the fascia of the TFL and between the muscle belly. So I will reflect the TFL. That's where it gives you the space, and it's a completely muscle sparing approach, and that's the whole advantage of it, being muscle sparing. So less bleeding, less pain, and quick mobility. And that's we develop the interval between the TFL and the rectus femoris. As you can see, pardon if you are not very, if it's shot with a mobile phone actually, this one. And then we place the retractors. As you can see, it's a little tight in this situation. I usually don't make. This is a small vascular leash. These are the ascending vessels of the lateral. So this is very important. If you don't ligate these, then they always come up as a hematoma, and it can cause a hematoma later on or infection. So I've had 2 such cases in my last 8 years. We cut you can cut the incision in inverted T. This I'm doing it with the inverted T, but usually it can be done in any other way. But I try to preserve the capsule. Initially, when I started, I was not preserving the capsule. I was taking down the capsule completely now. These are the 3 releases that you have to do. That is the inferior release. And the inferior release is just about as much as you can put your index finger inside so that that's freer or. So these releases are important because it's a muscle sparing approach and doesn't have, the space is constricted. If we do not release the things, then we will have a fracture, right? And that's a superior release and that's a trochanter. We take an approximate cut of the femur. Usually you will require to take a wafer, a napkin ring wafer cut, right? So that's a napkin ring wafer cut which has been taken. Otherwise you will not be able to dislocate the hip joint, right? And when we do that, we nickel the nerve out, otherwise the TFL can get injured. I'm demonstrating that the neck, if I'm not very careful, I can actually tear the TFL at this side, and the entire process, what you are struggling for, will be there. So that, if you can see this again with the convention, it's not an offset reamer, it's a conventional reamer. It's more difficult, but now offset reamers are available from many companies. But if you have an offset, I will say that you use an offset, otherwise you can still use a conventional reamer. It's not that you cannot do the surgery, right? And that's the aim of this presentation. This is a little trick that I learned. If you are not having offset reamers, if you are losing the large reamers, then you probably have to put it separately, because disengaging and engaging, you will have to do it inside. So this is like trying to manage within the instruments. But now offset reamers are available in our country, so we can use them. This is about 6 years back when I just started. So that's the way. So as you can see, the acetabulum is still head on. This is another patient's video. But here there is no anteversion and there is no inclination required, because you are not cutting the muscles. So there is no need to cover up, like in a posterior approach, we have to put the anteversion to cover up for the posterior instability that we create with the muscle cutter. Once the acetabulum is done, we can go and do another release for the trochanter. This is the most important release. As you can see, there's a lever below the trochanter, and this release is very important. You'll see a little fat coming out, and not to cut the 4 muscles. So the position of the leg is going to be like this when you're delivering the femur out. That's the trialing being done for this patient. And in this cases, for the implants, I would say only use fully coated and the colored stems also, which are now available in our country also. So that's the reaming being done in a supine position. There is no sandbag under the hip. Nothing is required. By simple figure of 4 and by hyperextension of the hip, one can achieve this. Right? So we almost finished, sir. That's the stem. That's a fully coated coil stem being used. And as you see, gently we can put it inside. Once the stem is inside, all the effort that you put is the proof that this is the stability it gives. And one of the important things that I get out of it is that even if the leg length is not good, I can cut it, and I have rarely used a high offset stent. I have never used a high offset if it was not a native high offset hip. So the stability that it gives is the proof, I mean, it's the entire learning curve and the effort. Just 2 minutes, 1 minute, it's the end of it. So with this, I'll go to they're the last 2 slides, sir. So I've used it specially for younger patients. This is one of the patients. As you can see, first day post-op, he's quite smiley. That's 3-week post-op, he can do that, though I never expected that. The person sitting behind him is an ACL who walks with a walker. He's walking without a walker. And that's another policeman, he was in the army earlier, and that's his bilateral hip done in the same sitting. So that's another advantage, that you can do a bilateral in the same sitting. And that's what's done for him. This is his progress in about 3 to 6 months. That's the effective function that he gets. With this, I've completed my talk. Thank you, sir. If there are any questions, I'll be happy to answer.
Thank you, Brigadier Sood. May I ask all the speakers to come to the front, please, so that we can have questions. Amit? Dr. Bhushan? And Dr. Bharat Raju, yes. So audience, any questions from any of these speakers?
To Dr. Naveen Thakkar. K-wire fixation and that external fixation, that could be good for a 2-part fracture. But if there is a comminution do you add more K-wires, and how do you fix it to the external to make it a one component? Because it can be as you showed, you have done an excellent job. Volar teardrop fracture, but if it is a depression, intra-articular depression, how will you get it up?
Intra-articular depression, you have seen the punch fragment. You can raise the punch and put the K-wire and fixation. Even though you are opening up in the punch fragment, it is a IITV image, you see that it is raised or not. You are not able to see exactly whether it is without arthroscopy. So you can raise it, whatever the fragment, you have to learn which are the planes. You have to go according to the plane and fix these columns in the fracture lines are different in different case. Once you stabilize that and link the joint, then it gives the stability, and you check the stability on table. Once you are satisfied, otherwise you add one more wire and combine it.
And is it a threaded wire?
No, it is not a threaded wire. Threaded wire is many times makes a problem and while drilling and coming out, because soft tissue gets entangled.
Sir, I have a question to Dr.
If you are applying a threaded wire, you may not need external fixator. It is important for smooth wires only.
Yes, sir.
Besides, something more, because there was an era where we used to apply only K wires. You take the pedicle probe, go through the fracture and elevate all the depressed fragments.
Yes, but I suspect that it's simply elevation, and leaving the fragment there is going to cause late collapse.
No, sir, no, sir.
It will.
I was talking about elevation. The moment you elevate it, apply a supportive subchondral wire, transverse.
One single wire is not going to help. That is the whole
Rest
point.
of the wires are there to
Sir,
hold.
we have a similar situation in the proximal tibia, and the standard recommendation is put a raft plate. Why? Because you have 4 screws going under this thing. Now in the distal radius, can you tell me if it is different or
yes, sir.
this thing? No, it is not. You still have those same you still have the same principle, and you still need to actually fix and make sure that you do not have late collapse of your fragment. The reason why we are not able to do this is not paying attention to this is because tibia is a weight-bearing joint, and it can show defects much earlier. But the distal radius is a non-weight-bearing joint, and small amounts of articular irregularity is better tolerated.
Even for the intra-articular tibia, depressions are well tolerated.
That is what I'm saying.
It is a containment, alignment and stability, that's all. Small depression doesn't make the function different. That has been also studied.
Endless talk, yes.
But in distal radius, ultimately whatever, even if you operate or not operate, at the end of 1 year, the results are the same. But the thing is that the people can lose their grip and functionality to some extent. In older patients, it's okay, but in younger patients, you have to give them a perfect result.
You told that you don't have to worry for worsen, etc., while you are doing through the anterior approach. And whatever may be the approach, you have to worry and ensure that the worsen and inclination is okay. And the chances of malpositioning in anterior approach is higher than the other approaches, probably. Because it's a constraint.
No. The best way to position a cup in a total hip is to have the patient supine. There you do not...
I'm not questioning that. I'm not questioning that.
Yes.
You have mistaken it.
Okay, sir.
So what I meant is that since it's a muscle sparing approach, so like it was never required, and now we are all using at least 32 heads. So that again, the stability is not an issue at all, sir. So that's what I.
Yeah, stability is not. Yeah.
Dr. Naveen, when you remove the wires which you have put for fixation, wire, when you going to remove that wire? 6 weeks, 8 weeks, 4 weeks. When you remove the wires,
you don't require incision.
No, wire removal.
Removal 6 to 8 weeks. You
6
see
to
the
8.
X-ray. Many patients require little more time. Then you have to get more time. Once you see the good callus, there is no collapse. You wait. If there is a pain, you wait. But only advantage with the linking the wires is loosening of the wire is been prevented. And there is no soft tissue drainage of the infection that is avoided with the fat necrosis and all that of the instability of only wires. Previously we were doing only wires and the plaster. Here you can remove the plaster slab at 2 weeks and start mobilization.
Okay. Dr. Bharat sir, if coronoid fracture is associated with some other fractures like radial head, which you fix first?
Radial head has to be tackled first.
I think coronoid should be
No. In a terrible triad, you always fix the radial head first.
I think
if it is a small fracture, type 1 coronoid, then and you're going from the lateral side, then fix the coronoid first and then take the radial head. But if it is a large fracture which is involving the sublime tubercle, you cannot go and fix it from the lateral side. You have to go from the medial side and put a small buttressing plate.
Not fix, you prepared for fixing the coronoid. You fix last, you pass the suture or whatever you do and fix it last after the radial replacement.
Yeah, but once you, for small fractures, actually it is the anterior capsule which you fix. The anterior capsule, once you get back, the elbow joint is non-dislocatable. Okay. Otherwise, it keeps on dislocating. Once it is a non-dislocatable joint, then you fix your radial head. That is what I do.
Okay, sir.
So
Thank you.
Rohan.
I think you put the suture lasso first. Try to bring it in place. Don't tie the suture lasso. Then loosen it. Put the radial head and then tie the suture lasso like Dr. Naveen is saying.
Yes. So my question for Amit sir. So this Massinu type of injury is very fascinating because most of the time we see it, you would never pick it up very acute. So there are delayed presentations in Massinu injuries because with time, with 2 weeks, 3 weeks, you see serial x-rays and the ankle starts subluxating. And sometimes you missed it. So once you fix those with your syndesmosis fixation, what is your propensity of going on the medial side and looking at it if the syndesmosis is not able to, reduce that medial gap?
Why do you say you pick them late? You can pick them earlier because you can take a stress views of your ankle. Your index of suspicion has to be there.
If you are the second surgeon, if the patient is presenting to you late because there was no fracture in the ankle, but when you saw the X-ray at 2nd week or 3rd week and the ankle starts subluxating, then you look at the proximal fibula.
He says that he is not missing. Somebody has missed and he has come to me. Now it is.
This happens.
So that's the reason he should be here. But anyway, okay.
Yeah. So how do you go about that? You are trying to fix the syndesmosis.
Very common because it's a medial space then.
Yeah.
On the medial space, the deltoid space, there must be some fibrous tissue over there. You have to release it, you have to open it and do your deltoid suturing. You will get a stability. And of course, you should rule out all the other injuries also by doing some scans. Yeah.
So any role of putting a transarticular pin to get the talus under the tibia if it is not coming?
Why? Medial clear space, if it's widened and you're doing a deltoid fixation, you may reduce it, pass a wire temporarily from the medial malleus to your talus to maintain that space. After debriding that space, do your suture anchor and remove the wire. That is what
I think you are describing a different situation where the fibula fracture is there and the fibula is shortened. Proximally. That's why you are not getting the ankle. Yes. First you have to make the length and rotation of the fibula. Then you will get the right ankle. And once you get the ankle, you check for the ankle stability of syndesmosis. And in the old injury, you may not able to reduce exactly syndesmosis. There you have to open and see whether it is reduced. And then you fix.
One last question by Dr. Ajit and then we close the session. Last question.
Yeah, I was also going to say the same thing. You need to restore the dime sign. You need to check that.
Yes.
Now my question is to Professor Sood. Tips and tricks to access the femur. Broaching is one of the major issues. Any tips and tricks to do that?
So I think, sir, the major issue is that don't hurry into it, otherwise you'll land up with the fractures.
Sure.
Sir, superior release is the key. So you have to do a very good superior release around the trochanter. Until you get a very good release and you get a ballotment of the femur, you don't start broaching. I think that is the key.
Unfortunately, I could not show, it was a little short thing, that femur will actually get delivered out and it will become really outside the wounds. You will deliver it out.
Thank you, speakers. I think we close.
Please come for the group photograph, please. Photographer, yeah. हाँ इधर आइए भाई. हाँ आइए ना. Thank you so much. Now we are going towards the next session. And for this, the moderator is our Dr. Firoz Alam. Before that, we have got a lucky draw. I will request my IOA president to pick any number. We are only 6 minutes late at present. Coupon number 88, registration number 88 is here. 88, next. 88 is not here. 32, 32, 85, 32, नहीं, हाँ, 38, 88 आ जाओ, आज आप सो क्यों रहे थे, जल्दी आ जाओ भाई. And yes sir, आप आ जाओ. Yeah, sir please. डाला हुआ सबका है, ये कॉमन वाला था सर. Thank you.
Hello. A very warm welcome to all of you. We now start our next session, that is session number 10. And in this session, we know almost new innovation, that is the ozone therapy, and another topic which is out of this conference and based on our theme. So for this, we invite our respected chairperson, Dr. Naveen Kumar Singh, Dr. Anil Kumar Singh, Dr. Karun Jain, Dr. Swastik Sivpuri, and Dr. Balmiki Prasad. Please come on the dais. Respected chairperson sir, please come on the dais. Take your seat. Dr. Karun Jain, Dr. Naveen Kumar Singh, Dr. Anil Kumar Singh, Dr. Swastik Sivpuri, and Dr. Balmiki Kumar.
इधर आइए, please.
And please take your seat, sir. And now I request our first speaker, that is Dr. Prasham Shah, who is talking about the ozone in musculoskeletal disorder. Please come.
So, hello. Good afternoon, everybody. So today I'll be talking to you about the ozone in musculoskeletal disorder. Before I start, can I just ask how many of you are using ozone in your practice? 1, 2, 3. Oh, there are only 3. So it's going to be a wonderful session. So everyone knows that the ozone is a naturally occurring molecule and it's a potent oxidant. And since it is naturally occurring, how is it coming in the nature? The ultraviolet rays of the sun is the biggest source of the ozone. So when it tries to enter into the earth atmosphere, the entire total upper strata gets converted into ozone, and that is how it is forming an ozone layer, protecting our Mother Earth and all of us from the harmful ultraviolet rays. And then how does the ozone happens at the bottom level, at the earth surface level? So that's the lightning and thunder. The waves dashing through on the rocks on the sea. And the waterfalls. And all these 3 places, whenever you go, you realize that you are very fresh, the environment is fresh, and the entire freshness is purely because of ozone. So if the ozone can clean the environment, can it clean our human body? And that was the main thing which started in Germany. To get ozone to go into the body, it requires a medically grade ozone generator with the medical grade oxygen to produce ozone. Now there are myriads of generators available, but I must take the name of Mr. Nikola Tesla. He is the guy who is the first, the guy who made the first ozone generator in the world. Ozone is basically anti-inflammatory, analgesic, immunomodulator, anti-infective. It improves the circulation. These are the basic mode of action. And how is it being an anti-inflammatory? Whenever it comes in contact with the body fluids, the polyunsaturated fatty acids gets activating NRF2 pathways, and that produces the reactive oxygen species and the lipid oxidation products, which in turns produces SOD, catalase, glutathione, and these are all the antioxidants, potent antioxidants. So this is what is the ozone paradox. The ozone is a potent oxidant, then how is it produced? This is the way it becomes an antioxidant at the end of the day when it's used inside the body. So in musculoskeletal disorder, there are gamuts of diseases like rheumatoid arthritis, osteoarthritis, autoimmune disease, fibrositis, tendonitis. Diabetic neuritis and frozen shoulders are the two best places where the ozone is very, very effective. Spinal disorders like spinal disc, even post-surgically, I use as a surgical wound toilet to clean out the surgical wound, as well as it can be used for the large wounds, and of course it is also used for the avascular necrosis of the hips. So how do you introduce ozone? It's gone as an intramuscular, intravenous, intra-articular, intradiscal. It can be given as a vaginal insufflation, rectal insufflation, and ozonated creams and oil can be used as a fantastic wound dressing material. So it's many, like from circulation to everything, and anti-aging is now the one where we are using ozone also as a very, very good modality. So now let me talk to you about the intraarticular ozone. I have my own cocktail where I use 5 cc of xylocard, 2%, 1/4 cc of methylprednisolone, 10 milligram, which is a long lasting, 1/4 triamcinolone, 10 milligram, which is a short acting, and both of them at the low dose is a chondroprotective and not destructive. Add to that about 4 ml of hyaluronic acid and top it up with 7 to 10 ml of 100 micrograms of ozone oxygen mixture. These are some papers to prove that the chondroprotectiveness of the low dose of the steroid for the joint. Now, one prerequisite, the ozone when you give intra-articularly to give the best effect, it has to be in one puncture you try to achieve your joint entry, and it should be given bolus. Now why one puncture? Because if you have a multiple puncture, then you will not be able to produce the bolus effect. And when you give bolus, it literally balloons the joint. And when it balloons the joint, it stretches out the capsules, the ligaments, and that is how it immediately improves even the movement of the joint. So if you just see this, a wrist, when you give injection and you give ozone, how it distracts the joint. Now, this is where I first introduced my cocktail, and this is the video showing how when you give injection at the elbow, you see how it distracts when you give ozone. Beautifully it distracts the joint. So it literally creates kind of a diastasis. See the wrist. And when you give injection of ozone to that, it distracts there. See? So the way, when it distracts, it immediately opens out capsules and ligaments, and you see the results. Now, if you see the before, about 10 to 15 degrees of flexion deformity, immediate, this is immediate post on the out of the theater, she is absolutely straight. And this happens because of the bolus effect of ozone and diastasis of the joint. This is where the wrist movements also, if you just see a movement, now the movements have increased. Any joint in the body, you can use the ozone. Now see the MP joint of the great toe. This is how it distracts. Even in the hip joint, for avascular necrosis of the hip, I use ozone injections inside the hip, and it does help. At CM joint of the thumb, every joint you can use, even the finger joints we have used this. Now this is my anesthetist. He has a frozen shoulder. Look at his movements.
Bus? Painful?
90 degree around, 80, 70 to 80 degree. Internal rotation hardly 5 to 10 degree.
Okay. Since how long it is?
And it's painful. Look at his face.
Okay. Okay, take it.
This is immediate. You can see the injection in my side here. This is immediately after the injection.
Very good. Go back.
It's a full abduction. No pain on the face. And the full internal rotation. This you can achieve it just within 5 minutes of your injection.
Okay, pain is less.
Now this girl was supposed to be operated for even the rotator cuff tears, acute rotator cuff tears. You can use ozone. She was supposed to be operated.
Dr. Prasham Shah in Dubai, the operation 3 September, but my shoulder is not moving. Now, Alhamdulillah, is moving. I can make everything after injection. So only 5 minutes, I can move my hand. Alhamdulillah.
So these are the various cases I have. Now I'll talk to you about intradiscal ozone injection. Here, any disc and multiple disc at one time, you can use the ozone. And even the disc like this, which causing a neurological deficit, you use ozone and you will find that the neurological deficit, reducing it and almost even going in. Here, along with the intradiscal, you must also have a foraminal block. You can use facetal block and give in spinal canal stenosis, give epidural injection also and paravertebral injection also. So these are the number of injections that you use for the spine for entire spinal disorders. Now you watch this. Watch this video here. I have put in my needle, confirm that it is there, and you see how it distracts the vertebra also. So imagine the vertebra, how can it distract with any force? But just because it's a one puncture in the disc and it's going a little bit with the force, the ozone distracts even the vertebra. So that's why we use even in a degenerated spine where it's painful, you use ozone, somehow I manage that space and you see the distraction. This distraction itself is a ligamentostasis and that makes the entire area painless. Similarly, you can use facetal joints, you can use the foraminal injections. Now, post-operative fibrosis, where otherwise we'll have to go again and try to relieve the fibrosis, I can relieve this fibrosis with just mere injection of ozone by separating the fibrosis from the dura. So my needle just goes in between the space and you see, watch this. Watch this here. Boom. It just opens out the entire fibrosis. This is my paper on the intradiscal ozone in September 2011 in the Journal of Maharashtra Orthopaedic Association. Now I'll talk to you about autohemotherapy. It's a simple words, it's drawing out of your own blood, ozonizing it and reintroducing it. Various conditions again like arthritis, avascular necrosis, ankylosing spondylitis. The best is a neuritis, diabetic neuritis, and now non-orthopedic conditions like even ischemic diseases of heart, brain and everywhere you can use with viral infections and all. So it's a very basic gadget of a vacuum flask bottle and the IV sets, and you see how it is. Take a needle and you see this blood flowing through. This is because of the vacuum bottle. So in this bottle, you take 50 cc approximately, and then you take whatever desired dose of ozone through this generator. Take 18 number needle, bend it to 90 degree, and just push through that channel.
To put your ozone there.
And you see here,
So
see how the ozone is bubbling into the blood, and this is ozonized blood, you put it back. So then, this was with 50 cc. Then we started using multipass, wherein 250 cc of blood was drawn out, and then you can ozonize it 7 to 8 times, and at one go you can do that. But now the latest thing that we do is EBU. It's extracorporeal blood oxygenation and ozonization. Here practically 3 to 4 liters of your human blood gets ozonized at one go, and almost 3.5 to 4 lakhs microgram of ozone. This really activates all your mitochondria and everything. It is now used for also anti-aging and for beautification. And you see this beautiful girl, she is a TV star.
Getting an EBU, superbly.
Here is a donor vein. You can see this darkish color of the blood.
Which is black.
This goes through the pump into the bottle here. The ozone is continuously going here, and that ozonized blood flows back continuously in this right side. So you see the color here. It's cherry pink and color there is little dark. So that when your blood gets ozonized, it really gets cherry pink. So this is...
So I'm getting my Ibu done.
Prashamsa getting it done.
My right hand is a donor vein. The left one is a recipient.
So even we take about a month and a half or two, you just take one Ibu, keeps you quite
So you can imagine the
energized.
confidence that I have on Ibu. If I take it, you can always take it.
Now, infection. Infection, you have a bones, joints, soft tissue. Now here, if you see this tibia with here the pus coming out, you use ozone bagging. So what happens is this legs is entirely covered with this ozone bag, and then you pass ozone through this. And if you see, when I give this, ozone becomes like this because this is a totally tight pack. And then 30 minutes you leave this ozone exposed to that area. And you see how in 3 bagging from here, it becomes this. Similarly, if you see these toes, most of them were advised amputation just with the ozonization, and this happens anyway. See this, both the toes, most of them advise amputation, and this is what the final results of the ozone treatment. See, look at these two and see the final result. Now this was a fracture of the tibia and it went into non-union. Somebody put dual plate and it went into a compartment syndrome, and the surgeon had to literally knock off, surgeon had to literally knock off the skin, the muscles. You can see the bone, you can see the plates, darkness here, and you see this. Even the knee was pouring pus. So most of the surgeons said that it is better that you go for amputation, the shortest route, and it will be a fastest route. She ultimately landed to me at this stage. Then I started doing the ozone bagging. After about 4 to 5 days, it started showing some blood supply coming to the thing. So I did a nice biological skin graft as a cover. Because I planned after 15 days, we go for a myocutaneous microvascularized flap from latissimus dorsi, and it connected to the tibial arteries and all, and make this color. So this is what was done with, of course, my microvascular surgeon and all. And at this stage, this was at both the plates on the tibia was difficulty. So we removed those plates and we put an interlocking nail. Now which surgeon has got a guts to put an interlocking nail in an infected tibia? But I had a faith in my ozone, and you just see what I did. This was the interlocking nail. This was on the 10th day, and you see this complete healing at 3.5 to 4 months, and you see even the fracture uniting completely. So this is what ozone can do it. This was published in the Indian Journal of Orthopaedics in 2012 or something. This again the testimonials, if you see. She's the one I gave injections about 10 years ago in the knee, and she was fine, and she came for shoulder. Now this is a pregnant lady, 3.5 months. Now there she developed a sciatica, and I gave her ozone injection. Nobody was ready to operate or anything, so we gave her that, and she was quite fine. Now I just showed you this picture because it's me. I brought the ozone to as a new thing in orthopedics. He is Dr. Arup Mukherjee. He brought Arup Mukherjee's regime for the rheumatoid arthritis and avascular necrosis. This is Arvind Divakar. He brought some hypodermic needlings and pain portal blocks, and he uses the hypodermic needles for the ganglion treatment, and he uses also for a large wounds tap water, and produces wonderful results. So this is something which is all out of box, something which is beyond the orthopedic books, and this is how all 4 of us came together and we formed the, of course he did hydrogen and peptide treatments. So we created IAOS, the Indian Academy of Orthopedic Surgeons, and we were doing all these procedures, and now we have started propagating it into and ultimately now we are on the 5th international conference, which is at Indore on April 17, 18 and 19. So I wish if any one of you gets feeling little bit of interested in ozone and all, and something which is beyond the orthopedic books, most welcome to Indore. Thank you so much.
Thank you, sir, for the excellent talk and very fascinating talk to all of us.
Thank you.
And this ozone therapy always excite all the surgeons. But sir, I have a question to you, sir.
Sure.
I'm sure that future lies in this kind of sciences. But current situation today, as of today, when we talk about this ozone therapy in wound management, that is fine. But when we give this as a IV therapy or intra-articular therapy, what is the medical legal aspect of this therapy right now in today's date?
In today's date, as such, ozone is otherwise not kind of in a mainstream. It is taken as an alternative method. So it can be used as an alternative method. And I have especially, because I was going to use intradiscal and all in IV, so during those time in 2002 or 2004, I took a permission from DCGI and I told them that I'm using this. So they have given me a letter stating that ozone from these generators are not attracting any cosmetic or drug licensing. So I'm doing it since almost 22
No,
years.
sir, I think I will reframe my question.
Sorry?
It is not, I will reframe my question. It is not about you taking the permission. We have...
Yeah, of course, there are so many
my
things.
question is, if patient takes you in the court of law, will you be able to defend that you are given ozone intra-articularly?
Both studies and with now everywhere in Germany and everywhere, even in states, everybody has started using it. In India, there are more than 10,000 people who are using it. Orthopedic as well as non-orthopedic. So this way, it is like this, you know, nobody wants to put a hand into the mouth of a tiger asking for a permission. But if the patient feels unsafe or in case if it doesn't get better, then only you will think. But I am being treating up till now more than 10,000 patients and not a single patient is unhappy.
Thank you so much, sir. Thank you. We were enlightened by your brilliant talk. बिहार की चर्चा हर जगह होती है, बहुत सारे कारणों से होती है. इधर पिछले एक महीने से कुछ ज्यादा ही चर्चा हो रही है गॉफकॉन के कारण ही, अंतर्राष्ट्रीय क्रिकेट मैदान के कारण. अंडर 19 में वैभव सूर्यवंशी ने जिस तरह से खेल दिखाया और उसके तुरंत बाद एक वैसा खिलाड़ी who was almost out of the ground for more than 1.5 years, he came back and he proved that there is some potential inside him which can make India the world champion. उन दोनों के बीच में एक समानता तो जरूर रही है कि they are Biharis from बिहार. दूसरी समानता यह होती है उनके एक गुरुदेव भी हैं जिन्होंने कहीं ना कहीं उनको बचपन से गाइड करते रहा. एंड ही इज इन फ्रंट ऑफ अस, फॉर्मर इंडिया अंडर 19 कैप्टन मिस्टर अमिकर दयाल. मिस्टर अमिकर दयाल who captained India from 86 to 88, and at that time Saurav Ganguly was playing under him. So I invited him. Let's have some words from you, some motivation, how you have motivated the young generation. He's having his own academy in Bihar where he's trained so many budding cricketers. Many more are going to come. There will be some more names which he can only tell. Over to Amikar.
Thank you, Dr. Mulya. Good afternoon, distinguished doctors, respected faculty, organizers, and dear participants. It is both an honor and deeply humbling experience to stand before a gathering of individuals who dedicate their lives to healing others. As someone who has spent years on cricket field rather than in operating theatres, I often reflect on how different our professions may seem, and yet how strikingly similar they are at the core. Both demands precision, discipline, resilience, and above all, ability to learn continuously from mistakes. The theme of today's session, Shaping the Future, Lessons Learned from Mistakes, is not just relevant, it is essential. Because if there is one universal truth across sport, medicine, and life, it is this: progress is not built on perfection, but on reflection. If you ask me personally how I deal with mistakes, I would say this: I do not merely brood over them, I document them. I do not spend too much time thinking, if I had done this, if I had done that, things might have turned out better. Instead, I try to understand what exactly went wrong, how it happened, and why it happened, and what I failed to notice because of a silly error, haste, or lack of thought. That to me is the real value of reflection, not regret, but learning. I remember one such turning point from 1992. I had a fallout with the administrators of cricket, and I was dropped from the team. They wanted me to change my pattern, to play, perhaps even think differently. At that time, it felt like a major blow to me. I was excelling and I wasn't ready to budge. But looking back, I realized that what they wanted me to change was also, in many ways, my niche, something that was deeply my own, and I chose not to give up. When I reflect on that phase today, I do not see it only as a story of loss and unfairness. I also see what I could have done better. I could have negotiated more calmly and more effectively. But recognition is a skill that often comes with experience, maturity, and age. That is something I have now, and I accept that some lessons arrive only after a bigger misses in life. So I have made peace with that journey. Mistakes do not disappear, but they do become teachers. And sometimes what feels like a setback in one moment turns out to be a beginning of a deeper self-understanding later. It is perfectly all right to learn late as long as one learns well. Let me take you briefly to a cricket field. In cricket, a mistake can cost a match. A dropped catch, a misjudged run, or a momentary lapse in concentration. These are just errors. They are turning points. Early in my career, I remember a match where I played what I thought was a perfect shot. It was technically sound and well timed, but it went straight to a fielder's hand. I was out. I walked back frustrated, but over time I realized something important. It wasn't just about how I played that shot, but when and why. So context matters much as skill. And that is where mistakes becomes teachers. In your profession, the stakes are indefinitely higher. A misjudgment is not just about losing a game. Every complication, every unexpected outcome, every moment of uncertainty carries within is a deep sense of learning. The question is not whether mistakes happen. They inevitably will. The real question is, do we have the courage to confront them, the humility to learn from them, and the discipline to ensure they shape better decisions in the future? One of the most powerful lessons sports teaches us is the importance of feedback. However, in today's world, the nature of mistakes is changing. We are entering an era evolving knowledge systems. While these advancements bring extraordinary possibilities, they also introduce new forms of error. systemic, algorithmic, and sometimes invisible. In such a world, the human capacity for judgment, ethics, and critical thinking becomes even more important. Because ultimately, whether on the field or in a hospital, decisions are made by people, not machines. Another lesson I've learned is the importance of team resilience. It is completely human aspect. As much as no match is won alone. When one player flatters, another steps in. Trust, communication, and collective responsibility defines success. I see a similar ecosystem here in surgeons, physicians, nurses, technicians, each playing a crucial role. Mistakes, when shared and understood collectively, become a source of institutional strength rather than individual burden. And perhaps most importantly, mistakes teach us empathy. When you have failed, you become more understanding of others who do. When you have struggled, you become more patient with those who are learning. In both sports and medicine, this empathy is what transforms competence into excellence. As we look forward towards the future, shaping it requires more than expertise. It requires a mindset, one that embraces learning, values transparency, and recognizes that imperfection is not the opposite of success, but a pathway to it. Let me end with this thought. The future is not shaped by those who never make mistakes, but by those who learn faster, adapt better, and remain grounded enough to question themselves. To all of you here today, I say, continue to push boundaries, continue to innovate, but also continue to reflect, because in that reflection lies not just professional growth, but the true sense of service, true essence of service. Thank you, and I wish all of a successful and enriching conference.
थैंक यू सो मच अमिकर। एक प्रश्न हमेशा उठता है, जो आपके समय की बातें होती थी 86, 90, व्हाट डू यू फाइंड चेंज इंडियन क्रिकेट टीम, क्या क्या अंतर?
क्रिकेट तो पूरा बदल गया है। इनफैक्ट मेरे शब्दों में बहुत अच्छा लगता नहीं है कि मेरे नेक्स्ट जनरेशन ऑफ क्रिकेटर्स को मैं कहता हूँ क्रिकेट अब बचा ही नहीं है, ये दूसरा गेम हो गया है। इनफैक्ट पब्लिक को अच्छा लगता है, क्राउड को अच्छा लगता है, फाइनेंसेस वो मनी ब्रिंग करता है, तो सबके लिए अच्छा है, तो विन विन सिचुएशन है, इसलिए नोबडी इज क्वेश्चनिंग दिस। बट आई एज अ क्रिकेटर हु हैज प्लेड मोस्टली ड्यूरिंग those areas when Sunil Gavaskar was where I used to look up to, where he was my captain in some of the games. और आज क्रिकेट को मैं देखता हूं जहां मेरे स्टूडेंट्स हैं, और जब अपने आप को कंपेयर करता हूं, जब मैं छोटा था, तो मैं जब खेलना शुरू किया था तो मेरा एक ही एम्बिशन था कि कंट्री को रिप्रेजेंट करना, कैसे मैं इंडिया कैप पहनूंगा। तो सारा फोकस फ्रॉम द एज ऑफ 8 was only playing for the country. Though my whole family, my parents, they were from education. My father was a vice chancellor, former vice chancellor. So we never had that facility at home. कि मेरे seniors हैं, मेरे elders हैं जो cricket खेल रहे हैं या कोई sports में हैं. But yes, my sister was a good badminton player. She played for the state. But उस समय ये decision लेना कि मुझे cricket ही खेलना है और parents का support मिल जाना कि let him go and play. So he never stopped me from playing. But मेरा केवल एक ही इंटेंशन था to play for the country, and for that I worked really hard उसके बाद जो फ्यूचर में हुआ तो सब देखा है सब लोगों ने। लेकिन आज के बच्चों में मैं देखता हूँ जो वो आते हैं मेरे पास तो उनका पहला एम्बिशन होता है कैसे आईपीएल खेलूं। तो ये डिफरेंस आ गया है। तो क्रिकेट यहीं पे दो तरीके का हो जाता है। जब आप इंडिया के लिए खेलना चाहते थे उस समय तो टेस्ट क्रिकेट ही दिखता था आपको, या वनडे मैक्सिमम दिखता था, वनडे क्रिकेट। अभी आप देखते हैं कि जो बच्चे आते हैं वो 2020 क्रिकेट की तरफ ज़्यादा टिल्ट किए हुए हैं और वो केवल वो आईपीएल देख रहे हैं। तो फोकस में अंतर आ गया है, उनके अप्रोच में अंतर आ गया है। टाइम नहीं है, जल्दी करना है, शॉर्टकट देखना है। तो यहाँ पे कहीं ना कहीं हम क्रिकेट का जो रियल एसेंस है उसको हम मिस कर जा रहे हैं। अब अभी भी पुरानी जब आप रिकॉर्डिंग्स देखते होंगे, कभी आपको टाइम मिलता होगा और सुनील गावस्कर या उनके पहले कहरा का कोई रिकॉर्डिंग्स देखते हैं तो आपको लगता है और देखते रहे। लेकिन आज जो आईपीएल के आप रिकॉर्डिंग्स देखते हो लगता है यार वही है, सारे मैच में एक ही टाइप का होता है, एक सेट पैटर्न है, मोर और लेस सेम टाइप का क्रिकेट चल रहा है। एक प्लेसेड विकेट मिलता है, एक अच्छा बैटिंग एटमॉस्फेयर मिलता है, तो जहाँ केवल रन ही बनते हैं। और रन भी बनते हैं तो टेक्निकली जो लोग थोड़ा सोचते होंगे क्रिकेट के बारे में, उसके कोई रूल्स हैं, वो सारे रूल्स वहाँ पे ध्वस्त हो जाते हैं। आप पीछे विकेट के पीछे छक्के मिलते हैं आपको, उसमें तालियां बजती हैं, उसमें कमेंटेटर्स भी, बड़े बड़े कमेंटेटर्स जो अपने समय में वो अगर वैसा कोई शॉट खेलता तो अपने जूनियर को टीम से बाहर कर देते, वो भी बोलते हैं व्हाट अ शॉट। बट एक्चुअली क्रिकेट चेंज हो गया है। इसमें आप जहाँ तक क्रिकेट के बल्ले की बात करें, क्रिकेट की बॉल की बात करें, क्रिकेट की ग्राउंड की बात करें, विकेट की बात करें, सब चेंज हो गया है। स्पेशली फॉर टू मेक 2020 क्रिकेट सक्सेसफुल बिकॉज इट ब्रिंग्स लॉट ऑफ मनी इनटू एसोसिएशंस पॉकेट। वर्ल्ड का जितने भी क्रिकेट खेल प्लेइंग कंट्री है, अभी आप देखेंगे जहाँ पे पॉपुलेशन ज़्यादा है, इनफैक्ट इंडिया जैसी कंट्री में, वो सबसे ज़्यादा उनके पास फंड कलेक्शन भी होता है क्योंकि लॉट ऑफ पीपल गो एंड वॉच दिस मैचेस। और जहाँ पे इंग्लैंड ऐसी कंट्री है जहाँ पे क्रिकेट का बर्थ हुआ, वहाँ पे आप उतनी अभी भी नहीं देखेंगे वो इतने ज़्यादा पॉपुलर हैं। ठीक है, देखते हैं वो मैचेस, पर अभी भी वो टेस्ट क्रिकेट पे ज़्यादा लोग बिलीव करते हैं कि रियल क्रिकेटर्स कम फ्रॉम टेस्ट क्रिकेट। सो मेरी भी वही सोच है। तो आज के जो यंगस्टर्स हैं थोड़े मेरे से नाराज भी रहते हैं कभी कभी कि मैं कभी पहले मैं कमेंट्री करता था, अब तो मैं छोड़ दिया हूँ। तो कई बार ऐसा होता था तो मुझे वार्निंग मिल जाती थी बीसीसीआई से, मुझे को कि भाई आपने क्या बोला, दिस गोज अगेंस्ट द इंटरेस्ट ऑफ द बोर्ड। बट मेरी आदत है ये शुरू से सच बोलने की, तो मैं अपने को रोक नहीं पाता था। आज भी मैं जब अपने बच्चों को या न्यू जनरेशन को बताता हूँ, इनफैक्ट ईशान किशन एक अच्छा एग्जाम्पल है कि वो मेरा स्टूडेंट रहा है 6 साल की उम्र से। कई बार वो आईपीएल में खेल के लौटता था तो पहले 2 सीजन में सक्सेसफुल नहीं हुआ और बहुत डिप्रेस्ड रहता था। और जबकि वो वहाँ जा रहा था तो उसको बड़े बड़े कोचेस मिलते थे, राहुल द्रविड़ उनको कोच थे, कहीं और कोई मिलता था बड़ा प्लेयर जो हमसे बहुत ज़्यादा खेला हुआ है, लेकिन फिर भी वो अपने आप को करेक्ट नहीं कर पा रहा था और ही वॉज फीलिंग डाउन। तो बहुत मेरे से बहुत ज़्यादा रिगार्ड, तो मेरे सामने सब चीज़ बोल भी नहीं पाता है। इन लोग जो बच्चे होते हैं, क्योंकि उस बच्चे से मेरे सामने खड़े हुए तो इनफैक्ट वो अपनी आँख भी नहीं मिला पाते हैं उस समय। लेकिन मैं उसको बुलाया था एक बार, मुझे याद है, सेकेंड आईपीएल जब वो खेल के आया था, एंड ही वॉज क्राइंग बेसिकली। ही वॉज क्राइंग बिकॉज उनके जो अंडर में क्रिकेट खेल रहे थे, वो जो कैप्टन था अंडर 19 का, वो सब अच्छा कर रहे हैं, मोस्टली अपने आप को सेटल कर लिया था उस लेवल पे, और ये अभी भी वो इन एंड आउट, नॉट अ परमानेंट मेंबर ऑफ द टीम हो पाया था। तो मैंने उसको 2 चीज़ें बोली थी उस समय। मैं सबको बोलता हूँ जो स्पेशली जो हमारे से छोटे स्टेट से बिलोंग करते हैं, खैर अब तो थोड़ा चेंज हो गया क्रिकेट सिनेरियो, लेकिन हमारे ज़माने में या उसके बाद बिहार और ऐसे स्टेट को क्रिकेट में बहुत छोटा माना जाता था, जहाँ से क्रिकेटर्स को बहुत अपॉर्चुनिटी नहीं मिलती थी। तो वहाँ पे आपको इंडिया के लिए खेलना एट एनी लेवल वाज बिग टास्क, ह्यूज टास्क। तो मैंने उसको यही बोला कि देखो तुम बिहार से आते हो, पहला ड्रॉबैक। दूसरा, तुम समझते हो कि तुमने भी 100 बनाया। मैं एग्जांपल दे रहा हूँ, बुरा नहीं मानेंगे जो बॉम्बे से है। मैं बोला जो बॉम्बे का लड़का वो भी 100 बनाता है, लेकिन उसका सिलेक्शन होता है, तुम्हारा नहीं होगा, बिकॉज दे फील, एवरीबडी फील्स कि बॉम्बे के प्लेयर बेटर होते हैं, तो तुमको 200 बनाना पड़ेगा। अगर वो 100 बनाते हैं तो तुमको 200 बनाना पड़ेगा, देन यू कैन क्लेम दैट यू आर एट पार विद देम। जो मैंने भी वही अपने लाइफ में किया है, वही आप भी वही करो। कि मुझे भी जब चांस मिलता था तो आई ऑलवेज थिंक कि लाइफ में एक ही इनिंग मिलेगा, सेकेंड इनिंग हमको नहीं मिलने वाला, दूसरा मैच नहीं मिलने वाला। आई एम नॉट फ्रॉम बॉम्बे। बॉम्बे वॉज अ वेरी कॉमन थिंग बिकॉज क्रिकेट वहाँ पे मेन सेंटर था वो, तो मुंह से मेरे बॉम्बे ही हमेशा निकल जाता था। मैं बॉम्बे का नहीं हूँ, तो आप समझ लो कि जो बॉम्बे के प्लेयर्स हैं वो 100 करते थे तो मैं वहाँ 200 करता था एट अंडर 15, अंडर 19, अंडर 22 लेवल, इवन रणजी। और सब मैचेस में मेरा फर्स्ट मैच भी सेंचुरी है, अपना फर्स्ट मैच के फर्स्ट इनिंग में, बिकॉज दैट वॉज विद इन मी। हम ऑलवेज सोचते थे कि आपको दूसरा मौका नहीं मिलेगा, अगर हम पहले मैच में फेल किए शायद मुझे सेकंड मैच मिलेगा ही नहीं लाइफ में। सो दैट सेम थिंग आई यूज्ड टू I tell my youngsters.
Yes, Amikar, we have seen you playing. ये जब ग्राउंड पे उतरता था तो विश्वास नहीं करिएगा जिस तरह से छक्के मारता था, एंड वहाँ की बहुत ज़्यादा रिकॉर्डिंग तो हम लोग के पास है नहीं, बट अमिकर वॉज अ प्राइड ऑफ बिहार। और इसने खुद बताया क्या कारण से उस लेवल पे नहीं जा पाया। He has to come back because a man of ego, a man of respect. Thank you so much.
मैं एक इंसिडेंट और आपको बताना चाहूँगा, शायद आपको अच्छा लगेगा, मैच लाया नहीं। The best moment of my life was meeting Sir Don Bradman and having lunch with him. That happened in Australia at Adelaide. मैं सुनता था कि भाई I was leading the Indian under-19 team to Australia. तो वहाँ टेस्ट क्रिकेट था मेरा, टेस्ट मैचेस थे, तो वो अपनी वाइफ के साथ मैच देखने आए थे एडिलेड में। I was not aware. He was sitting in his pavilion. There was Bradman's pavilion है उनका। So I was in my dressing room. तो जब मैं बैटिंग करके आया तो मुझे किसी ने बोलना खबर किया कि सर डॉन मिलना चाहते हैं, he has called you. I just उस समय मेरे दिमाग में यह कौन हो सकते सर डॉन, तो बोला ब्रैडमैन सर। हम लोग ओके। Then I went there straight away with my manager, and there he said, I saw your batting today for 15 minutes. You work hard, you can do better. You can improve. And he asked my manager also, please look after him. When you go back, look after him. But I have to go today. I'll see again. I'll come tomorrow. My wife is not feeling well. So you must have lunch with me. So you manager, you also come with Amikar. So that was how I went to his pavilion next day for lunch. And he gave a write-up, and he signed and said, keep it with you, and all the best, and I think you'll be playing for the senior team very soon. So that was the best time of my life, because उसके बाद जब मैं वापस आया था तो मैं कई बार ऐसा सुनने में आया, मेरे को न्यूज़ पढ़ा कि सचिन, he wanted to meet him, he has got an appointment after 2 years. So I was so lucky, spent so many hours with him. Thank you very much.
Thank you so much. और आज के लंच के पहले का जो सबसे इंपॉर्टेंट कार्यक्रम है, थैंक यू ऑल द चेयरपर्सन सर, थैंक यू ऑल द चेयरपर्सन। कैन आई हैव द साइंटिफिक प्रेजेंटेशन? वो दे दो। एंड नाउ वी कम टू द मोस्ट इंपॉर्टेंट पार्ट ऑफ दिस afternoon, I will say, is Dr. Haram Singh oration. Just before lunch, for this we have got dignitaries to chair the session. First is Dr. Bashir Alam sir, the past president of Bihar Orthopaedic Association. Dr. Bashir Alam sir. पकड़ा के ले चलिए. Next is Dr. Captain Vijay Shankar Singh, again the past president of Bihar Orthopaedic Association. Third is Dr. Captain D.K. Sinha, again the past president of Bihar Orthopaedic Association. Fourth is Dr. Shivendra Kumar, the past president of Bihar Orthopaedic Association. And luckily I see Dr. Sunil Malik sir, the past president of Bihar Orthopaedic Association. Please sir, आप यहाँ आ जाइए. Even मुझे विश्वेंद्र सर दिख रहे थे. विश्वेंद्र सर, डॉक्टर, तब रंजीत सर है. रंजीत सर प्लीज आ जाइए सर, आइए सर। यहाँ 6 पास्ट प्रेसिडेंट यहाँ बैठेंगे सर, बिहार ऑर्थोपेडिक एसोसिएशन। विश्वेंद्र सर हैं ले। तो दिस इज डॉक्टर हरिराम सिंह ओरेशन। और किस्मत यही होती है जितने पास्ट प्रेसिडेंट यहाँ बैठे हुए हैं, ऑलमोस्ट मेरे पिताजी ने उनको पढ़ाया था। कैन आई हैव दैट वीडियो प्लीज?
रुक जाना नहीं तू कहीं हार के, कांटों पे चल के मिलेंगे साए बहार के। रुक जाना नहीं तू कहीं हार के, कांटों पे चल के मिलेंगे साए बहार के। ओ राही 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 ओ राही। देख रुक गया है, तेरे आगे झुक गया है। सूरज देख रुक गया है, तेरे आगे झुक गया है। जब कभी ऐसे कोई मस्ताना निकले है अपनी धुन में दीवाना।
थैंक यू। ये है हरि बाबू, मेरे पूज्य पिताजी। आज इस दुनिया में नहीं हैं। 2019 में इनकी मृत्यु हुई थी। आज उनकी याद में हम लोग यहाँ पे खड़े हैं, बैठे हुए हैं कुछ सुनने के लिए। और जिनको मैंने बुलाया है, कहीं ना कहीं मुझे लगता है अगर ट्रॉमा में कुछ भी जानता हूँ तो सर की बातों को सुन सुन के, मुझे नहीं लगता किताबों से मैं कुछ सीखा। मैंने हमेशा उनकी बातों को सुना है। डर भी लगता रहा है कि पता नहीं कब डांट भी पड़ जाएगी। डांट तो नहीं पड़ती थी, लेकिन आवाज़ से ही रॉब जैसी आवाज़ आती है। मैं अपने बड़े भाई आलोक सिंह जो फॉर्मर जीएसटी कमिश्नर, उनको अनुरोध करूंगा डॉक्टर डीडी तन्ना सर को लेके आए। और अपने बेटे डॉक्टर अक्षत सुमन, मेरा भतीजा अनुज और अंकित, प्लीज डॉक्टर तन्ना सर इधर आ जाइए। आप आगे आते जाइए, बस थोड़ा सा मुड़ जाइए और आप लोग मिल जाएंगे। एक चेयर बीच में, एक चेयर प्लीज, एक चेयर। रमित प्लीज एक चेयर के लिए हेल्प करा दीजिएगा। वी वांट 1 चेयर हियर। सर 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 A big round of applause for Dr. D.D. Tanna sir. बीच में, बीच में, बीच में, एकदम बीच में, इधर बीच, सामने सामने, और आगे, और थोड़ा आगे। सर ये, सर प्लीज, डॉक्टर तन्ना सर सभी के गुरु रहे हैं, अ टीचर ऑफ टीचर्स। हमेशा जितने भी यंग जनरेशन आप देख रहे हैं, हर कोई इनसे ही सीख के आगे बढ़ा है। एंड सर मैंने भी कोशिश की थी कि इस बार कुछ बदल के करूं, तो शायद ये हुआ मौका आपके नाम के कारण हुआ सर। जो पास्ट प्रेसिडेंट 6 एक साथ बैठे हुए हैं और सबको जिनसे मैंने रिक्वेस्ट किया, सबने बोला कि मुझे उस समय रहना है। सो देयर पीपल विल बी चेयरिंग द सेशन। सबसे पहले मैं डॉक्टर विजय शंकर सर को भी अनुरोध करूंगा, एक शॉल हम लोग के तरफ से डॉक्टर डीडी तन्ना सर के लिए। मैं सब लोग का अनुरोध करूंगा कृपया खड़े हो जाएं सर के बगल में। सर वहां दीजिए। सर क्या है, मोमेंटो। जो फेलिसिटेशन ग्लोबल एक्सेलेंस अवार्ड है, मैं पहले उसको पढ़ देता हूं, उसके बाद मैं चाहूंगा हमारे जितने पास्ट प्रेसिडेंट ऑफ बिहार ऑर्थोपेडिक एसोसिएशन उसको प्रेजेंट करेंगे।
Global Excellence Award 2026 to Dr. D.D. Tanna of Mumbai. Recipient of Dr. Haram Singh Oration in Gofcon 2026, organized by Global Orthopaedic Forum at Patna. It is with immense pride and profound reverence that the Global Orthopaedic Forum confers the prestigious Dr. Haram Singh Oration Award to the living legend of Indian orthopedics, Dr. D.D. Tanna. A master surgeon, a prolific author, and a visionary mentor, Dr. Tanna's name has become synonymous with excellence in complex trauma and fracture management. His journey from the hallowed halls of Mumbai's premier institutions to becoming a global authority is a testament to his unwavering dedication to the healing arts. You retired as professor at Nair Hospital. Now you are working as consultant at Jaslok, Bhatia and Safai HN Reliance Hospitals in Bombay. You are actively involved in teaching mainly orthopedic surgeons all over India. We appreciate your contribution to the field of orthopedics. Dr. Tanna's influence on the orthopedic fraternity is immeasurable. Dr. Master Surgeon, you are a master surgeon. You are respected for your surgical precision, particularly in the management of complex proximal femur fractures and non-unions. The authoritative voice, the seminal textbook on interlocking nailing remains the Bible for resilient surgeons and a seasoned consultant alike, bridging the gap between traditional principles and modern technology. Dr. Tanna's interlocking nailing is in the 5th edition, which has become textbook of interlocking nailing in India. Your author book, Orthopaedics in Tidbits, now in 2nd edition, named Orthopedic Secrets, is very appealing for orthopedic surgeons. Your book on proximal femur fracture is a good guide for all surgeons, irrespective of the age. You have also contributed chapters in Textbook of Orthopedics, which is All India Orthopedic Association official textbook. The H.R. Singh Oration is reserved for those who demonstrate exceptional leadership and a commitment to the advancement of the medical science. By delivering this oration, Dr. Tanna continues the legacy of excellence and intellectual rigor that this forum represents. The Global Orthopaedic Forum is proud to present this citation to Dr. D.D. Tanna. We salute your dedication, your spirit of teaching, and your unwavering commitment to the healing touch. Presented this day, March 28, 2026 at Hotel Maurya, Patna. Now I request all the chairperson to take their seats. We will have their comment later on. It's now to Dr. D.D. Tanna, sir.
Fund manager, that is my title. It's a pure orthopedic talk. It has nothing to do with the finance. This is a lovely slide in Slovenia. He changes his position on scripts which you buy or sell when the time comes. There is a huge flow of articles appearing in innumerable journals now. From his own practical orthopedics, he finds out the best way to treat a patient successfully. It has nothing to do with academics otherwise. Trying to be one of those fund managers in orthopedics today, hopefully with enough past. Whether I succeed or no, it depends on you. So in this talk, I will only mention the scripts which you should buy and not go into the details of the massive articles which are now pouring in the world in a recognized and unrecognized orthopedic journals, because there are so many. You can find out pros and against of any article you want to read. You can find out any subject. Unfortunately today, PFN or no PFN. I try to first say that PFN in this is okay. To me as a fund manager, if the GT is shattered, PFN alone is not safe. Positive reduction does not always assure success, but one of the most essential elements if the collapse is going to occur while healing, which is almost always going to happen all the time. These are the positive reduction, anterior reduction, positive reduction, and still it doesn't work because you see the GT is compromised. The hold in the upper fragment is very poor even after a positive reduction because the GT is gone. And the fixation only depends on the bone in this area. And more osteoporosis, it becomes more and more difficult to hold only with these two screws because the lateral wall and the GT is not supporting at all. Again this, GT is not there. All this is the one which fails. These are some of the cases which have been given to me by Dr. Garigune, which I am showing it. At this point of entry, GT is shattered and giving inferior ability in proximal fragment. PFN in IT fracture, when the GT is shattered, PFN is an inferior surgery. All I mean is PFN alone. In such fracture, look for a better option. Now this sort of a fracture, the CT scan shows everything is shattered. Whether you can do a PFN if you are addicted to PFN. But otherwise the options are there. This is a nicely well reduced fracture. You can go ahead, do a blade plate with keeping it a little out so that the valgus is correct, virus is corrected, and there it comes and you get a perfect 100% result which is there. Don't forget blade plate. It is one of the excellent implant which has been produced. My choice, the blade plate today or the same PFN with an adjuvant plate. PFN alone is contraindicated. To me, the PFN in such situation it must be added with the blade plate. It may not be required all the time, but in a comminuted fracture, GT shattered, PFN alone is not a safe implant. I was never sold out to PFN, still continue to doing a blade plate as an alternative to PFN many occasions. This is the fracture. Excellent reduction was achieved. I felt if I do a PFN, this part will become separate. And once I pass the screw, this will be the one which will separate out, which happened over here. So I decided I'll do a blade plate. Patient, and there is a myth that if you do a blade plate, patient doesn't walk for 2 months. It's not true. He can walk about in about 4 days, 5 days, whenever the pain is comfortable, she can walk about. This is a 6 years, perfect anatomy restored, and everything goes on perfectly as desired. PFN in IT fracture is recommended to do a piriform point of entry. Piriform entry means go through the gluteal muscles. This is what is the piriform entry, you go to the gluteal muscles. And this is the superior gluteal nerve, which is around here. When you go through the gluteal muscle, this is the superior gluteal nerve which is attached here. These are the ones which are the things. And while doing the PFN, you damage the few fibers of superior gluteal nerve. Various muscles and tendons branches of superior gluteal nerves are injured, and you also damage the gluteal muscles, gluteus medius. So piriform point of entry, which has become so popular, and it has been sold as if it is the best thing to happen, it has a lot of complications which are there. Still, people will go on talking about a piriform point of entry. Piriform point of entry, you can see the gluteal muscles on the opposite side, and here it has weakened out. ChatGPT, incidence of limp in IT fracture in PFN. The study on the patients with the bone fractures, it has been showed that the limp was present in 3% of the patients with the femoral shaft fractures and 42% with the patients with the IT fractures. Femur fracture is treated by a GT point of entry, while the limp is very, very less, while the IT fracture is treated with the PFN, with the piriform point of entry, where the percentage is very high. This is the one where you can see the abductor weakness is a higher incidence, with the piriform point of entry, while the GT point of entry, it is a lower incidence. GT point of entry is superior, or it is the higher one which you can probably do it. Now these are all the GT point of entry, intertrochanteric fractures. But once it is supported by a adjuvant plate, the virus doesn't happen. So it is a myth that if you can go to the piriformis, then only the virus can be avoided. You go to the GT point of entry, put on any of the adjuvant plates, you will still be able to maintain the same valgus, and you will have a much more percentage of healing without a limp. So to me, never only order PFN. Always order a GTR or a TSP or olecranon plate or any of those adjuvant plate. And in such a situation, you never know when needed. Smallest doubt, use it. If it is needed or not needed, it is always needed. That overkill is not a sin. Particularly I am talking about when the GT is shattered, the trochanteric is shattered. In a younger man, only PFN will work, but in a porotic fractures with the comminuted fractures, PFN alone will not be able to give you that result. Now you can see here, this is the orthopedic surgeon's wife from Bihar only. This was treated, and this is where ultimately this originally, if in case it was treated with this was treated with the adjuvant plate because of the non-union which happened with this. This is what the fracture broke down, and it was treated with this with the GT point of entry. On day one, it could have been avoided. If there was an adjuvant plate which was put, it would have become all right. You can see all these cases of adjuvant plates. It is the one which will give you a far better result. So my strong suggestion is, when in doubt, put a PFN from a GT point of entry and put in an adjuvant plate, and you have very good chances of success without a virus. These are the words I strongly feel with the GT entry, not piriform entry, PFN edge and adjuvant plate. This is not a PFN alone here, but to me, nail with the GT point of entry, any of the above plate is a new PFN in porotic and a comminuted fracture. Again, I am not talking about a young man with the IT fracture, I am talking about this group. 29-year-old plastic surgeon resident in a premier hospital in Mumbai. Day one injury. You can see this small opening. You can see the posterior malleolus opening. Day one picture. This is the CT scan. And this was how it was treated. Surgeon felt it is a small posterior malleolus fracture which doesn't need anything. You see 3 months, 2 years and 4 years. Ankle is gone. This is the day one. This is 4 years. This is MRI 4 years. You can see syndesmotic is gone. Small posterior malleolus. It's not a posterior malleolus which we are trying to fix it up. It is a ligament which is attached to the posterior malleolus we are trying to fix it up. So my suggestion is, if there is a posterior malleolus, small or big, don't conserve it. Go ahead and fix it up with the leg screw, or far better is a posterior buttress plate, and that is the one which will avoid all these dramatic problems which you get. Day one and 4 years, this ankle is gone completely because the posterior malleolus was not fixed. Surgeon believed posterior malleolus is too small and needs no treatment. Told this to the doctor patient. Unfortunately, at this stage now, nothing more can be done. This is the one which is the indication that you got to fix it up completely. Without that, you will never get the thing. Do not conserve a posterior malleolus. Fix it even if it's small. Occasionally, it may be an overkill, but it's not a sin to have an overkill and get the best possible result. When posterior malleolus is fixed, When the posterior malleolus is fixed, it is not the bone, but it is this posterior tibiofibular ligament which you are fixing it up. And that is a major ligament of the ankle fracture. That's the reason why you got to fix up all posterior malleolus, do not conserve it. Distal transverse medial malleolus fracture is very faultily fixed quite often. You can see this one after the other. Surgeon feels that it's a small minor piece, but it's the one which is going to give you all the trouble if you don't fix it up. All this medial malleolus fracture needs a different treatment all the time, and this distal medial malleolus fracture, which is the one which needs a lot of treatment properly. This is the distal fracture. My suggestion is only a tension band in a spatial way. Fix it up first K-wire. First K-wire should go from medial malleolus right vertically and come out of the bone. It comes out of the bone, so it is at a 90 degrees to the fracture, is the one which will reduce. Now neutralize with the other K-wires and put in a tension band. Do not try to use a screw in the very, very distal fracture. I am only talking about the distal fracture. Such tip of the medial malleolus distal transverse fracture, first put a wire 90 degree to the fracture after holding the reduction with the clamp. And then you put it. Either you can put it from superior to inferior or inferior to superior, whichever you feel is all right. And then you put in a tension band. In osteoporotic fracture, this screw is required in order to give you a good tension, but in a younger patient, it can pass through the bone, there is no problem. And this is the way you will get 100% reduction of the distal tip of the medial malleolus. Do not neglect it, because otherwise the ankle is fired for life. This is the one, first hold the medial malleolus, fix it up, and that's the only way you can fix up this medial malleolus distal fracture all the time. Otherwise, you can see here, you fixed it up, you fixed it up there, and then you can put in the screw if at all it is required, but that clamping and fixing it up is more important. Now here, 6 months pain continues. This is the one medial malleolus is fixed with this tension band. But you can see here, still the patient is having too much of pain. You go back to the first, this is how the medial malleolus is. This is how it is reduced and it is how fixed up. You can see on day 1, but what has happened? Medial malleolus is not been reduced. Tension band has been used, but medial malleolus is not reduced. If this is not reduced, this is what is going to happen. And you can see the shape of the medial malleolus. This is where the wire is passed only from the proximal fragment. This is what has happened. This is how the shape of the medial malleolus is. So if you had reduced it properly, it would have been able to get up 100% reduction, then only the ankle would have survived properly. My suggestion is, in this distal medial malleolus, we always depend on the outer surface reduction, and that is not the one which will be able to give you 100% reduction. So what my suggestion is, go down anteriorly, see the tibial articular surface uniting with the medial malleolus, and see that that curve is very well maintained. This is the way in which you will be able to probably assure 100% reduction. Do not rely on the outer surface reduction all the time, because you will not be 100% right there. This is the way in which ultimately the medial malleolus should look. And open up the fracture, then you will realize there is a malposition which is there, which you can correct it. Junctional fractures, upper 2/3 and lower 1/3 femur. This is where probably the maximum non-unions we see. Antegrade nail with even 4 to 5 distal screws is inferior. Do a antegrade nail and adjuvant plate on day 1. DFN, that is a distal femur nail, may be a better option in this, but safe is any nail and a plate. Antegrade nail in order to avoid a knee opening, or if you are not used to a distal femur nail, antegrade nail and put in an adjuvant plate. This is how the Generally it is being treated, you get this, and this is a non-union, ultimately antegrade nail and an adjuvant plate will solve the problem. Even 4 or 5 screws, still the fracture is not stable all the time. As you can see, it goes on moving there, and that's the reason the bone goes on getting absorbed. You can see here the CT scan. There is a good hold on the proximal fragment, but the distal fragment, it is floating. It depends upon your screws. 2, 3, 4 screws also will not be able to give you that stability all the time. And what I feel is, when you're doing it for the non-union, go down and make an anterior cut. Go down anteriorly so that you go medially and do the bone grafting medially. Do the shingling anterior medial, medial and posterior medial. You go down and cut there. This is the one you put in a medial graft and put in an adjuvant plate. Your chance, because you can see the medial bone formation. If you see every time there is a good amount of callus happening on the medial side. If you see the biomechanics, orthoscanogram, the line passing from the GT, from the head of the femur to the ankle, it passes medially. That is the line of weight bearing. So grafting on the medial side is the one which is going to mature. Grafting on the lateral side will go away. That's the reason I feel the medial grafting is the one which is most important. Now, in a TKR, if there is a periprosthetic fracture, just on or below the flare of the femur, primary double plating is a must. Do not do a one single lateral plate. Primary double plating, it will solve the problem. Non-union also, that is the treatment. Because what happens is, non-union is the treatment here. We all know the stable fixation and grafting. Grafting alone is not enough. One has to rekindle the healing process by shingling. Most of them do shingling 2 inches above and 2 inches below to refreshen the whole area and then do the grafting. This is what I am talking about, the shingling. You have the fracture, single it all 360 degrees. Like here is the fracture. Now this is the humerus fracture which is treated with the reverse bending. This is not the one which will give you any compression. The treatment is compression. You do the compression by the posterior approach and do the things. That's the one. To me, 6 or 7 hole plate does not exist. Minimum 8 hole plate, and keep 2 screws around the fracture empty. And do the compression, whatever you want to do. But my observation is, unfortunately, in all Indian plates do not have this design. So DCS, which we use, an Indian plate, it will not give you compression all the time. So if you are using an Indian plate, probably you will not, they are only oval holes, so from there you may not get a compression. So that's the reason I feel use a compression device, Muller device, otherwise a Weber plate holding forceps in order to do a compression. This is a Muller device, as you know. If you are using an Indian DCP and if you find on the table it is not compressed, then probably it will not compress because the design is not very good. So use a Muller device, because this is the one which will not give you the compression all the time. Or you put a Weber device, this is a bone holding forceps, you put in a screw and compress it, you will be able to easily compress. That is the one which is available everywhere. This is the one you can see I am using that Weber's device, and this is the one which is compressing it, and all the time the fracture will be compressed very well if you do not have a Muller device. Majority of the newer sets in Indian things, they do not have a Muller device, and that's the reason why you need all these things. This is the fracture. Surgeon operated and compensated with the poor fixation with the huge bone graft. You cannot compensate with this huge bone graft. Bolo, no compression, distal only 2 functional screws. Graft cannot compensate for the instability. So it broke down, and he went down again and did the leg screw and the plate. Leg screw in the small fragment is the one which will give you necrosis of the edges, and this is what was happened. And ultimately This is the stage after so many months I went down, did the fibula, did the grafting, and the fracture heals up. This leg screw into the small fragment to me is contraindicated. No leg screw in a short oblique fracture. You do the leg screw and this part of the bone becomes necrotic and it will create a problem to you all the time. So use compression and not a leg in a short oblique fracture. This was the short oblique fracture comparatively because the prosthesis was there. He could do only the compression in the distal part, did the compression, and ultimately it went into a problem there. So it was ultimately treated without any screws there, a long plate and a grafting. And you can see again the medial graft, which has really given rise to a good fixation there. So in a short oblique fracture, compression is a different way you have to do it. Large majority of the people not been able to do that. This is a short oblique fracture. The first screw, you put it here in the acute angle. And then the second screw into the opposite side and try to compress. This will not compress properly. This is not the right way to do it. This is the wrong way to do it. While the right way to do it, put it in the obtuse angle of the fracture, as you can see here. This is the obtuse angle of the fracture. Then, having put it, now you go on the opposite side and compress it the way it is, because in this acute angle it will always overlap, as you can see. Now here was the fracture, transverse fracture, no compression, 7-hole plate, reverse thing, second surgery. Grafting was done without shingling. Good fixation, this doesn't hold. Those solid double fixation, shingling 2 inches and graft in this area was not done. So third surgery, fibula, took out the tissue which was necrotic and X-fix. 2 X-fix will not again stabilize the fracture. Necrotic area excised, fibula, but X-fix is not stable. This is, and this was, if I give you the names of people treated, you will be surprised. And still I would trust them for the next surgery. But this is how it happens. This is what it went down. And ultimately, I did this intramedullary fibula and the grafting and everything healed up. Again, subtrochanteric fractures. You can see that's a comminuted fracture is not stable. So it went down, the surgeon did the fibula graft there in a piddly little plate. That plate broke down, and after 5.5 years, this is the time, GT point of entry, medial grafting, and everything which was grafted, and the hook plate, and everything held up ultimately. So I feel that on day 1, if it was fixed up properly, fixed up with the adjuvant plate and a graft, this probably could have been avoided. Upper end fibula is not a site for a bone graft retrieval. Adjuvant plate would have helped in such unstable situation on fracture healing. Patient wouldn't have gone through for 5 years in order to become all right with multiple surgeries. Day 1, put an adjuvant plate. Overkill in orthopedic is not a sin. Again, you can see this again and again and again. You will see this nailing failing. Instability not understood by a surgeon on day 1. I think Dr. Naveen talks about invisible instability. You can see here, this is the one which is not going to heal up just like that. On day 1, put in an adjuvant plate, whatever type of plate you want to put. In such fractures I am talking about again. Then this will heal up on day 1 without a major problem. Hold in the upper fragment is poor, so failure. Put an adjuvant plate on day 1, it will lead to a union. Overkill in orthopedic is not a sin. Now, when this fracture is not united, surgeon does a replacement and he relies on the stem, but non-union is not treated. And you can see the stem itself cannot really allow the healing to occur. So if there is a subtrochanteric fracture which you are doing the implant, then at least it has to be treated with the tension band and the grafting or adjuvant plate. Do not rely only on the stem of the total lip. It will not be enough for that subtroch fracture. Subtroch fracture is a very sinister fracture. It has to be treated properly. In tibia, day 1, good fixation, 3 screws, still it failed. What went wrong was instability on day 1 was not observed. And this was, you can see, it is a short oblique fracture, ultimately treated with the plate. Now, similar to the last fracture, you can see I did the nailing first, and you can see after the nailing, there is an instability which on the table I could find. So even if I put in a fibula plate, and then again I did it, still there is an instability. If there is instability on the table after nailing and a fibula plating on day 1, I went ahead and put in an adjuvant plate, and everything heals up. Adjuvant plate, 5 months, patient walks about on day 1 and it heals up. So in that long, short oblique tibia, on day 1 on the C-arm, you can feel the instability which is there. Go ahead and put in the plate. If nail and plate is done, it takes a long time to have a radiological healing, but the patient is functional, can move about and walk about, and it will take time. Here it was a doctor. I did this close reduction with the clamp and did the nailing, and an adjuvant plate moves about and walks about, he becomes 100% normal. But this sort of a oblique fracture is not necessarily stable only if you do a nailing with 2-3 screws also. Isolated tibia fracture without a fibula fracture. The chances of non-union are a little higher. I wouldn't say it will go all the time in non-union, but the higher. So ream short dynamic nail with the fibular osteotomy is a treatment of that. As you can see, this was conserved, and again it was treated the same way with the fibular osteotomy. Intact fibula conservative treatment is also dicey. Today, I do a dynamic nailing and an oblique fibular osteotomy on day 1. Not necessary all the time, but it gives you a perfect healing process without any problem. And that's the reason I feel today, if it is only a fractured tibia, oblique fracture like this without the fibula fracture, I go down, do a nailing without the screws in the proximal fragment, as you can see, and a fibular osteotomy, and this heals up very well. Olecranon, this screw type of a fixation, I feel is not an ideal one, because it depends upon this hold over here. It purely depends upon how much is the fixation of the screw into the medulla. If it holds too tight, it will not go further. If it is too loose, it will not compress. So to me, the screw is not an ideal position. If it is perfect, it will go and it will be perfectly all right, but not all the time. And if you, once you do the tension bend after the screw, and it doesn't tension, then it will open it out. And that's not the ideal thing for the fixation. Do a tension bend. And as I mentioned, tension bend wiring should be done around the olecranon, around the triceps, and not around the K-wire. Same thing, as you can see, I have spoken in the earlier talk. And you must put the wire not on the lateral side where it can hit onto the head of the radius, but put the wire on the medial side. Here you can see the wires were on the lateral side exiting out, so it was hitting onto the radius, and when you're doing it, you could hear the click all the time. So the wires are passed onto the medial side, and that is the only way in which you will be able to avoid the complications. Not many people do this all the time there. Surgical tips K-wire presentation, full pronation and supination should be checked after the wiring are inserted. Anterior metaphysis is triangular, and lateral X-ray cannot be, it can be misleading. Penetration is underestimated. Put the wires onto the medial side, and then you will be completely safe. Even in the patella, as I mentioned, the wire behind the quadriceps is the one which is indicated. You can put the K-wires, but the tension wire should go behind the quadriceps, and it should go behind the tension, it has to go behind the ligamentum patelli, and not on the wire. You can see this patella, as I have shown you in my first talk. If wire becomes loose, and the whole patella becomes haywire. There is a non-union. This is the stage I saw the patient. Patient came to me for a non-union patella surgery. But you can see this is on day 1. With 3 kilo weight, he could flex, he could extend with this wire and a non-union patella. Non-union patella, because the transverse thing is intact, you do not need the surgery there. All those wires were hurting, so I removed the wire, non-union persist. But see, you can see this. He has a perfect ankle, perfect knee extension with even a 3 kilo weight. So non-union patella, if it is not separated or much, that means that the extensor expansion is still intact. And that will give you a perfect healing, perfect extension. You don't need the surgery. Ganglion. Ganglion surgery is the one which is it is done by juniors most of the time in a medical college. But you do not see, when you're doing the ganglion, your vision beyond this is not there. Ganglion comes out, and what my suggestion is, ganglion first decapitate it. Deflate the whole tissue which is inside. So decapitate it, never enter and then feel the bottom of you. Now you enter the cyst and now you feel the bottom. Now you can see here, I am cutting the ganglion, deflating the ganglion. Okay, sister. So once you deflate the ganglion, it is flat. Now you will be able to go to the base of it and take it out, and you will be able to cauterize the end of it, so that the ganglion will not recur. Otherwise, the recurrence of the ganglion is very, very high. Clavicle fracture, Harvey cited results of meta-analysis of 2000 plus clavicle fracture and found the non-union to be greater in 15%, which we have not been able to find all the time. And in comparison, complications of fixation are usually nothing more than a local plate irritation and possibly a numb area. This is what he said. This is the one article made all of us rich. We got one more indication of surgery, that is a fractured clavicle, which was treated conservatively. This was the clavicle, and he talked about the shoulder sternum distance is the one which will give you poor result, which is he mentioned about the function is affected even though fracture is united. And he talked about this. Never in our conserved patient we have found the problem with the shoulder function. Somehow the other, this is one article which went on doing it. Heel fracture, fracture treated non-surgically, not a bump, and the shortened shoulder width is a one which gives you problem. We all prospered. Gynec was advised surgery. I conserved. 6 weeks minimal discomfort. 1 year everything healed up. Mid-shaft fractures it is advised to conserve, advised to operate. When you operate, these are 6 small nerves which pass by. Best while doing operation I could conserve 3 before putting the plate. After putting the plate, none of them were conserved. All of them gave way. And you would get paresthesia, and this scarring is the addition. Keloid, if you get, you had it. Otherwise, the big scar which comes. And non-union doesn't give a problem. Here was a fracture which didn't unite. This is 2 months, and you can see everything is still perfectly all right. And you can see this is a non-union, full function after a non-union. So non-union also doesn't need surgery. Even if you put this subcutaneous wire, at times you will have to do the open reduction and you can get a clavicle, you can get a scar which is not very acceptable. And this was a fracture. This is Dr. Garigune has given non-union, perfect function which is there. And he says, sir, you add up these things, which is clavicle, which is the one. So today, when I talk, I have traveled through the whole journey of clavicle fracture. Today I talk on surgeries I have given up, and clavicle fixation for a closed fracture is one of them. Only a few rare indication of a clavicle fixation is there to me. Conclusion. Fund managers in long time is almost always succeeds. Thank you very much, friends. Thank you.
Thank you so much, sir. एक चेयर प्लीज, चेयर अभय जी, एक चेयर जो यहाँ था अभी बीच में, वहाँ पे आप लगाइए. And to the teacher of teachers, can I request you all for a standing ovation? It deserves it. It deserves it. Big round of applause for Dr. D.D. Tanna, sir. Thank you so much, sir. Thank you so much. Thank you, sir. और मैं चाहूँगा अपने परिवार के सदस्य हमारे सभी आए हुए, प्लीज हैव अ सीट सर. मेरे बड़े भाई, मेरी सिस्टर, सब लोग आए हुए, कृपया आप लोग सब स्टेज पे आ जाए. वी वांट टू ऑनर आवर गेस्ट चेयरपर्सन सर. प्लीज आप लोग आ जाइए जल्दी जल्दी, समय की भी कमी है. माई सन, माई नेफ्यू, माई नीस, आ जाओ जल्दी जल्दी. I will request Dr. Sarsis Nanam, who is also the president of Global Orthopaedic Forum, to honor Dr. Captain Vijay Shankar Singh, sir, first. Dr. Captain Vijay Shankar Singh. Dr. Captain Vijay Shankar Singh, sir. Misha, please. Misha, help करो जल्दी जल्दी. आ जाइए, कुछ लोग इधर आ जाइए प्लीज, आप लोग इधर आ जाइए. एंड वी आर प्रिविलेज, द फैमिली इज हियर, जो कि अपने पिताजी, अपने बाबा, अपने नाना, जिसके बारे में वो सुन रहे थे. तुम लोग आ जाओ प्लीज, यहीं आ जाइए. पहले सर से आशीर्वाद भी ले लीजिए. मेरी पत्नी सर, मनीषा, मेरी दीदी डॉक्टर अमिता गायनेकोलॉजिस्ट, मेरी बड़ी भाभी, एक और भाभी कहाँ चली गई? अच्छा उधर हैं, ठीक. चल प्लीज. हाँ, इसके बाद डॉक्टर बशीर आलम सर का, डॉक्टर बशीर आलम सर का सारा चीज. डॉक्टर बशीर आलम सर. वैसे लंच इज रेडी देयर. लंच बगल वाले कौटिल्य हॉल में शुरू हो गया है. फॉर डॉक्टर कैप्टन डी के सिन्हा सर, कैप्टन डी के सिन्हा सर. I will request Dr. Prashamsa to stay here with Amikar Dayal and Dr. John Mukhopadhyay, sir, please. Dr. John also, please stay here, sir. Dr. Shivendra Kumar, sir, just take that. Dr. Shivendra Kumar. हाँ, इधर है, Dr. Shivendra sir इधर है. शिवेंद्र सर को. इसके डॉक्टर विश्वेंद्र कुमार सिन्हा सर. आइए सर बीच में, आइए इधर आ जाइए, इधर आ जाइए, इधर आइए, इधर आइए सर. हाँ, यहाँ पे विश्वेंद्र सर. हाँ, विश्वेंद्र सर का कीजिए कीजिए कीजिए. हाँ, आई विल कॉल यू, आई विल जस्ट विद डॉक्टर एस के मलिक सर. लिखिए. हाँ, मलिक सर का. डॉक्टर जॉन मुखोपाध्याय, डॉक्टर जॉन मुखोपाध्याय प्लीज. वो दूसरा लोन है, एक लोन फोटो भी हो जाएगा, कल हो जाएगा.
कोई भी
कल आ जाएगा सर, आपका कल वाले में था. हाँ, आइए सर, प्लीज प्लीज सर, मलिक सर का यहाँ पे कीजिए, चलिए हो जाएगा। अच्छा प्रशंसा, एक और दूसरा लेकर और लेकर शमसा है, ये करो ना। अच्छा ये करो ना, फिर हम इसी का ही कर लेंगे। रहने दो, रहने दो। हाँ ये मैं रिक्वेस्ट डॉक्टर प्रशंसा सर। हाँ नहीं वो मैं चेंज कर लूँगा। हाँ ये लगा दो, वो इनका सर का घर पे है। डॉक्टर प्रशंसा सर। At the last, I request Mr. Amikar Dayal, और इसके लिए मैं अनुरोध करूंगा अपने IOA प्रेसिडेंट डॉक्टर नवीन ठक्कर सर, प्लीज present this memento to Mr. Amikar Dayal. Please come here. Mr. Amikar Dayal का memento and shawl. Yes, yes. इंटरनेशनल इतना अच्छी मिल चुका है अब ये सब तो, लेकिन हमारे प्यार आप लोग है ना। मैं रिक्वेस्ट एवरीबडी टू काइंडली कम फॉरवर्ड एंड एक ग्रुप फोटोग्राफ सबके साथ। सर प्लीज इधर आ जाइए। आगे बैठा दें तो तुम लोग आगे आ जाओ, आप लोग आगे आ जाइए, नीचे नीचे चलिए, फैमिली मेंबर्स नीचे आ जाइए, आ जाइए आ जाइए, एंड प्लीज प्लीज कम फॉरवर्ड सर, बस यहीं पे आप लोग नीचे नीचे। हाँ इधर से जाना है, ठीक से ठीक से। अमिका प्लीज प्लीज, हाँ आ जाओ, इधर भाभी उधर चली जाइए, उधर चलिए। एक मिनट अक्षत अक्षत एक मिनट बोले, एक मिनट लास्ट लास्ट जाओ जाओ। थैंक यू सो मच। द लंच इज रेडी, बट एक छोटा सा रिक्वेस्ट, जितनी जल्दी लंच करके फिर वापस हॉल में आ जाइए। थैंक यू सो मच।
एक दो बार announce करो. For the post-lunch session, our moderator is here, Ms. Dr. Vaibhav Sinha. Over to Dr. Vaibhav.
So good afternoon, everyone. So we are going to start the dreaded post-lunch session on spine. So I'd like to call the panelists to the stage. Dr. V.K. Sinha, Dr. Vijay Goni, Dr. Upendra Prasad, Dr. Marut Nandan, Dr. Prabhat Agarwal, and Dr. Balmiki Kumar. Panelists, please come on the stage. We are going to start the session. I hope people are not leaving for an afternoon nap after a heavy lunch. So we can start our session now. I'd like to call upon stage our first speaker, Dr. K.K. Mukhopadhyay, who will be speaking on thoracolumbar trauma, surgical decision making. So this is a topic which young surgeons like me find very confusing. So Dr. Mukhopadhyay will be shedding light on it now.
Good afternoon. So as he said, so this is for a little bit of confusion for particularly young spine surgeons to take which one we have to operate or which one not. So for TL spine fracture, so it is caused by high energy axial load. So there is failure of anterior and medial columns, and that constitutes the burst fracture. The fracture of the T11 to L2, it accounts for about half of all the spinal fractures. T10. So the spine is kyphotic and the line of gravity passes in front, and from L3 to sacrum, so it's lordotic, and the line of gravity passes behind. But for the junction area, that is the T11 to L2, so it's a tangential area. So it's a transition for immobile to mobile and a transition for kyphotic to lordotic, and the axial loading, it happens on the anterior as well as the medial column. So the diagnosis of the burst fracture is a morphological based on the radiology, maybe on X-ray or on CT. So there is a uniform height loss of the body due to crushing effect of the cancellous bone with horizontal spread and dispersal of the fragments. In India, the majority of the TL fracture, this occurs due to fall from the height, usually from the tree or nowadays from the construction site. So in X-ray, so how we will diagnose the burst fracture? So in AP view, we will find that there is a interpedicular distance, that is the AP distance is increased, and in lateral view, the reduction of the posterior vertebral height, body height, as well as the anterior, and there may be retroversion of fragments due to centrifugal dispersion of force. CT scan is the best one to delineate the burst fracture, and MRI is essential to know the status of the cord, but more importantly to know the status of the posterior ligamentous complex of PLC. So there are so many classifications. The Danish classification is of 5 types, but AO is the most simple one. A3 is the incomplete burst, A32 is burst plate, and A33 is the complete burst, that is both the end plate are involved. So how to take the operative decision? So if there is a progressive neurologic deterioration, or if there is a more than 50% loss of the vertebral body height, or if the local kyphotic angle is more than 30 degree penetration, these are the indications for operation in thoracolumbar burst fracture. The retroversion of fracture fragment of the spinal column is a relative indication, it is not an absolute indication. Though after that, everybody of us who does the spine, they know the Tillich coding system, established by Vaccaro. So many of us follow this one also. So this depends on the point system. So first one is the injury morphology. If there is a compression fracture, axial flexion, or burst, there is a point system at 1, distraction 4, translation rotation 3, complete to nerve root to intact 0. And lastly, the condition of the PLC. If the PLC is intact is 0, if it is suspected or indeterminate is 2, or if it is injured 3. So the decision to be taken on the point system, that injuries with 3 points or less, that should be done non-operatively. Injuries with 4 points is the gray area where we can do a non-operative versus operative. Injuries with 5 points or more, so we usually do a surgery. The goal of the surgery is to restoration of the spinal stability and the alignment, correction of the kyphotic deformity and decompression of the spinal column. And the purpose, that is the major outcome criteria, is the pain relief, the radiological correction, as well as the neuro recovery. The posterior approach is done by most of us. Is the efficient realignment can be done, indirect decompression can be done, even direct decompression can be done from the back, protection against the late deformity can be done, and it provides adequate stability. So there is a debate between long versus short. So in thoracolumbar past fracture, so it's a young patient, no osteoporosis. The literature says the long or short both are same if we put a index screw fracture vertebra. So and the we know the end point of the all spinal surgery is fusion. Transpedicular augmentation is done by within 3 hours. So posterior approach is the preferred one. So it stabilizes as well, it decompresses indirectly or directly. All operations are not devoid of complications. So there are general complications like PT, DVT, even blindness. Blindness is a devastating complication in prone surgery. And for local complications like nerve injury, dual tear, infection, implant failure. Thank you for your patient hearing.
Any questions from the audience for the speaker? So I would like to put up a question, sir. So how often do you go for fixation alone, and when do you plan for fusion? So my point is, when do you put bone graft and try to fuse the fractured segment? And especially when we are doing MIS surgery and only percutaneous fixation, what is your plan for so as to ensure that the fusion takes place?
The determinant is only one. There is the PLC injury. If there is a PLC injury, I always fuse. But if there is not a PLC injury, but the point system is more than 4, so point system is around 4. I don't do.
And my work mainly focuses on the Standu system. So before I begin my presentation on the Standu system, I'd like to mention this person, Dr. George Standu. He is from France, Bordeaux, and he is the one who designed the endoscopic sleeve system, which revolutionized the way we approach our spine. He is no more working. He has taken retirement and he is sailing somewhere in the Bay of Biscay. He is very fond of fishing. He has his own yacht. But then he was the one who designed, along with Anthony Young, the YES system, and Kevin Foley, transforaminal. So this was a phase. These are the people who were behind the invention and the innovation of endoscopic spine surgery. So what he designed, this is what he designed. This is a sleeve system which helps approach well-selected cases like disc and stenosis via very small and minimally invasive way, as we do, say, laparoscopic cholecystectomy and appendicectomy and all. So this was his prototype instrument. As you can see, top left, green. This is what he designed by himself on a CNC machine. This system consists of an outer and an inner tube, and the inner tube has 4 ports through which you can put in your camera, your nerve root retractors. The biggest one is for the surgical instrumentation. The one on the right is for your level marking. That's the targeting device, a non-invasive targeting device. This is what he designed. The design was then patented by Karl Storz, and this was marketed worldwide. The index surgeon has done more than, I think, 20,000 cases, and worldwide I think more than 100,000 cases have been done via this technique with good and excellent long-term outcomes. So this is being marketed by Karl Storz. I think in India, Jivan is also going to launch the same. So where do we intend to target put our targeting device? You can see on the left the interlaminar window. There is an inherent angle between the scope and the instruments so that you approach your disc well. So what you need to learn this technique is triangulation. We, being an orthopedic surgeon, We are well versed in arthroscopy and we know how to handle our camera. So this is a demonstration on one of the pig models we did in MISAP Con 25 at Gandhinagar. And you can see how do you need to learn your hand movements, because the concept of surgery is basically the same as you do in an open surgery, but what changes is just like you are doing your arthroscopy or how you are doing your laparoscopy. So you need to learn this triangulation as to how to manage these instruments. And why the shift to endospine? I think this is a very big topic to discuss, but then again, just to jot down, to minimize the collateral damage, not to harm our paraspinal muscles, reduce our need for fixations. We don't want to compromise on instability. We want to give a motion preserving surgery. We need to our ability to approach everything, our pathology, through a small incision, but doing the maximum at our site of pathology, and of course preventing adjacent segment disease in long run. So just illustrating my technique by an example, a young male, 32-year-old, severe low back ache, claudication, radiculopathy. You can see MRI, there is L5S1 disc, big posterior central. We did flexion extension X-rays to rule out any instability. There was none. We marked our level through a targeting device. This is a non-invasive, very few shots needed, hardly 2 or 3, and you can mark your level. So after marking, you can see the marking of the patients. We take up our patients in knee chest position. You can also take in prone, but for endospine, as was propagated, we take them up in knee chest position. You don't need costly tables, just that your table height should be low. This is how we position our patient, just as with any other spine surgery. My theater setup, very few instruments. Since the patient is in knee chest position, the table height should be low so that your hands don't tire out and your vision should be good. Instruments are very few. The entire set has less than 15 instrumentations. And when we go in, this is what we see. For orientation, 12 o'clock is midline, the spinous process. 6 o'clock is facet. Over 3 o'clock is your inferior lamina, L5S1, so that is S1, and this side is L4. So we can see the superior lamina. You can see the superior lamina, and then we start taking our Kerrison, our punches, 2 mm and 3 mm, 245, 345 is basically the workhorse. So we start taking bites in our superior lamina, you can see, and you can see the underlying glistening flavum. Then we make use of our neurosurgical patties, we put in, we insinuate, we dissect the flavum from the superior lamina, and we create a rent in the flavum. So you can remove your flavum piecemeal, or you can also remove them in toto like a butterfly. Butterfly challenge is a thing. So after I have completed my dissection, you can see I have removed all the flavum. You can see very well how you can see. You can see the dural tube, you can see the nerve root. You can see a big axillary disc. It's like a good morning disc, which is the cause and the chief culprit of the pain. And it's compressing both S1 as well as S2 nerve roots. That's the beauty of endoscopic spine. You cannot get this kind of visualization in any system. And as well, you can approach your axillary, superior migrated, inferior migrated, any kind of disc, whether it's central, paracentral, foraminal. So this is the disc which we can see. And after doing my annulotomy with annulotome or a 15-number blade, this is the disc material which is coming out, which is the culprit. So all of this is possible by a very small incision. And it's not the cost, it's not about incision, it's about preventing the collateral damage. So after the decompression has been done, you can see well relaxed nerve root, the canal which was so stenosed, and you can see the pulsated transmissions of spinal cord so well. So that is the beauty of the system. That is the advantage of endoscopic spine surgery in these kind of cases, if you select your cases well. So that's a flavum, half a butterfly, that's a Mordo disc which came out. So you have to really choose in your cases as to what you need to do. Another of my case, same L4, L5 disc, L5 sacralized. We again went in through the axilla and we did a discectomy, and we were also able to go even over the shoulder of the nerve root. So even a small disc, at times we see patients in our OPD and we feel that the patient is in a lot of radicular pain, but then we think that we cannot offer. So that's the beauty of the system, that you can even approach a 2 mm or 3 mm or any location of disc through this. Another of my case, I think I'll rush through them. Big posterior central again, you can see the disc fragment, you can see the spinal cord. So scope, we are doing disc, of course we are taking up stenosis, even multi-level stenosis, 2 or 3 levels can be taken up as well. We have evolved on to do the stand-to fusions, wherein we have been able to put cages, tumor surgeries as well as cervical. SGPGI, Dr. Ashutosh, they regularly publish papers about disc fusions. Long-term results have been very good, 95% good results, good to excellent results. And we as a society, it's World Endoscopic Spine Society, and we promote and propagate the stand-to endoscopic system as well as uniportals as well as full endoscopy. And we did last conference at Gaya. We did a cadaveric course at Gaya, and the last cadaveric course was attended by delegates from Zimbabwe, few from India as well, few from Bihar as well. It was done in Feb at Kolhapur, and the next Westcon is at Bali. So since Bihar is coming on chapter of World Endoscopic Spine Society, and we are having frequent visits to our courses, so I'd like to give a shout out to everyone. Those who wish to attend Westcon Bali, you can drop in a message to me or to the email ID here, and we will like to have all of you at Bali. Thank you.
Any questions from the audience for Dr. Anupam? So I would like to ask you, sir, so have you ever considered moving to biportal or uniportal? Because the main advantage of a water-based medium is the uniportal and the biportal system which uses a saline medium, which gives better visualization of the anatomic structures. So as we could see in the video, the visualization was very good, but ultimately the field was, you know, same as open surgery, which was like blood tinged, everything was blood tinged. So what do you think using a water based medium will be better compared to this system, because you are not using water as a visualizing medium?
I think it's not only about the medium. I have tried full endoscopic, I have tried biportal as well, and the stand-to also has a modification. Not the original set, but the other set, wherein there is a channel for water irrigation as well. Dr. Mohinder, he has changed the design. It's patented by Jesco, and they market it and they put in water. But what's the advantage of having water there? There is a lot of debate. Basically, there is basically a fight out between neurosurgeons and the orthopedic surgeons, because we as orthopedic surgeons are more comfortable with water because we have been doing arthroscopy. But then again, there is no added advantage which you get out of water, especially with respect to vision. If you say different systems have different kind of visions, different type of telescopes, different type of SD, there are systems which we have 3D and depth perception and everything. They say that if you add on water and then you have a small dural length, you cannot delineate, and then you close down your water and then you check back again and then you do your surgery in an open technique. So as far as studies have been concerned, water hasn't been of much benefit. In fact, on the contrary, there have been complications which have been reported out of if your surgery is long, and especially when you begin in, if you do your surgery starting. So your surgeries can go on for 3 hours, 4 hours, and if your outflow is not good, as is your inflow, and then the tissue edema, brain edema and all that. So there have been lots of issues, but I think water is not the main crux of their stand-to, because, and that too, studies have also proven that they do not give any difference as far as vision or outcome is concerned. So yes, no water for now, but yes, you can always add on.
Thank you, sir. So next we'll have Dr. Vishal Kumar speaking on a very under discussed topic, managing spine trauma in pregnant females. Over to you, sir.
Warm greetings to one and everyone gracing this occasion from Chandigarh. My talk is focused on we cannot leave 50% of the other part of the sex, that is females. And this talk is mainly focused for our young orthopedic surgeons who are coming into spinal surgery, practice of spinal surgery. So it will be a presentation case based, which will discuss management of thoracolumbar fracture in early pregnancy, balancing maternal stability and fetal safety. A young patient, 23 years old, female, presented with history of fall from height on 21st of May 2022 due to slip from stairs, following which she complained of difficulty in moving her lower limb and pain in lower back region. No comorbidities, almost 3 months pregnant, with no history of bleeding or leaking PV. General physical examination was absolutely normal, except pallor. Systemic examination was also normal, not the neurology one. Spine examination, spinous process were aligned in midline, L2, L3 spinous process were tender, SLR was negative. The neurological charting revealed it to be an ASIA D. Obstetric examination, abdominal examination, abdomen was soft, non-tender, uterus 12 weeks, no guarding or rigidity. So, organogenesis is largely complete, so there is no major malformation risk at the end of first trimester. CNS and genital development is ongoing. There is always a risk from radiation and anesthesia. So radiation sensitivity persists. The risk of threshold at 12 weeks is about 50 milligauss. So we need to be very careful about the radiation exposure. Miscarriage risk is reduced but still present under physiological stress. Early maternal physiological changes are going on with increased carbon monoxide, carbon dioxide retention and a hypercoagulable state. There is minimal aortocaval compression. Anesthesia is relatively safer than early first trimester because of lower teratogenic risk and progesterone levels a bit high. So this was the X-ray, which reveals widening of interpedicular distance on AP view and defect in the superior end plate of L2 vertebra with focal kyphotic deformity. We don't opt for CT scan. We went for an MRI. This is what the picture revealed. So level of fracture L2 burst with a significant canal compromise. So challenges in this case looks pretty simple, but still we need to know thoracolumbar fracture with neurological deficit monoparesis, early pregnancy, need for urgent stabilization versus fetal safety concerns. There are radiation exposure during imaging as well as during surgery. Patient positioning itself is a challenge during pregnancy, and anesthesia related fetal compromises. But indications of surgery, it has a neurological deficit, mechanical instability, risk of further neurological deterioration, and need for early mobilization to prevent DVT and pulmonary issues arising thereof. Choice of approach, posterior, only stabilization preferred because it avoids anterior, because that way we avoid anterior approach. It has got increased surgical morbidity and greater fetal exposure risk. Short segment preferred in such cases because of adequate stabilization and minimal operative time and blood loss. Alternative management options, conservative management, but it has the inherent risk of worsening neurology. Delayed surgery has the risk of permanent deficit developing, and anterior approach, if pursued, has a higher morbidity. Anesthetic considerations, avoid teratogenic drugs, maintain adequate oxygenation. Prevention of hypotension and hypoxia is must. Aspiration prophylaxis and be careful against it. And fetal considerations to be discussed with OBS guys pre-operatively. Surgery was done, posterior fixation, minimal of it, L1, L3 pedicle screw fixation with radiation minimization risk. Intraoperative consideration, ACUG guidelines say prone positioning with abdomen free to avoid uterine compression, minimization of fluoroscopy exposure, use of lead shielding of pelvis, careful hemodynamic monitoring, avoid hypotension, and maintain uteroplacental perfusion. So to minimize radiation exposure, we put all the 4 entry points simultaneously and check it on radiology. Post-operative outcome, hemodynamically stable, no worsening of neurological status, gradual mobilization initiated. Fetus remained healthy, no maternal or fetal complications. One of the goals of surgery is post-operative early mobilization. So with all this, what could have gone wrong? There could have been neurological deterioration, fetal loss or miscarriage, radiation-related risk, and anesthesia-related complications. This was the timeline of events. Injury day 0, presentation to us day 2. Surgery, we purposefully performed it on day 5 because by and large 99% of the spinal shock period is over by 48 to 72 hours. We took a gap of another 1 day. Post-op mobilization was our main aim to have a favorable outcome. To discuss, spine trauma in pregnancy is rare but challenging. Conservative versus surgical management remains controversial, particularly in patients without neural deficit but with a PLC compromise. Literature supports surgery when neurological deficit is present, and posterior approach is a safer option. A multidisciplinary approach involving obstetrics, orthopedics and anesthesia is essential. So to take home points, maternal stabilization takes priority in early pregnancy. Surgery is justified in presence of neurological deficit. Posterior approach offers optimal risk-benefit balance. Radiation exposure should be minimized but not avoided at the cost of care, and multidisciplinary planning is critical. Thank you.
Excellent talk. So now we are going on to the next topic, dural tears in spine surgery by Dr. Sanjay Yadav.
So cutting short all the formalities to save time, I thank you Dr. Mulya sir and whole the organizing team. So dural tears in lumbar spine, that's the commonest one which we operate. So I thank, I pay my regards to my mentor, Professor Arvind Jaiswal, who is no more now, and it has no conflicts of interest. This is morning view from Varanasi. So dural tear, durotomy is actually an important factor. We can have malpractice cases with with the current times and all, and it may lead to litigation as per this article. So decision favoring the patient was more likely in cases with an alleged delay in diagnosis. So it happens, that is not a problem, but when you fail to recognize the importance and or delay in diagnosis, you ignore it as a surgeon, we feel okay, and then that becomes the problem. So from a legal standpoint, surgeon should not consider it an entirely benign event. It should be identified and it should be repaired, and when you identify and repair it properly, long-term outcomes are almost similar. So it affects the cost and length of the stay. The rate of dural tears in teaching hospitals was significantly higher, probably few of our junior colleagues as part of the training, so little higher than when we operate in a private setup, around 1% difference. So it's usually iatrogenic. One of the commonest occurrences, or most in spine surgeries, it may occur during exposure when you use cautery a little carelessly or less careful, or at the end of the decompression by sharp bony edges. Undetected or unmanaged durotomy is actually present as a CSF leak or a pseudo meningocele. Most common use is when decompression using a Kerrison ronger or the high-speed burr when it slips. Most common in lumbar spine, uncommon in cervical regions. The capsulate portion of the lamina in a lordose spine is usually the culprit because it dips into the cord. So again, in the large series, more than 1 lakh cases, they have occurred. The unintended durotomy occurs in 1.5% of the cases. Both young and experienced, it's the same depending upon the complexity of the cases. These are some of the predisposing factors. Advancing stage because the fat is less, the productive layer is less, and the dura is thin. Ossified flavum, anatomical variations one should be identifying in the preoperative radiographs. Chronic stenosis results in the thinning of dura and sharp bony projections. So in some of the studies, lumbar epidural steroid if you give and you do a procedure within 6 months of injection, it has more risk of durotomy. Then again, in another study, the rate was around 10% in adult spinal deformity cohort. So these are complicated cases where the incidence can be more. So prevention is always better than treatment. So one should have adequate magnification and illumination, adequate exposure, avoiding slipping in the canal, using, like when the cord is exposed, you cover the cord with some protection. Fixation prior to decompression is a preferred approach. Decompression should be done from the caudal to the cephalad, and lateral decompression should proceed actually the in a cephalocaudal fashion. Disectomy should be done actually after identifying the nerve roots. No shortcuts in all those basic rules and parameters. Adequate protection of the dura during lumbar interbody fusions. Use cotton patties. These are available. Previously we have the nurses making it for us. Now these are readily available. Thin and fine. In ossified ligamentous flavum cases, the thin bone of dura can be actually left with the dura. One, if it's as a flotation segment, need not try to take out everything. It can cause damage. And in revision surgeries, one common dictum is that you start from a relatively, do wide exposure and start from a relatively normal side towards the scarred area. So these are all the diagnosis. Patient may remain asymptomatic. One clinical pearl is like drain output, which is increasing rather than decreasing over 24 hours, should actually raise a suspicion. Low pressure headache or all those and dizziness, vomiting should be the clinical findings. So large compressive pseudomyelitis can be rare and potentially devastating, so one should not ignore it and should be recognizing it and thinking of the possibility of it. So MRI is the modality of choice. What happens when you detect it intraoperatively? If you detect it intraoperatively, don't worry, take a deep breath. Head low position, we ask the anesthetist to keep a head low and trend position. Suction pressure should be reduced. Bony decompression should be extended for a proper visualization. Any prolapse rootlet should be repositioned, and it should be sutured with a 5/0 or 6/0 proline. You can do it with the 2x or a 4x loop. And then multi-layered closure, subcutaneous tissue and skin. So which are repair to be done from cephalic, slightly proximal to the tear, then again after a rip by local muscle, fascia or fat, and today fibrin glue is available, so that these all these things come very, very handy. Then we ask the anesthetist to check it by Valsalva maneuver. Then close it by a continuous suture. We use official drains, but I don't give any negative charge on it. So the fibrin sealants are available now. These are standard management. So when you do it post-operatively, you can do all these epidural patch, or you can sew some gauze piece over it to tighten it, or otherwise if doesn't improve, then you can actually re-explore and repair. So one should not hesitate to re-explore and repair rather than having some long-term complications like infections. So this is the technique described by Papaver et al. So again, the repetition of same thing: enlarge the bone defects, find out any bony fragments, reposition the extruded nerve fibers, watertight closure, check by Valsalva, fat patch, closure in multiple layers, and drain if needed. And then again, one is the sandwich technique: put a small patch inside the dura, then close the dura and put above it in a sandwich fashion. So this is just showing the positioning of the rootlets and doing a continuous closure. Then these are all the things which are available in the market for augmentation: dural seal, exact, all these things. Delayed protection. So treatment for this is lumboperitoneal shunting. So in minimally invasives, because we actually spread the muscles, so the muscles actually close, and undergoing MISS and unneeded durotomy was associated with fewer complications rather than in an open procedure. So surgical outcomes in case of incidental durotomy. So 14% sustained a dural tear in his study, which was repaired during the surgery. A dural tear that occurs during an operation can be treated successfully with primary repair followed by bed rest. Such a tear does not appear to have a long-term deleterious. So that is the importance of recognizing it, managing it on table. And closed suction wound drainage does not seem to aggravate the leak and can be used safely actually in the presence of a dural tear. So this again, to conclude in this study, the accidental dural tear did not have an overall significant adverse impact on short-term clinical outcomes. So this is an algorithm for an accessible tear, and so primary repair is one with all the methods, then secondary repair is by dural patch or graft, and these add-on reinforcements by all these techniques. So this we'll skip for this. It's better to team up with the neurosurgery team. And in our series, we had around 75 cases with 8 dural tears. One was more than 1 centimeter. So these are all the starting time of your career and practice. Rest were less than 1 centimeter. So we repair primarily all these with 5 or 6 proline and fibrin sealant. One was identified post-operatively. So that was re-explored. We could not find it, but still the only thing we did was we did the closure more meticulously, and it was settled. So average increase in surgical time in our experience was around 45 minutes to 1 hour. And in one case where it was more than 1 centimeter and it was the beginning of time, so the rootlets actually came out. So I called the neurosurgery colleague for some guidance, and we reposed it inside the dura with a patty and closed it above that. And there was no neurological deterioration in any of these cases. So now some examples. So this is again one case of a lumbar stenosis with the dural tear. So we have repaired with proline and then reinforced with the fibrin glue, this T-seal. So this is the science behind that, and this comes in a syringe. We have to mix and use a Duplojet. So this is another example. So this works well. This works well in so far in our experience. This is another example. So this is one particular case where this is an ossified ligament, and there were multiple level problems. So the main compression was at the lower 4 levels. So this was just 2 more slides. So this we did a long segment decompression. The idea was to do a long laminectomy only at the lower 4 levels. So in this case, because the bone was inside, we had a big dural defect. So again, this was the first experience with the large defect. We harvested the thoracolumbar fascia with the help of neurosurgery team. And then we had the Duragen patch, which is a bioresorbable collagen matrix available with us to cover this frame. We tied it at the edges, and the edges were sealed with the T-seal. So this patient we kept for around 10 days, and finally the wound healed, and she did well. So to summarize, intraoperatively dural injuries are not uncommon. They are more in revision and complex cases. Magnification and illumination and appropriate instruments are must. Meticulous surgical technique, increased operative blood loss, increased surgical duration, and longer hospital stay. And the crux is that the time for repair is actually a lot more than time for meticulous surgery. So we spend little more time with the surgery to avoid the time for repair. And common during last surgical stages, second case, and fag end of the day, over enthusiasm. So you should know your appropriate surgical endpoints. Team approach is must, and one should keep learning. So this is a spine emergency kit. When we usually ask our resident or the OT team to have it with them. And I thank the team from Hong Kong University, and I thank Dr. Amulya for, I'm coming to this meeting for the last 4 years, and it has been an exceptional experience apart from academics and the organization which he has. So I invite everybody to this BHU Spine Cadaver course on 18th of April. It's a Saturday, and 19th April we have a state level course on spine. So anybody who's interested, please get in touch with me. Thank you. Thank you. Thank you.
Very nice talk. So one of my teachers used to say, dural injury is not a complication, it is an intraoperative event, and how you manage it will decide whether it becomes a complication or not. So with this, we'll go ahead with the next speaker. Our next speaker is Dr. Gautam Prasad from Paras Hospital, and he will be speaking on osteoporotic fracture, challenges and lessons learned. Over to you, sir.
Very good evening to everyone. Osteoporosis is increasing with the geriatric age group that's increasing, and also the expectations of patients is also increasing. So let's look at this X-ray. There are multiple osteoporotic fractures. Few are the old ones, and few are the D12 is a new recent fracture, and there is a subacute fracture D10. So what we did in this morbidly obese lady with various comorbid, diabetic, hypertensive, then she had CKD and was bedridden for almost 3 to 4 months. So this is what we did. We did a hybrid fixation. She was doing well. After some couple of weeks, she had a fall, and then she fractured a vertebra just above. If you can make out, the suprajacent vertebra has fracture at the lower end plate. So the other chronic fractures are still there, but this fracture, which has been a new one, that caused the disability, and so we had to go in again, and this is what we did. We have to cut short the previous rod, then put in a domino, and then extend the fixation. This is her 11 months follow-up, and she is doing fine. There is another case, a 50-year-old gentleman, BSF personnel, so we expected a good bone stock, and because he was not willing for any major kind of surgery, we did a MIS fixation, and this is how at 3 months it failed. Probably because of the poor purchase, the bone was not as good as I expected in a army personnel. It was a short segment at its junctional level, and obviously in MIS you don't do fusion. So probably this was the causes, and then we have to revise him eventually, and this is what we did. We corrected the deformity, went in long, and did good fusion. So why these fails? So osteoporotic fractures fail because of multiple reasons. We can divide into the patient's factors, like the patient is having osteoporosis to begin with, but apart from the bones, the muscles are also weak. So there is an element of poor muscle strength, sarcopenia is present, and most of times these patients, they present with various comorbidities. Apart from diabetes and hypertension, many times they have a previous history of stroke or Parkinson's disease, which affects the muscular structures as well. And even if they are on osteoporotic regime, at times, most of the times, they are on irregular management. Surgeon's factors, inadequate screw purchase, if the alignment is not restored to what is expected, or the sagittal profile is not good, as expected, or fusion has not been done. And some factors like repeated trauma, which is not in our hand. So how to prevent it? To prevent it, first we have to manage the osteoporosis, which is the root cause of this. Along with that, manage the muscular strength. Of course, in chronic cases, we can do this, but in subacute or acute cases, it will be difficult to manage this. And medical management. Medical management in terms of calcium and protein-rich diet, calcium supplements, vitamin D, teriparatide, denosumab, romosozumab, and treatment of sarcopenia. So all these things has to be started in advance when you plan a management of osteoporosis. When we go for implants, we have a choice of, apart from the routine screws, we go for double thread screws, double DOD, that's double outer diameter. If you can make out on this, the threads pitch is different proximally where it's at the pedicle level as compared to what it's at cancellous level, the body. Hydroxyapatite screws or cement augmented screws that increases the pull-out strength of the construct. If the bone stock is very poor, we can go in for sublaminar wires, or you can use a combination of both of these. Surgical techniques, your screws should be more longer than what we actually put. Usually we are satisfied with the screws end reaching the anterior 1/3 and posterior 2/3 junction. So here we go in right up to the anterior cortex. Use thicker screws, 6.5 and even 7 mm screws. The screws could be in different directions, like the proximal screws can be going much superiorly, the lower one can be going downwards. The screws have to be more medially placed. You can go in for a bicortical purchase, and if need be, augmented with cement. Always see to it that the normal alignment is maintained. If you need cement, vertebroplasty or cage for that, just go in for that. Plus, other conditions like physiotherapy is a must, management of various other comorbidities, and always assess the patient in terms of walkers and braces. So to prevent failure, you have to have a proper patient selection, good preoperative management, adequate techniques, keep your every implants ready with you, and post-op management. Let's go with some examples. So this lady came with a very poor bone stock and also poor financially. We just did a good fixation with sublaminar wire, and there was some weakness to begin with, so we even did a laminectomy in this lady, and she did well. The weakness improved, that though she was bedridden for almost 9 months, she could walk within 4 weeks of surgery. She was a walker. Another lady, when we made her prone, that vertebra just opened up, so the gap was there, so we had to put in cement in her, and we supplemented with sublaminar wire. Again, a very good result. Another gentleman, he had a fracture in the lower end plate. We put in a cement and supplemented with hybrid fixation. Now, if you look at the screws, these are the double thread screws, and these have been supplemented with the wires in between. So this prevents the failure at the index level, that's the fracture level, and hence prevents the kyphosis being developed at the index level. Now this lady, I had operated on this lady long back. After some 6 years, she came with another fall. She had a fracture at the suprajacent level. We checked her out, and it was less than 2 weeks old. We could manage her with just kyphoplasty, balloon kyphoplasty percutaneously done, and she did well. Because it was just an intravertebral lesion, which was not, the instability was not intervertebral, we could just manage with vertebroplasty in her case. Another case with multiple vertebral fractures, she had to be put in means we did pedicle fixation with the screws in the index. Yeah, in the index screws also were put in, and long construct was made. And if you can make out, there was a cross-link connected to prevent the parallax effect of the construct. As I told about the anterior column construction, so if you don't manage the anterior column, the screws are not going to be strong enough to hold the spine in normal position. So you see to it that your anterior column is reconstructed, whether you construct it with cement with the help of vertebroplasty, or if there is too much of communication, then we have to make an anterior column reconstruction with the help of cage and local graft. But at the end of the day, when you come out, the normal alignment has to be achieved, and the anterior column has to be sturdy. Another case which just presented with intravertebral instability, so we could manage with only vertebroplasty in her case. This lady, she had very porotic body. In fact, it was we didn't need to even put in the pucca and everything to drill in her case. So the cement augmented screws were inserted in this lady, and she was a walker by 3 months' time. So the take-home message in osteoporotic cases should be a proper patient selection is a must. Pre-operative preparation in the form of osteoporosis management in the form of the muscle strengthening, that has to be done. Keep your all instruments ready, whether it is screws, wire, a combo of both, cement, everything ready. Bailout strategies should always be at the back of your mind and should be ready in your OT system. The adequate techniques has to be applied, adequate alignment has to be restored, and supplement this with medical management in the form of teriparatide or bisphosphonates or denosumab, and a good physiotherapy which will help the patient to have a better outcome. Thank you.
Moving on to our last speaker, Dr. Prashamsa. He'll be speaking on intradiscal ozonucleolysis. Dr. Prasham.
He had covered the topic.
Yes,
even.
yes. So he has already spoken on it. So we'll call all these speakers onto the dais for a group picture. And if there's any question from the audience, now is the time. All the speakers can please come on the stage. Any questions from the audience and the panelist? We can take them now. So I have one question for Dr. Sanjay Yadav, who spoke on dural tears in spine surgery. So if in any case, Dr. Vishal Kumar, please come on the stage. So my question is to Dr. Sanjay Yadav. So if after a dural injury you do a Prolene 5.0 repair, and after giving a Valsalva, if you check there is still a leak, will you still put a drain in that patient, or you will choose not to put a drain? Or what is your salvage strategy after repairing and then not getting a watertight closure after doing a Valsalva?
So after doing a Valsalva and you feel that there is a leak, then you have to see that time and make sure that nothing comes when you do Valsalva.
So you will resuture it?
Yeah, of course,
okay.
of course. That means one of the stitches loose or something like that, you can put a fat over it and take one more stitch. That's the, otherwise you can't proceed.
Oh, thank you. Any other questions from the audience?
Safety is there, only 2 to 3 millimeters. So how?
Most of times in osteoporotic bones, even in otherwise also, I try to be as close as to the cortex. So the moment in this osteoporotic bones, we try to put in the pedicle probe, and you try to push it, it actually punctures the anterior cortex. And there itself you take out, means you take the measurement and put the same thing.
So do you do the bicortical?
Bicortical in osteoporotic I can do, but not in a normal person. Because when you're actually trying to push in and try to find out, you first hear a tick, tick, tick. The sound changes when you're at the cortex, just like how you do the sacral fixation. And with that only, many times it gets punctured. So there and there itself you do it. That's the measurement.
But the safety margins are very narrow, you know,
Very
only
narrow. Yeah.
2 to 3 millimeters are there with the outer and vena cava.
Yeah.
And sir, do you ever
But only in, means if I am sure that I won't be supplementing with cement. So if I'm going to put in cement, then I am extra careful not to perforate that.
And sir, do you ever decide to wait before you fix a osteoporotic fracture? Like, do you want to give a course of teriparatide and then go in for surgery? What is your criteria for such a decision?
Fortunately for me, most of the patients, they arrive 2 to 3 months after they have fallen and tried all those things. It's very rare nowadays that I get a fresh osteoporotic fracture, which if it comes, my always preference is to conserve. Now there are few features on the MRI, like if it's very hyper or very hypo on both T1, T2, or if the end plate is of both the sides, the superior as well as inferior, those are actually damaged, and the PLC is also gone, then these fracture, even if you keep them in bed rest for 2 years of the time, that after 2 years and 1 day when you make him stand or her stand, she is going to complain of pain. So these patients are not going to heal. So in such cases where I'm very sure it's actually a surgical, 100% I'm sure, I offer them surgery there and there itself. Otherwise, you always try to conserve, because it's a very bad case to have osteoporosis, and you don't know when when they will again revisit you for another fracture.
And when you do decide to operate and when you're putting screws, do you tap the trajectory or not?
Only the initial few millimeters I tap in osteoporotic.
Okay, not along the entire length.
Not entire thing. And also I under tap.
Yes.
For a 6.5, that's under tapping is for my all. Even for normal persons, I under tap it. For 6.5 screw, I use a 5.5 tap.
Thank you, sir.
Thank you.
Any other questions from the audience?
You mentioned about teriparatide.
Yes, sir.
2 months, 3 months, it won't make any difference at all. It works only after 6 to 8 months. So try to give it teriparatide and hope that the bone will be better. Then you fix it up and take it into use.
Noted, sir.
Yes, sir. It's only if it's a chronic case where the patient is just having LCS or kind of listhesis, where we will actually get the patient, make the patient wait for a few months, then that's, otherwise in osteoporotic fracture it's not going to be option. Thank you.
Good afternoon, everyone. I am Dr. Surya Prakash. I am moderator for the session on nails. May I welcome Dr. Naveen Thakkar sir, Dr. Janendu Sekhar sir, Dr. Rajiv Anand, Dr. Satish Mutha, Dr. Arvind Kumar Singh, as a chairman and panelist. So let us start our first session by calling Dr. M. Ajit Kumar sir for his topic on multi-lock nailing in 3/4 part fractures, proximal humerus. Ajit sir. Okay. So let us call Dr. D.D. Tanna sir for his topic on alternate surgery for PFN.
Please put the sound as I mentioned you. Alternate fixation for IT fracture. Can you explain why this in these 3 different heel fractures, 4 different heel fractures? Minor varus, no varus, still deformity, and there is a gross varus. This is the end result of a PFN when we do it in quite often things, and we present this, the fracture is healed up. But when we see the patient walking, that is the time we realize they cannot walk for a long distance. Now this is the one which, as I mentioned, we brag about it that the fracture is healed up, we don't need any supplementary plate or anything. Now here is the one fracture healed up, young man. Herein. अरे साउंड नहीं किया तू यार. Sound है क्या? Anyway, he is telling, he is a young man, I am asking him कितने चल सकते हो? तो वो बोलता है 5-10 मिनट से ज़्यादा चल नहीं सकता, हमको बैठ जाना पड़ता है. चलो छोड़ दे अभी, चल. जाने दे, चल. All he is talking to me is 5-10 मिनट से ज़्यादा हम चल नहीं सकते ज़्यादा और थोड़ा बैठ जाना पड़ता है. The young man, we describe a fracture as healed up. So PFN is not a solution for all fractures, and even a minimal varus occurs, he is going to have a problem.
तो कितना चल सकते हो?
15-20 मिनट तक चल सकता हूँ.
बाद में थक जाते हो?
बाद में थक जाता हूँ, बैठना
पड़ता है. ज़्यादा.
Importance of reduction, entry point and placement of an implant. That police wala. I know the surgeon has been charged 1 crore of rupees. It is in the Supreme Court. Yeah, I know. But that we don't consider. We just give a fracture as healed up. Now see here, in this sort of a fracture, when we put the PFN is actually going through the fracture. And still, we continue doing PFN. It's damn difficult to talk against PFN, and I'm really trying to be very brave to talk against the PFN. PFN Bharat is such a big Bharat that if you talk about a PFN, 10 people will jump on you. Now this fracture, what's the use of doing a PFN? If you do a PFN, now that piece which is there outside is going to break out. It broke out and is a failure. Why not do a DHS? Is there any problem? Do a DHS, do a tension band and everything is fine. Don't give up DHS. I think there are PFN wala tell you DHS is in the cupboard. All these DHS will do wonderful job into certain cases. You don't have to. Only thing is the lateral collapse above the GT, if it is big enough, then the DHS is going to work very well. All these are the perfect DHS and you will not regret it at all. So don't give up DHS. All these are the cases which are DHS which will do much better. Now here, this is the fracture, big beak, which is the big thing about it. I tried to do the fixation, but ultimately I did a diamond Houston. And you can see there is no varus, diamond Houston. If it is a big beak, you do a diamond Houston. I think it is, to me, whatever they talk about diamond Houston is given up, it is not given up. In such a big case, to me, still primarily, I go ahead and do a diamond Houston. And diamond Houston, you get excellent healing, patient walks out almost immediately, and you don't end up into varus. This is the sort of a fractures which do not need a PFN, and you can just do a DHS or a diamond Houston, whatever it is going to give you an excellent result. Now this sort of a fracture which I have showed, the traction view, you do a blade plate and that's the one which will solve the problem. I have already shown you in my previous talk. Now this is the proximal femur plate. Somehow I don't know why it is not taken up. The Smith & Nephew device which is there of a copy which is available, original is not available. But copy of a Smith & Nephew is available which is extremely good. This sort of a fracture, you reduce the fracture, open it up is not a sin. Open it up, do a proximal femur plate with a tension band if it is needed, and you will get no varus and the things will be perfectly all right. Don't do a PFN in such a fracture which is going to really shatter everything. Copy of original Smith & Nephew is available. Now this is the I want to show this is not being done. This is Dr. Jawar Jethwa from Ahmedabad. He does these enders with this sort of two screws here. And see, these 8 months, in such a fracture, there is no collapse. This is another student of Jawar Jethwa, Nitin Patil from Karad. Such a bad fracture. Again, enders with 2 screws, no virus. Patient walking about well. I think every time Jawar speaks, people are all the time highly criticizing, "Arey enders sala Gujarat mein hi hota hai aur kidhar nahi hota hai." I think you have to see the results and then you talk about it. This is Dr. Mukhi does it. And I think cases after cases after cases he has shown me. He does a DHS, 2 screws, enders, and a tension band. Such an old lady moves about, walks about. This is an old man. He sends me cases after cases. Walking about, climbing staircases. Now this is this is a polio patient. Only PFN is just not worth it. This is a GTR plate with a polio patient. He can walk about, move about. With such an oblique fracture, otherwise you won't be able to really do anything. So PFN alone is not the treatment. Now, I feel the replacement in our intertrochanteric fracture in the elderly is undersold. I don't know why people don't do it. It is a wonderful operation. Such a badly comminuted 78-year-old with a big gap there, do a replacement, GT reconstructions, and the patient walks about immediately for ages. This is the one whom I knew socially very well. I did the GT reconstruction. I did the LT reconstruction. Whether it heals up or no is different thing. And she is walking about very well. And I know that 8 years she went on and she died after 8 years. So the replacement is undersold, I feel. This is also the choice in this age group in experienced hands. All GT point of entry, no virus healed, as I mentioned to you earlier. This is my hypothesis. This is not only PFN in comminuted fractures. You must add up a plate in order to be absolutely sure to get a good result. Please do not order only PFN, but order also the plate along with it. PFN with the side plate, any type, hook plate, TFN, or whatever it is, whenever in doubt, just add it. Thank you very much.
I think Dr. M. Ajit Kumar has come. Okay, so I'll call upon him for...
Ajit, sir.
Yeah.
Please come.
Good afternoon. Sorry, I was a little busy in the earlier session. My brief is to talk on multi-lock nailing for proximal humerus fractures, and again grateful to the organizers for the opportunity. So everybody starts off with this slide. Most humerus fractures, proximal humerus particularly, can be managed conservatively. But I think more and more there is a demand for these to be managed operatively, and most of us are actually operating on these. So this is one example, conservatively managed in this particular individual, and an excellent result. But there are indications for very complex fractures like 3 and 4 part fractures like you're seeing there, head split fractures, and if there is significant medial void, medial comminution and void, that's another indication for these fixations. So these are all the indications, right? So far the Philos has addressed most of the problems with proximal humerus fractures, and it is considered the gold standard for fixation of proximal humerus fractures. And if done perfectly, has excellent results. My friends from AIMS, Dr. Trika and Dr. Samarth, have a great series, and that is, as of now, considered the gold standard. Right? So this is one of our cases in the earlier days. Did that, and I think it has done reasonably well. But if you look at the literature overall, even from Boileau's article, the authority, world authority on proximal humerus, whether it is arthroplasty or osteosynthesis, there is a huge incidence of repeat surgeries with Philo's implant, whatever be the cause. It may be minor causes, it may be major causes, but there are issues. So they have tried to overcome that with the medial plate, with the fibular strut, and so forth. Now, multi-lock nail is one of the devices that has come in recently. It's not just the one. There is this telegraph nail with the other company, and few others are there, where the entry is more medial. It is not through the sulcus, unlike the other nails. The other nails would, the earlier ones, in which again for shaft humerus, I had a huge series. The entry was through the sulcus there, and the issues with rotator cuff, shoulder stiffness, all of that was there. So this addresses that problem. So here, much more medial entry, and going through the cartilage, you do not actually interfere with the shoulder range of movement. And since you're going with through the substance of the rotator cuff, there's not too much of a problem with the shoulder stiffness. And then you have these bolts. They are not screws, they are bolts. You can see the threads much closer. And there is an option for screw-in-screw fixation, just like some people are familiar with the FNS, the similar way. And there is a kickstand screw, just like you have in Philos there, that gives you the medial stability to prevent varus. And then multi-directional locking, or at least in two directions distally. There is a bushing in this which prevents migration. So all of these give an added stability or added benefit in fixing these elderly osteoporotic fractures. The important thing to realize is the lateral part is the most osteoporotic part of the humerus. This entry is more in line, and all of us know that load sharing device is better than a load bearing device. So this is through the more dense bone in the proximal humerus. These are the things that I mentioned, screw in, screw. So it overcomes the deforming forces. The entry is more medial, like I've mentioned there, and better torsional stability. And it can, this bushing actually, some of the Indian designs do not have this, and I think that may be a disadvantage in the long run if you look at the follow-up cases. So, yeah, just to show load bearing versus load sharing, all of you are familiar with this. So just run through some cases. Yeah, 3 minutes. So that's at healing, and that's the function. At the end of 2 years, he will be much better. So in the elderly, much more elderly, totally displaced. Many people might think of a reverse shoulder for that particular age, but not all of us are very familiar with reverse shoulder. Not all of us can reciprocate the results that is mentioned in the West. So this, the same elderly lady, elderly man, this is the outcome following that fixation. In a head split situation, again, that's the CT showing you the split there. If there is enough, about 10 millimeters of bone for the nail to go down, you can hold the head split fragments together and then pass your guide wire and get it. Here, the fixation is not great. In fact, like Dr. Tanna showed in some of his trochanteric fractures, the nail is a little more lateral than where it should be. However, because of the kickstand screw, I guess, and in a younger patient, it has held on and he has gone on to union in spite of being a head split fracture. Yeah, that's his range of movement. In segmental fractures also, this is a good option, right? One implant for 2 fractures, and they do well. These are all immediate or early follow-ups. In the long run, of about 1 year, most of them have regained. That is the entry point, much more medial than where the sulcus is, and that and there is a facility for repairing the rotator cuff just like you have in the Philo screws to fix it all back. That's the most critical portion actually, so that the cuff heals well and that restores the function. So, yeah. Okay, so just running through a load of cases, even in a much more complex scenario like this, with so much of comminution there and a compound fracture to match. This was like in all fractures, femoral fractures also, this was not touched. and you can see how well the bone reforms over a period of time. Right. So huge number of cases we have done, right? And we have had some problems, but overall our experience with this is far superior to what we had with the Philos plate. And so this has actually improved our outcomes, and we can do it in any age group, including elderly patients whom I think many arthroplasty surgeons would consider a reverse shoulder. So thank you very much for your attention.
May I call upon Dr. Samarth Mittal, nail plus plate in distal tibial fractures.
Thank you, Ajit sir. I think you've just told us how we should move away from plates onto nails. And thank you, Tanna sir. You've told us that we should not only depend on nails but move on to side plates. So now everyone is confused. In lower limbs we are using plates, and in the upper limb we are going on to nails, when the real philosophy was lower limbs are weight bearing and we need a nail, and upper limb it doesn't matter. So just to end that confusion, I think both work equally well, but if you combine them both together, they work the best. And that's what I'm going to talk about. This is going to be a nail and plate construct in distal tibia fractures. A disclaimer, the gold standard remains what you already do. If it is an extra articular fracture with good amount of hold for a nail, I think a nail will do a good job. If it is an intra-articular fracture and you've been trained as a plating surgeon for those fractures, I think they do well enough. So that is not a problem. But there is some amount of evidence. Looking at this paper, they say in terms of biomechanical stability in a distal tibia fracture, nailing with a polar screw is much far superior than just nailing, and which is superior than plating. Another similar paper looks at distal tibia fractures, what is more stable. They say it is not just the nail, a reamed nail is better than an unreamed nail, is better than a plate. It makes more sense for this paper for a shaft tibia, but we are talking about a distal third tibia where you think that reaming does not make much of a difference. Another similar publication where it says when to fix the fibula, and it says if you fix the fibula, it gives you more stability and the chances of late malalignment with the nail only is decreased, while if you do not fix the fibula, then there is a chance of late malalignment with the nail. And another publication which says if you are nailing these fractures, the least you need is 2 distal screws and 1 proximal screw. If you are using these, there is no difference if you have 4 distal screws or 4 proximal screws or 5 distal or 5 proximal screws, no difference. All you need is 2 distal screws, and they've proven how 2 distal locking interlocking screws in a nail is good enough to 5 or 6 screws of a plate. And this publication, it says you could do either, but plating leads to more chances of infection and nailing leads to more chances of malalignment, if not in the immediate post-op period, but over a period of time, especially when you don't fix the fibula. Hence, when you come to cases like these in very osteoporotic bone, there is a chance, yes, many of us would plate this, some of us would nail this. And just because I was speaking on nail and plate in distal tibia, you could do a nail and plate for a fibula as well to get the alignment right, reduction right, and give it more stability and get a very good post-operative X-ray. But that is not something that I'm here to talk about today. If you have these very, very osteoporotic fracture and look at the medial cortex, yes, common knowledge would say that this is failing in varus, it needs a medial plate. Any fracture of the distal tibia failing in valgus probably requires an anterolateral plate. And so many times in these very thin, very osteoporotic, you see the soft tissue shadow in these patients. The skin is really bad. If you open up from the medial side, it becomes really challenging. We put up this patient in a fixator to get the alignment right for the soft tissue swelling to go down. And once that went down, I thought I could nail it. Started off with a good entry, put in a nail after reduction, got a good reduction. But if you see the lower 2 slides here, I am trying to push it in varus and valgus, and you see there is some opening at the fracture site. So after this nailing is done, I checked for stability, and these patients are not the ones at 70, 74 years of age that you cannot make them weight bear. So the easiest thing to do is everything is done, you just need a small incision, reduction is already done, you need to just add on to the stability to make these patients weight bear very early. And I've just made a very distal incision, slided the plate, put in 3 or 4 screws, and you see how I've locked this screw from lateral to medial. You don't always need to lock it from medial to lateral if you want to make space for the plate, because if you think you are going to need a plate, you need that real estate to put a plate in. And that's all the incision that is required for such a patient. You see the soft tissues are bad, but that's all the incision that you require to do this surgery. And that's the immediate post-operative X-ray of this patient showing good reduction. Another very bad looking fracture, yes, one could plate it. Some people might do a dual plate in this, put it in a fixator, waited for the swelling to come down, and then came back in, put in a nail, tested the stability, thought that it is not too stable for early weight bearing, and then added a plate. All you need to do is just add a plate and it becomes a nail and plate construct, and this is just 6 weeks later. Another patient with a very distal tibia fracture going into the joint in the lateral view here. Very osteoporotic bone, very thin lady. You don't need to always do a nail first. You may start off with a plate, and if you think these patients are going to put their full weight, entire weight on this leg, I've reduced this with a plate. This is not the norm. Normally you would do a nail first, and then I tested the stability, found it not so good, and then supplemented with a nail. And you see this lag screw, the interlocking screw of the nail going in from lateral to medial. There is no fixed rule in trauma. You can put the screw in from lateral to medial if your medial to lateral screw is not going in. And this is the immediate post-operative X-ray of the patient. And this is the 6-month follow-up and 5-year follow-up of the same patient showing very good union. So I think my take-home message is simple. You do what you are doing. If you are only plating, that is fine. If you are only nailing one, that is fine. Most of us would probably use nails for extra-articular fractures and plates for intra-articular fractures. But if you do have a subset of patients which have very, very osteoporotic bone, where you feel you need early mobilization, or you think only a single plate is probably going to fail or break, only a nail is not going to give you enough stability, I think then it is best to use a mixture of both. It gives you more stability. Yes, evidence says only using a plate has higher risk of infection, but better chances of alignment. Only using a nail has better chances of preventing infection, but higher chances of malalignment, especially in the post-operative period if you don't fix the fibula. So do a nail if you think you can and test the stability, or do a plate and test stability. If you have any doubt about stability intraoperatively, I think I love the Tanna sir's word, more is less. So you add more implant, you give more stability and the advantage with the nail plus plate is it gives you early mobilization. There is less chance of failure, especially in the elderly patients who cannot afford another surgery. Their body cannot undertake a second surgery. Yes, it has a slightly longer surgical time, but once you have alignment with either a nail or a plate in place, then adding in the other does not take much of a time. Thank you.
Now I call upon Dr. W. Gedgon. His topic is revision of IT fracture failures.
Please come, sir.
Good afternoon. So, proximal trochanteric comminution, floating lateral wall, distal trochanteric comminution, and thin walled medullary canal, wide medullary canal, a variant of intertrochanteric fracture, not well characterized in existing classification system. And then you can see
looks
here.
A very stable fracture on X-ray, and when I reduced it in C-arm also, it was looking like a stable fracture. But on exploration, you will find that there is a coronal split, the greater trochanter is fragmented, and the anterior piece is translated, though it was looking very
बरू देखो क्या करना वो टाइम चेंज कर दो. Yes, I will start again. A proximal trochanteric comminution, floating lateral wall, thin walled medullary canal, and trochanteric comminution, a variant of intertrochanteric fracture not well characterized in existing classification system.
It looks a very stable fracture on X-ray, and when I reduced it in C-arm also, it was looking like a stable fracture. But on exploration, you will find that there is a coronal split, the greater trochanter is fragmented, and the anterior piece is translated, though it was looking very good reduction on C-arm picture. And therefore, what I say that the close reduction in intertrochanteric fracture is an illusion, and therefore it should be nicely reduced, and then the surgery should be done.
So biomechanics of failure of intertrochanteric fracture, higher the instability, more difficult the reduction, maintenance and ultimate implant failure. So this is an example, a intertrochanteric fracture fixed with DHS, 9-month postoperative non-union at the fracture site, inability to bear and pain. So removal of implant, valgus osteotomy, compression at the fracture site, and then a 3-month post-op immediate, and then this is how a 6-month follow-up, a complete restoration of anatomy and the function. Another example, a 73-year intertrochanteric cervicobasal fracture. It looks very simple fracture, precarious lateral wall because of osteoporosis, and then you can see post-op X-ray on IITV reduction and was anatomical, and this is the 2-month post-op varus collapse and screw cutout. So this is the, everybody knows what is the fracture jammerate and why the fracture, there is a lateral wall fracture is seen in the intertrochanteric fracture after a DHS fixation. So why failed? It is because of the lateral wall fracture, and then how to revise it, revised with a cemented bipolar with reconstruction of the trochanter. This is another example, a compromised lateral wall fracture with osteoporosis fixed by DHS, 1 month post-op, and then ultimately after 6 months everything is haywire. It has been revised with a replacement of a bipolar cemented. After 3 years of follow-up, Z defect, complaints of pain and limping, and then ultimately removal of scope. After 1 month of the screw removal, immediately ambulate, and what today there was a stress fracture at the neck and avascular necrosis revised with a bipolar prosthesis. Another example, a bifocal trochanteric fracture, rare in young adult, few cases are reported in old osteoporotic bone, but in young patient there is a rarest entity intracapsular fracture along with the trochanteric comminution. Treated with PFNA2, and you can see this is the surgery was done by a surgeon. There is a coronal split and a widening of the trochanter. It looks good on X-ray, but it is unstable construct, and ultimately it has gone into the non-union at the both the sides, and there is a varus collapse. So how to revise it? After 9 months of follow-up, and then non-union doubtful viability of the head. So why I did it, removal of the implant and curettage of non-union, and then what I did, I reduced it openly and did a internal bone grafting.
The graft corticocancellous through the hole created by PFN screw, and then I will impact the graft inside the fracture site, and the gap will be filled up.
So this is how abduction osteotomy was done, and this is the X-ray subsequent follow-up, and then you can see 2 years follow-up, and there is a complete restoration of anatomy, and the patient is able to walk. So you can restore the anatomy by DHS also by doing abduction osteotomy. epsilon intertrochanteric fracture treated by the PFN, and you can see there is a migration of the lateral, migration of the screw. Surgeon has again revised it by putting the another screws and as well additional screw, and then ultimately it failed. There was a non-union, and then patient was then managed with implant removal, DHS with abduction osteotomy and a fibular graft. That has also not worked for a long time. All implant and prosthesis with a hook plate. This is immediate, and this is the 6-month follow-up. Now the patient is walking after 3 years of primary surgery. Another example, lateral migration, DHS with abduction osteotomy and tension band wiring with a lateral plate. This is an example where there is a stress fracture at the hip joint, and you can see there is a failure because of the lateral wall was not there. There was a distraction at the time of fracture fixation, fatigue failure, then single screw fixation. There was no 3-point fixation, and fracture union 1 month, 2 month and 3 months follow-up. So mechanism of failure of IM nail, sliding screw nail, nail in the center of the femoral axis, reduction of lever arm, no lateral neutralization on tensile side, and sintering in varus with cutting out of the through is a very common phenomena in a PFN surgery. So as Tanna sir said, don't sold out to the PFN. PFN is not a good implant, and 2-screw system, I think it should be out. So if you want to do it, augment it with a proximal nail with unstable trochanteric fracture to address the lateral wall like this additional screw. This is already published in Chicago by me. Another paper, a trochanteric but plate with a combined proximal nail, unstable intertrochanteric fracture. So plate augmentation, or if nothing works, then it is better to do a bipolar surgery. So in get it right for the first time, revision surgery, brain taxing to surgeon and prolonged suffering to the patient. Please avoid prolonged surgery and combine the surgery on table and see the stability before you leave the operation theater. Thank you very much.
Thank you, sir. Our next speaker is Dr. Amit Rastogi, sir, for his topic on subsidence necessities.
Dear friends, after listening to Dr. Tanna's talk and Dr. Gadegone's talk, it seems like we are committing a crime by doing a PFN in a trochanteric fracture. You get demotivated. PFN alone in a trochanteric. So we are going to talk about PFN alone in trochanteric fracture. So we are going to talk only on PFN alone in trochanteric fractures. So we have come a long way. We had fixed implants which actually failed very badly. We did lots of DHS also, and unfortunately they also never gave a very, very good result, in spite of the fact that in certain subset of cases the DHS might work well. So this is an article, so femoral medialization fixation failures. So previously, our study demonstrates the previously theoretical predisposition for unstable fractures treated by sliding hip screws, that is a DHS, to undergo medialization much more than in PFN. And for A3 fractures, they recommend a proximal femoral nail. We did a lot of studies on testing for femoral biomechanical testings. Single screw unlocked nails actually failed very quickly. Better to do a 2-screw PFN in spite of the fact that many people don't like the 2-screw PFNs now. And but even these actually ended up having screw backouts. But still, they were better than the single screw implants. But even PFNs, they have their own set of problems, as everybody has mentioned, Z effect and things like this. And then poor reductions and failures of even 2-screw type of integrated 2-screw PFN systems. So do a good, nice reduction and see what happens actually after some time. So this is how the fracture is united. Like Dr. Tanna said, that patient who was walking in his video, the fracture is united, but what happens? You see shortening, you see lateral protrusion of screws, you have decreased mechanical advantage of abductors, increased joint reaction force. So this is hardly can be called a good reduction. This is basically because the fracture has settled down into and has gained secondary stability. So subsidence refers to axial migration of lag screw within the barrel of a SHS or within the nail of a PFN. And excessive subsidence can lead to shortening of the neck length, varus collapse, varus limb length discrepancy, and lateral position of screws. So you've got a decreased neck length, which reduces femoral offset and alters abductor biomechanics. You have a decreased neck shaft angle, which has varus malunion risk and implant failure or cutout. And you have decreased limb length, which causes limb length discrepancy, fatigue, and abnormal gait. Is the broken lateral wall a culprit? This is a study on DHS, trochanteric support plates minimally reduced fracture subsidence, and we found no correlation between subsidence and our measurement of pain and function in unstable trochanteric fractures. So if you use plates or you do not use plates, does not really matter, all that, at least in DHS. And the same thing if you do in a PFN, well-aligned anteromedial cortex coupled with a valgus reduction of the neck shaft angle, a helical blade in the center and TAD less than 20 millimeters, the fixation of lateral wall has no role in preventing fracture collapse, nor in the healing of an unstable IT fracture. And this is borne out by biomechanical studies. This is a study from China. And if you look at this, this is a positive reduction in the AP view, a positive reduction in the lateral view. This is a negative reduction in AP view, a negative reduction in the post. And look at the von Mises stresses on the implant. If you have got negative everywhere, wherever it is, it's an intramedullary nail, at the level of intramedullary nail, at the level of the helical blade, and at the level of the head-neck junction. Everywhere the negative reduction actually has more strain on the implants, which can lead to implant failure later on. People have resorted to unique methods of getting a positive reduction. This is one interesting article from the Korean Hip Society from Korea by Kim. And you see, this is the last picture. You see there's an intrafocal screw which tends to keep the proximal fragment anterior to the distal fragment in the lateral view. And so that it does not sink down and cause a negative reduction in the lateral view. But what if the implant does not allow subsidence at all? So we just did a study, a small study. I used a Halifax nail because that is the only nail which I have, which has a set screw on top and which you can actually lock. And other screws were single helical blade systems. So we assessed clinical outcome by using modified Harris hip score, neck shaft angle, fracture union, tip apex distance, and cutouts in the femoral head. And so we achieved positive reduction in both planes. Intraoperatively compressed all the fracture fragments and used and locked the set screw completely in the Halifax group. We assessed the neck shaft angle, tip apex distance, the Cleveland index, that is where your screw is, the lateral protrusion of screw, and functionally we assessed modified Harris hip score. So the patient population was approximately okay for PFN2 and comparable for Halifax as well as for this thing. Not much difference in the operative parameters. The blood loss was approximately the same. We had slightly more C-arm shoots in the Halifax nail because it has additional implant material. Surgery time was also slightly longer, but nothing statistically significant. But look at the scores for modified Harris hip scores after 6 months. So the excellent results were approximately the same, PFNA2 and Halifax. But the good results were really much better in the Halifax group with a completely locked set screw Fair results were approximately also the same, and poor results were substantially less. The neck shaft angle in complications, so less than 5 degrees was 19 and 17, more than 10 degrees 6 in the PFNA2 group and 4 in the this thing, as well as the fact that the most important thing was this subsidence. There was no subsidence because we had locked the set screw completely, and PFNA2, all the fractures in both the groups actually united. And these are some this thing. So this is not a very ideally placed Halifax actually. You see it's slightly superior, but even then does not lead to subsidence and ultimately unites. This is a patient who had a left hip fracture. We had done previously an unlocked Halifax nail some years back. This time we did this, and after 6 months you see no sign of subsidence, absolute proper reduction, in spite of the fact that in the lateral view the reduction is not really very positive, and ultimately had a good result. Not all, I'm not saying PFN is bad. This is a very well reduced, this is fairly well reduced helical blade PFNA2, and gives you a good result. So the fluoroscopic shots were marginally higher in the Halifax group, and intraoperative blood loss, incision length, and overall surgical duration was comparable. But what is important is functional outcome. Marginally superior modified Harris score in the Halifax group, but not statistically significant. But what the complications were far lesser. Lateral screw migration, medial migration, and joint and varus collapse were observed in marginally higher rate in the PFNA2 group. So both locked and sliding implants demonstrated efficacy in the management. Although PFNA2 exhibited marginally shorter surgical duration and fewer fluoroscopic exposures, the Halifax nail demonstrated fewer complications and superior functional outcome. Just one slide more, sir. So subsidence is as a result of malreduction. So get a positive reduction in the AP and lateral views. It's also linked to varus. So valgize your fracture prior to your fixation. It is caused by axial micromotion and bone resorption. So have an implant which can compress your fracture intraoperatively, and keep, if you've got a set screw, keep the set screw tight so as not to allow any collapse. It is also aided by incorrect screw position, so keep your tip apex distance center or center inferior. That's the way you can prevent these complications. Thank you.
Our next speaker is Dr. Ashok Sinha, sir, for his talk on my failures.
Good afternoon, everybody. Up till now, we were learning how to do surgery. I am dealing with my failures. Honestly speaking, all cases are my failures. So don't be afraid of your failures. Failures are just come to teach you, provided you are ready to learn. They are your best teachers. The legends sitting in hall have faced maximum number of failures. That's why they are legend. I am coming to my first teacher, class teacher. 23 years female. Subtrochanter fracture. AP view was good. Lateral view C. Wrong short PFN, wrong implant, improperly reduced. Revision. Little bit malreduction, varus, but finally it united. But for sake of money, I removed implant and see the result. So again, first time, poor reduction, poor implant. This time, my greed, failure. 23, third surgery. Nailing, bone grafting. I think I have done my job nicely. See, copious bone graft has been done. Iliac crest is no more now on right side. But, sorry. What happens? Every graft has been absorbed. Osteolysis is there. So it is non-union. Again, revision surgery. I am coming to back. Sorry. I am coming to back. In this case, we have put bone graft, copious bone graft on posterior medial also side, but osteolysis was there. I think in this case, posterior medially improper chiseling was there in proximal fragment, because that is little bit difficult. So went into non-union. Same thing, posterior medially over chiseling, copious bone grafting. No doubt, as a matter of fear, I put a plate just to buttress. It was not my intention, but just to do everything whatever you like. See. So simple, one case taught me a lot. Proper reduction, proper implant, do proper medial bone grafting, don't be greedy. 32 years female, plating done, but there was medial void. I thought it will work. Revision, again supplemented with plate and posterior medial bone grafting, copious. So don't think that God is going to help you. No, you are your God. God never helps you. You have to do everything. 65 years male, plating done. I thought it is working. Revision with long PFN. This got broken. Sorry. Failure. Revision with long PFN. Copious bone grafting. Again, posterior medial. Failed. Again, because posterior medial was not properly chiseled. Finally, see, the bone graft has taken up to neck. Mid cervical region, bone graft was gone because there was much chiseling up to that level also. So whenever you are treating with bone grafting in subtrochanteric region, always think about posterior medial maximum chiseling. Middle-aged man, hybrid nail, caisson nail, it is locking a lock nail, done by me. Again there was void, gap, failed. Nail bit plate, posterior medial chiseling and bone grafting. So always think about, whenever doing revision surgery, always think about bone graft should go to the stress bearing area, and that should be properly chiseled so that you can take it. Any graft, whether it is skin graft, bone graft, any graft, there should be bleeding bed to receive it. Baby can't grow in dead uterus. There should be bleeding to receive the bone graft, and that bleeding will be only after chiseling. Young female, compound, X-fix, I removed, it will unite. Again, God is going to help me. Yes, it will unite. No, God is not going to help you. Double plate, again locking nail, caisson nail, that is designed by me. See the bad scars on her thigh. So many scars. Poor follow-up. Plating done by me. Patient thought, yes, hum to theek ho gaye. Lost in follow-up. I was also happy. No, he must be doing job nicely. Don't be. The patient has lost, lost. You always cause us, ye kyun nahi aa raha? Again, nail with bone graft. See the scar. that gentleman. He's so hyper now. Again, failed subtrochanter with broken PFN. In this case, I thought there is no space in head, so I should do plating. Plating, bone grafting. After some time, failed. Now, there is no hope now. I thought, no, I have to do a screw in head. So this teaches you, don't be afraid, there is no space. There is always a space provided you dare to do it. Since there are so many holes have been occupied by plate and nail, I was so much afraid. No, this head is not going to give me any purchase. But you have to dare it. There are spaces. Compound segmental fracture done by me. And honestly speaking, there was no fracture neck femur on traction table I had seen in this case. But after some week, he went to a senior surgeon. He was close to that surgeon. He asked me, "Sir, thoda dard hota hai." Bola, X-ray kara ke le aao. He got it X-rayed. See. Revised. And I relied on unicortical plating in DHS. See, again, chalega. No, back out. Simply I added wire. So, accept your failures, analyze shortcomings, think what went wrong. Rectify your mistakes, go to basics and redo it. Success is at next door. Thank you.
All the speakers come on the stage for group discussion. Any questions from the audience? सर सर को माइक यहाँ दे देते हैं. हाँ, सर को माइक दे दो. ये माइक. Anybody has any question? सर को, अग्रवाल सर को माइक दो.
Yes. Thank you. I must compliment Dr. Sena. You have the courage to look at your mistakes and accept them publicly. And what is most important is inspiring is that you are ready to learn from them. And that is the message which should go to every orthopedic surgeon here, that we should learn from our own mistakes. They are our biggest teachers. Thank you very much.
Thank you, sir.
And I must also compliment Dr. Rastogi there. He has done a wonderful study. And my question to, I know about the whole history of this Halifax nail. Dr. Haldar has been such a close friend for more than 35 years. Is it still available? It is. It is available. Somehow, we did quite a few cases.
It is manufactured by a company called Jesco.
Jesco, Chennai. Are they supplying it still?
They are supplying, yes, sir. Yes,
okay,
yes.
Because in between they had stopped because they could not make a good jig.
They did make a good jig, sir. Actually, they had stopped because they wanted to convert that steel nail into a titanium nail.
Okay.
It's still available.
Because it's a very good implant. It's the best PFN that I have ever used till now. I've used practically all types. And the addition of wires have made it very good, and then some refinements in technique also over the years that we have learned from Dr. Gadegone and Dr. Shiva, that it has become a very good implant. Thank you. Thank you.
One question to Dr. Same thing I am talking about. The PFN Bharat is so big.
The problem is the confusion in the literature, and the group of the patients are different with the different persons.
And the literature you can find on both sides.
Yes.
I don't think there is any way you
problem
can talk
is
about
the spectrum of the instability is different in the different groups and different.
Yes,
That's
sir.
why
Panna, sir, I agree with you. You can find your own type of paper for whatever you wish to say.
Yes, yes.
Sir, nothing new in that, sir. Shakespeare said that the devil can cite scriptures to suit your purpose. So, abhi to kya? But you talked about Ender's nailing, you talked about Dr. Mukhi's technique, you talked about angle blade. हम क्या करें sir? आप तो confuse कर दिए.
Purpose was to confuse you.
The message is instability, instability, and instability. Again, sir said same. Everybody said same.
Let's come for a group photograph, sir. And the next moderator, because the next moderator.
Sir, time constraint hai.
Dr. Anurag. Dr. Anurag.
Please. Photo is sir. Photo ke liye.
Dr. Anurag.
To take your charge. Yeah, the next moderator is Dr. Anurag. We are running about 30 minutes late, so we have to be slightly careful. Dr. Anurag, please. Call the chairpersons. Yeah, please.
Good afternoon, sir. I would like to start the 13th session of this scientific program of Gofcon 2026. I would like to call on the stage the panelist of this 13th session, Dr. Rakesh Chaudhary, sir, Dr. N.J. Karne, sir, Dr. Mahesh Prasad, sir, Dr. Rajiv K. Bhatt, sir, Dr. Alok Kumar, sir.
Alok, chaliye. First speaker.
I would like to start call on the stage the first speaker of this session, Dr. Rajiv Raman, sir, for his talk on the PLC injury treatment algorithm.
Thank you, Amulya sir, for invitation. So I will be talking on PLC treatment algorithm. So posterolateral corner of the knee uni, we call it as a dark corner, but now it's not a dark corner of the, we know about the anatomy and the biomechanics. So there are three primary stabilizers and three pillars of the posterolateral corner of the knee: the fibular-collateral ligament, the popliteus and popliteofemoral ligament. So this photo I have taken from the Laprade article. You can see it's a very good dissection. The fibular-collateral ligament is the primary static stabilizer to varus opening of the knee. So that is a very important static stabilizer for varus opening. The popliteus is primary static and dynamic stabilization to the posterolateral rotation of the knee. And as you see, this popliteus is come just above the soleus, and it just inserts in front of the popliteus sulcus here, 1.18 millimeter just anterior inferior to your lateral epicondyle. And the popliteofemoral ligament, and this is very important. Some of the patients who get excessive external rotation deformity in the PCL and the PLC, PCL plus PLC cases, it acts as an important stabilizer for the external rotation. So these are three important pillars, and when you are reconstructing, you should judge what you will do in which case. So just what is most important part, you assess whether you are dealing with an isolated LCL tear or a posterolateral corner injury, a complex posterolateral corner injury. And I think I will just show you two case scenario. So this is a 35-year male, pain and history of giving way in left knee for 6 months. The transtibial ACL reconstruction was done 1 year back, and on examination the latchman is positive and dial is positive. So if you have dial test positive, that suggests that yes, the posterolateral corner has gone. And you can see the excessive external rotation in this patient. Almost you can move the feet to 90 degree. You can see excessive external rotation in this patient. So these are the cases where you should plan for a classical Laprade or modified Laprade technique, that is a Tibia based technique. So in this patient with ACL reconstruction with a peroneus longus graft here and reconstruction with the modified Laprade technique. So I do it in 90 degree knee bending position. So lateral epicondyle 5 centimeter proximal, and just in front of the guddy tubercle made a L-shaped incision, then posterior based flap. This is very important. So to go for neurolysis of the common peroneal nerve. So just try to develop the posterior based flap, and the important landmark is your biceps. So bicep femoris, you identify that, and just posterior to that you can see, you can find your common peroneal nerve. So once you have done the neurolysis of the common peroneal nerve, now you have to create the windows for the posterolateral corner reconstruction. So this is your iliotibial band. So your first window is at the level of the lateral epicondyle. You can see this is your lateral epicondyle, at the level of the lateral epicondyle, and identify lateral epicondyle, because lateral epicondyle, just anterior to lateral epicondyle, you will get your popliteal sulcus also. So you can see with the artery forceps, I am identifying the lateral epicondyle, and then you extend the incision over the iliotibial band proximally, and this is your lateral epicondyle. So once you have identified the lateral epicondyle, the first tunnel you make in the fibula from the anteromedial to the posterolateral part, and always you can use your PCL jig also, or when if you are drilling yourself, you can use your index finger and try to protect your common peroneal nerve, which is just ulnar to your index finger. So you protect your common peroneal nerve and make your tunnel from the anteromedial to the posterolateral, anterolateral to posteromedial, at least 1.2 centimeter from the tip of the fibula. Now pass your first suture loop from the fibular tunnel, and that suture loop you pass to the fibular tunnel. The next important part is identifying the insertion of your tibial tunnel for your popliteus. So you can see here, this is your Gerdy's tubercle, and again you can feel this popliteus circle posteriorly. You can use your PCL jig. I usually prefer using my index finger, but when you are using your index finger, always drill yourself. Don't ask your assistant to drill. And then identify the two structure. You can see this thinned out. This anterior is a popliteus insertion, and this is a LCL insertion. And this is a pull-out technique, very good technique to identify the insertion point. So according to classical Laprade technique, you make two tunnels in the femur, one for the popliteus and one for the LCL. So this is the modified Laprade technique I use in revision ACL, especially because you have a ACL tunnel there. Again, you are creating a new ACL tunnel and a two tunnel for the posterolateral corner. So I make a single tunnel in between the lateral epicondyle and popliteus. So now you make a tunnel and always try to drill towards the superior pole of the patella. So here we have used a quadriceps split graft, which has a long limb and a short limb. So you can see, you try to take quadriceps split graft, and always when you are reconstructing your LCL and popliteus, be careful that your popliteus should be over the LCS. Now pass both the graft through the second window. You can see this is your first window, this is your second window, and you first fix it over the aperture. Here we are doing aperture fixation for this. I will just forward it. Aperture fixation, and see for the stability. So now you have two limbs here. So try to pass these two limbs in just over the distal flap of the iliotibial band, and then one limb will go from the anterior aspect of the fibula towards the tibial tunnel, and second one will go directly towards the tunnel. And the attachment which is there from the fibula towards the tibia, that will act like your popliteofibular ligament. So at the end of the procedure, normally what we do, we fix it in 60 to 70 degree of the flexion and see for the stability of the knee. So you can see at the end of the procedure, you can see the dial test is negative. So this is very important. If you have a dial test positive, these are the group of patients where you should think of reconstructing through a classical Laprade or a modified Laprade technique. Second group of patient, and this is very common, this patient has posterior door and varus stress positive. So these patients are having isolated LCL tear. So you don't need a classical Laprade taking a tibia based procedure. You can plan for your just varus stress positive fibula sling procedure, either a Larson procedure or a arcerio. So in this patient, you can see the isolated LCL injury is there. So it's a isolated LCL tear. You can see the sagging, it is a torn. The posterolateral corner, the popliteus is intact here. So in this patient, we did a PCL, and you can see the varus stress is positive. In this patient, you can see excessive varus opening in the knee. So these are the patient you have to plan for a fibula sling procedure. So in this patient, same process, and at the end of the process, just you make a tunnel to the fibula and try to insert in between your lateral epicondyle and popliteus sulcus. And you can see you achieve a good varus stability. So my dear friend, this is very important. When you get a posterolateral corner injury, it's very common with the ACL or your PCL injury. So assess, you will get three group of the patient. You have a dial test positive and varus test positive. These are the candidates you have to plan for the Laprade or modified Laprade technique. That is a tibia based procedure. If a dial positive and varus test is negative, these are the group of the patient you can just manage with the popliteus sling procedure, just reconstruct the popliteus. And the third group of patient, dial negative and varus test positive, here you have to fibula sling procedure, either a Larson or a arcerio technique. Thank you so much.
Thank you, Raju. And thank you for finishing well in time.
Yes, yes.
So there is a time for questions.
At the end of the session, we have
Last question at that.
Our next speaker is Dr. Kiran Acharya sir for his talk on the ACL reconstruction complications.
Good afternoon. I bring greetings from the University town of Manipal. My topic is why do ACLs fail and how do we overcome them? Side by side, when I'm discussing the failures, I'll be discussing how we can overcome as well. ACL failures are described as recurrent patholaxity or in a joint which is stable but stiff and painful, which interferes with the activities of daily living. These are the two components of ACL failure. If an ACL fails within first 3 months of its reconstruction, means that it has lost its fixation. Fixation was not good, or it is because of a infection. Too tight a graft also fails very early. If the failure happens within 3 months to 1 year, it's a failed surgical technique, non-anatomic ACL reconstruction, or an aggressive rehabilitation, or early return to sporting activity. The last one is most important, missed concomitant injuries like meniscal injuries and collaterals. More than 12 months, if an ACL has failed, for sure it is due to a re-injury. So recurrent instability, arthrofibrosis or stiffness, and infection. These are the three broad categories of problems which can lead to failure. Recurrent instability is almost always due to technical problem, non-anatomic graft in about 80% of the cases. Biologic factors like graft related issues are about 17%. Trauma accounts to about 79%. And all these lead to secondary laxity. This is a non-anatomic ACL using interference screws. It's a vertical tunnels likely to fail. So technical reasons are almost always the primary cause for failure of ACL reconstruction. Another example for a vertical femoral tunnel. Graft related issues are because of a tension in the graft. If it is tension is inadequate to start with, or if it is a too tight graft. In Indian males, graft diameter less than 8 millimeters is likely to fail. Fixation devices failure, use of allograft and irradiated graft can lead to about 13% failure rate according to literature. Lost graft tension, impingement in the lateral notch or impingement in the trochlear notch itself can be the cause for failure. Graft fixation, improper fixation, inadequate fixation, all these come under this category. In this case, the tibia, the screw is outside the tunnel in the soft tissues. Suspensory ligament and post usage is acceptable. Interference fixation using biol, aperture fixation, suture disc and post is acceptable. Many devices are available for fixation. But suboptimal fixation using wrong implants is another cause for failures. Inadequate placement of the button is not sitting on the femur in this case. Definitely it's a primary failure. Wrong placement of the tunnels, all these are primary failures. Infection is another. About 12% of the cases of irradiated grafts and allografts are likely to have infection as well. Biologic factors, where the graft is atonic, non-ligamentized, more common in freeze-dried grafts, and infection can also damage the graft. Here is a first look of an infected graft. Traumatic causes are early aggressive rehabilitation and re-injury. Secondary laxity could be in the form of missed PLC, MCL, PCL, and missed varus alignment of the knee joint, and also the meniscal injuries with significant bucket handle tears. Arthrofibrose can be a result of impingement, tight ligament, capsulitis, cyclops lesion. Most often, immobilization. If it is inadequately fixed in the beginning, immobilization is not going to help. Immobilization will make the knee further stiff. CRPS and infection are other causes for arthropfibrosis. Infection is almost always due to cannulated. In arthroscopic surgery, we use many cannulated instruments. So if there are back-to-back cases, surgeon has to ensure that cannulated instruments are cleaned well. Graft contamination on the back table is responsible for about 12% of the infection. So once a graft is prepared, it has to be kept well covered, and use of antibiotic soak is a revision ACL. I will just run through few tips and tricks. First, we need to evaluate the patient very well clinically, radiologically, and by imaging. We need to do the planning, and we need to have full armamentarium with us before we jump and do the revision. The patient exact symptoms, whether it's a pain or instability or stiffness. Graft fixation, if you can, always goes to the other surgeon. And mostly in centers like us, patients do come back to us with complications, but most of the time, patients tend to go to another surgeon for second opinion with the complication. So if you are suspecting sepsis, always get the imaging to look at the extent of synovitis and bony involvement. Always aspirate and see, and plan for debridement. Early debridement of the joint saves the joint. Relook arthroscopy is helpful in case of doubt, because loose bodies which may not be seen on the X-ray, cyclops lesion, missed meniscal tears, cartilage lesions are best diagnosed by relook arthroscopy. For revision, imaging is very important to look at the tunnel widening and tunnel placement, whether they are anatomic and whether they are widened. These two questions we need to know. And patient has to have a counseling with respect to outcome and expectations. If required, revision can be in the form of a staged procedure. Look at the skin and be prepared to do the hardware removal with adequate tools. It can be quite messy. Tunnels will have non-absorbable sutures. Also have a graft options ready for the revision. If it is expanded tunnel, be prepared to use the bone blocks and bone grafts. Non-anatomic tunnels are easy. You make a new tunnel, anatomic tunnel, and use the graft. Meniscal repair for torn meniscus. For varus alignment, you can combine with high tibial osteotomy, extra-articular ligament reconstruction if they are present. Avoid accelerated ACL protocol. This is a photograph of one of our patients who underwent ACL reconstruction 3 times. She's a marathon runner. Finally, she broke the 3rd ACL also during a Ladakh marathon and decided not to get operated. So this is a take-home message. You need to have excellent pre-op planning, be prepared for stage procedures, and you need to have supervised rehab and late return to function. Thank you.
Thank you, sir. Our next speaker is Dr. Shekhar Srivastava, sir, for his talk on regenerative cuff tear and its management principles.
So good afternoon, and we'll be discussing something other problem which is a very common problem, and most of us see it in our general practice. Now we all know what are rotator cuff muscles and how do they work. So rotator cuff, just to summarize, they are a group of 4 muscles which surrounds the shoulder joint and which are responsible for stabilization and function of the shoulder joint. So it stabilizes the joint, and it also is very helpful for the action of deltoid. So what happens if the cuff is not working? So let's see. So when the cuff is not working, the cuff is torn, then there is micro instability in the shoulder joint. The shoulder joint starts to move up, and we know that the cartilage doesn't tolerate shear stresses very well. So as there are shear stresses, it undergoes arthropathy, and you start developing rotator cuff arthropathy. So that is the role of rotator cuff in development of cuff arthropathy. Now it was recognized by Charles Neer way back in 1993, and where he explained that in severe rotator cuff arthropathy there is superior migration, glenohumeral arthritis, glenoid erosion, and then you also get stabilization of the acromion. But that is the severe cases. In end stage, it's not always like that. So if we talk of the cuff problem or the area in the subacromial space, so the problems which you can have are rotator cuff tendinitis. You can have partial cuff tears, which can be either articular, which can be bursal or intratendinous, or you can have full thickness tear. Based on the patient's clinical symptoms, based on the anatomy of the cuff, one has to decide the treatment pattern. So all these things can be judged on the MRI. What is the degree of retraction of the cuff, and what is the quality of the muscle? So that is very important, because on MRI you can assess that whether the muscle tissue has been, whether there is any fatty degeneration of the muscle. So there can so 2 things can happen. There can be either atrophy of the muscle, or there can be fatty degeneration. If the muscle has undergone fatty degeneration, then that's a bad sign, because that means that even if you do proper repair, it's not going to heal. Now what are the causes of cuff tear? Most of the cases it is intrinsic factor. These are age related microscopic changes, and that leads to decreased vascularity of the tissue. So almost 90% of the tears are degenerative in nature, less than 10% are traumatic in nature. So accordingly you have to decide that what treatment are you going to offer. So usually the patient comes with pain, then there is restriction in activity of daily living. The patient becomes more disturbed when they start having night pain, and then decreased strength. So the patient is bothered when the night pain is disturbing his sleep, and that's the time when they come to you for treatment. And one must know that the aim of your treatment is not regaining the strength. The aim of the treatment is always pain relief when you are doing a rotator cuff repair. Now as far as diagnosis is concerned, well, in severe cases X-rays will show some changes. There will be decreased acrohumeral distance. There can be sclerosis of the tuberosity as well as the acromion, and sometimes there can be calcification at the cuff insertion. These are very severe changes, but most of the time it is diagnosed on MRI, which will show either a partial cuff tear or a full thickness tear. So what we know about cuff tear is that rotator cuff tear are very common. By the age of 60 to 70, almost 50% will have some sort of tear. If you get their MRI done, it will show that it is having a partial tear or interstitial tear. Most of the tears are degenerative in nature. Larger tears have a greater dysfunction of the shoulder. Rotator cuff tear do not heal on their own. So that has to be made very clear to the patient, that even on subsequent MRI you will see the tear, but that doesn't mean that every rotator cuff tear requires surgery. Some patients with rotator cuff tear do not have pain, but most of the cuff tear, they gradually progress and then they eventually get pain. So for small tears, degenerative tears which we are talking, we are not talking of traumatic tear at all. So for small degenerative tear, one can always give a trial of conservative management, which can be in form of strengthening of your scapular muscles and deltoid, and medicines for pain relief. One shot of steroid can also be given to reduce the inflammation, and it has been shown that it doesn't lead to progression of the tear. But those cases where the tears are not responding to conservative management, or where the asymptomatic tears have been converted to symptomatic, or middle or large size tears, those are the tears which require surgery. So surgery, if we talk of a partial thickness tear, one should avoid surgery in partial thickness tear unless it becomes very painful. So in those cases, the various options which we have are debridement. If the tendon involvement is more than 50%, then it has to be repaired. But in cases of full thickness tear with symptomatic with symptoms, one has to go for arthroscopic or mini open repair. The results are almost similar, but with arthroscopy you can perhaps do them better, and you can also address the concomitant problems in a better way. The success of rotator cuff repair depends on the tendon quality, the bone quality, and also the technique. The tendon should never be fixed under tension, because if it is fixed under tension, then eventually it's going to fail. Then these are various technical things, whether you should go for single row, double row, or triple row repair. But what's most important is that if you have got a tear like this, you must ensure that when you bring this tendon back to the footprint, this should be tension free. So you should release all the tissues, release the adhesions in the subacromial space properly. You should place your anchors in proper way. You should also prepare the bony bed so that the vascularity is good, the biology is good. Only then the tendon heals. So this is how we do a triple row repair in this case, which completely covers the footprint of the shoulder joint. So this is a small video where you can see that this is the tear, and first you put your anchors on the footprint, and then you take the bite through the tendon tissue, and then you reduce the cuff back to the footprint. So this is the middle row. This is a triple row repair. Once you have done the middle row repair, then you tie the medial row and bring all those sutures back to the lateral row to get the triple row repair. So it covers the head properly, so you get more surface area for healing. Now when the tear becomes chronic and it is retracted, then they become irreparable. So there the direct tendon to bone repair is not possible, and these are usually massive tears. So in cases of massive irreparable tears, these are the various options which we have, and one of the most promising option, and which in elderly patient which gives very good result, is reverse shoulder arthroplasty. So reverse shoulder arthroplasty gives better pain relief. The functional results are also very good. And so in elderly patients, chronic retracted cuff where the tuberosity is also poor, in those patients one can go for reverse shoulder replacement, where within 4 to 6 weeks you can get results like this, which is perhaps not possible even with the best cuff repair. But then it has to be reserved for patients who are elderly, who are above 70. That's another patient. You can see that she's having total dysfunction of her arm, and she's not able to control the activity because the cuff is not functioning. She's having drop arm sign positive, and then the same patient after reverse shoulder replacement can do all the activities properly. So to summarize, rotator cuff tear are very common in elderly patients. Most of the cuff tears are degenerative. They don't heal by themselves. Cuff tear may remain asymptomatic, and in those patients you don't need to do anything. Only symptomatic cuff tear needs to be treated. Surgical treatment only after the failure of conservative trial, except traumatic tears. Tension-free repair is very essential for the success, and in chronic irreparable tears or with patients with arthritis, one can go for reverse shoulder replacement. Thank you.
Thank you, sir. Our next speaker is Dr. Gurudev Kumar, sir, for his talk on osteochondral defect.
Good afternoon, everybody. Respected chairperson and dear delegates, my talk of presentation is osteochondral defect, lesion from fixation to reconstruction. As we all of us know, the osteochondral lesion is a bad lesion. If it is not treated on time, it may lead to the osteoarthritis. So I am going directly to the case presentation, not going to discuss about classification, etiology. So this is the girl presenting on Republic Day program, and she fell down, and there is lateral dislocation of the patella. Further investigation, CT, X-ray and MRI, there is the osteochondral defect over the medial patellar facet. We can appreciate here. So my again confirmation by putting the scope inside the knee joint, and we can see there is big defect over the patella on the medial side, and this is the condyle piece of the bone. So fix it with the number 2 vicryl, and this is the post-op X-ray after 1.5 years. There is well healing of the condyle defect both in the lateral and the skyline view, and this girl underwent epiphysiodesis for the genu-valgum deformity later on. So this is another case, 36-year-old female, 3-month-old injury, and she is not able to walk, bear weight on the left side of the lower limb. And the previous consultant tried to reduce this patellar dislocation 2 to 3 times, but not able to reduce. The further investigation, we can see here there is a impaction, dislocation of the patella on the lateral femoral condyle with a chondral defect here. So my plan is again examination under anesthesia. Patella is not able to reduce, midline parapatellar incision, reduction of the dislocation and fixation of the condyle piece with the 2.7 mm screw. At the same time, we go for MPFL reconstruction, and this is the follow-up after 3 months. She is able to put weight on that limb and full range of movement, and she is happy with her movement. And this is the X-ray. There is well healed of the defect. This is the 31-year-old male, right knee, pain for 2 months, and this patient came to me with 20 degree of knee flexion for last 7 days. And we can see here there is flex of bone in the knee joint, and the MRI confirmed there is a bone edema along with the chondral lesion. So this is the endoscopic finding. There is a chondral piece with some hinge attached here, and it is able to we can able to reduce under endoscopy. So my plan was to fix it with the bio pin along with the bio nail, and this fixation is quite stable. The another case, 18-year-old male, there is pain and sometimes locking of the right knee last 9 years. And in the X-ray, we can see here there is a defect on the medial femoral condyle. So the further investigation, MRI confirm there is a condyle defect and little bit edema of the bone edema. So again, my plan, put the scope inside the knee joint, but it is the condyle piece is attached with the femoral condyle, and it is able to reduce. But since this is he had problem for last 9 years, so my plan was to do the oats. So 3 oats 8 mm we have harvested from the non-weight bearing site, and fill the gap. And this is the post-op picture after 1.5 years. It is well healed, and he has full range of movement, and he is happy with his movement. So another case, 13-year-old female, right knee injury. She fell down from the bicycle, and there is pain and locking for last 2.5 years. There is a lateral femoral condyle, there is defect on the lateral femoral condyle. So further investigation, and the MRI, again bone edema and the condyle defect. So my plan, the midline arthrotomy, and this is the defect around 12 to 14 mm. So 2 plug of the bone from the non-weight bearing area, 8 mm fill the defect, and this is the post-op picture after 8 months. It is a well healed defect, and she had full range of movement, and she is able to walk independently without any pain. So this is the last case, 63-year male. There is a gross varus deformity and active. He is so much active, and medial compartment osteoarthritis. So my plan was to put the scope, correct the alignment, and then do the microfracture. So after putting the scope inside the knee joint, there is a big void here on the medial femoral condyle. So many of us among us is directly planning for the arthroplasty or UKR in this case. But considering his profession and active, we plan to just correct the deformity and do the microfracture. So this is the post-op X-ray after 9 months of correction of the deformity. And this is the X-ray after removal of the implants. Somehow this patient has some complication over that area, so we have took out the implant from the limb. And this is the picture, full follow-up. This is the first picture at the time of doing the correction osteotomy. There is a full defect on the medial femoral condyle. How big it is, and this is the picture of doing the microfracture at the time of doing the corrective osteotomy surgery, and this is the final picture of removal of the implant. We are lucky to put the scope inside the knee joint and see in just 8 months how nicely the cartilage is getting the healed up. So this patient is lucky. Thank you.
Thank you, sir. Our next speaker is Dr. Manish Kumar, sir, for his talk on single stage multi-ligament reconstruction.
Good evening. So I'd be showing a few cases of a multi-ligament injury, and all of them being managed by single stage reconstruction and their follow-up. So this is the first case. As you can see, it's a 24-year-old male who had a fall from bike about 8 months back with a BMI of 21. He had dislocated his knee, and there was also a fracture of the proximal tibia. So when he presented to us, we did a reduction and applied a spanning fixator, and the proximal tibia fixation was done by means of CC screws. The fixator was removed after 3 weeks, and the patient was sent for rehab, and at the 5 months time, the CC screws were removed, and we planned for the reconstruction. So this you can see the patient, after rehab, he has got a good range of the movement of his lower limbs, the knees. And here, this is the examination anesthesia. You can see the laxity in the knee. And when we performed the reconstruction of ACL and PCL, and after this, at the same stage, we planned the PLC reconstruction. So this is the incision which has been traced out, and here you can see the femoral sockets. 2 femoral sockets are created for the reconstruction of the PLC by means of the Lateral technique, and you can see the sockets. They have been marked by the bead pin, and these sockets, the shuttling sutures are being traced inside, and through these shuttling sutures you can pull in the graft for the popliteus and the fibulocollateral ligament. And once they have been pulled in, they are secured by means of interference screws, and the other end of the fibulocollateral ligament, that is passed through the fibular tunnel. And after being passed through the fibular tunnel, it is fixed by means of interference screws. Then the grafts, for the popliteus and the fibrocollateral, they are pulled from behind anteriorly and they are fixed by means of another screw. So this completes my surgery, and this is the intra-op stability you can see. The follow-up of the patient, this is the follow-up. He presented to us, the knees appears to be stable. The patient can jump, he can run, and he is happy with his results. Single stage multiligament. Now another case, a 20 years old boy who had a BMI of 25, he presented to us about 1 month after a bike accident, and he presented with instability. Along with that, there was a foot drop. So he had an injury of his PCL as well as PLC with a CPN injury. This is the pre-op X-ray, the stress view, and you can see the sag sign, and this is the Muller's test, it's positive. The laxity of the knee, you can see the external rotation recurvatum test, that is also positive, and the posterolateral draw test, that is also positive. And this is the preoperative gait of the patient. Here you can see the varus stress test, and this was the reconstruction of his, you can see the ACL. This ACL is lax, but it is intact. And the dial test of the patient, and this is the final reconstruction with when all the screws are put in, the Leprard's technique of the PLC reconstruction and the fixation of the ACL and PCL, sorry. So this is the follow of the patient at 1 year. He is able to walk, but there is some amount of foot drop. He is able to jump, and he is able to run. He is happy with the result. We got his video again. We got his video at 3 years, and he is happy with his result. Another case, 26-year-old male, BMI 26, pain and instability left knee. 3 months back he had a fall, and the knee was deformed. That means it is dislocated knee. Aspiration was done by some local practitioner, and the slab was applied. When he presented to us, the knee was in a reduced position. This is a stress view, and this is the fixation of the ACL and the PCL on the tibial side, and you can see the patient at 3 years, 8 months follow-up. He is able to jump, good squats, and he is able to run. Another patient, 24 years, BMI 20, pain instability right knee, 1 year, twist injury of his knee, and he had a ACL and a PCL tear. That was reconstructed, and we got his video which was sent by him, and at 4 years, 5 months, that's his activity, the function. He is able to run. He is a professional who works on the road, but he is happy with it, his results. The last patient I'll show you, a 22 years old male, 4.5 months, fall from bike, had a twist injury of his knee. The different tests were like posterior draw, posterior sag, they were positive. Muller's test was positive. Dial test 1390 positive. Varus stress test positive. Posterolateral draw test positive. This was the picture of his leg when he presented to us, and that's the gait of the patient. You can see the Muller's test, that is positive. A lax ACL, but an intact ACL. PCL reconstruction was performed, and after that we planned the PLC reconstruction. You can see the CPN is being protected, and that's the passage of the screw into the fibular tunnel for the PLC reconstruction, and that's the intraoperative stability of the patient, and that's the follow-up at 9 months. You can see And this is the follow-up at 1 year, 3 months. The patient is able to squat, jump, sit cross-leg, and is able to run. So my take-home would be a multi-ligament reconstruction should be always given a trial to be performed in a single stage, and it can give you good results. Thank you.
Ayani? So last talk of the session, so I will be talking on massive curved tear treatment algorithm. This is very important. What are the treatment options for the massive curved tear? Either you rehab this patient, most of the time I try to repair these patients. Sometimes repair is not possible, you have to augment, and then sometimes the repair is like irreparable cuff. In young patient, you have to go for tendon transfer. Now SCR and balloon therapy is also available, and finally in elderly patient you can plan for reverse shoulder replacement. So repair, I think it's the primary job. In this case, you can see the massive cuff tear is almost, if you see classified radiologically, you can classify it irreparable cuff here. You can see the cuff rotated supraspinatus is detected at the level of the supraglenoid tubercle, and if you put your scope inside, you can see almost 2/3 of the humeral head. So these are the cases where you have to plan, we have to release, you have to go for a subacromial release, try to go for capsular release, and at the end of the procedure you can see you can repair this cuff with a medialization with a single or double row anchor. So repair should be your primary option. On radiological basis, don't try to define any cuff as irreparable cuff. So put your scope inside, go for release and try to repair it. Sometimes there is a massive tendon defect. You can see this is a neglected supraspinatus tear, almost 6 months old. You can see from the subacromial space the glenoid, and if you try to pull, you can see the posterior part of the cuff. You can bring it toward the footprint, but there is a defect in the anterosuperior part. And for this patient, the best cheap biological option available is your long head of biceps. All the degenerative cuff tear, I don't use patches in those cases. The best cheap biological augmentation is long head of biceps. To try to reroute the biceps, you can see here, once you release this cuff, try to reroute the biceps, try to go for some amount of medialization, up to 6 to 8 millimeter of medialization I recommended. Don't try to medialize too much, and then try to relocate the part of the infraspinatus and the anterior posterior layer of the supraspinatus. So once you have repaired it, you see what is the second important step, rerouting of the biceps. This is long head of the biceps. Now you are rerouting it. It's like a biceps SCR. So you are filling the defect of the anterosuperior part of the cuff with this biceps tendon, long head of the biceps tendon. And this rerouting of the biceps is very important. It gives a good biological augmentation and acts like a superior capsular reconstruction also. And at the end of the procedure, you can see this irreparable cuff tear with an anterosuperior defect. We can repair it completely with biceps augmentation. Tendon transfer, young patient irreparable cuff tear. So what are the options? We can go for a latissimus LD transfer, and that is basically for a posterior superior defect, and when the patient has loss of internal rotation. Pectoralis major transversor, where you have an anterosuperior defect, and the lower trapezius. Nowadays most of the arthroscopic surgeons prefer this because most of this patient has loss of external rotation, and lower trapezius is in line with your infraspinatus. So biomechanically it's a very superior tendon, just you have to augment it. Only thing is that you have to add a peroneus longus or a semity or a allograft, because the tendinous part of the lower trapezius is very small. So young patient, irreparable cuff, plan for tendon transfer. In space or massive cuff tear, in space for the or SCR for the massive cuff tear. One thing is important when you are planning for a superior capsular reconstruction or a balloon implantation, your force couple should be intact. And what is the force couple of the shoulder joint? Anteriorly you have subscapularis and posteriorly you have infraspinatus. So if your sub and infra is intact, then only you can plan for your SCR. In this patient, this particular patient, you can see it's an irreparable cuff. You can see whole of the glenoid. In spite of that, we can't, you can see, you can't bring the part of the thin part of the rotator cuff towards the treatment. These are the cases you can plan for your superior capsular reconstruction. Again, mind it, be careful that your subscapular infra is intact. If your force couple is intact, then you can plan for your SCR or balloon. In this case, we plan for a balloon implantation. This balloon, a biodegradable balloon, it's available there now in India also. And if you see how it works, so if your force couple is intact, as you inflate this balloon with a normal saline, it will depress the humeral head downward. You can see gradually as you inflating it, there are normal 3 sizes of balloon available, small, medium and large, and again you have to measure it from the supraglenoid tubercle towards the footprint of the SCL, and you see gradually as I am filling it with the saline, the humeral head is coming down, and now your deltoid gets a biomechanical advantage. Now you rehab this patient because now you are what happens with the massive cuff tear? There is a proximal migration of the humeral head. You are depressing the humeral head down. Now you can take the advantage of the deltoid and rehab this patient properly. But the only thing is, you be cautious. The force couple, the subscapular infraspinatus should be intact. Patches, normally 3 patches are available. Now in India also, some are structural, biological and structural biological. For me, biceps is the best patch. Bicep tendon is the best patch. Sometimes if you want to augment it, you can augment it with the tensor fascia lata also. Last but not the least, some of the patient had irreparable cuff tear with a cuff arthropathy. These elderly group of patients, you don't have any option. You have to plan for your reverse shoulder replacement. So my dear friend, we have 4 group of patient with a massive irreparable cuff. Young patient, good cuff, always try to repair or repair with augmentation. Young patient, poor cuff tissue, irreparable. These are the patient you can't plan for a reverse shoulder or a balloon implantation. Always go for tendon transfer. So young patient, irreparable cuff, tendon transfer is the best treatment option. Elderly patient, poor cuff tissue, irreparable cuff, you have the best option available, that is your either superior capsular reconstruction or a balloon implantation. Again, be careful in both before the SCR or balloon implantation that your force couple is intact, your subscapular infraspinatus should be intact, then only plan for your SCR or balloon implantation. The 4th group of the patient, sorry, elderly patient, cuff arthropathy. These are the patient you have to plan for reverse shoulder replacement. Thank you so much.
Thank you very much. We are very much behind the schedule, so you can ask the questions to the faculties during tea time. Thank you very much.
Thank you, sir.
Rakesh is here.
So now let's start the session 14, which is based on trauma. First, I would like to call the chairpersons on the dais. Dr. V.C. Raj, sir. Dr. S.N. Saraf, sir. Dr. Somen Chatterjee, sir. Dr. Amit Ajgaonkar, sir. And Dr. Bipul Prakash Singh, sir. So the first speaker for this session is Dr. Shekhar Srivastava, sir. I would like to call him on the stage, sir.
Thank you. So from cuff tear, now we come to the shoulder trauma, and we all know the anatomy of shoulder and how it works. Well, there's a basic difference in thinking between a trauma surgeon and a shoulder surgeon. A trauma surgeon tries to reduce all the fragments anatomically to get the good function, whereas for a shoulder function, it's only the tuberosity which matters. The head is just a fulcrum for which, over which the tuberosities work. So that's how a shoulder surgeon thinks. So we all know about the classification, the needs classification and hurdle classification. Now, the treatment of the shoulder fracture varies according to the patient's age and demand, the type of classification, the type of displacement, the bone quality, and the soft tissue injury. And based on all that, one can determine whether it can be managed by conservative method or if it requires surgery. If it requires surgery, whether it requires fixation or it needs to be replaced. So when we come to the fixation part, nowadays we have got very good implants, both in terms of plating as well as the nails which have come now, the multi-lock nail. They are also extremely helpful in management of these fractures. The positioning of the patient is very important, otherwise you will find it difficult to reduce these fractures, and assess the treatment. That means if assess the implant positioning. So you should be able to see this head of the femur, head of the humerus in both the planes, both axial and lateral position. The exposure, mostly the deltopectoral approach is the workhorse for all these fractures, though one can go for deltoid split approach. It is especially helpful if you are you have to manage the tuberosity, because sometimes it goes back and then it becomes difficult from deltopectoral approach, but almost all the cases can be managed with deltopectoral approach. Now, in shoulder, the fixation failure typically occurs due to varus collapse. So never ever leave the head or neck in varus. That is the dictum. If the head is in varus, then it's going to collapse. It is seen in almost 79 of, so failure is seen in almost 79 of patients with varus deformity and rarely with valgus deformity. So always maintain the medial continuity either with a stud graft here or with a medial calcar screw. And sometimes you can also medialize the shaft so that it gives an armchair effect and doesn't allow the varus collapse. So that is very essential. Never leave a void in the medial part because it is ultimately going to collapse. So you restore the valgus, you restore the calcar support, you put the plate, and you also restore the retroversion of the head. So most of the time we are focused on the AP view, but you must always do the lateral view also, and you can see that this angulation needs to be corrected, otherwise again the head will fall behind. Correct placement of the plate is also very essential. If the plate is too high, it will lead to impingement, and if it is low, then you won't have good hold in the head. So the proper placement of plate is very essential. But most important is the tuberosity fixation. So you should put enough time in fixing the tuberosities back to the head. The screws are never good to hold the tuberosities. It must always be first taken in the sutures, non-absorbable sutures, especially ethibond, or now you have got sutures like orthocord. So it must always be first taken in the sutures, and then it should be fixed over the head and then over the plate also. So suture management, so tuberosity fixation, enough time should be given for fixation of tuberosity to the fragment, because that will ultimately decide the function of the shoulder. You should have a stable construct, so you should have at least 5 to 6 screws in the head, and always try to put the calcar screw, because that will prevent the varus collapse. And always take a look, relook. You move the shoulder in all the plane to see that there is no screw which is going into the joint, not impinging in the joint. If in any of the view you find that the screw is out of the head, that means it has to be changed. Now, the plate failure usually happens if the bone is very osteoporotic, but mostly it's a technical thing. If the medial combination is there, and if you haven't reduced the head properly, or you have failed to put any stud graft immediately, then it will collapse. So restoring medial column continuity and tuberosity reduction, it becomes the key factor for successful outcome. So again we discussed, so varus reduction, tuberosity management, that is very essential. Now comes the other implant, which is very successful nowadays, and if done properly, it works very well with very good results, are the nailing. So initially one can use it for two-part fractures, for combined proximal humerus and shaft fractures for osteoporotic bones. But as you gain experience, you will see that it is very helpful in 3- and 4-part fractures also. So this is a typical example. These nails are different from the previous generation of nails. So they have to go from the head of the humerus. So it gets good hold here in the subchondral bone in the head, and then it works very well. So these are the various fractures which can be managed with nailing. The advantage is that it is mechanically more stable fixation. In minimally displaced fracture, it can be done percutaneously with lead dissection and pain, and the vascularity of the head is preserved. The problem is that you are going through the cuff muscle, but then you are not going through the tendinous part of the cuff. You are going to the muscular part, and so it works very well. But if the nail is kept proud, then it may lead to impingement. Arthroplasty is done in patients with 4-part fracture dislocation in elderly, in head splitting fractures, and in impaction fractures where the humeral head involvement is more than 40% of the joint surface. So options we have got are hemiarthroplasty and reverse shoulder replacement, especially in younger persons where the tuberosity quality is good. There one can go for hemiarthroplasty, like this is a young person, and you can see that there is just a sliver of bone here of the head. So it was managed with hemiarthroplasty, and the reconstruction of tuberosity over the hemiarthroplasty is very important. But in elderly patients with fracture dislocation, with poor tuberosities, patients with pre-existing cuff problems, or previously failed fixation, so those are the cases where one can go for reverse shoulder replacements. So these are the various indications for reverse shoulder arthroplasty. So based on the patient's age, based on the patient's bone quality, the cuff pathology, one can decide the treatment. Thank you.
Thank you, Dr. Shekhar Srivastava. May I call Samarth Mittal, please. Dr. Samarth Mittal for his talk.
Thank you, Shekhar sir. So I think I'm going to talk about augmentation and hip fractures. Good thing is Dr. Tanna, Dr. Gadegone have already talked about a lot of these things. So they've talked about not just using a DHS but augmenting the DHS, and they've talked about nails and augmenting the nails. So I'm just going to add on to that. I'll just start off with this case of a 90-year-old female having aortic stenosis, epilepsy, hypertension, bipolar disorder and epilepsy. So probably most of us would do a hemi replacement arthroplasty with these patients, but she's a very high risk patient with aortic stenosis and a very high chance of dislocation. So option here is limited. I think previous speakers have talked about augmentation. The only thing different I can talk about is cement augmentation here. Otherwise, adding a nail to a plate, any sort of plate to a nail or nail to a plate is also augmentation. And even adding fibula or biology to fixation is also a sort of an augmentation. I think the indications of augmentation are very, very limited. We don't need to do it in all the patients. In a very, very unstable fracture pattern with poor quality bone, I think Naveen Thakkar sir was trying to imply in specific patient populations, that is where we need to use augmentation. Very weak bone, when you pull in a put in a blade or just screw in a lag screw and you feel the screw or the blade will just come out and back out. Those are the patients. When you are extending the indications of fixation, when you should ideally be replacing these patients, I think that is one scenario. Of course, revision scenarios where there has been a previous implant and you need more hold in the proximal part of the femur. Most of the patients weight bear as tolerated after hip fracture fixation, but the only problem is if you have a uncooperative patient or a delirium patient with delirium, they put non-physiological very high level of loads onto the hip, and these are patients where probably one may need augmentation or a combination of all of these factors will need augmentation. So that patient I started off with the 90-year-old female. Ideally, I think she would have needed a hemi-replacement arthroplasty, but she wasn't a good candidate. We knew the chances of failure with a fixation are higher in that age group, so we added in cement because at that age the lifespan is limited, and as long as the implant doesn't fail and the patient can be mobilized, it can be done well. Another case is this of a 85-year-old female on alternate day dialysis for a chronic kidney disease. We know by experience that chronic kidney disease patients are poor candidates for fixation. The risk of failure is really high with the poor bone stock that they have, and doing any sort of replacement in them is also barred with a lot of risk of infection. So here we reduced this fracture, fixed it well, but at the end of the day we did not want a failure at this age. So just to get more peace of mind and get a good hold in the proximal head, we put in cement augmentation, and this is the 1-year follow-up of that very patient. So cement augmentation delays the time to failure, gives you a better hold in the proximal head, decreases the failures that you may have over a period of time, and the chances of revision of these revision in these patients at this age where they are not probably fit for another surgery decreases. Another 94-year-old male, the bone stock is very, very poor. We know that the chances of blade or screw cutout is really high, and if you don't want a superior cutout, medial migration of the blades, most of the x-rays that Dr. Tanna has already shown, I think augmentation can really help. It adds on to the stability and the failures start decreasing. Something like this in a 69-year-old male where a pre-FN with 2 screws has already failed, we just corrected the varus, put it into valgus and put in some cement augmentation, and this is the 2-year follow-up of the patient. Another 83-year-old female having this atypical femoral shaft fracture, had a history of alendronate use, was fixed elsewhere with a simple AFN in varus, failed, and then we went in and we corrected the varus, pushed it into valgus, put a nail, and then the augmentation here is not with cement but with a locking plate, and this is the 6-month follow-up showing good union in this patient. Another 74-year-old female having this proximal femur locking plate. This is the 3rd time failure that she was operated thrice before. First a nail, then a plate, then a nail, and this is the 4th time she has been plated. So we don't want to go in a 5th time because the chances are bleak. Made a medial entry point, pushed the fracture into more valgus, did a nail, added a plate, added iliac crest, added stimulan, added a lot of bone graft. So you add a nail, plate and biology. So this is a complex kind of an augmentation where you add both mechanics as well as biology, and she went on to do well. So I think the take home message is pretty clear. The role of augmentation is really, really limited. We don't need to do it in all the patients. Less than 1% of the patients will require augmentation. Wherever when you fix these patients either with a lag screw or a blade or a DHS or whatever device you may use, you feel that you don't have the hold in the proximal fragment and you want to increase the hold in the proximal fragment, these are probably the cases where you need cement augmentation. Whenever you're trying to extend the indications of a nail, Dr. Gadegone showed a case where he had a trochanteric fracture with a neck femur fracture which had failed. Probably that is an indication. Wherever you're extending the indication of fixation and the chances of failure are high, there you can do it. Definitely in a revision scenario where you need more hold in the proximal part, patients who will put non-physiological, supra-physiological loads on the hip, like uncooperative patients, patients with delirium, patients in alcohol withdrawal, I think are good candidates for augmentation. Or if you have a very unstable pattern or a combination of these injuries will require augmentation. I have 2 minutes left, so this is a simple video of augmentation and it is not working. Anyways, this is a simple technique. You can just put in cement through the black screw or the blade of the nail to get in a proper hold in the head, so you've not burnt any bridges. Anyways, sir, thank you so much.
Professor C.S. Yadav, sir.
वंस अगेन थैंक यू अमूल्य भाई। यहाँ एकेडमिक्स के अलावा सबसे ज़्यादा जो मुझे अच्छा लगता है अपने भाइयों से मिल लेता हूँ, और इतने जाने पहचाने चेहरे और मिलके जो खुशी मिलती है शायद दिल्ली में नहीं मिलती वो रूटीन काम करने में। पूरा भी अंदर आपके So this is very important topic, whether to do osteosynthesis, arthroplasty, which arthroplasty. Here there is a no dilemma in fracture upper end of femur. Osteoarthritis hip, here it is a tumor. And what happens sometime even in the, you plan for the bipolar, in late, old fractures, sometimes you see there is a no cartilage at all in the acetabulum. So you, whenever you plan for the bipolar, always ready for the THR in these situations. So, but dilemma is in this situation, fracture neck of femur after the age of 60 and fracture IT after the age of 70. What to do? Whether to sacrifice that joint or to save the joint. So modalities treatment are these. Non-operative treatment, almost it has no role, whether it is a upper trochanter or whether it is fracture neck of femur. Internal fixation has very limited role, and fixation has role in the IT. And trend of arthroplasty is increasing, and arthroplasty also have many questions, what to do, how to do. And when you treat fracture neck of femur undisplaced, even undisplaced fracture, if you treat by internal fixation, non-union is around 7% and AVN is around 8%. Overall conversion is around 15%. If you treat them non-surgically, even in the undisplaced fracture, then conversion to the THR is very high, THR or bipolar. Displaced fracture neck of femur, failure rate with the internal fixation is very high. If you go for the hemiarthroplasty, then conversion rate to THR in both the modalities is also very high. You can see from these studies. Because of shortage of time, I will not go into the detail of the studies. Now question is which arthroplasty, whether it is uni, bi or total hip arthroplasty, whether dual mobility and or large head. This depends on one important point. Whenever you do, whether it is bipolar or even old hemi, processes should outlive the patient. It should be lifetime procedure. Keep that thing in the mind. So decide yourself. And there should be minimum chances of failure and complication from the first intervention, because these patients are elderly. You cannot offer them another surgery. And the procedure which gives better functional score result and provide early rehabilitation, that is the most important in these patients. Unipolar, like this type of processes, I don't do. There is no scope in my practice, and probably it can be done in very desperate situation. You can go for in this situation for this old hemiarthroplasty, because it has many drawbacks, long list of drawbacks and long studies. So I don't do. But bipolar can be done. And bipolar has many advantages over the unipolar. Revision rate is very less in conversion rate into the THR. And but it also has additional advantage of, you can restore the limb length, you can restore the offset. That is not possible in that hemiarthroplasty. So bipolar is better than hemi. So I go for bipolar in many situations. But sometime what happens with the bipolar? The thigh pain and the erosion of acetabulum, that is not uncommon. So if you go for the THR, there is a no scope for the acetabular erosion, and Harris' hip score is better than bipolar. Even this score doesn't reduce with the time. In bipolar, what happens? With the time, Harris hip score reduces, and THR is definitive procedure unlike bipolar. If patient is, what is my criteria? If patient has outdoor activity, and I think patient will survive more than 2 years, and patient goes for walking, grocery सड़क पे जाता है, दुकान पे जाता है, बगल से दूध लाता है, then I will go for THR, not for bipolar. And if many meta-analysis is there, overall internal fixation hemi-arthroplasty among the total hip arthroplasty, reoperation rate is least in the total hip arthroplasty. These are the meta-analysis. Now question is which type of total hip arthroplasty, whether it is a cemented, uncemented, this depend on the surgeon and the patient, quality of the bone, whether conventional stem or long stem. Long stem is used whenever there is a loss of integrity of upper end of femur like fracture intertrochanteric. Dual mobility, it can be used in the intertrochanteric fracture, but it should not be overused or misused. I rarely use dual mobility because a lot of surgeons, they use dual mobility because of fear of dislocation. Additional fixations are required in fracture IT, like tension band wire, encirclage wiring, ethibond. I use lot of ethibond number 5. So overall aim is patient should walk next day of the surgery. So for that, achieve good primary fixation of the component into the bone and stability of the joint. Cemented, uncemented, both can be done. But in elderly osteoporotic bone, these are the most of the time I am doing uncemented stem, but these are undisputed advantage of cemented stem over the cemented stem over the uncemented stem, like less chances of periprosthetic, less thigh pain, better initial better hairy hip score, better early ambulation, patient satisfaction. Whenever the patient is terminally ill and very low demanding patient, it is not need to use gun because it may cause monomer absorption, it may cause side effect. So do manual cementing. Now few points about the which approach. Many surgeons, they go for the entry approach in this situation, but I go by standard posterior approach. Thing is that I say many times, we have done studies over it, and if you do it properly like this, we have what we take a flap, myocapsular flap, take a, like various steps are there, and repair it. Repairing myocapsular repair, जहाँ से आपने उस flap को उठाया है, repair it then and there, and do not reduce your combined antivision. Then dislocation rate is almost nil, 0. What I say, and we have published. This is the video. कितना time है? Yeah. So I will not show the video. This paper, Samarth has published this paper with us, and about our technique. Our technique is, and we use just ethibond number 5. इसमें drill करने की भी जरूरत नहीं होती. Ethibond number 5 needle is so strong, it can take bite from any thing. And few points, 2-3 slides about the fracture IT. It is much more challenging, and why it is challenging, and identification of entry point is difficult. Position of the patient, table, position foot, femoral. So you should be very good at eyeballing when you are doing total hip arthroplasty in fracture IT. So I have already discussed fracture this patient, and when you do total hip arthroplasty in the field fixation, it is more difficult than fracture IT. These are the additional problems of, in this situation, removal of hardware, high speed wear is needed, bone is not normal. This patient, very interesting, multiple time operated, dislocation, periprosthetic fracture, loosening of the component. We did just a small dysplastic cemented stem, fixation passed in, patient healed, patient walked. Another patient, dual mobility was done after the field fixation, it dislocated. As I told you, because bony landmark are not there, so it is very difficult to put into the better version. So what we saw, this stem bar in 20-degree retroversion. This was the father of faculty at, so we changed just system. So even dual mobility can dislocate if you do not do it properly. Another case, so dual mobility, it should not be misused. It definitely increase jump height. So message is, modality of treatment depend on type of the fracture, pre-fracture activity, life of expectancy, and fitness of the patient. So you can go for osteosynthesis, bipolar, or total hip arthroplasty depending on the situation. Thank you.
Good evening, friends, again. Well, now there are hardly 3 lectures are remaining. We'll see about the lateral wall in the proximal femur fractures. This new key to stability, and we'll see the myths, controversy, and clinical importance. In proximal femur fracture, especially in intratrochanteric fracture, the lateral wall has replaced the posteromedial calcar as the most critical predictor of fracture stability and surgical success. It is defined as a segment of cortical bone located lateral to the femoral shaft, providing a buttress for the proximal fragment. It is measured on an AP X-ray, the distance from a reference point. Let's start the pointer. Yeah. So a reference point 3 centimeters below the great trochanter to the fracture line, angle at 135 degrees upward towards the midline of the 2 cortices. And the threshold value is about the 20.5 millimeters, which is widely accepted cutoff. If it is more than that, then it is considered as a competent lateral wall, there is stable fracture. And if it is a less than 20.5, it is considered incompetent on the thin lateral wall, which is unstable variety. What is the clinical significance? The integrity of the wall detects whether the fracture remains stable or collapses after surgery. And this buttress effect of the lateral wall, it prevents the proximal fragment from sliding laterally and the distal fragment from medializing, as if the book is held on the edge, book end holding the book. But if the wall breaks, this fracture gets converted into subtrochanteric type or the reverse oblique type of instability. So this can lead to the varus collapse, limb shortening, medialization of the femoral shaft, higher rates of the reoperation and non-union, and as well as abductor insufficiency. So before 2018, the stability was mainly focused primarily on the posteromedial cortex or the lesser trochanter. But after that, it is the status of the lateral is now primary determinant of the A1 or A2 types. This is the classification. If it is a more than 20.5, it is a competent lateral wall. It has got 3 subvarieties. And if it is less than 20.5, it is an unstable fracture. Remember, apparently simple fracture, but with a very thin wall is also inherently unstable. The status of the lateral is primary factor. How you are going to choose between extramedullary and the intramedullary fixation. This is a chart. If it is a more than 20.5, it is a stable one. So you can use the DHS as the wall is strong enough to support the lag screw and the prevent collapse. If it is a less than 20.5, and it is not comminuted one, you can use intramedullary nail, which act as the internal buttress and making the lateral wall strength less critical. But it is a comminuted one, and you have to add the trochanteric stabilizing plate into that to construct the lateral buttress. So certain myths we will see. Previous the myth was the posteromedial cortex is the only pillar. If the lesser trochanter is stable or intact, the fracture was supposed to be stable. But up to 2016, that even the intact lesser trochanter, thin lateral wall can lead to the failure. That is a fact. So this data in 2025 shows that the lateral wall thickness is an independent predictor of reoperation regardless of the medial stability. The second myth is DHS is always safe for simple 2-part fractures. But the fact is that if the entry point of the DHS leaves a thin lateral shell, it can, which generally fractures intraoperatively, the problem can come. So correction is for thin walls, intramedullary nail is the gold standard. Another controversy, just I said, does the PFN always beats DHS for the thin walls? So most literature, they support PFN for incompetent walls which prevent the telescoping and the medialization. Some surgeons argue that THS plus TSP is equally effective and cheaper in the specific settings. Another is reconstruction always necessary if the lateral wall is fractured or the nail alone is sufficient. But the literature tells that the PFN for incompetent walls to prevent telescoping as well as medialization, they favor PFN. Some surgeons still argue that DHS and TSP is equally effective here also. Now about the CT versus X-ray measurement. Is this 20.5 mm X-ray rule is outdated? What is the modern view? The CT gives a true cortical thickness, often 2 to 4 millimeter. This Hasu's 20.5 is a geometric proxy and not an anatomical thickness. An emerging trend is the use of 3D CT to identify coronal plane fracture which are invisible on the AP X-rays and they can compromise the wall. So what are the complications which can occur? Is one is a varus collapse, where the head and neck drops into downward angle. Then there is a medialization. If you don't take care of the lateral wall, there is a medialization of the femoral shaft. There is a lateralization of the screw and lag screw can back out through the lateral cortex, and there can be Z effect specific to dual screw PFNs when the lateral wall fails to provide the support. So intraoperative tips are there how to protect the wall. First is for entry point. For PFN you avoid 2 lateral entry point which can shatter the remaining wall. Avoid over-reaming in the case of DHS barrel which can destroy the 25 wall down to the 15 mm wall. And there has to be positive cortical support on the medial side to offload the lateral side. So take home message is that the integrity of the lateral wall influences classification, stability and the treatment plan of intertrochanteric fractures. A stable fracture generally involves an intact lateral wall. An unstable fracture which often involves a compromise of the fracture lateral wall which leads to potential collapse and malalignment after fixation. And the fractures with intact lateral wall, internal fixation with DHS or the cephalomedial nail is usually sufficient. But when the lateral wall is compromised, it will require augmentation or the alternative fixation to prevent the collapse and fixation failure. Thank you very much.
I'd like to call
Good
all
evening,
the
friends.
speakers.
At the outset, I would like to thank my very dear friend, Dr. Maurya, for inviting me here and allowing me to share one of my cases. Can we have the presentation? Kaise? Ek minute. Aa gaya. Yes. Now, I'm going to present a case of polytrauma who was unconscious and in ICU for about a week, but my focus of discussion is going to be on fractured neck femur. Friends, this patient on 5th May 1999 was involved in one of the most serious train accidents near Ludhiana. He was a CRPF Jawan from Kerala and he had survived the accident, but he had multiple injuries to his right side, left side, open injuries in hand, both the femur fracture, right side was shaft fracture, left side was intertrochanteric fracture, going on to subtrochanteric fracture and comminuted intracapsular fracture all on one side. And then he had elbow injury, head of radius, capitulum comminuted. He had left shoulder injury, left lateral and fracture clavicle and ACJ dislocation, all in the same patient, and then fascial injuries also, open lacerations. He was involved in the accident on 5th evening and presented to us on 6th morning. Dr. Ajit is sitting there and laughing because he also knows about the case. Now, how to manage this? On the same day, in the morning, we stabilized his general condition and planned to fix all his long bone fractures and look after his open injuries on merit. I will not go into the details. We did all that. Open injuries were managed. Right shaft of femur was closed interlocking nail. Left side intertrochanteric, subtrochanteric and intracapsular. 27 years back, we got a recon nail. At that time, we used to get it from US. It was not easily available. And we did the recon nail on that side. And then the only thing left were the ankle fracture, left side, elbow fracture, capitulum and head of radius comminuted right side, ACJ, fracture dislocation, and lateral and fracture clavicle grade 3. These were the things left. These were the unattended. This we thought we'll plan in a staged manner. Now what happens next? Next day, he developed fat embolism and was put on ventilator. He was shifted to ICU where he remained on ventilator for 1 week unconscious, and 3 days after ICU, he developed very big chest effusion for which a chest tube had to be put. Luckily, after 7 days, he was stabilized, came out of ICU, another 3 days, chest tube came out, luckily no infection, and he was fairly stable, and in next 10 days or so, we managed all his other injuries, left ankle fracture, right side, all the loose fragments had to be excised, capitulum and head of radius. the left lateral and fracture clavicle and ACJ dislocation. He says that he doesn't want any more surgeries. Next few months we followed him up, all fractures united, dynamized right fracture neck femur, except fracture neck of femur. We took out the recon nail, did an MRI, there was gap, of course there was gap was visible on X-ray, and there was AVN. So this is the status. Recently united intertrochanteric subtrochanteric fracture on the same side with a gap non-union fracture neck of femur in a 33-year-old man and avascular necrosis. What to do now? This has been discussed since yesterday. Most of the speakers, quite a few speakers have discussed on this, and there are varieties of treatment options available. Basically, we have to minimize the number of surgeries required for him in next 60 years of his life. How did we do that? What we did? Of course, we removed the nail and then we did uncemented modular bipolar with a ceramic head, because we knew that ceramic over plastic wear rate is much less than metal over plastic. So we wanted to extend the life of this patient, of his bipolar. This is what we did, uncemented Muller, rough blasted titanium. At that time it was very new and we again had to import it, and this was possibly the first case of its kind in the country 26 years back. This was post-op X-ray. He kept on doing very well, and this was 7 months follow-up. You can see the bone growing onto the stem, sclerosis, and we lost him to follow-up. He went back to Kerala, went to his home, and we didn't know what happened to him. We had told him that you might need acetabular, conversion of this to total hip in about 10, 12 or 15 years, because he was very young. Now, we didn't know what happened to him till 24 years later. I got a call from Dr. Shantaram Shetty. And he said, Dr. Agarwal, this call is to compliment your work. I'm seeing a patient operated by you 24 years back. He's kicking around, he's doing very well, he has no problem, he's doing his all activities of daily living. I said, thank you very much, sir. I'm very happy that the patient is alive and kicking around. He has not yet required conversion to total hip. But what happened next was, patient knew that I was around still. So he went to the net, found my clinic's address, called my clinic that I want to come to Ludhiana to meet Dr. Agarwal. I called him back. I said, in few months, I'm coming to Chennai for a talk. From Kerala, it will be easier for you to come to Chennai rather than Ludhiana. You come to me in Chennai. So in last year, August, he traveled for 12 hours, came with his family. He was now 60 years man. He was so happy. He said, all my children are settled, married, doing very well. I have done very well in my life and I'm very happy, and I'm doing all my activities of daily living. I had asked him to bring all his records, because I said, now I will be able to get his record. This was 7-year follow-up, doing very well. This was 16-year follow-up, doing very well. This was 24 years. That is when you can see Tejaswini Hospital. Dr. Ajit has also been seeing this patient in Mangalore, and that is when Dr. Shantaram Shetty called me. And when he came to me in 2025, I said, you do a new X-ray and bring it to me. Now this is what happened last year. He was not aware. He said, I'm doing fully fine, I'm doing all well, I'm doing everything all right. I said, but you need now the revision. He said, but I have no pain, I'm doing all right. This was the elbow X-ray, some calcification we can see. We had removed all fragments. And this was his left shoulder, left fracture, left clavicle. And let me see if I can play this. See the function. Done nothing to lateral and clavicle grade 3 ACJ disruption. 25 years down the line, 26 years now at that time for this. Doing excellent. Very well, shoulder function very good. Dr. Tanna said this morning, I have now relearned not operate clavicle fractures. This is elbow, full function, flexion extension, full supination, pronation. Only thing I noticed was mild limp. That is because plastic has worn out and there is some shortening. But he says he doesn't want anything. He's 100% all right and doesn't need anything. Now this, just before coming here last month, I told him send me a new X-ray. So it is the same and he is doing same. So what now? He is managing ADL very well. There is no pain, mild limp. Radiologically, there is plastic wear. No lytic lesion in the bone despite plastic wear, because the bone is grown on through the stem, and acetabulum possibly is still okay. Stem is well fixed. Acetabulum we don't know, about a centimeter shortening. He said he doesn't want anything. I You raise your shoe by 1 centimeter, he said, my limp has also gone. So my plan is, whenever he needs something, I will contact the same company, stem is well fixed, I will replace, if acetabulum is not eroded, I will not replace acetabulum again, I only replace the outer shell. If acetabulum is eroded, I will put an uncemented cup, just half the surgery, and hopefully this will be good for another 30 years and rest of his life. Friends, my message through this talk is, we used to be taught, my message is an answer to this question, is fractured neck of femur still an unsolved fracture? Not really. We need to be pragmatic, conserve bone, and plan for life of the patient. Match the life surgery to the remaining life of the patient, life of the surgery. And for 35 years, we have an algorithm for fractured neck of femur. Young patient, all grades, fresh fracture osteogenesis, there is an algorithm. I won't go into the detail. You can have a look. Any fractured neck of femur, any stage, any age, this will give you an answer. Thank you. We have to match the life expectancy of the patient with the life of the surgery. Thank you very much. Thank you.
Thank you, Dr. Agrawal, for your nice presentation. Now the last talk, Dr. Umair, hip fractures, update and national guidelines. I think this is the last talk of the session, session 14, and last of the day also. Thank you.
What is allowed? Hi. Good afternoon, and this is the last lecture. I hope there will be few minutes of attention here. So everything has been talked about the hip fracture, I think, in last few sessions. So I'm just going to summarize in a other way and practicing in different part of the world. So what's the best practice for the hip fractures? And I will just give you the model of the practice which we do in Ireland. So in my part of the world, the hip fracture care is governed by the Irish hip, or you can say the local hip fracture standards, which are managed and audited by the Irish hip fracture database under the National Office of Clinical Audit. And these standards are based on the international best practices such as NICE guidelines and the British Orthopaedic Association Blue Book. So England, Scotland, other European countries, they have their national guidelines for the hip fractures. So we don't have the luxury doing anything, but we have to stick by the guidelines for the hip fractures. Now, because the talk has to be short, so I'm going to limit to the fractured neck of femur. So we get an annual report for the Irish hip fracture database every year. So population of Ireland is 5.5 million. We get about 4,000 hip fractures annually. It's just double the population of, I think, Patna town. And all the hip fractures over 60 years of age, they are recorded into the database. And our data coverage is 99%. So we have 60 trauma centers in the country. So all the acute fractures and trauma, they are not treated in the private hospitals. They are always in the trauma centers. And hospitals with best compliance to the Irish hip standards, they get the Golden Hip Award. This is a big trophy. And compliance to all these standards are about 93 to 95% overall. And the hospital or the surgeon who are not compliant with the guidelines, they are under a scanner. Actually, there is one friend of mine whose license is under scrutiny. So we have to be with that. So we can't just do whatever we want. So what are those 7 standards? Just I go too quickly. The patient admitted to the orthopedic ward after the fall or after the fracture is within the 4 hours. So we have that time limit. And I think this standard are met by most of the hospitals. Now they are going to receive surgery within 48 hours. So all the surgeries of the hip fracture, they are done is a neck of femur, trochanter, subtrochanteric. So they are going to get within 48 hours for the best outcome. So this is very important point. If they are having some medical issues or blood thinners, they have to be optimized by the time. Now, pressure ulcers to be 0. So no pressure ulcer. They have to be looked after well.
and they have to be seen by a geriatrician or advanced nurse practitioner, and they get a bone health assessment. Also, they get a specialist falls assessment, that what's the reason falling, having this fractured neck of femur or other hip fractures. Now, very important next point is to be mobilized after the day of surgery. No any other thing. So after the day of surgery, they have to be mobilized. Doesn't matter whatever you are doing, whatever implant you are putting, they have to be mobilized the next day. So what we are including in hip fractures, those colored areas, fracture neck of femur, trochanteric fracture and subtrochanteric fracture, and also we include periprosthetic fracture in those regions. Now these are the nice guidelines. So replacement arthroplasty to the people with a displaced intercapsular fracture. Now the new thing, revision to the guidelines, has come in 2023, offering a total hip replacement to the patients who are in gray area, like 50 to 70 years of age. So those are the patients who were able to walk independently out of the door with no more than the use of a stick. So those get this total hip replacement offer, and they do not have a condition or comorbidity that makes the procedure unsuitable for them, and also they are expected to be able to carry out activities of daily living independently beyond 2 years. So this guideline came in 2023. So after that, we are sitting with the patients who comes in this age group and offering them total hip replacement in place of hemis or other options. Now the other recommendation is use cemented implants in people undergoing surgery with arthroplasty. Important, that has been adopted in 2011. And then you have to record the long-term data for the hemis, including patient reported outcomes and advanced events. Well, consider anterior lateral approach in favor of the posterior when inserting a hemiarthroplasty. This is one of the guidelines. The two other things, there's a lot of trochanteric or subtrochanteric fracture has been discussed here. So basically, if there is a stable fracture, you can use a dynamic hip screw or the fixed angle device. But if there is unstable fracture, subtrochanteric fracture, reverse obliquity fracture, there is no question you are going to use any type of plate or a screw. If you are using, NICE has written, you are not protected in court. So that's the line written in the NICE guideline. And also for the subtrochanteric. So now, all considering everything, the options, modalities of the treatment available: internal fixation, hemiarthroplasty, and the total hip replacement. So I say option for preserving native hip for non-displaced fracture in all age groups. You can use that in all age groups if it's non-displaced. Hemiarthroplasty, as it is a gold standard for intercapsular fracture in elderly patients. Total hip is an option for active young age group patients, also in hips with pre-existing conditions, as the Mr. Yadav was showing arthritic hip with a fractured neck of femur. So just I'm going to run through a few of those cases. This is 62-year-old with a non-displaced fractured neck of femur, classical fixation with a DHS and the derotation screw. Other one, 66-year-old with a non-displaced fractured neck of femur, again. So 3 screws, traditional way, and this is a 1-year follow-up, so well healed up. Hemiarthroplasty, cemented versus uncemented, again recommendation is the cemented. And otherwise the literature suggests that there is a higher periprosthetic fracture with uncemented stem within 6 months of post-op period. So cemented design, there are basically 2 designs available. One is the Exeter system and one is the Charnley system. Exeter is a taper slip, highly polished stem. Working principle is the force lock. Charnley system, they are matte finished. Working principle is shape closed or composite beam. Both have equally good long-term result. Time proved. Well, uncemented, there was a time during 13 and 17, I was almost 90% of my cases I was using uncemented. And there were 2 kind of implants: porous coated, proximal loading, no collar, bone ingrowth. and the grit blasted one, the other side, which is colored one and allows the bone growth. Now, then the recommendation came for the cemented hemiarthroplasty, so I have to change. So in 17 and after, I have to change with all the hemiarthroplastics going with the cemented. So in those years, this is 87-year-old who had, it's my case in both sides. I did one on the uncemented on the left side, and after a year came with the right side fracture. So I just equalized both. So I put a non-cemented on the same implant on the other side. So this is other, I was saying about the porous coated and the proximal loading one, uncemented implant that did very well. And this is a classical one, 95-year-old with a left neck of femur fracture. A cemented hemi was done, classical exeter stem, bipolar head. This is what the recommendation is. And fantastic, this is the one that I love. So it's the best implant actually available, I say. So now this is the question lies here. 60-year-old, fit, healthy, active. She was actually doing running or something and she fell down. Very recently done, about 2 months ago. So the question is what you are going to do here. 60-year-old active, displaced, preserving, non-preserving. But the recommendation is, again, offer, explain everything about total hip replacement. If patient agrees, go with it. So this is the total hip replacement performed on this patient. So if you go with a nice search, nice guideline search with a total hip replacement and hemiarthroplasty, the overall Harris hip score system at 1 year and 3 year favors total hip arthroplasty. All of the other parameters like the functional independence are not different. It's just a comparable. Well, hospital length of stay, I don't think it matters more in this part of the world, but for us, yes, it favors hemiarthroplasty. Infection, periprosthetic fracture, dislocation are the same in both modalities of treatment. So, take-home message from this is patient selection is very important. Appropriate surgical option should have been to put. Early surgery is the best for the best outcome. Immediate mobilization. And my suggestion is, like Bihar Orthopaedic Association should start a hip fracture database, and we can learn a lot, and even Indian Orthopaedic Association, and lot to learn from the varied kind of options that you put in late presenters, because we don't get any late presenters like the patient coming after 2 weeks or 3 weeks or something like that, or even the failed implants and all those. So I think if that comes in a database, because the individual practice is not going to matter that much. So we have to put in a database, and that if you produce too, and it's going to impact. So I think that will be the best thing. So that's a take-home message. Now there's a lot of discussion was done. Just I'm putting these 2 slides. From here I don't have a long much options. So what do you do? One of the best implant in the cephalomedullary nailing is this one. So I had hundreds of cases done with the gamma nails, and failure rate is almost negligible for unstable reverse obliquity subtrochanteric fractures. So right implant, right patient, and the rest of the parameters. Thank you very much. I hope this will give some thanks.
Thank you, Dr. Omer. So now we come to the close of this session and the day's session. So I hope we'll be going to prepare for the inauguration session, sir.
Sir, I would like to call all the faculties of this session for the group photograph.
Yes, sir.
अरे कहाँ चले गए? चेयर लगाना ऊपर, चेयर लगाना, कहाँ चले गए?
अरेंज करा दीजिए. हाँ. I will request everybody to take the seats, please. आगे बहुत सारी कुर्सियां खाली हैं. जो लोग पीछे खड़े हैं कृपया आगे की तरफ बढ़ते जाएं. और we will start the inaugural function. चार तीन सात हुई गए, एक और. अरुण वो दो ना, लकी ड्रॉ का. Is registration number 248 available in the hall? 248. मैं नाम अनाउंस करता जा रहा हूं. 195. 195 के कोई है? 261. सारे लोग लगता है बाहर निकल गए. 139. 71. रजिस्ट्रेशन नंबर अपना देख याद कर लीजिए. 80. 21. 87. 137. 260. 39. 194. 134. 32. 85. 110. So unfortunately faculties और इसका नहीं है इसमें, बाकी डेलीगेट्स वाले, इसलिए आप लोग को डोंट. 177. 254. 82. 266. 45. हाँ, ये तो लगता है कि 91. 4. नहीं आ रहा है किसी का भी. 46. 43. सुबह में तो तीसरे में निकालने में निकल गया था मेरा. 252. 93. 33. 81. कोई नहीं आ रहा है तो ये लगता है कल ही इसका लकी ड्रॉ का किया जाएगा. Is any PG postgraduate student sitting here in this hall? Postgraduate कोई भी एक? आ जाओ, अब तुम्ही को मिल जाएगा, छोड़ो.
Good evening, everyone. आवाज नहीं आ रही है. I think lunch was not good enough today. Good evening. Okay, fine. So good evening again, a good evening everyone. My name is Anjali Singh. I'm the president for Eurokids Preschool Patna. Today I'll be one of the hosts for your evening. Along with me, my co-host will be my younger brother, Dr. Akshat Suman, resident doctor with IJAMS. So today, for Gofcon, I would like to start and give my respect to, in fact, respected dignitaries, esteemed faculty, honored guests, and dear delegates. It is with immense pride and great enthusiasm that I welcome you all to Gofcon 2026 in the vibrant and historic city of Patna. Gofcon has always stood as a beacon of academic excellence, collaboration, and innovation in the field of orthopedics. This year, as we gather in Patna, a city which is rich in heritage, culture, and intellectual legacy, we bring together some of the brightest minds, skilled clinicians, and passionate learners from across the country and beyond.
Gofcon 2026 is not just a conference, it is a platform to exchange ideas, challenges, exchange existing paradigms, and explore the future of orthopedic practice. Over the coming days, we will engage in insightful scientific sessions, hands-on workshop, and thought-provoking discussions led by experts who continue to shape our specialty. Beyond academics, this conference is also an opportunity to build lasting professional relationships, foster mentorship, and celebrate our shared commitment to improving patient care.
We hope your time in Patna is not intellectually enriching, but also personally memorable. So when we say a memorable time in Patna, hope you had a time to enjoy the delicacy of Bihar, which is litti choka. If not, please do enjoy. And if it's not available in the menu, then you have to, get in touch with Dr. Amulya and team for that. Yes. May you experience the warmth of our hospitality, the richness of our culture, and the spirit of learning that defines Gofcon. Once again, I extend a heart welcome to each one of you. Let us make Gofcon 2026 a truly inspiring and unforgettable experience.
We'll now proceed to invite our esteemed dignitaries onto the dais. I'd like to call upon our chief guest, Dr. Naveen Thakkar, sir, President, Indian Orthopaedic Association, a personality who has worked significantly to enrich our field. We request you to please join us on the stage, sir. I now invite our respected Dr. Amulya Kumar Singh, President, Bihar Orthopaedic Association, without whose support this would have been impossible. Kindly come forward and take your seat on the dais, sir. We also request Dr. Bhuvan Singh, President, Central Zone Orthopaedic Association, to please join the dignitaries on the stage. Extend a warm invitation to Dr. Sarsij Nainam, President, Global Orthopedic Forum, whose presence adds great value to this occasion. Please grace the dais, sir. May I also request Dr. Rajiv Raman, Secretary, Indian Orthopaedic Association, to kindly come forward and take your place on the stage, sir. It is indeed an honor to invite Dr. Vinod Thakur, sir, whose vast experience and expertise continue to inspire us all. Kindly join us on the dais, sir. I would also like to call upon Dr. Ashok Kumar Sinha, sir, Reception Committee Chairperson, a stalwart in the field, to please grace the stage with your presence, sir. Dr. Ashok Kumar Sinha, sir. May I request Dr. Ramit Gunjan, sir, whose contribution has truly been noteworthy, Scientific Committee Chairperson, to kindly come forward and take a seat on the dais.
Can we have the floral bouquet ready with that? Yes. As a mark of our deep respect and heartfelt appreciation, we shall now proceed with the presentation of floral tributes to our esteemed dignitaries on the dais. May I request Dr. Feroz and Dr. Dinesh to kindly come forward and present the bouquet as a token of our gratitude and warm welcome. This small gesture symbolizes our sincere acknowledgement of your gracious presence and the invaluable contribution you make by being a part of this occasion. लैंप लाइटिंग जब लैंप बनाए तो म्यूजिक कर देना So we'll just start with the lamp lightning thing. Nisha, can you please help with the lamp lightning?
वक्रतुण्ड महाकाय सूर्यकोटि समप्रभ निर्विघ्नं कुरु मे देव सर्वकार्येषु सर्वदा। वक्रतुण्ड महाकाय सूर्यकोटि समप्रभ निर्विघ्नं कुरु मे देव सर्वकार्येषु सर्वदा। प्रभ
सिंदूर लाल चढ़ायो अच्छा गजमुख को, चोंदिल लाल विराजे सुत गौरी हर को, हाथ लिए गुड़ लड्डू साई सुरवर को, महिमा कहे न जाए लागत हूँ पद को। जय देव जय देव जय जय जी गणराज विद्या सुखदाता, धन्य तुम्हारो दर्शन मेरा मन रमता। जय देव जय देव भगति से कोई शरणागत आवे, संतति संपत्ति सब ही भरपूर पावे, ऐसे तुम महाराज मोह को अति भावे।
It is my privilege to invite Dr. Multiligamentous Singh, President Bihar Orthopaedic Association. We are honored to have him to set the stone for this occasion. Sir, can we have you for the welcome address, please?
So before Dr. Amulya comes on the dais, unfortunately we coordinated for something with this. So he is one of the man which I have observed since childhood, the Dhurandhar of Patna, Bihar. So a big round of applause for him. All of you please. Thank you.
Thank you, Anjali. She is my niece. We have got a joint family. बड़े भैया का जो डेथ हुआ था 2014 में, और उसके बाद परिवार आज भी वहीं से है, हम लोग मिल के ही रहते हैं। और इस मैसेज के साथ आई वुड लाइक टू स्टार्ट जॉइंट फैमिली मैटर्स। फ्रेंड्स, अ वेरी वार्म वेलकम and a very, very good evening to everyone present in this hall. It is a moment of immense pride and profound privilege for me to stand before you as the President of Bihar Orthopaedic Association, the President of NAILS, and the Secretary of Global Orthopaedic Forum. तीन एसोसिएशन के साथ मैं खड़ा हुआ हूं। जो दिल का खूबसूरत हो, खुदा ने ऐसे कम लोग बनाए हैं। जिन्हें ऐसे बनाया है, आज वो सब हमारी महफिल में आए हैं, और आपके आने के बाद ही इस महफिल की खुशियां बढ़ जाती हैं। On behalf of the organizing committee, I extend a heartfelt welcome to each and every one of you from Gofcon 2026. Here in the history and vibrant city of Bihar, in these 3 days, we are going to witness a true conference of minds sharing knowledge, innovations, and the future of orthopedics. Today, our dais is graced by some of the most eminent personalities. I am deeply honored to welcome them. First and foremost, I am here as a member of Indian Orthopaedic Association to welcome our dynamic President, Dr. Naveen Thakkar sir, the President of Indian Orthopaedic Association. Friends, my deepest gratitude to our concerned Chief Guest Dr. Naveen Thakkar, President of Indian Orthopaedic Association, sir. Your visionary leadership is steering the IOA to new heights. Having you here at Gofcon validates the hard work of the organizing team and inspire all our delegates. Sir, मैं सच में बोलता हूं, मैंने जब आपसे अनुरोध किया था शायद 5 महीने पहले, I was not sure कि now you were heading the whole organization. I was not sure whether you will be coming or not. मुझे 15 दिन पहले till you were in USA, मुझे उस दिन में लग रहा था किसी दिन एक मैसेज आएगा कि मैं नहीं आ सकता हूं, because I know that you don't want to come to Bihar. You are really busy. उसके बाद भी समय निकाल के आना और कॉन्फ्रेंस के पहले पहुंच जाना. Sir, we love you like anything, sir. We are grateful to you. I would also like to extend my deepest gratitude and a very special welcome to the son of the soil, Dr. Rajiv Raman, the Secretary General of Indian Orthopaedic Association. Dr. Raman, you are a dynamic force and the administrative backbone of our parent organization. We thank you for your relentless support of regional associations and for gracing this occasion. Thank you so much. He was busy till yesterday at Coimbatore. Directly from that place, he has come here with the same smile. I don't know how you manage this smile. Right from morning you are busy, then also you are available everywhere. I am equally delighted to welcome my younger brother, I will always say, Dr. Bhuvan Singh, the President of Central Zone Orthopaedic Association. Sir, going back to the history, आज मंत्री जी नहीं आ रहे हैं इसलिए समय थोड़ा ज्यादा मिलने वाला है. First time I met this gentleman, Bhuvan, at Saharsa conference in 2021 or 22, exactly I don't remember, when I was the Secretary of Bihar Orthopaedic Association. नहीं, उसके पहले 2004 और उस समय पहली बार मिला था और जिस जोश के साथ डॉक्टर अबुल कलाम सर को ये सारा चीज, he was managing everything. What you are saying, Amulya, today, he is the same person for Saharsa Bihar Orthopaedic Association, Central Zone Orthopaedic Association, और मैं तो बोलूंगा कुछ दिनों के बाद IOA के लिए भी यही होने वाला है, क्योंकि इसमें जो जोश है वो हम सब लोग को सीखना चाहिए. आई एम प्राउड ऑफ यू भुवन, यू ऑलवेज देट विथ मी. फ्रेंड्स, यूं ही नहीं मिलती राही को मंजिल, एक जुनून दिल में जगाना पड़ता है. वो जुनून जगाया है आप सब लोगों ने मिलके. मैं इसलिए ये बात कह रहा हूं, ग्लोबल ऑर्थोपेडिक फोरम पहली बार, कुछ लोग नए हैं, जब पहली बार 2017 में इसका अनाउंसमेंट मैंने किया था कि आई विल फॉर्म अ स्मॉल ऑर्गेनाइजेशन, उसमें वी विल ट्राई टू डू सम साइंटिफिक एक्टिविटीज. 9 लोग आए थे, केवल 9 लोग, और काफी लोगों ने यही बोला था, अमूल्य लगता है कुछ पागल हो गया है, कुछ कुछ सोच लेता है जो जिंदगी में कभी सफल नहीं होगी. एंड टुडे आफ्टर 9 years you see what we are up to. It's just because of the cooperation, motivation of all of you. You people have made it Gofcon what it is today, friends. And the Zunoon has been taken and cooperated by Dr. Vinod Thakur, the organizing committee chairman, Dr. Ashok Kumar Sinha sir, the reception committee chairman. Those 2 people who are sitting here, जब भी कुछ पूछता हूं हमेशा अमूल्य मिलके करना है, लेकिन हमारी इज्जत कहीं से कम नहीं होनी चाहिए. थैंक यू सर, यू हैव ऑलवेज कोऑपरेटेड मी, मोटिवेटेड मी. एंड द प्रेसिडेंट ऑफ ग्लोबल ऑर्थोपेडिक फोरम, डॉक्टर सरसज नैनम सर, यू आर द पर्सन जो कि इतने शांत स्वभाव के होते हैं, ये पीछे छूट भी जाते हैं, पता नहीं चलता है, पर हमेशा पॉजिटिव थॉट्स. मैं आज भी अपने कल रात में लेक्चर में बोल रहा था, हार्वर्ड स्कूल ने भी प्रूव कर दिया है, इफ यू हैव नेगेटिविटी इनसाइड यू देन योर लाइफ स्पैन बिकम्स लेस. और ये आदमी वही हैं जो कि ऐसे तो माय ब्रदर इन लॉ भी हैं, लेकिन जिस हिसाब से ऑलवेज ही टॉक्स इन पॉजिटिव फॉर एवरीबॉडी. कोई भी कार्यक्रम जब भी होता है तो उसका एक साइंटिफिक प्लेटफॉर्म इज वेरी इंपॉर्टेंट. अगर साइंटिफिक प्लेटफॉर्म अच्छा नहीं हो, कितना भी पैसा फार्मा कंपनी दे दे, कितने भी फैकल्टीज आ जाए, उनको ढंग से अरेंज नहीं किया जाए तो बहुत मुश्किल होती है. क्योंकि सब साइंटिफिक कमिटी के जितने भी लोग आते हैं, एवरीबॉडी इज बिजी. और जिस व्यक्ति ने उन मोतियों को पिरो के एक माला बनाया है, ही इज सिटिंग हियर. डॉक्टर रमित गुंजन, जिस तरह से इसने एक एक कार्य किया है, लोग सोचते हैं अमूल्य ने किया है, लेकिन वो शायद ऊपर दिखावने वाली बात होती है। बाकी सारा चीज जिस तरह से मेहनत से साइंटिफिक प्रोग्राम इसने बनाया है, टेकिंग कॉन्सेंट ऑफ मोस्ट ऑफ द पीपल, सबको ध्यान में रखते हुए एक एक लोगों को तहजीब दी है, सबको इज्जत दिया है। उसके बाद आई एम थैंकफुल टू यू एंड इट वॉज ट्रूली कोऑपरेटेड बाय येट अनदर पर्सन हु इज none other than Dr. Feroz Alam. Feroz, where are you? Yes, standing there. हमेशा हमारे साथ रहता है Dr. Karunesh Ranjan Tiwari. Karunesh, most probably you are not here. Dr. Colonel Vivekanand. Colonel Vivekanand is here, the sports medicine expert. और काफी कुछ जब आप करने लगते हैं, पैसा आता है, फाइनेंस बात, और कुछ व्यक्ति ऐसे होते हैं उन पैसे को कहीं खोने नहीं देते हैं, एंड ही इज डॉक्टर जीवेंद्र चौधरी. सर, डॉक्टर जीवेंद्र चौधरी, द ट्रेजर ऑफ ग्लोबल ऑर्थोपेडिक फोरम. और उसके ठीक पीछे हमारा छोटा भाई दिनेश बैठा हुआ है. दिनेश, पता नहीं हर दिल अजीज, सबसे ज्यादा अच्छा. मैं हमेशा पाता हूं कि दिनेश के अगर किसी का दोस्त बन के रहता है, उस व्यक्ति को कभी भी जिंदगी में दुख नहीं होगा. आई एम लकी पर्सन दैट दिनेश, आई हैव गॉट यू इन माय लाइफ एज अ ट्रू फ्रेंड. टू अवर इंटरनेशनल एंड नेशनल फैकल्टी, डिस्टिंग्विश्ड गेस्ट एंड ऑल द डेलीगेट्स हु हैव ट्रैवल्ड फार एंड वाइड, वेलकम टू बिहार. डॉक्टर डी तन्ना सर, our mentor and guardian, Dr. S.K. Tyagi sir, renowned gastroenterologist. Dr. Tyagi sir, are you in this hall? Yes sir. सर आप पीछे क्यों बैठे, प्लीज आ जाओ, आगे आ जाओ, प्लीज प्लीज सर. आई विल रिक्वेस्ट यू सर, आप आगे आओ तो आ जाइए सर. संजय जी प्लीज सर, आगे वहां पे डॉक्टर उमैर के बगल में डॉक्टर एस.के. त्यागी सर के साथ मेरी मुलाकात अभी विशाखापट्टनम में हुई थी आज से 5 महीने पहले. वी वर शेयरिंग द डायस, आई एज अ ऑर्थोपेडिक सर्जन, ही एज अ गैस्ट्रोएंटरोलॉजिस्ट. और इनकी बातें जब मैं सुन रहा था तो मुझे लगा कि अगर इनका कार्यक्रम किसी दिन पटना में हो तब मुझे भी लगेगा बोलने के लिए कि देखो कितने अच्छे अच्छे वक्ता हैं. आई रिक्वेस्टेड हिम एंड ही एक्सेप्टेड. सर आई एम रियली हम्बल्ड इन फ्रंट ऑफ यू. और सर से जब मैंने बात की तब फिर मुझे लगा कि भाई आप आ रहे हो तो मैं आपके बराबर का कौन रखूं, किसको मैं रहा हूं चेयरपर्सन के रूप में. एंड यू वोंट बिलीव, I requested 5 Padma Shri of Bihar, Padma Shri Dr. R.N. Singh, Padma Shri Dr. Shanti Rai, renowned gynecologist, Padma Shri Dr. Vijay Prakash, renowned gastroenterologist, Padma Shri Dr. J.K. Singh, renowned oncologist, and Padma Shri Dr. Hemant Kumar, renowned nephrologist. सभी लोगों ने बोला कि मैं रहूंगा, and sir, we are blessed that way. कि हम वो 5 कल आपके कार्यक्रम रहेंगे सुनने के लिए. एंड सर ने एक शंका जाहिर की थी कि अमूल्य तुमने मेरा प्रोग्राम इस तरह से प्लेस कर दिया है, 1:30 बजे तुम्हारा प्रोग्राम खत्म हो रहा है और 1 बजे मेरा लेक्चर रखा है. मैंने बोला उनको उस दिन एश्योर किया था कि सर आपके कार्यक्रम में सबसे ज्यादा भीड़ होगी, आप खुद देखिएगा, कल अभी आने वाला है. क्योंकि मैं जानता हूं कि सर जब कुछ उस तरह के टॉपिक होती है, आज मुझे गायनेकोलॉजिस्ट सोसाइटी से आया है, नॉन वर्बल कम्युनिकेशन में अमूल्य यू आर डूइंग समथिंग, वी वांट टू बी अ पार्ट ऑफ इट. तो इस तरह से दूसरे स्पेशलिटी से कल लोग आ रहे हैं सुनने के लिए. इट विल नॉट बी ओनली ऑर्थोपेडिक्स. सर you will see for yourself. I'm thankful to you that you are here. Friends, Dr. Omer, my dear friend who has come all the way from Ireland, he was very busy, he was in Ranchi, then also he came here. Dr. Carlota from Spain, just now, I have not met you up till now, it was just a telephonic discussion, please stand up. Dr. Carlota from Spain, she is here and she will be delivering a lecture tomorrow, future of orthopedics. बहुत सारी बातें आज हम लोग की हुई है, क्या हो रहा है, आगे क्या होने वाला है. We will be hearing something. Even I don't know what she is going to tell, but let's see. I welcome you here in Patna. I know that you all are very busy, but you took your valuable time of coming to Patna. Patna is a city steeped in history, known for its rich cultural heritage and warm hospitality. We hope that alongside the rigorous academic session, workshop and symposium, we will also have a moment to experience the essence of our beautiful state. Gofcon 2026 has been designed with a clear vision to foster global collaboration, share cutting-edge surgical techniques, and ultimately improve patient care. Whether it is through the lens of the Bihar Orthopaedic Association, the specialized focus of nails, or the international reach of Global Orthopaedic Forum, our goal remains the same: excellence in orthopedics. Our theme of the conference is shaping the future, lessons learned from mistakes. I urge all the delegates, especially our younger colleagues and postgraduates, to make the most of the platform, interact with the master, ask questions, network with your peers, and take back knowledge that will empower your practice. Friends, मैंने पूछा एक चिड़िया से, कैसे बनाया है तूने अपना आशियाना? चिड़िया बोली, भरनी पड़ती है उड़ान बार बार, तिनका तिनका उठाना पड़ता है. वही हाल है हम लोगों का अक्षत सेवा सदन में कार्यरत जितने भी ये जो हमारी बच्चियों को आप देख रहे हैं, ये काम करती हैं. ऐसा नहीं है कि दे आर द इवेंट मैनेजर्स. They are working with me for last 20 years, 25 years, 30 years. और इन्होंने पिछले कितने साल से ये कार्यक्रम बनाया है, विश्वास नहीं कीजिएगा. परसों रात में ये 3 बजे रात तक काम कर रही थी. अब छोटी सी मैं इसलिए बात बता रहा हूं, रात में 11 बजे यहां से निकला था, आंधी तूफान आया हुआ था, बीच रास्ता पूरा जाम था. करीब 11:30 बजे मैं पहुंचा हूं घर में. वहां पे ये लोग फिर आज की तैयारी में लगी हुई थी. ये घर पहुंच के, मैंने हॉस्पिटल पहुंच के फिर आज 6 बजे कैसे निकलना है उसकी तैयारी हो रही थी. मैं गया आराम से सोने, मनीषा थी घर पे. मैंने बोला कि चलो भाई अब सोने जाता हूं. 12:05 में एक फोन, सर एक पेशेंट आया हुआ आपसे मिलना चाहता है. बोले यार मुश्किल है. नहीं बोला कि सर आपसे मिलना चाहता है, थोड़ी देर मिल लीजिए. 1 बजा दिया उसने. घर आया, एक नींद की दवा खाई, बहुत दिनों के बाद अल्प्राजोलैम खाया कि मैं कुछ देर सो लेता हूं. 1:30 बजे फिर एक फोन कि सर एक पेशेंट आया आपसे बहुत क्लोज है, पटेला का फ्रैक्चर है, वो बोल रहा है कि एक बार मिलने दीजिए हमको. 1:35 में मैं उठ के गया हूं. कितना डिस्कशन किया है, 2:05 तक उसने बातें करते रहा. बोला कि सर मुझे अभी ऑपरेशन कर दिया है. नहीं पॉसिबल है, संडे इवनिंग कर दूंगा. वो इतना जिद में आ गया, मुझे भी गुस्सा आ गया. मैं बोला 5:30 बजे कर सकता हूं. बोला कि मैं तैयार हूं. और यू वोंट बिलीव, 5 बजे मेरे पास सारे स्टाफ जगे हुए थे. 7:05 में मैंने दोनों ऑपरेशन खत्म किया हूं. 7:40 में मैं आपके बीच में था. दोनों ऑपरेशन खत्म हुआ है. यही स्टाफ लोग कोऑपरेट कर रहे थे, दिन भर ये जगे रहे हैं. लेकिन अच्छा ये लगता है, दे आर ऑलवेज ऑन विथ मी. और उनके कारण तो वही बोलता हूं, जो तिनका तिनका उठाना पड़ता है. Rome was not built in one day. It needs courage from inside, motivation from friends, and blessings from well-wishers to reach the goal with success. If you are happy and satisfied, then this is the success of Gofcon. Once again, I thank our dignitaries on the dais for the invaluable presence, the organizing committee for the sleepless nights, and you, the delegates who are assembled here, for making the event a grand success. Thank you. Before I say thank you to all my friends from the surgical industry and pharmaceutical. सर इस बार मैंने ज्यादा मेहनत नहीं किया था, साइंटिफिक बनाता जा रहा था, मैं रोज काम करता था, कभी भी नहीं. और मेरे पास 109 रिक्वेस्ट आया स्टॉल लगाने का. मौर्या मुझे 90 से ज्यादा नहीं बना सकता था. पूरा ग्राफ मैंने बना लिया. 90 को हम लोगों ने स्टॉल अलॉट किया है. 19 लोगों को स्टॉल नहीं मिला है अभी भी. पर उन्होंने बोला कि सर हम खड़े रहेंगे, किसी का स्टैंड ही लगा हुआ है, किसी का कुछ लगा हुआ है. तो ये सब भी आप लोगों के कारण हुआ है. थैंक यू सो मच एवरीबॉडी. थैंक यू सो मच.
Thank you, Dr. Amulya, for your kind words. Now, I think it is my great honor and privilege to introduce a personality who is really very grounded. Can I request Dr. Sarsish Nanam, who is President, Global Orthopaedic Forum, to come and give certain information about this forum.
मंच पर उपस्थित डिग्नेटरीज, सभा में उपस्थित मेरे कलीग्स और जो भी सदस्यगण उपस्थित हैं, हर साल हम लोग गॉफकॉन का कॉन्फ्रेंस करते हैं. हर साल कुछ न कुछ मोटो रहता है. इस बार का भी मोटो था लर्न फ्रॉम आवर एरर्स। मुझे एक कहानी बहुत पहले याद आती है। एक आदमी ने, बहुत बड़े आदमी ने, अपने यहाँ स्टाफ रखना था, उससे पूछा कि इंटरव्यू चल रहा था, उन्होंने पूछा कि आपने काम में कभी कोई गलती की है कि नहीं, तो मोस्ट ऑफ द सेड कि साहब इंटरव्यू है, अच्छा कहना चाहिए। तो उन्होंने कहा कि नहीं, हम लोगों ने तो गलती नहीं की है कभी, मैं अच्छे से काम करता हूँ। तो कहा कि जब आपने गलतियाँ नहीं की तो आप गलतियों से सीख नहीं पाए हुईएगा। तो अगर हम गलतियाँ करेंगे तभी तो हम उसे सीखेंगे। और हम लोग, इतने सारे लोग बैठे हुए थे, इतने सारे व्याख्यान हुए, सबों ने बताया उनसे क्या गलती हुई, उससे उन्होंने क्या सीखा। तो आज हमारे पास एक डाटा बैंक है कि कहाँ कहाँ गलतियाँ हो सकती हैं और उसको हम कैसे प्रिवेंट कर सकते हैं। ये बहुत बड़ी बात है, कम से कम उन लोगों के लिए जो अभी नए नए यंगर सर्जन्स हैं, उनको इससे काफ़ी मदद मिलेगी। क्योंकि हम लोग जब प्रैक्टिस में आते हैं तो पहला फेज होता है अंडर कॉन्फिडेंस का, हम लोग को हिम्मत नहीं करती है, पता नहीं क्या हो जाएगा, और कुछ दिन के बाद ओवर कॉन्फिडेंस में चले जाते हैं, जो होगा सब तो ठीक ही होगा, हम लोग सब जानते हैं। और तब तीसरा फेज आता है जब हम लोग नॉर्मल कॉन्फिडेंस में आते हैं। तो यंगर सर्जन्स को काफ़ी फ़ायदा होगा, चूँकि हम लोगों ने जो सीखा है वो उन्हें दिया है, उन्हें बताया है, उन्हें आगे काम करने में आसानी होगी। क्योंकि जो चीज़ बहुत सिंपल लगता है वो ऑपरेशन के दौरान जब आप खोलते हैं तो पता नहीं उसमें क्या क्या वेरिएशंस हो और क्या क्या प्रॉब्लम फेस करना पड़े। आशा करता हूँ इस कॉन्फ्रेंस में आप लोगों को बहुत फ़ायदा होगा और आने वाले जीवन में आप इसका फ़ायदा उठाएंगे। धन्यवाद।
थैंक यू डॉक्टर सरसुज, वी रियली थैंक यू, बिकॉज आपने बताया कि अगर काम होगी तभी गलतियां होंगी। सो वी थिंक गलती नहीं करना है। सो ये दिस इज अ मिसकंसेप्शन, काम हो रहा है, गलतियां हो रही है, इसका मतलब काम हो रहा है। थैंक यू। कैन आई रिक्वेस्ट Dr. Vinod Thakur, Organizing Committee Chairperson, whose guidance and leadership have been invaluable, to kindly address the gathering.
सबसे पहले सभी को मेरा नमस्कार, especially यहाँ dignitaries, those who have come from the long distance, Dr. Naveen Thakur, IO President, Rajiv Raman, Dr. Bhuvan Singh, Dr. Ashok, Dr. Nayanam Amulli, and Dr. Ramit Gunjan. So far Gofcon is concerned, I am involved since his first conference, as far I remember, directly or indirectly. Every conference I was present, I was doing whatever was given to me. So-called, you can say, a minister without portfolio, but this time I am a minister with portfolio, so I am very, very happy this time. And thanks to Gofcon, thanks to Amulli, who has pulled me this time here, to be part of this here. So, as we all know, the Gofcon is doing very nice work since so many years, and it will continue. And now the young surgeons who is started his career, they are very, very much lucky than us. When we started our career long ago back, we didn't have so many conferences, we didn't have so many things, we didn't have even CT scan, we didn't have even MRIs, we didn't have image intensifier, so many things we didn't have, but we did our job with confidence and reached a goal and came over here. And so many things have to say, so many, but I am not a very good speaker, but still Gofcon is doing good. At last I will say this much in and with the Sanskrit slok, as far I remember, जो विद्या ददाति विनयम विनयम ददाति पात्रतात पात्रतात ददाम धनमान मुख भी यदा धर्मम तथा सुखम। विद्या जो है वो दया, करुणा, एक सभी तरह से एक फुलफिल मनुष्य का निर्माण करती है, एक चरित्र का निर्माण करती है, एक व्यक्तित्व का निर्माण करती है, जो कि सब पुण्य काम करते हैं, हम लोग ज्ञान बांटते हैं, और इस सब से सब तरह के धनों का उपार्जन होता है। धन का मतलब पैसे के साथ साथ गुड फ्रेंड, गुड हेल्थ, एवरीथिंग, सब तरह से सब धर्मों का निर्माण होता है और एट लास्ट में वह धर्म का काम करता है। और कहा जाता है कि यथार्थ धर्म, जहाँ जहाँ धर्म है वहाँ वहाँ खुशी है, वहाँ वहाँ सब तरह से खुशी है, मोक्ष है, सब कुछ है। इसी के साथ मैं अपना वाणी को विश्राम देता हूँ। थैंक यू वेरी मच फॉर हैविंग मी हियर।
Thank you so much, sir. I take this opportunity to invite Dr. Ashok Kumar Sinha, sir, Reception Committee Chairperson, to kindly share his valuable perspective with us.
Respected dignitaries available on dais, Dr. Naveen Thakkar Sahab, Dr. Raman Sahab, Dr. Mulya, Dr. Thakur Sahab, Ramit Ranjan, Bhuvan ji, and all delegates or senior colleagues and junior colleagues. Actually, I was the wrong person as a reception committee because everybody wanted to see Mulya first, and so I couldn't receive any person. Anyway, but I am very much grateful to Dr. Mulya to I associated with him, and I cannot, say that much about Dr. Mulya, but I always say, Dr. Mulya जी कहाँ से इतना एनर्जी आता है आपको? मैंने सूर्य से देख रहे हैं, 94 से हम इनको जान रहे हैं और पता नहीं कहाँ से एनर्जी आता है कि सब जगह अवेलेबल होते हैं। कभी सोशल गैदरिंग में भी अगर हम इनवाइट करें, पता चल के मैंने बेटी के शादी में इनवाइट किया था मुलिया जी को, पता चल के बनारस तक पहुंच गए और कभी भी मिस नहीं करते और हम बराबर पूछते भाई कहाँ से इतना एनर्जी आता है सर। और बाकी क्या बोलना है, मेरी तरफ से सभी को बहुत अच्छा से क्या बताएं, रिसेप्शन एक्सेप्ट करिए और अपना समाप्त करते हैं अपना बात कुछ। ठीक है, थैंक यू।
Thank you, sir. We would be honored to hear from Dr. Bhuvan Singh, President, Central Zone Orthopaedic Association. May I request you to come forward and address the session, sir.
Chief guest of this ceremony, President, Indian Orthopaedic Association, Dr. Naveen Thakkar, sir. Guest of honor, Dynamic Secretary of Indian Orthopaedic Association, Dr. Rajiv Raman. President, Bihar Orthopaedic Association and everything of Gofcon, Dr. Mulya Singh, sir. Dr. Sarsis Nenam, sir, Dr. Ashok, sir, Dr. Vinod, sir, and my younger brother, Dr. Amit Gunjan. It is a proud privilege today to be here at Gofcon. I think I have never missed Gofcon till now. जब से शुरू हुई है यह यात्रा, मुझे फुर्सत हो नहीं हो, जब एक बार अमूल्य सर का फ़ोन जाता है तो डर से भी आना ही पड़ता है। और ये सच्चाई भी है, आज तक हम लोगों ने जो भी सीखा इन्हीं से सीखा। सो ही इज रियल धुरंधर ऑफ ऑर्थोपेडिक कॉन्फ्रेंसेस। And sir, this is not the time to give you best wishes. This is the time to give you big congratulations for this grand gathering, great academics, wonderful faculties in front of us here. Thank you very much, sir, for giving us this chance. Thank you very much.
Thank you, sir. Now I take this opportunity to invite Dr. Rajiv Raman.
Respected Chief Guest, President IOA, Dr. Naveen Thakkar, sir. Dignities on the dais, dignities of the dais. Gofcon के लिए बोलना चाहता हूँ, I am coming in Gofcon since its inception. अमूल्या सर उस समय पाटलिपुत्रा होटल में करते थे ये मीटिंग। 2-3 मीटिंग के बाद मैं बोला सर हॉल आपका छोटा पड़ रहा है, लोग खड़े रहते हैं। फिर उन्होंने मुझे फ़ोन किया, राजीव इस बार अब मौर्या में करेंगे। और मैं दिनों दिन देख रहा हूँ गॉफकॉन किस तरह से ऊंचाइयों पे जा रहा है। साइंटिफिक एक्टिविटी, पार्टिसिपेशन ऑफ नेशनल इंटरनेशनल फैकल्टी और वो 3 महीने पहले ही फ़ोन करेंगे, राजीव अपना कैलेंडर देखो, ये डेट है, एक दिन के लिए तो आना है। और जैसा भुवन सर ने कहा, जब अमूल्या सर बुलाते हैं तो आदेश होता है। मेरी हार्दिक शुभकामनाएं इस कॉन्फ्रेंस के लिए अमूल्या सर, और मुझे लगता है कि गोफकॉन एक नेशनल और इंटरनेशनल फोरम पे बहुत बड़े कॉन्फ्रेंस ग्रुप में उभर रहा है। बेस्ट विशेस।
Can I please request Dr. Shivendra Kumar sir, past President BOA, to kindly felicitate our chief guest Dr. Naveen Thakkar sir. It is both an honor and a privilege to stand before you today to introduce a truly remarkable individual, a name that has become synonymous with excellence, compassion, and unwavering dedication in the field of medicine. In a world where healing is both a science and an art, he has mastered both with exceptional grace. With years of tireless service, groundbreaking contributions, and an unrelenting commitment to patient care, they have touched countless lives, and not just through treatment, but through empathy, integrity, and hope. Can I request you, Dr. Naveen Thakkar, sir, to address the gathering, please?
Good evening to everybody. After a long academic session, on behalf of Indian Orthopaedic Association, we really thankful to Dr. Amulya Singh and his whole team here, those who are working very hard since long. It is a one-man army with a great supporter, unsung heroes. They have worked very hard for us. And all the faculty, those who have contributed here, the science of the orthopedics, sharing and contributing and learning together by interaction. And it's a very great program. I have a small message for the young orthopedic surgeons, those who are present here. If you are not a member of the Indian Orthopaedic Association, please become the member of the Indian Orthopaedic Association. Dr. Rajiv is here, he is our secretary. Join the IOA. Just click the Join IO on IO website and join with the IOA. If you are already a member, just get the verification, because your Bihar Orthopedic Association is, I know that's bidding for the next IOCON, and increase your membership number and your strength. I think you have a lot of orthopedic surgeons in Bihar, but all are not Indian Orthopaedic Association members, and many are not verified members. So increase your strength. You have a great strength. During the Corona time, we have done a great work for webinars, and sir is here, all past presidents are here, all are active, all Bihar Orthopaedic Association, all district places. Every time I have come here, I have a special love for the Bihar Orthopaedic Association, and I am also a life member of Bihar Orthopaedic Association. So I must say that I love to come here, and I feel like a family here whenever I come. And every time Amulya is inviting us and giving this feast. I will not take your much time, but at this junction, we need to unite together. There are so many problems with the orthopedic fraternity in their practice. So we have made the presidential task forces. Please join the presidential task forces of the problems in the practice with the all members and the orthopedic surgeons, those who are not members even. The first problem we are taking, the executive committee has decided just before 2 days to join with the public interest litigation of Consumer Protection Act. If you know, the advocates as a professional has become out of the Consumer Protection Act, then why not the doctors should be out of the Consumer Protection Act? We are joining with the Indian Medical Association as a party to Supreme Court to fight for each and every orthopedic surgeons, and we must unite for this. And other problems we all know, we'll send you the details. Please join the task force. We need each and every person's contribution. Without unity, it is not possible at all. And it is a long fight for all problems. They are here, people are complaining, but we have to not complain only. We have to part of the solution, not the part of the complaint. And the last, I must congratulate the team of Dr. Amulya Singh for fantastic venue, fantastic facility, all the team, and they need a standing ovation for this event, please. This is a small request to you, and thank you for accepting my request of standing ovation. Thank you very much. Thank you all. Thank you.
Thank you so much, sir. It was a great honor listening to you. We shall now proceed with the felicitation of our esteemed dignitaries. It is our privilege to honor those who have graced the occasion with their presence and those whose contributions continue to inspire us all. May I request our honorable chief guest to kindly felicitate the distinguished dignitaries on the dais as a token of our deep respect and appreciation. So the first name is Dr. N.K. Agarwal. Dr. N.K. Agarwal from Ludhiana. Dr. Pradeep Chaudhary from Indore. Dr. M. Ajit Kumar from Mangalore. Dr. C.S. Yadav from New Delhi. Dr. Amit Rastogi from Varanasi. Second, Dr. Pradeep Chaudhary. Dr. M. Ajit from Mangalore. Dr. C.S. Yadav, New Delhi. Dr. Amit Rastogi from Varanasi. Dr. C.S. Yadav, New Delhi. Dr. Amit Rastogi from Varanasi. Dr. Amit is here from Varanasi? No. Dr. N.J. Karne, Pune. Dr. Piyush Mishra, Allahabad. Dr. Piyush Mishra, Allahabad. Dr. Amit Rastogi, sir, please come. Dr. Amit Rastogi. Dr. D.P. Bhushan, Dhanbad. Dr. Shekhar Srivastav, Delhi. Of Delhi. Dr. Shekhar Srivastav. Dr. Tarun Nagada, Mumbai. Okay. Dr. Brigadier Chetan Sood, Delhi. Dr. Rajiv Raman, Kolkata. Dr. Rajiv Raman. Dr. Umair, Ireland. Dr. Bhuvan Singh, Saharsa. Dr. Firoz Alam, Gopalganj. Dr. Piyush Mishra, Allahabad. Dr. Piyush Mishra from Allahabad. Dr. Vinod Thakur from Patna. Dr. Akshat Suman, Patna. The family should clap for Dr. Akshat. Louder, more louder, I can't hear it. Dr. Jitendu Chaudhary from Patna. Dr. Ranvit Gunjan, Patna. Dr. Ashok Kumar Sinha, Patna. Dr. Sarsish Nanam, Patna. I can't hear the clap from the family. Dr. Amulya Kumar Singh, the Dhurandhar of Bihar, Patna. तालियां जोर से with whistle, CD and hooting. Yeah. Last but not the least, the most beautiful woman in the hall, I would like to invite Dr. Manisha Singh from Patna. She has been my role model since my childhood. I was at the age of 5 when they got married, in fact, and since then I have been, observing her and trying to copy her.
थैंक यू एवरीबॉडी। अभी भी कुछ मोमेंटोज इसलिए रोके गए हैं कि कल वैलिडिक्टरी के बाद जब हमारे माननीय मंत्री संजय सिंह साहब आएंगे उस समय कुछ और भी जो गेस्ट बचे हुए हैं उनका होगा। तो आज का जो हमारा सम्मान समारोह है यहीं पे, एक बच्चा कोई, हाँ, सम्मान समारोह और इनॉग्रेशन खत्म करते हैं। अब हमें जाना है जिस जगह, वो तो है कि आफ्टर द साइंटिफिक प्रोग्राम समथिंग मैटर्स इज अ गुड इवनिंग, और उस सब के बीच में एक व्यक्ति जो कि आने वाले हैं, और ही इज लाइक माई यंगर ब्रदर डॉक्टर रमित गुंजन फॉर हिज वोट ऑफ थैंक्स।
I was so thankful, Dr. Mulya sir, for this opportunity. People have already said so much about Gofcon, but it really makes sense when I say that I have been associated with Global Orthopaedic Forum right since the stage of incipience. वो एक छोटा सा रूम जिसमें कि ग्लोबल ऑर्थोपेडिक फोरम का स्थापना हुआ था अक्षत सेवा सदन सर के हॉस्पिटल में. At that time, very few of us were present, and really, we know people were there who would say कि ये बहुत आगे तक शायद ना भी जा पाए. But he did it with his grit, with his determination, with his perseverance. I would like to quote a few lines. सीढ़ियाँ उन्हें मुबारक, छत तक जिन्हें जाना है, मेरी मंजिल तो आसमान है, रास्ता मुझे खुद बनाना है. And you would have heard these lines almost always. Anywhere where there's a gathering, you'll come across anchors quoting these lines. But I have felt these lines. मैंने देखा है इस व्यक्ति को इन शब्दों को जीते हुए. अगर डॉक्टर मूल्य सिंह कहते हैं he regards me as his younger brother, then that is for a reason. I have been with him through his ups and ups. I won't say downs, क्योंकि इनके डिक्शनरी में डाउन नाम का चीज कुछ भी नहीं है. He is a bundle of energy, full of positivity. Somebody right now was asking कि कहाँ से इतना एनर्जी लाते हैं. The key to his success is his positivity. I have seen when days haven't been sunny enough, but then it was again his perseverance, grit, and firm determination and never say die attitude which helps him bail out of difficult situations. Thank you so much, sir, for having me here. और इतना बड़ा कॉन्फ्रेंस जब 14 अध्याय हो चुका ग्लोबल ऑर्थोपेडिक फोरम के वेरियस कॉन्फ्रेंसेस राइट फ्रॉम द रूमेटोलॉजी कॉन्फ्रेंसेस एंड द गॉफकॉन्स, and I have been through all these seasons with him and I have seen it grow in stature. मैं अकेला ही चला था जानिबे मंजिल, मगर लोग मिलते गए और कारवां बनता गया. तो वाकई में ये कारवां बना. एंड आज ये इतना बड़ा इवेंट हुआ है, इतना सक्सेसफुल हुआ है, तो ऑब्वियसली देयर आर अ लॉट ऑफ पीपल behind the show who make it successful. And the most important thing which makes a conference successful is the scientific content, and that has been delivered by our esteemed guest faculties. From the core of my heart, I thank all the esteemed faculties, the luminaries, the dignitaries who've come across from all parts of the world, right from the various parts of our nation to across the boundaries as well, who have come across, and they are sharing their knowledge so that we can impart better care to our patients henceforth. So truly thankful to all the faculty members, and then all the delegates who have found out time from their busy schedules. They are all busy practitioners in their respective areas, and they have found out time to make it again a grand success, and they have been very interactive as well. Thank you so much, all the delegates as well. An event of this stature obviously has its own financial requirements, and that goes without saying that we need and have always got help from our pharma friends, who have always stood by us in supporting us in our scientific endeavors. So I thank on behalf of entire organizing committee all the pharmaceutical people for your never-ending support. Thank you so much. Hariji and his team, the audiovisual team, who makes sure that the scientific sessions go glitch free. They have always been associated with us through the annals of Gofcon, and we really appreciate your efforts. Thank you so much. Young guns, Akshat and Anjali, people, the young generation taking over the mantle from me has really lessened my, I wouldn't say burden, but definitely have shared a lot of load, and so that I am able to enjoy these scientific sessions with more attention as compared to what I would be able to do in yesteryears. Thank you so much, and congratulations, Akshat. By the way, he has cleared all the stages of FNB. Ganga, he has cleared for his fellowships and is eligible for arthroscopy, arthroplasty as well as pediatric. Congratulations, younger brother. Manisha ma'am, congratulations and thank you. You've always let sir work so hard so that he can curate these scientific programs so well. The volunteers, the health staff, the support system which Dr. Maurya has got. 3 days back when there was a press conference at Akshat Seva Sadan, I went there, and while going upstairs, we got a sneak peek into various rooms and we saw people were sitting cross-legged and whatnot. कोई ये मोमेंटोज सजा रहा था, कोई ये नेम टैग्स को सजा रहा था, कोई कुछ पैक कर रहा था, सब लोग वर्क मोड में थे. Again, Bharat Raju sir was asking कि it would have required a lot of effort in organizing conferences of this stature. So I told obviously that is there, but डॉक्टर अमूल्या के रिलेंटनेस एफर्ट्स ने एक ऑटो मोड में चीज़ों को सेट कर दिया है, और एक बटन दबते के साथ ये लोग शुरू हो जाते हैं अपने मोमेंटोस को सजाने में. मैं साइंटिफिक तैयार करने लगता हूँ, और माई ऑल विद अ फ्रेंड डॉक्टर फिरोज आलम इज ऑलवेज देयर टू हेल्प मी. ऐसे वो 3 इडियट्स में कहते हैं ना कि दोस्त अगर फेल हो जाए तो दुख होता है, लेकिन वह दोस्त अगर टॉप कर जाए तो ज़्यादा दुख होता है. इसको बड़ा दुख हुआ मेरा नाम याद देकर. Thank you, Firoz. You've always been there through my ups and downs. All the media people who are giving so much good coverage about all the scientific contents yesterday, obviously we'll have good coverage tomorrow as well as day after tomorrow. The Maurya people, Ashish ji and your entire team, Maurya has really taken very good care of all our esteemed guests. I hope I am not missing somebody. So, on behalf of the entire organizing committee, all our seniors, our mentors, all who has taken so much of pain to come over, Naveen Thakkar sir, Rajiv Raman sir, our president Sarsis Nanam sir, V.K. Thakur sir, Bhuvan sir, Ashok sir, all of you, I thank you from the core of my heart on behalf of the entire organizing committee for making it a grand success. Thank you so much.
May I invite Dr. Manoj Chaudhary sir, मेरी भतीजी को felicitate, क्योंकि जिस तरह से अंजलि, the way she has taken out, sir, आप आ जाइए sir, please. हमारे past president of Bihar Orthopaedic Association sir, आपका ऑनर कल होना है, लेकिन आप दूसरे को तो ऑनर आज ही कीजिएगा. सर अंजलि पीछे जाओ. Request everybody to stand up for the national anthem.
जन गण मन अधिनायक जय हे भारत भाग्य विधाता, पंजाब सिंधु गुजरात मराठा द्राविड़ उत्कल गंगा, विंध्य हिमाचल यमुना गंगा उच्छल जलधि तरंगा तब शुभ नामे जागे तब शुभ आशीष मांगे गाहे तब जय गाथा जन गण मंगल गायक जय हे भारत भाग्य विधाता जय हे जय हे जय हे जय 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 हे।
Now I will invite everybody to join us for the musical program near the poolside. Just you have to go out, and behind the stall area, beside the stall area on the poolside, there is a musical program. We will have dinner and everything there only. Thank you so much. Tomorrow morning the program starts at 8 a.m. sharp.